Ladies and gentlemen, day 2 of our CHIP Summit 2023. I request you all to kindly take your seats. We begin in a couple of minutes. After the jam-packed session of last night, we again begin with the scientific sessions now. May I request you all to kindly put your phones on silent or a vibratory mode, please. Before we begin the scientific sessions, Dr. Anil Kumar will be addressing us with the introduction to CHIP 2023. Welcome, sir.
Good morning. After going through the ABC of CHIP, we have still a long way to go. D to Z is still pending. We will have elegant discussions. We are having experts from all over the world, from US, from Australia, New Zealand, from France, who are redefining the concept of CHIP, enhancing outcomes, as our theme is, enhancing outcomes in CHIP and making things better. We have sessions dealing with mastering the CHIP, evolving newer concepts, minimal access angioplasties, going on to mechanical supports, and then we have the live case coming in at 7 o'clock from New York. The New York live case is being done by Jeff Moses, one of the pioneers in angioplasty, and we'll have Zayed Ali moderating the latest in OCT. So we have a lot on offer today, and I welcome you all to these sessions once more. CHIP 2023, we had a good beginning yesterday, and I had to pull out people from the simulated sessions. Karthik's session was going on late into 10:30 and all. We had to pull out before the restaurant closes. So I'm sure today's sessions also will bring renewed interest, and welcome you all once again to CHIP 2023.
Thank you very much, sir. We move on to the scientific sessions, starting with the first session. May I request the chairpersons to kindly take your seats on the dais, please. Dr. Shiva Prasad, Dr. Deepak Davidson, Dr. Rajashekar Verma, and Dr. Deepak Raju. For the kind attention of the chairpersons and the speakers, the time allotted is 15 minutes plus 5 minutes discussion time. Over to our chairpersons, and we begin with the bang. Dr. Sharath Reddy, please.
Good morning. PPT, please. Yeah.
Good morning. I think we'll start the opening session of CHIP 2023 with an important topic, that is mechanically circulated support devices. We'll have a great speaker on hemodynamics and choice of MCS device, Dr. Sharath Reddy, please.
Thank you. We all know this is a very, tough topic to justify because you have volumes of information, but very less robust data to support as of now, what we are doing in these kind of situations. I mean, these are the various devices which are available for temporary mechanical circulatory support. So you have IABP, which is widely available and lowest in terms of cost, and Impella, which nearly cost around 2 million in India, and Tandem Family, which is not available in India. ECMO, which is widely available. Again, many cardiothoracic centers are well versed with this. And another is Centromag. This is available, but personally, I don't have any experience with Centromag again because it is quite invasive and deployment, so which we may not prefer in most of the times in interventional cardiology. Coming to these devices and the kind of support they provide, so if you look at the kind of support they provide, IABP, I think it is a least support. We all know it gives kind of 500 to 750 ml of support, and Tandem Heart around 30 to 60% of support, and Impella 2.5, and this device is about to be weaned off even from India. We remain with only Impella CP and Impella 5, and this gives almost equivalent support as ECMO and Centromag. But these two devices, where you can go even up to 10 liters of output, which is generally not used in regular patient care. So these are the pros and cons of VA ECMO. It is widely available, and many cardiothoracic units are well versed with this. And the problems are like the cannula sizes and arterial complications, and vasoplasia, and LV venting, which might be needed for this device. So, and this is Centromag. It is centrally implanted from RA to PA and LA to aorta, and which is driven by externally magnetically levitated heart pump, and that is the reason this can be used for long duration, and in fact for months as well. But it is invasive procedure, so it needs. You have to open chest, and surgeon has to do it. And what is the ideal MCS device? I think nothing justifies, as far as ideal device is concerned. So it's easy to implant, easy to maintain, and easy to remove, and less number of complications, and gives maximum hemodynamic support when required, and biocompatible and durable and cost effective. I think none of them justifies this criteria. So there are a lot of trades off. When it is cost effective, it is not hemodynamically effective. So there is nothing like ideal device. And coming to whom to use, when to use, what to use, I think again this is riddled with a lot of issues. Most important is availability, and heterogeneous availability in centers, so leading to the heterogeneous experience of centers because of the preference, based on the resources available. That is the biggest limitation in our country as well. And there is lack of robust evidence. We have evidence, but till now the evidence is very weak towards these devices being used in certain scenarios. And another limitation is the resource intensiveness which these devices needs, like shock teams, which consist of intervention cardiologist, heart failure cardiologist, cardiac surgeon, and perfusionist. So and critical care physician, and the team has to be involved in taking care of this patient. But what is well known is, in such patients where MCS devices are required, that is a cardiogenic shock patients, if these patients are taken care by shock teams, their outcomes are much better. This is what it showed from 2017 to 2018. Wherever shock teams are taking care of patients, the survival has just jumped from 44% to 82% in acute MI cardiogenic shock, and in decompensated heart failure, it gone from 60% to 72%. So this is something which is now almost established. So shock teams makes difference for these patients. The reason why these devices are not showing robust evidence in these kind of patients is the risks involved in using these devices. So all the devices have some sort of complications like hemorrhage or infection, hemolysis, and limb ischemia, embolic or thrombotic event. So, and nearly it is hovering somewhere around 25 to 30% of patients can have these kind of complications. So the teams which can take care of these devices can make difference to these patients. So coming to choosing the device, factors to consider while choosing the device is, of course, the local expertise and resource and availability, which constitutes the biggest limitation. Next is the right heart function, and then expected duration of support and having an exit strategy. So these are the things which affects your decision making. And so this device, we don't have an experience. We use only these three devices in our center, but it is available in India. And so usual indications where we use, especially in an intervention cardiology dominated scenario, then in heart failure dominated, is cardiogenic shock, and most often it's an acute MI cardiogenic shock. And next is an adjuvant to prevent a cardiogenic shock in a vulnerable patient, that is a protected PCI. I'll just go into a couple of cases to explain, how to choose a device. This is a 26-year-old male, no known comorbidities, and this is how he came to emergency department, acute extensive antiviral MI. And 1 hour window period, as soon as he reached emergency, he got arrested. So they initiated CPR with the ACLS protocol. They achieved spontaneous, reversal of circulation, but it didn't maintain for a long duration. Patient went on going into VTs, VFs, they started doing DC cardioversion and started a lot of inotropes. And by the end of, during these resuscitation, this was the ABG which showed, lactate is already 7.9, pH is 7. So what is the choice of MCS in this scenario? A patient with an acute MI, post-resuscitation, and not maintaining hemodynamics and going into recurrent VT, VF, and high-dose inotropes. And you can see we kept patient on Lucas CPR machine. And in such patient, among the devices available, see, IABP, it doesn't produce such kind of hemodynamic support. So this patient needs bit significant hemodynamic support already in shock, recurrent VT, VF, and requiring high-dose inotropes. IABP is not sufficient. And one more thing, when patient is going into VT, VF, it really doesn't work. Coming to Impella, again the same story. So it gives a good hemodynamic support, but the problem is patient is going recurrently into VT-VF, that's when Impel also again keeps troubling with the suction alarms and lack of RV outflow. And Centromag, this installation of this device takes longer time because it's an open installation. And the best choice, and which can be commissioned quickly in this patient, which gives you both right ventricular and left ventricular support, is VA ECMO. So VA ECMO is the best choice. So we went ahead with Lucas on. We took an arterial cannula from right femoral and a venous cannula from left femoral vein. And then we commissioned within 15 to 20 minutes. That's the usual time we take in our center. And then we did a primary PCI. So the first thing is put patient on MCS, and then only you start doing revascularization. So in this patient, see, this revascularization is a pretty straightforward revascularization and not a challenging intervention. It's managing his hemodynamics is the most important thing. So we did a thrombosuction and then stenting, and during the course of procedure as well, patient was going into recurrent VT and VF. So when you keep patient on VA ECMO, there is no need to worry about VTs and VFs. You can just leave it, you can keep doing your job. But if you use an Impel in such a scenario, you keep coming back to the same point because it will start giving you suction alarms because of lack of RV outflow. And this is, we always use 100% of patients. We use antegrade flush into the ipsilateral femoral artery where we kept an arterial cannula. Here it's right femoral artery. You can see this is the antegrade flow to the limb. We use it in all patients with VA ECMO, younger, older, it doesn't matter because that's what even data shows. Limb ischemia chances will be less if you use preemptively. And this is what happened. You can see the LV function immediately after procedure because we couldn't do anything before procedure to this patient. And then you can see this is after 3 days, you can compare. So almost normal LV after 3 days. So yeah, you can see here. So it is almost a normal LV after 3 days. And this is the hemodynamics chart of patient. You can see his lactate was 7.9 around arrest and CPR, and it came to 1.4 by day 2, and his ECMO flow is gradually reduced to 2 liters. We started with 4 liters and then gradually reduces to 2 liters. And from severe LV dysfunction, he came back to nearly normal LV function. And his inotropes being, you can see the inotropes, and it almost reduced to mild levels. And this is how we know VA ECMO. This is, usual technique. So, and we weaned off, and patient got discharged on day 7. So this is another case, 46-year-old male hypertensive diabetic, had SOB for more than 8 months, and he was diagnosed as heart failure, and he was labeled as cardiomyopathy, and he was on treatment for cardiomyopathy. So one day suddenly he came with a class 4 symptoms to hospital, and pressure is like this, and dobutamine was started to just maintain the pressure, mean pressure, and heart rate is almost 120, and tropi, you can see significantly elevated. And I'll show you the echo. This is ECG, no acute significant changes as such, and you can see this is the LV. So there is almost severe LV dysfunction, you can see. You can also notice, tachycardia. And this is what angiogram was done, using, keeping patient with dobutamine. And his creatinine also elevated, so 1.9. And you can see there is a total occlusion in LAD, total occlusion in RCA, and also OM is occluded significant. OM is totally occluded. So this is anatomy, total occlusions, LAD, RCA, and OM, and severe LV dysfunction. And yeah, this is RCA, totally occluded. And this is the gist of this patient. Ischemic cardiomyopathy, acute decompensated heart failure. Can I have one more, couple of minutes more? Yeah, acute decompensated heart failure, NST and QMI, Sky Shock C with low dose inotropes, not deteriorating, is able to maintain with simple dobutamine over a period of 24 hours, and prerenal renal failure, high syntax score, high euro score, high chip score. So we need to revascularize. I think there is no contention in that point. And when you do revascularization, do we really need to do an MCS? You can see these are the comorbidities. This is his hemodynamic situation, and this is his anatomical parameters. CTOs in all three vessels, calcified vessels, might need guide extensions. So this kind of scenario, it's always better to use MCS. And what kind of MCS? The next question is it a biventricular heart failure or univentricular? You can see 50% of patients will have biventricular. And why we are so fascinated with right heart when you're using an MCS is when you start using a percutaneous LV assist device, you will pull the septum towards LV, and a borderline RV will go into dysfunction, and your RV output will come down, and your LV output also subsequently come down. So you end up in putting an RV assist device as well. So you have to do a right ventricular function assessment. This is a TAPSE and TDI, which are quite good. And we did a right heart catheterization. So with a CVP of 6 mmHg and PAPI of 1.7 and PCWP by CVP 0.2. So this says this is a decompensated heart failure, NST and QMI, normal RV function scenario, and no LV clots, no AR, no VSD, ASD. So obviously it zeroes down to IABP doesn't really support this fellow because significant hemodynamic dysfunction, and VECMO is not required because RV is quite good. Only LV assist device is enough. That is, Impella becomes a choice, and such patient, it's always better to use Impella CP and above, not Impella 2.5. So this is how to take a decision. And we did a RCA PCI. I think, sorry, yeah. So you can see this is RCA PCI, which took us almost 3 hours. And again, we completed the LAD PCI. And we couldn't do OAM because of time, because it took almost 5 hours for us to complete this whole procedure. And residual syntax score anyway is less than 4, so that is acceptable. This is a hemodynamics. And this patient, we weaned off ECMO after, Impella after 6 to 12 hours, monitoring PA pressure. His PA pressure increased at the end of procedure, so we wanted to pull it down, by continuing Impella. So, and we weaned off later. So you have to keep even exit strategy in these patients where you are using, MCS devices. And this is the typical time you can use these devices, temporary support devices. But if patient is not improving, you need to have your next plan, exit plan, either transplantation or permanent LVAD, or care withdrawal and palliation. So to conclude, temporary mechanical circulatory support now forms a cornerstone of treatment of cardiogenic shock and protected PCI patients. Shock teams make difference to outcomes. And new devices are rapidly emerging, but evidence is still bleak. And RV function plays a key role in choosing the device. And we need to learn more who is the right patient, when is the best, and which device to use, and how to minimize complications. Thank you.
You mentioned about the role of heart team, shock team, management of these patients who require mechanical circulatory support devices in acute MI. Can you elaborate on the members of the heart team and their roles?
So in our center, we have an interventional cardiologist, heart failure cardiologist, and cardiothoracic surgeon or a vascular surgeon, and critical care guy, so cardiac intensivist. So along with a perfusionist and nurse care. So we form, a shock team in our hospital. See, whenever such patient comes and lands in an emergency, so we have a system where the message goes to all the people simultaneously and everything is activated simultaneously. For example, the first case, so we installed VA ECMO within 20 minutes of patient landed in emergency department. I think that is a key. Yes, you have a window of 40 to 60 minutes, provided a good CPR is done with a good Lucas machine, because human efforts of CPR for 40 minutes, 60 minutes is, you don't know, sometimes people may not do properly and patient may end up in ischemic brain dysfunction subsequently.
So both cases were good, and with the use of technology, you could save the patients. You are excellently shown. I think the most important thing is the timing when to put the device. Mostly, what happens is we discuss, we think that inotropes can save the patient, we delay, and once the lactate level goes up, multi-organ dysfunction sets in. Then we again come back and discuss about MCS, and by the time the use may not be there. So deciding the sky stage, which stage to put, as a crucial timing. I think the earlier the better. Both your cases you did early and good results.
Yeah. So, I mean, wherever you think you wanted to wait, so it is paramount that, you have to keep monitoring shock stage every 6 hourly. So, if patient is slipping down the stage of shock, despite, whatever care you are doing, I think that is when you have to upgrade or escalate, your circulatory support to the patient. So, otherwise, I mean, the delayed detection, I mean, there is enough data. Once patient is in shock D and E, so outcomes are very bad. So the right stage where you have to escalate to circulatory support is when patient is in a classic shock and not went into D and E.
And can you give us some idea about the cost of VA ECMO to be established in acute MI?
So in our organization, typically the commissioning, the installation of device itself costs patient around 6 to 7 lakhs. And post that, everyday care is again different. I think the VA ECMO patient care nearly cost 1 to 1.5 lakh per day of ICU care. So that's what, apart from, your procedure and procedure related costing.
Yeah, I think the cost of the VA ECMO, there are two types of ECMO circuits that are available. The traditional VA ECMO circuit that can be put for weeks together. That is the one that is costly because of the cost of the oxygenator, which can last for so many days. There is another short-term ECMO circuit that is available that is much less costlier. Actual cost may come to around 70,000 or something.
That is what is used in cardiac surgery, oxygenator.
Yes, yes.
But that won't last longer,
No, it will not last longer. But for a high-risk PCI, where you're almost sure that you can get away within 48 hours, you can try that, and that comes to a cost of around 1 lakh to 2 lakhs total for the VA ECMO for a high-risk protected PCI.
So typically, these are the two oxygenators. One is 20 to 30,000, which is used in cardiac surgery. Another is 2.5 lakhs, which is heparin coated, which lasts longer. So, but see, in our practice, all these heparin coated, now there is a oxygenator shortage in India, especially this heparin coated oxygenator. Every time in last two cases of mine, we have to start with our cardiac surgery oxygenator, that is 20,000 oxygenator. 6 hours later, we shifted patient onto the heparin coated oxygenator. See, I mean, these are the practical issues, which we face. Yeah, we can reduce 2 lakhs if you can use this cardiac, surgery oxygenator. But yeah.
But I think in acute MI, the temporary option of ECMO support may not be holding good because they may require support for some more days.
Yeah, if you have no limitation, it is better directly go to this heparin coated oxygenators.
We have an ECMO machine, but the problem is the running cost is not met with the public sector. That is. So we had a wonderful discussion on hemodynamics and choice of MCS device, none other than the expert in it, Sir Dr. Sharath Reddy. Thank you for this wonderful presentation, sir. And we'll go to the next.
Yep, the next talk is an online talk. Yeah, I invite Dr. Mihas Kodancheri from the United States. He'll be giving a talk on Impella, its utility in chip. Dr. Mihas, over to you.
Thank you. Good morning. Can you hear me?
Yes, sir, we can.
You're able to see my slides?
No, not yet.
Can you share your screen?
Yeah.
Yeah,
See
we can
now?
see your slides now. Can you put it on show, pop on show mode?
Yes. All right.
Yeah.
Good morning, everyone. My name is Dr. Mihas Kodinchuri. I'm an interventional cardiologist at Methodist Physician Group in Merrillville, Indiana. I work in a medium-sized community hospital south of Chicago, and I run a very avid complex high-risk interventional program in my hospital. We do around 100 to 150 cases with mechanical circulatory support. And I'm going to here discuss about the role of mechanical circulatory support, what evidence do we have, how far we have come. I'm a consultant and a proctor for Abiomed, which is the company that makes the Impella device. As you know, the complex high-risk intervention has these three components: the comorbidities of the patient, the technical factors of coronary artery disease that is given by the syntax score, and the procedures that we do increase the risk as well. So the very fact that we are using a mechanical circulatory support increase the risk of the intervention. We already spoke about this. I'm going to skip from the slide. So what is the rationale for a mechanical circulatory support device? So it is the equivalent to heart-lung machine in CABG. The reason why we have so much avid evidence of patients doing well from coronary artery bypass surgery was because of the support that the heart-lung machine was giving to the patient during the procedure. When we do CHIP, and we see this on a daily basis, there is periprocedural myocardial ischemia, decreased cardiac output, and increased filling pressures. And if the patient has an inherent low reserve or a fixed cardiac output state, which is one is low EF, there is severe diastolic dysfunction, severe mitral stenosis, severe aortic stenosis, severe pulmonary arterial hypertension. Whenever there's a hemodynamic compromise, the heart will not accustom to it by increasing the cardiac output. And many of these people will go into electromechanical dissociation, and there'll be complete cessation of systemic circulation. So if you don't have a support, you'll have to do CPR. Mechanical circulatory support will actually prevent this cascade and will help the operator to just concentrate on the intervention. Now, believe me when I say this, there is definite evidence from non-randomized data that Impella works only if you use it as an upfront strategy. If you do it as a bailout, or if you do it in too late in hemodynamically unstable patient, it will not work. This is a personal experience. There's a patient who is having a left main shock wave. This whole strip is only 6 seconds. And you can see that in this 6 seconds, what is happening. Within about 4 to 5 seconds of we inflating the balloon in the left main, the cardiac contractility and the ejection fraction goes to 0. Now, because this patient has an Impella in, it is maintain a mean arterial pressure of 100. Otherwise, you would be doing CPR here. And we see this almost in every other case. Now, I'm going to review a little bit about the evidence. Now, I know that balloon pump is more and more seldomly used nowadays. Many of the trials that was done on primary PCA for STEMI, unprotected left main, LVF with less than 30%, and the latest one is a BCS trial. They all showed the same thing. There's no significant difference in major adverse cardiovascular events or all-cause mortality whether you do high risk interventions with balloon pump or not. The data that we have on CHIP with Impella comes from the PROTECT trial. The first PROTECT trial was a prospective multi-centric trial to see the safety and feasibility of the Impella 2.5. It was done on 20 patients. 2 patients died, but there is a 100% implantation and explantation rate, and none of them suffered any hemodynamic compromise during PCI. And this started the process, and this is what got the FDA to approve the Impella. Then came the Prospect 2 trial. It was a prospective randomized clinical trial of hemodynamic support of Impella 2.5 versus balloon pump in high-risk PCI. The problem was it was terminated prematurely because it failed to show any benefit. Even though the study was prematurely closed, and even though there was no change in the 30-day MACE events, we learned a lot from the study. So the people whom we studied were LVEF less than 35%, PCI to an unprotected left main, last remaining conduit, or LVEF less than 30% with 3-vessel disease. The hemodynamic support that is provided by Impella was far superior to IABP. Even though there was no benefit in MACE in the 30-day outcome, the 90-day outcome had a trend towards lower MACE. Now, what is interesting is that when they excluded the first case from every recruiting center, which is the learning curve case, that is, they're learning to put the Impella in, and when they analyze the people after the first case, there was definite evidence of decreased MACE. And when they changed the criteria to include only clinically significant MI, Impella 2.5 decreased MACE in people at 90 days interval. When we specifically took the subgroup with an LVEF of 30% and 3-vessel disease, Impella 2.5 significantly decreased MACE at 90 days. And this is probably the 60 to 70% of chronic ischemic cardiomyopathy intervention that we do with Impella today. This is the US Pella registry. What it predominantly showed was that whether you do it in an elective setting, urgent setting, in general, at 90 days, there is a 15% increase in the EF after intervention if it is done with the mechanical circulatory support. And this is important because a 15% increase in EF significantly changes your 5-year and 10-year mortality. Then came the PROTECT 3 study. It was a single-arm study to evaluate Impella CP to support complex PCI with depressed EF. 504 patients were recruited. They were older, sicker, and more complex coronary anatomy and higher syntax score. The study demonstrated that patients with PROTECT 3 study had significantly lower in-hospital bleeding, required less transfusion, had less hypotension and ventricular arrhythmias. And at 90 days, the rate of MACE was significantly lower in PROTECT 3 when compared to the PROTECT 2 patients. So this is the comparative outcome that we can come up with as we do high-risk PCI with mechanical circulatory support from balloon pump to Impella 2.5 to Impella CP. There is a significant decrease in MACE at 90 days. The PROTECT 4 trial is an ongoing trial. It is a multi-centric trial that is looking at randomization of high-risk PCI in people with EF less than 40% with or without a mechanical circulatory support. It's a big multi-centric trial, but the recruitment is very slow. It'll at least take a few years before we'll have this data to help us guide patients. This is the VAD registry. It is the largest database that we have of high-risk PCI with mechanical circulatory support. What we analyze from this is simple. The use of prophylactic MCS has increased over time. Intra-aortic balloon pump is associated with a higher MACE but lower risk of procedural complication. So if we learn to do Impella with lower vascular complications, then we can have a good MACE when compared to doing it otherwise. So now we come to the discussion, who should we use mechanical circulatory support? And I think there are 4 things we need to consider. Certain things do not need evidence because it applies to your common sense and physiological sense. For example, antibiotics and septic shock. There is no level of evidence for use of antibiotic and septic shock, but common sense and physiological knowledge will support it. some are evidence-based medicine. Something doesn't make sense, but is helpful. For example, beta blockers in heart failure. Then there is a patient preference of and his choice. The one that is most controversial is physician knowledge, experience, and preference. And that should be the smallest part of the pie because when we talk about mechanical circulatory support, the physician often struggles between two things: his level of comfort in doing a high risk PCI with the hemodynamic support that the mechanical circulatory support provides, to the high risk of bleeding and vascular complication from using a large bore access in the groin. Now let's understand this from the physiological and mathematical sense. In a normal heart, the mean arterial pressure is 90, LVEDP is 12, the coronary perfusion pressure is 80 millimeters of mercury, cardiac output is around 4.8 liters, with the ability to augment by heart rate and stroke volume to 15 liters. So coronary perfusion is normally 250 ml, and when put under stress, it can go up to 750. Now look at the cardiomyopathy patient with an EF of 30% lower. The MAP is 60. The LVEDP is around 30. The coronary perfusion pressure is usually 30. The cardiac output is stuck at 1.8. There is usually no reserve. And because of that, your coronary perfusion is stuck at 90 ml. So this 90 ml of blood has, with a pushing pressure of 30 millimeters of mercury, has to skew through your guide wire, your balloon, your guide liner, and the pushing force is only 30 millimeters of mercury for 2 to 3 hours, which is the duration of a high-risk PCI. So if you're doing a CTO, this is probably not a big deal, but if you're doing it in a patent vessel, you're precipitating peri-procedural MI, and if most of the myocardium dies in this 2 to 3 hours that you're intervening on, all you will have is a good-looking angiogram, but a lot of dead myocardium, and you didn't really do any service to the patient. So common sense and physiological sense. Use a device that sucks the blood from the LV, decrease the LVEDP, end-diastolic volume, oxygen stress and oxygen demand, and increase the outflow, increase the mean arterial pressure, and decrease the LVEDP and increase the coronary perfusion. This is a 2020 guideline of the recommendations for using MCS in a high-risk PCI. We also have to differentiate between complex and high risk. In the term CHIP, complex stands for the patient comorbidities, and high risk stands for the coronary anatomy and the interventional procedures that we do. And we have to catch points that support the use of mechanical circulatory support. This is what we use. This is called as Impella score. This was validated from University of Washington, and now we are doing our own analysis on the 200 patients that we have done to justify the use of Impella. It gives a score of 2 when the patient is in cardiogenic shock, left main intervention, and last remaining conduit. It also gives the score of 1 to a lot of other criteria. But the important thing here is that you have to think beyond EF. EF and dilated cardiomyopathy is not the only people who will benefit from mechanical circulatory support. If the score is 3 or more, then we use it. If it is 3, we use these criteria to push the pendulum to one side or the other. Now, in our job, you only need one failure to abandon a device, and you only need one save to start trusting it. This is a patient I took care of last week. 57-year-old comes with chest pain, dyspnea. The lab show markedly elevated troponin in 8,000 and BNP of 10,000. EKG shows nothing impressive. There's evidence of acute kidney injury. The patient has soft blood pressure. He is not on any pressors at this point. But because of the high troponin, we took him to the angiogram. In the cath lab, during the angiogram, he becomes hemodynamically unstable and goes on dobutamine. You see there is diffuse disease of the LAD and the diagonal, subtotal occlusion of the circumflex, chronic total occlusion of the RCA. And these people come in packages. You have blockage somewhere, one place, you have blockages everywhere. Right iliac and femoral is diseased. Left iliac and femoral is diseased. dilated heart, severe MR, EF was 15%. So we decided to take the patient off the table and get the cardiac surgeon involved either for ECMO, LVAD, or CABG. The right heart cath actually shows low cardiac output with cardiogenic shock. In the ICU, the patient codes has VT, VFib, asystole, 20 minutes of CPR, and the patient comes back to spontaneous circulation, but still hemodynamically unstable on Levophed and dobutamine at this point. I tried to transfer this patient to tertiary care. He was turned down for CABG, left ventricular assist device because of his peripheral vascular disease, unknown neurological status. These are the calculators that help you understand and where to take the patient. The medical risk score actually calculates the risk of a patient to go into a productive life. So using that score, we found that his risk of ending up in a vegetative state is around 40 to 60%. When we use the SOFA score, his calculated mortality was 95%. Calculated survival by the shock initiative in a stage D was around 5%. Now, if you use a device, what device to put? The cardiac power output, which is given by mean arterial pressure multiplied by cardiac output divided by 451, was 0.56. And this is on presses, however. Anything less than 0.6 is an indication for the left-sided Impella. The pulmonary artery pulsatility index was 1.32. Anything above 1 is considered safe. So as the previous discussion, there's a patient who would benefit from an LVAD but doesn't need an RVAD. And that's what we do. If the LVD, if the CPO is less than 0.6 and the PAPI is more than 1, we first put the RVAD in and then put the LVAD in. The syntax calculator calculates a mortality of 90 to 100%. If the patient went for CABG, his expected mortality is of 90%. And the Impella score gave us a score of 13. So we put the Impella CP in. Wiring the LED was not very difficult. We ended up doing angioplasty, shockwave, and stent of both the LED and the diagonal. The circumflex gave me a lot of trouble. I had to use a guideliner for support by using the Fielder FC, XT, and Miracle Pro 3 grams. I was able to get through the circumflex. But after that, nothing would go. I did something I've never done before. I did an orbital atherectomy through a guideliner. So with the guideliner staying there, I was able to do rotational atherectomy all the way to the distal OM, followed by guideliner, exchange for Ironman, angioplasty, and shockwave and stenting. This was the final picture. Not great, but acceptable. Kept the patient on heparin and tirofiban for 3 days, brought him back on the third day to the cath lab. I did a thermodilution injection with the Impella, which showed a cardiac output of 3.2 liters, and then shut down the Impella completely, waited for 5 minutes, and the thermodilution showed a cardiac output of 2.8. Patient was stable on 8 mics, so I explanted him. He's still alive. I had to complete the groin, shockwave, stented, and close the right side with a Kelt device. And on the left side, again, shockwave, stented the iliac and closed it with a manta. The patient is still alive, is neurologically intact, and on presses, however. He still has acute kidney injury. His shock liver is improving. I hope he makes it. It's 4th day from the time we did the intervention. I also want to introduce everyone to this Impella Connect, which is an app on your phone. And the good thing is that even when you are sleeping, if the nurse decides to pull the Impella out, you'll get an alert. So this is the normal where you can see a phasic current flow here and the LV and the aortic pressures on top. This is what you will see if the Impella is too deep in the left ventricle, where you have a continuous electric current and LV tracing. And this is when it gets pulled into the aorta, where you have a continuous electric tracing and aortic pressures on top. That's all I have. I'm happy to answer any questions.
Thank you, Dr. Mihas. Can you come online now?
Yes. Yep. Can you see me?
No?
All right.
Yeah, right. So, how easy is it at your center to put a patient on an Impella? Does it involve a lot of bureaucracy, or is it just a medical decision alone?
Initially, to get the device in the hospital is a tough thing, because there is an initial investment. You have to buy at least 5 of the device. If you are successful in starting a program like now I am, where I use about 120 devices in a month, then in a year, it's as easy as pulling out of a drawer. So we have around 20 Impellas sitting on our shelf at any given point. So the decision for me is very easy. But once you start a program, it's very heavily reimbursed. The Medicare reimbursement of an Impella assisted PCI is $100,000. And the expenditure of the device is around $18,000 to $20,000. So once the program is established, it's very lucrative for the hospital. An Impella assisted PCI at this time in the United States gets paid more than what a cabbage pays. And if you end up putting a Bipella in, which is an Impella CP as well as a RVAD, it is paid the same as that of a transplant. It's like $160,000. Yeah, so many of the challenges that you face, I don't face.
Dr. Sharad?
Yeah, Dr. Mihas, I'm Dr. Sharad from Hyderabad. So,
How are you?
Hi, sir.
Excellent presentation at the beginning. Thank you.
Thank you. It's a nice case and very informative presentation. And yeah, we have not used Arpella till now, so because it's available only since last 6 months or so. And you mentioned you use Arpella first, followed by Impella in LV. Is that what you said during the presentation?
Yes.
When there is a biventricular dysfunction.
That's correct. So there's not a lot of evidence to decide which one goes in first. If the patient is arresting, there's no doubt that you should put an Impella CP in first. If the patient is not arresting or the patient is on pressors, then my experience is that if you put the CP in and you suction an empty left ventricle, it will cause, well, in milder cases, it will cause just alarms. But in severe cases where the RV is completely short, it will collapse the left ventricle and the patient will go into electromechanical dissociation. So in severe cases, it has been my personal experience that that Impella RP should go in first, followed by Impella CP. Because otherwise Impella CP is just going to suck and there'll be nothing coming in.
But do you start Impella RP before you start implanting
No.
Impella, or you start both at a time?
No, I put in the Impella RP. I put in the Impella RP first and then CP. Start the Impella RP first and then the CP.
Yeah.
Impella CP insertion is very easy. Impella RP insertion is difficult because the way this device was designed was that it has a curve that is considered an average of the right atrium to right ventricle to pulmonary artery curve, and negotiating that is not very easy. So it's not a very easy device to put in an emergency. So if you are doing an Impella RP in an emergency, like somebody is coding, what I do is that I have a 24 French 60 centimeter dry gore seal sheet. So over a Lundequist wire, you advance the sheath all the way to the left pulmonary artery. use that to deliver the Impella RP and pull the sheath back to expose the inflow. It is very difficult to put that in so when you're coding or doing CPR.
Thank you, Dr. Mia. That's a great input, for me because after I heard your presentation, I thought the moment if you start Impella RP and then you start installing your Impella, meantime patient may go into pulmonary edema because you are start pumping more into lung, but there is no exit out of LV. So it's a great point. And the second thing is about intervention, not about chip in this case. You used orbital atherectomy through the guide extension. Is it the 7 French guide extension?
No, it was 6 French guide extension.
Oh, it's a 6 French guide extension. So which company?
Which one? The guide?
Because the Lumen should allow your orbital atherectomy device. Because
to go.
oh, it will go through the 6 French guide extension.
1.25 it will go through.
As I said, it was my first time, so it went.
Okay.
And I wasn't 100% sure. I've not done it before, so.
Okay. Because we do rotational atherectomy, but I always use 7 French guide extension because it's hard to pull rotational atherectomy out of guide extension.
Yes, so that's the biggest advantage of the rotational atherectomy is that the burr is very small. So people who become comfortable with orbital atherectomy will tend to use more of that. It's also a little bit more riskier than the rod ablator. It is also a little bit less tolerant to tortuosity than rod ablator. But because the orbital atherectomy burr is much smaller, your chance of getting stuck is much lower.
Deepak? Thank you, Dr. Mihas, for an excellent presentation. We'll move on to the next talk. Dr. Madhav Menon from New Zealand. I think he's coming in online. He'll talk to us on newer MCS devices.
Dr. Madhav, you can hear us?
Can you hear me?
Yeah, we can.
Let me just share my talk.
We can see you now.
Okay, I'm just trying to share my talk. If not, can you play my talk out there?
You have the slides? Yeah, we can see that new hemodynamic.
Because I don't see the.
That one? Okay.
Yes, we can see your slides
We
now.
can see your slides now. Can you
Okay.
see the slides?
Yeah, I can see the slides
Okay.
here.
We'll move it forward.
Perfect.
Okay.
Yeah. Well, it's been very. Thank you for your time and allowing me to talk here. And it's been amazing to listen to the last two speakers and great cases. So, just a brief. So, I'm a chip operator, CT operator, TAVI operator for the last 10, 15 years now in Waikato Hospital in New Zealand, which is kind of Middle Earth of New Zealand. And this is increasing, these problems are increasing, and it's nice that these discussions are happening. So if I go to my next slide. So this is a case I did a few weeks ago, about a month ago, I think so. Ongoing symptoms with surgical turn down left main with viable ventricle, but poorly functioning EF about 25%, with a reasonably right ventricle and a reasonable right coronary artery. So this is what we deal with on a weekly basis in our hospital. And unlike, and I don't have the luxury of having Impella in New Zealand. In fact, New Zealand does not have Impella because of political bureaucratic reasons. And our government has just recently changed, and I'm hoping that we'll get some momentum on this. So All this while, I've been doing my CHIP cases. What I tend to do is use the old balloon pump, and I have a cardiac anesthetist, and I do the case together, and that gives me a lot of support. Next slide, please. And I won't go through the complications. We all know what CHIP is. The next slide. So the key is, you got to catch. You don't want to wait for problems to come before you start considering MCS. So you got to have some support in place before you start the case planning, and that's very important. So I'm going to share you my experience with a new device which I've been using recently. I don't have a lot of experience. I have some experience, and this is probably somewhere between a balloon pump and an impeller, is where I sit. So so trying to catch these cases before it becomes worse is crucial. Next slide. And not every CHIP case needs hemodynamic support. We know that, and I won't go through that detail, but you got to sub these cases very well. So I'm going to talk about pulse cath in a minute, and I won't touch base on ECMO has been well covered, and impeller has been well covered. Next slide.
Sorry to interrupt, Dr. Madhav. Is it all right if we cut off the video feed because I think there's some interruption? We'll just go on with the slides. If it's okay with the chair? Yes, sir.
Okay, next slide. So basically, in this case, what I did was, next slide. I put a pulse cath, which I'll talk to you in a minute. I ended up doing an orbital atherectomy of circumflex, orbital atherectomy of the LAD, lower ablation of the LAD.
Madhav, can you just put your video off and talk? Maybe the transmission will be better. Some audio interruption is coming.
Is it better now?
It is better.
Better? Okay. So I did an orbital atherectomy of the circumflex, orbital atherectomy of the LAD, lower ablation of the LAD, and I didn't use much inotropes for this case at all, and hemodynamic it was stable throughout. And next slide. And we finished up with a reasonably good result based on IVUS, and we obviously sealed the arterial site, which I'll talk to you in a minute. Next. I won't touch on this. This has already been touched on. Next. Next slide. So what is pulse cath? The technology is, it's a 17 French thin-walled catheter, which has got a two-way valve. Next slide. So basically, if you've got a balloon pump in your department, you can use pulse cath. It's a 17 French, so you need to put an 18 French sheath. It's got a bidirectional valve, and it's got an interface between an IABP console and the membrane pump. And it's run by the IABP console, and it kind of delivers around up to 2.5 liters output. Next slide. So it is activated by, it's an ECG trigger, so it's a pulsatile output, just like the IABP, but it sucks blood from the ventricle and puts it out just outside the aortic valve. And that's, I was told that it can work in asystole in an asynchronous mode. I haven't tried it. I don't want to try it. Next. So, and it's, it's useful for all your standard cases we've been talking about, multivessel disease, left main, all the complex cases we're doing with poor ventricular function. Obviously, you can't put it through a severely stenosed aortic valve, or if there's a thrombus in the LV, or if the vessel, you need at least 6 millimeters of femoral artery or iliofemoral system for this to go through. Next. So we are a TAVI center, like probably many of you are, and we assessed the iliofemoral system before, and fortunately this man had reasonably good vessels, which we assessed with our CT ultrasound. Our axis is ultrasound combined with up and over. Next. And then we put through a pigtail to put a superstiff wire into the ventricle. Next. And this flows very smoothly. I mean, it's not like a TAVI valve where you have to grudge it through. It actually flows very smoothly. And next. And I used a pigtail just to position it right at the aortic sinus. Next. And yeah, it kind of goes up and down a little bit, but it's fairly stable. Next. And then this was another case I did with next. And you finish up with reasonably good hemodynamics, and IVUS-based PCI, everything looked okay. Next. So I'll show you a small video about the pulse cath procedure. Just can you go back? I think there's a video which comes up. Yeah. So this is kind of what it looks like. It's a very soft catheter, and you've got to flush the whole system. And you insert the PTFE tube inside, and you've got to de-air the whole system, flush it all out. Yeah, so you got to be comfortable using Vibor Access, and you have to be comfortable managing all the issues which comes with Vibor Access. So that's one limitation in terms of smaller centers being able to do this. And you got to de-air the pump, and unlike what's kind of being shown here, you prefer not to shove the syringe inside the pump because it's much harder. Just let it drip through and fill it up. And once it's all, it just got to take a bit of time to do this. And then you put your, big sheath in. So this takes a little bit of time, but you got to make sure it's all okay. And I'll put a pigtail into the ventricle through which you put the super stiff wire. And then one of my cases, the device actually fell out of the aorta, and even if it does, it's okay. You can leave it in the aorta. It still works. It's just that. And there's a sheath which comes with the device, and I'll recommend you to use that sheath. I think once I used a Centrum sheath, and the device was almost stuck inside that, and that taught me a lesson not to use that. And once it's in, stabilize it, stick it on, and then you just start the IABP like how you do. And when you take the PTFE tube out, it'll bleed a lot, and you just need to put a clamp on. And just like how you connect the machines, you can just de-air it and connect it to the pump. And Bob's your uncle. It just starts. So it's quite easy to do. There's nothing complicated. And just leave it there. And then all the cases I've done so far, I believe you can leave this for a few days, but I have not. I've taken them out. Because of I don't want them to be ischemic and things like that, we closed both with Manta or ProGlides, and whatever you're comfortable with, and also whatever the anatomy allows you to do, and then you finish up the case. So next slide. I won't go through the data, it's all been covered. I think MC has based PCI for the right patient, for the right reasons, the right indications.
does offer a benefit, but it's all about case selection, and we're learning this sphere. It is exciting. Next. Size comparison, I guess this is a tad smaller than the Impella CP. That's just a figure to show you that. Next. Next slide. So the good news is there are a lot of newer MCPs coming, and as there's an Impella ECP, which is a 9-French system. That's a good game changer, I think, because then you don't have to deal with large varieties. It's so easy to deal with a 9-French system, and I think that's and I would love to have that. The Superior system was presented at TCT on a live case. I'm so looking forward to working on this. It is still in clinical trials. That's a 10-French system, and really nice to see the newer systems coming into the market. I think we need more competitions, because one of the limitations I have in New Zealand is because of cost of Impella, and unlike the United States, I don't get reimbursed because our healthcare is a social public healthcare, and they don't want to spend. So the cost of the PulseCat is probably half the price of Impella at the moment. Next. There's another company which is called Magenta, which is coming with this device called Elevate. It's another 10-French system delivering up to 5 to 7 liters a minute. And that's another exciting, again, this is in clinical trials. And next. There's a lot of other heart failure devices coming, and they may have spin-off effects to some of the, these are not chip devices, but what we learned from this might relate to a chip case later. You got the Nova pump, which is a kind of an IABP technology for the right heart. Then you have the new Pulse CV, which is again for advanced heart failure. And that's like a device inserted through the axillary artery. And it's like a pump that stays inside the aorta. And I've never used this, but this is interesting. Again, the Proceron aortics for heart failure. So we're learning a lot from this, and no doubt this will spill over to new technology in the near future. Next. So if you do chip, your lab has to be prepared to react. So React is a course I teach in New Zealand, and it's a course I've developed, which is now spilling over to Australia, UK, and a few other places. Hopefully this is going to come into the guidelines. And this is a cath lab simulation course to deal with complications. So we simulate, so we have a dummy which does everything. We have the physiology. It looks like a real cath lab with real scenarios. And we have a simulation program, and we throw people into programs, and we learn team behavior. And this is coming on behind of airline industry. Airline industry does this, anesthesia does it. I think cath lab, we should do this. And if you're going to get into chip territory and things like that, we definitely need to plan the whole team, not just about devices. Thank you very much.
Thank you, Dr. Madhav. Can you come online?
Yeah.
That was a good presentation on the new mechanical support devices. The PulseCat, how does it compare with the Impella in terms of cost?
So cost-wise, it's half the price of Impella.
Okay.
For us. So it is, and the way I kind of got it through to our hospital was, it's a new technology, but I've kind of said that this is actually a balloon pump technology, and this is an extension of a balloon pump, and I got the buy-in because of that. Otherwise, look, I've got bureaucracies to fight.
So with this greater French size, is that a problem in cases?
That's a problem. That's because again, it's not for every case. Yeah, unfortunately, because there's a case I'm doing next week, and I'm waiting for the CT. So I do a CT analysis of the vessel before, just like how you do for TAVIs, because it's an 18 French system. So the problem with when you put a large bore device is the case is not over until you sort the large bore axis, just like a tabby. You know, the valve's gone in, now you got to deal with the large bore axis. So that's another layer, and you know, you don't want to introduce more complications because of that. So we respect the vessels, and that limits. And some of these patients have terrible arterial disease, and we can't use that. So, which is why the 9 French impellers ECP would be great for some of these cases. Yeah.
What about patients with the smaller size iliac arteries or iliofemoral vessels? Do you have a surgical cut down with a conduit through which you can insert the device? Or?
We probably could, never tried it. I don't think if we can get access. I mean, we do subclavians. That's another way of doing it. We're comfortable doing subclavians, so we could do that.
Transaxillary punctures?
Axillary punctures, yeah, that's right. Yeah. And we have been closing our axillary punctures with Manta. So if it's feasible, that's an option. I've never tried it, but that could be an option.
Any questions from the audience? Ashraf? Sharat?
It costs around 7 lakhs in India. So regarding support, I think it's something equivalent to Impella 2.5. So you'll get around 2 liter support. And one advantage is you don't need a special console for this. You can connect to your routine IBP console and you can use it. So that's one advantage. Hospital need not buy a console. But I mean, otherwise it's a good device. Only thing is it is a bit larger device. And how often you see the clots formation within the device, Dr. Madhav?
That's what
Clot formation, and what's the ACT typically you maintain for this device?
The company says over 250, but I try to keep it close to 300.
Yeah. See, that's one issue. See, for Impella, we can manage around 160, 180 is typically okay, but this device needs a bit higher ACT and and higher, bigger size bore, and yeah. See.
And I haven't left the device in after the case. I've taken it out, so I don't have a long-term use like for days, and so we'll find out.
And you always remove immediately after procedure, or you try to continue for a few hours?
I've had the luxury of taking it out because the case has been stable, and because I'm not using it in any cardiac shock and things like that scenario, so I haven't had the opportunity to leave it in for a few days yet. So time will tell.
Yeah, I think all of them are only protected PCIs, and yeah.
Dr. Madhav, Dr. Deepak here. It was very informative talk. Just a query on your first case. We saw a calcified LAD and calcified circumflex. You had a rotablation for the LAD and you had a orbital for the circumflex. What is the reason for that? How do you decide on these two ablative strategies?
So the LAD I used orbital and rotablation both. I've been using orbital a lot. I've been a high user of rotablate over the years. For the last 2 years, I've been using orbital, and I've finally figuring out which lesions are better with rotablation, which lesions are better with orbital. Not every lesion orbital is the best. Like for example, when I use the orbital in the LAD, it didn't really fully crack the lesion as I wanted to. And sometimes when you use orbital, because the drill of the orbital is not at the tip, there's a nose cone at the tip of the orbital, and so if the lesion is very tight, the actual drill doesn't reach the lesion. And then in those cases, I have to use rotablation. So the orbital didn't work fully well at the LAD, which is why I had to use rotablation to get through. And I hear that rotablation with the burring capacity in front and back is now coming.
Thank you, Dr. Madhav, for a wonderful presentation. Thanks for being here online for the CHIP Summit. We will move on to the next live in the case presentation by Dr. Sharad.
Yeah, good morning. So I'll quickly take you through the case. So this is a 71-year-old male, diabetic, hypertensive, had stents in LAD, RAMS, and distal RCA in 2006-2012 with a moderate LV dysfunction, a drug defaulter. And he came with chest pain probably around 8 months before, came with chest pain with decompensated heart failure with almost like class 3 to 4 symptoms. And he had a couple of admissions before he came to us. 2 admissions are with the decompensated heart failure, wherein he got stabilized with medical management and angio was done. In this admission as well, it is a decompensated heart failure with high NT-proBNP and high troponin and with a normal creatinine. And this was his echo. You can clearly see there is a severe MR and there is also LV dysfunction. And this was the angio done outside. You can see ostial LCX is tight lesion and LAD stent is patent and RAMS stent is totally occluded. And it's almost a long segment. This is in the ramus, though the territory is and ramus is filling from LAD branches retrogradely as well as from OM. And RCA is total occlusion. So this is high syntax score, high Euro score, and high STS score, and high CHIP score. So clearly not a great case for any open surgery. We had a heart team discussion due to advanced age and high surgical risk and dynamic nature of MR. So his MR actually, in every admission, he went into severe MR, and again it came down to moderate MR. That's when he got improved and got discharged, again readmitted with same situation. So this was the 3rd admission with us. And in heart team, we took a decision to go for a PCI. And these are the issues with him. So advanced age, diabetic, heart failure, and ACS presentation, moderate LV dysfunction, and severe mitral regurgitation. And there is a multivessel disease. So kind of left main bifurcation because already there is a stent in ostial LAD and LCX is tight lesion, and RCA is a CTO, might need retrograde, and also calcified vessel, might need even rotablation or so. That's the reason we planned protected PCI for this patient. So the plan is basically to use an Impella CP and then do left main bifurcation and then do RCA CTO. And if time permits, mostly we can also do RAMS. That was the plan, before we entered the case. But certainly, decisions were dynamic, during the course of the procedure. So I think this was a case open for discussion, and then I'll show the live inbox.
So a very complex case in terms of the background morbidity, the patient characteristics, the lesion characteristics, as well as the underlying LV dysfunction with MR that worsens and improves, veins, waxes and veins, so dynamic MR. So the targets, did you think the targets were good for intervention?
I'll show you. You can just show the slides, please. So LCX is a very good target, and RCA, there is a good retrograde filling, and both PD and PLVB are nicely visualized in angiogram, and it's a viable territory.
Ramus?
Only Ramus, I'm not really convinced about it, so that's what I kept it open, during the course of the procedure based on the time, and I would mostly leave Ramus. Even if I leave Ramus, my residual syntax score will be, I think it's less than 4. If I treat rest all, the residual syntax score becomes less than 4, which is okay. Yeah, ideally 0, but less than 4 is also okay.
Your strategy for the intervention?
See, once your MCS is on, it really doesn't matter, which vessel you are treating first. If you are not putting an MCS, then, you have to think twice before which vessel you want to handle first. It's always better to clear off recipient vessel if you're not using an MCS. But once MCS is on, you can use anything. You can treat donor first and then you can treat recipient next. I mean, it's up to your comfort. That is a comfort which you get with a mechanical circulatory support device. So it really doesn't matter, which once MCS is on. I decided to do donor first and then I do RCA in this case.
The Austral LCX?
You can open live inbox. Yeah.
Austral LCX?
I'm not really convinced about Austral LCX lesion. That anyway, all those decisions we take with IVUS. If IVUS lumen areas are okay, I mean, if it is more than 4 mm square, I just leave it. Okay, so go to live inbox, please. Video.
Then the dynamic MR could be usually due to circumflex lesion, no? So that could be an indication that circumflex may be important.
Yes. But it is, even RCA territory is viable. So, and most likely in this case, it could be the LCX lesion which is causing the problem. Yeah.
And once you treat it, the MR will come down and the pulmonary edema will improve.
But as we want to do a complete revascularization, so, you can even try and do it without MCS support, but if the patient, decompensate during procedure, then your whole attention is diverted towards, stabilizing the patient. So that's when things will go wrong. It is better to use an upfront MCS and do a complete revascularization as much as possible. That is the best chance for the patient.
Actually, 3 vessels are occluded. So it's very important that MCS is there, high risk intervention.
So we'll just move on to the live inbox. Anyway, we did IVUS from LAD fast, just to understand, whether stunt is covering ostium or not. That is the first step in the case. This is IVUS from LAD. And we will show you, I'm not able to move video here.
We need.
I have to
Okay.
move the video, not you.
Okay, just give me on LAD. See, this is not going into LCX, so I'll do it on LAD and let us understand where is my LCX wire. Is it through the stunt strut? Okay.
Okay.
It's
Right,
gone
thank you.
individually. What is the LMCS size? You calculated pot balloon, everything?
Sorry. So we did IVUS from LAD. So,
Infusion.
and
How
we
much
made
time you
out
gave that
stunt
time?
is there from
Yeah.
ostial LAD clearly. So which you can make out in IVUS, by keeping and rotating.
But again, you have to monitor that input output, because before we remove impella again is okay. Give us a sense of what is the size of LAD, proximal LAD, because for me it appears the size of proximal LAD is quite small here. Give me 2.5 balloon.
So we dilated LED stunt first because there is some under expansion, and then we started wiring
Give me
LCX.
another cyan blue, please.
You can see here, this
Keep
is
watching, any for high colored urine for hemolysis. Huh? So what we are shown now is stunt edges at the ostial LED. We are still waiting for EEM size dia.
So this is the EM size. You can see 3.3, 3.5. So around 3.4.
Go down and measure, okay? Wherever you have a good.
So we can take around 3
Okay.
balloon.
I think I need a fine cross, please.
The LCX wire was
So
not
this
going.
wire is not crossing, I think there are two reasons. One is the bend, and because of the bend, it is not supportive. Okay, so I think I have to take a micro catheter there, and then probably switch to a channel wire and. Okay.
So we took a fine cross. Now, I'm sending the wire. It just went in. But what happened is
Show us
I
few.
could.
Yeah, this is good, right?
So these are the LED sizes.
All right,
Parallelly,
okay.
our IOS
So we can
person is
dilate
measuring
only
LED
with 3
sizes.
max.
These are the LED sizes.
Okay.
I can safely
Okay.
use a 3 balloon.
For LED,
to
it should be
dilate
3.
LED.
Okay.
And then we
Yeah,
tried going
right.
with IOS into LCX.
Trapper always take 12 millimeters. Okay, dilate.
And you can see here,
14, 16.
it was not
18,
going.
20.
So then we just dilated it with a balloon. Then again I tried going with IOS. It was still not going. So then we did an IOS from LED just to make sure where from my LCX wire is going into the vessel, whether it went through the strut in ostial LED or it is off the LED stunt. So we did an IOS. I think I'll just take it. Yeah. So, and with IOS, we confirmed, the LCX wire is not through the stunt strut. And then we used a guide extension to send IOS, and then did, IOS from LCX. You can see this is where we used a guide extension and then sent IOS through the guide extension. This happens often, IOS won't go into LCX. You have to use a guide extension. So, yeah, this is a IOS from LCX. I think I can just show you these. This is a distal reference. You can see 4.9 and the EEM size is 2.83, and this is one lesion you can see in longitudinal view. This is another lesion. This is a tight lesion. You can see all the plaque. So, this is, with this we decided, and ostium is tightest portion. You can see this is the ostium, and there is also a little bit of calcium nodule if you have made out in ostial LCX. But we decided to go with a cutting balloon. So we can even do a rotablation, but keeping another RCA CTO, I have to optimize my timing also. That's the reason we decided to use a cutting balloon. We used a FlexTome 3 millimeter, and we dilated the entire LCX with FlexTome. This is post FlexTome, and we had a good expansion and good lumen areas. So this is a post FlexTome image. You can see there is a good luminal gain. Yes, there is a little bit of nodule, but we thought it will definitely yield. At this juncture, we had a discussion whether to enter into ramus and also open ramus, but due to time constraints, the effort I'm putting on ramus, And the result I get, because it's a long stunt sitting from ostium, nearly 48 millimeter stunt, so I felt, it's better we leave it. And anyway, the ramus is filling from both OM as well as from LAD, diagonals from LAD. So we kept it in mind that, we shouldn't lose any branches which are supplying this ramus retrogradely. So that's what, with this IVUS, we decided to stunt proximal first and then distal. And so this is a proximal stunt which we deployed. And then we took distal. Because of the size mismatch, we stunted separately. So we crossed the LAD. And we confirmed again wire cross with IVUS. We confirmed wire cross with IVUS. That's what we do regularly. And then we did a kissing. And then again we did an IVUS from LCX and decided the distal stunt size. We kept second stunt into LCX. You can see this is the second stunt which we deployed into the LCX. And then again, we did kissing. We had to do re-kissing, and then we did a part, and then, we achieved final luminal areas around 5.5 to 6 in LCX and more than 7 in LAD, and I think it is more than 10. You can see here this is LAD ostium, so it's around 7, and LCX ostium was around 5.5 and LMCA was nearly around 10. So those are the good numbers, and we stopped at that level, and then we came to RCA. So what typically happens when you're doing a CTO, we start with a dual injection, but the problem when there is impella, so here I can use SHIP technique, single axe, we can take another guide catheter through the impella sheath. But the problem is, your maneuverability will be very less. So what we did, we took 3 arterial axes. This right guide is coming from radial. The left guide is coming from, right femoral, and impella is from, left femoral. So, and I couldn't able to use amplarger. So that's a big problem, when there is an impella. So maneuvering amplarger guide is very difficult. So you will lose your support in PCI, and you have to have plans to, boost your support during the intervention. So with such guide, so it's a JR, and you can see it's a long total occlusion, and there is a stunt in the distal RCA. So I took, this is Corsair directly, because with the Workhart's wire inside. And then we started upgrading or escalating wire. Initially, I tried with a microchannel wire, channel tracking wire, but it was stuck here and it was not going beyond that point. Then I started escalating wire. Before I escalate, always I boost support to the system. So if you don't boost support to the system and you are pushing your escalated wire, so your entire guide will, jump out. It happened in this case. If it is there in the recording, I think you can witness. So this is Gaia 2. You can see 1 mm tip. And you can see how it is. We are just advancing Gaia 2. But at some point, it's only anchor wire support. I tried an anchor balloon, but balloon didn't go inside. Because of, again, the poor support and a lot of calcium sitting all around here. So at some point, when I was pushing my wire, directing and pushing my wire, so you can see how the guide came out. So this is what happens, support is very crucial, when you're handling. And the balloon was, we wanted an anchor balloon in this branch, but balloon was not going. So then what I did, so it's better you take a similar tip load wire, but slippery, that is either Pilot 200 or Gladius, because the distal part, I crossed up to the stunt, and the distal part is something which I have to cross, and that is mainly instance CTO, which I can typically cross, with the Gladius as well. This is not moving. Can someone? Okay, right. You can see in this case, we can use guide extension, but I would prefer an anchor balloon because I want my system to be there. See, anchoring is always a better choice, but subsequently I use guide extension that comes later on. We can, yes.
Because you were not able to get the balloon into the anchoring branch.
I have to clear all this way and then send, guide extension. Yes, I mean, that's a good choice. So, yeah. So, it's, wiring is easy here. So, can someone help? This is not moving. So what is important here, please stand here. What is important here is there is a stunt here. So you see in two orthogonal views the stunt entrance and direct your wire into the entry into the stunt. And in the two orthogonal views, you have to exit through the stunt. See, that is a key. So when there is a stunt, you have a good visualization, where you have to enter, where you have to exit is much easier than in other CTOs. So in that way, instant CTO gives you much leeway in wiring. So you can see I'm seeing in two orthogonal views to see where my wire is, whether the wire is within the stunt in two views or not. So you can see here it was actually exiting out of the stunt, and again I redirected wire. So within the stunt. Yeah, so, and you can see here, we reached. So you have to keep wiring in two orthogonal views. You can also see, I trapped microcatheter with a balloon. As the balloon was not going into side branch, that is for anchor balloon, I trapped microcatheter within the main vessel while I am doing wire escalation and sending wire down, because that gives you immense support for your antigrade wire escalation. So you should have a stable antigrade system when you are escalating wire. So the wire went into distal vessel, and we confirmed in two views. You have to confirm that it is exiting your stunt inside the stunt. So that is, for this position, it is alveocaudal and alveocranial. So we confirmed, but I lost entire wire position because of the support. So then I came back with a guide extension, and then, Corsair, and then this is a Gladius wire. So the advantage with Gladius, see, already I made a track with Gaia 2 in this case. Now the job becomes easy for Gladius. Since the Gladius is a slippery wire, so it slips through the track which is already formed by Gaia 2. And it can easily get into, your distal territory. So that's what we did. So guide, yeah. So this is Gladius. Again, same thing. You have to keep seeing in two orthogonal views and advance the wire. And entry and exit, make sure in two views. So we went into the PDA, and I also advanced even Corsair down, and then we exchanged to workhorse wire. So this is a Workhorse wire exchange. And I took a laser. Originally, I have a poor support system here. So I want to use, a laser preemptively so that, my next devices will go easily and I don't lose the access again. That was the basic idea. So I've sent laser through, guide extension, and we laced entire stunt as well. And one of the other reason why I wanted to do it is not to lose the side branch. So if I can handle intima at the bifurcation well, so if I have to stunt into PL in this case, I don't want to lose, PDA. That is also another reason why I decided for easy entrance and not to lose the side branch. So this is after lace. At this juncture, patient went into severe hypotension. Despite Impella, his mean pressure was like around 50 or 55. So that was almost for nearly 10 to 15 minutes. In fact, I stopped doing anything. So what happened here is there was a guide extension in the right coronary artery for almost like nearly more than 45 minutes. And before guide extension, I kept a balloon to trap microcatheter. That's again around half an hour. So nearly 1 hour RCA flow was not there. So, and though it is a CTO, there is a big RV branch, which we can see. And once we opened vessel, and still your guide extension is there, occluding the vessel. So that is one patient had a severe hypotension and lost it for almost 10 minutes. So his CVP was 6 at that point of time. So immediately we pushed the CVP to 10 to 12. And we have to give even intravenous adrenaline along with Impella to stabilize his hemodynamics. And after stabilizing hemodynamics, then we dilated the entire stent. So that is a typical phase where we had a VA uncoupling. So there is only a flat line blood pressure in the monitor. So there is nothing like an pulsatility. So then we stunted distally. Since MLAs were good in a proximal RCA, so we didn't want to do anything to this part of the RCA, and we treated only distal RCA into PL, so with 2 stents. And yeah, so this is the second stunt which we kept. I think here there was a lesion, so in IVUS, so then we kept a second stunt into PL. And after second stent into PL, we optimized so entire vessel, and you can see, and we did a post-dilatation with serial balloons. And this is a final flow. Yeah, okay. Yeah. So this is a final flow into right coronary artery. We achieved good flow. And there is nothing like slow flow. And even the branch here is, the big RV branch is also filling. So, and all the lumen areas were good. So plaque areas were good. And then immediately you have to start looking at decommissioning your Impella. We also did IVUS from LMCA before coming out because patient went into hypotension. See, we wanted to understand did we do any harm in LMCA stunt. So after and confirming, and we started assessing for Impella removal. So what we typically do, we do a right heart cath before procedure, and we note down all the parameters. So we note it down, like PA pressure and central venous pressure and PCWP. This was not a smart assist device since it was done more than 8 months, I think more than 6 months before. Now we have a smart assist device which gives you even LVEDP. So if PCWP and PS systolic pressure and CVP are similar to where you have started, and mean arterial pressure is similar to where you have started procedure. And then we also did an echo. So if your echo LV function is similar to where you started, and in fact MR is reduced in this patient post-procedure. But always you have to assess all these parameters after coming to P2 flow, not at a peak impeller flow, because at peak impeller flow, your parameters will be totally different. So come back to P2 flow, and we waited for 10 minutes. We took lactate, and we took mixed venous oxygen saturation, and MAP and PCWP and CVP. And when all of them are similar to what it was before, then we wind off impeller on table. If there is any issue with these parameters, we extend the impeller support to patient for 6 to 12 hours. So in this patient, all those things were fine, and he was on very minimal inotropes. So, and we weaned off, I think this is at P2 flow. And we pulled impeller out, and then we removed, and we closed it with pre-closure sutures, which were already kept at the beginning of procedure. And you can, so this is another advantage with the newer sheath which we have right now. So you can keep a wire inside, and then you can pull your impeller. So you can keep a wire through the sheath inside, so that you will have your access control, so which was not there in earlier sheaths. And we closed it, and there was no issue with vascular closure, and we came out. And this patient, we kept him in ICCU for next 24 hours. Then we shifted him to room, and now it is 8 months. He's doing fine. Thank you.
That was an excellent demonstration of mechanical circulatory device supported complex PCI, but we have exceeded time by nearly half an hour. I think we can have discussion with him personally later on.
Thank you.
No. Dear all, for the younger generation, younger crowd, we have a small quiz that's coming up on the screen. Can you please project the question? You just have to access the this particular QR code, and you need to answer this question. And this will be discussed later on, and probably will be rewarded with good prizes. Can they start answering now? Yeah, please do answer. 10 seconds, and then we move on to the next session. You can just scan that QR code. That's for the younger generation, not for you, Mahesh sir.
While you answer your questions, I'll be inviting the chairpersons for the next session. May I please call upon Dr. Deepak Davidson, Dr. Ashraf, and Dr. Anil Kumar, Dr. Anil Kumar from Gurgaon, to kindly chair the next session.
Yeah, the answer is correct. We saw in the first session when Dr. Sharath was presenting, when you have a cardiac arrest, probably IBP will not work. A VV ECMO is primarily for the lungs. When you have inadequate oxygenation, that's when you have the VV ECMO. Impella, you need to have the heart contracting. And when you have total asystole cardiac arrest, V ECMO would be the ideal thing. You need to have the circulation supported. You need to have the oxygenation done. So V ECMO would be the ideal thing.
We'll start
Dr.
the
Sarjan Narayan.
Let us start. Due to paucity of time, we'll straight away go to the session. Now, Dr. Sarjan, talking on the balloon strategy for tackling calcium. Thank you.
Good morning to respected chairpersons and colleagues. I'll be talking about the balloon strategies for tackling calcified lesions. A balloon-based strategy is very relevant for an operator who is in the early or mid phase of the career, and especially in a low resource setting, primarily because the learning curve involved in the mastering this handling of balloons is minimum, and the training requirement, the learning curve is less steeper, and the complications associated with the handling balloons is lower when compared to ablation strategy, which is primarily a tool with the experienced operators in a high resource setting, and the cost for most of the balloon-based strategies are lower when compared to ablation-based strategies. So balloon-based approach to calcified lesions is highly relevant in current practice. So this is a 43-year-old gentleman who had an acute anterior wall isolation of eye. LAD was totally occluded. You can see that LAD is heavily calcified. When we tried to open up the vessel, the balloon was not opening even at 22 atmospheres. So at this point, we performed an intravascular ultrasound. As predictably, there was a heavy calcified lesion which was not given way. But most importantly, in the proximal distal segments, the balloon has created a very bad dissection. So this is a major drawback of a non-compliant balloon. Most of the current generation non-compliant balloons are highly deliverable and has an RBP up to 24 atmospheres. But because of single layer technology, this may not crack the lesion. And if there is a calcified spicule, this balloon can rupture. And most often, the perforations and rupture will happen at the junction of a calcified and soft segment, complicating the management. So this is a Rotaxis trial. The strategy of rotablation was superior to standard non-compliant balloon with regard to strategy success, which is defined as achievement of angiographic stenosis of less than 30% at the end of procedure with successful delivery of device without crossing over. So that was better for rotablation. So in this case, we used an angiosculpt scoring balloon at nominal pressures and increased the luminal area and created calcium fractures. We can see that 9 o'clock and 3 o'clock position. And patient received 2 long drug-eluting stents with good results. So a scoring balloon is essentially a semi-compliant balloon which has a rectangular nitinol struts which is arranged across the balloon. And this will help when the balloon is dilated, the struts will get into the plaque and create controlled dissections and fissures. And because of the rectangular structure, it will help to hold the balloon in place and prevent the balloon slippage. And because of the presence of the struts, the balloon will not overdilate and the chance of dissections and perforations are minimum. So these are the specifications of commercially available scoring balloons in market. And in a bench-side model, this is a calcified bench-side model, the pressure needed to crack the calcium with score flux was lower when compared to the non-compliant balloon of the same venter, meaning that you can crack the calcium with lower pressure and lower incidence of complications. And in a broad group of patients, a strategy of lesion preparation with the angiosculpt was superior to direct stenting or pre-dilatation with regard to intravascular ultrasound measured minimal stent diameter at the end of the procedure in a broad group of calcified, mixed and fibrocalcific lesions. And there was a larger acute luminal gain with scoring balloon. This is a 56-year-old gentleman, end-stage renal disease on renal replacement therapy, acute inferior isolation, tubular lesion at the obtuse margin. We tried to crack the lesion with the balloon, but that was not yielding. And intravascular ultrasound showed there is a eccentric calcium that was occupying around 270 degrees. So we used a scoring balloon and created fractures and placed a long drug-eluting stent from proximal circumflux into obtuse margin. So what are the predictors of lesion preparation with scoring balloon? We have an OCT data that shows that if you have a larger degree of calcification and lower the minimum thickness of calcium, then that may crack. In this particular study, the calcium thickness of less than 565 microns on OCT predicted successful lesion preparation with the scoring balloon. So if you have a more circumferential calcium and a thin calcium, then that may predict the successful preparation with a scoring balloon. So this is another case, 58-year-old gentleman, 2 long drug-eluting stents in 2012. There's a critical calcified neotherosclerosis, acute STEMI. Here we used another modified balloon, that's a cutting balloon. So 3 millimeter cutting balloon was used to create controlled dissections. You can see the dissections in OCT run. And then we applied a similar sirolimus coating balloon with the good results. So cutting balloon is another form of modified balloon. It's a non-compliant balloon where about 3 to 4 microsurgical blades are arranged longitudinally. And when the balloon is inflated, the blades will get into the plaque and provide focused force and create stress opposite to the plaque and create dissections. And the cutting height is around 127 micrometer, and there is no chance of perforation because this will not perforate into the plaque. In a bench-side model, you can see that the Wolverine cutting balloon, the pressure needed to crack the calcified tube was lower when compared to the non-compliant balloon of the same vendor. And most importantly, on the slide on the right, as the length of the calcified tube increases, the efficacy of non-compliant balloon comes down drastically, while the efficacy of a Wolverine cutting balloon is retained, meaning that if you have diffuse, long calcified lesions, the efficacy of non-compliant balloon is questionable, and the cutting balloon efficacy is retained. So in a clinical trial, a strategy of cutting balloon angioplasty followed by bare metal stenting, when compared to balloon angioplasty with bare metal stenting, all the QCA and IVUS parameters were favoring a strategy of cutting balloon angioplasty followed by bare metal stenting. And in intravascular ultrasound subset, you can see that the restenosis rate was lower when you routinely prepare a calcified lesion with cutting balloon when compared to routine balloon angioplasty. So the major drawbacks of these devices are that the poor deliverability, especially these are high-profile devices. So to maneuver across the tortuous lesions is very difficult. And if you have a very calcified lesions, all the drawbacks of a balloon dilatation will be there for scoring balloon, like plaque shift, abrupt closures, and dissections involving side branch. So how to improve the deliverability? This is another case. This is a highly tortuous RCA calcified lesion. The target lesion was in the distal RCA. Here we had to use a patient presented with acute STEMI, so we had to use a aggressive guide like Amplats and delivered the imaging catheter with a guide catheter extension. Then subsequently delivered a 3 mm angiosculpt, pre-dilated, then placed 3 long drug-eluting stents with good results. So that's one method by which you can improve the deliverability of these high-profile devices using aggressive guides and guide catheter extensions. This is very important because you have a data from PREPARE calc trial where a strategy of rotablation was compared to modified balloon in heavily calcified lesions. And if you see, the primary endpoint was strategy success, that is successful delivery of device and achievement of angiographic stenosis less than 30% was favoring rotablation. But when you see the slide on the right side, that is co-primary endpoint at the end of 9 months, the late loss was comparable. That means if you can deliver the modified balloon to a lesion and successfully dilate it, then the results are equivalent to rotablation. And if you see the OCT substudy, all the stent parameters, stent asymmetry, stent expansion, eccentricity, number of cracks, everything was equal to rotablation, meaning that if you are able to deliver the device successfully to the lesion, and then if you can dilate it, then the results are almost the same. This is a long segment lesion in the proximal to mid LAD involving a large diagonal. So here we performed intravascular ultrasound pullback from the main branch. You can see that side branch that is coming from 12 o'clock position, the ostium is heavily calcified. And also the main branch, there is a concentric calcium. The lesion preparation in the main branch is very crucial because if you use balloon dilatation, then all the drawbacks of a non-compliant balloon dilatation exist for modified balloon as well, like lesion, like plaque shift, abrupt closure, dissections, everything can happen. So in this case, we had to resort to ablative strategy in the main branch, then prepare it, the side branch with a scoring balloon, and then subsequently place 2 long drug-eluting stents. So this is very important, the strategy of preparing main branch in a calcified bifurcation. We have data from PREPARE calc sub-analysis that a strategy of rotablation was superior to balloon preparation in main branch if you encounter a calcified bifurcation lesion. So this is another case, 55-year-old gentleman, CKD, end-stage renal stage 3. We had heavily calcified lesion in the proximal LAD. We couldn't deliver any device, so we had to rotablate it, then deliver the imaging catheter that showed concentric calcium. So here then we had to further prepare it with the angiosculpt balloon and create dissection and placed a long drug-eluting stent and pot with 3.5 balloon with good results. So another strategy is that we do not view this as a competitive strategy. We can use it as complementary, like through ablative strategies with modified balloon. We can PREPARE calc combo trial that actually compared rotablation with cutting balloon and compared it with the historical cohort of PREPARE calc and showed that the minimal stent area and acute luminal gain was better if you combine rotablation followed by cutting or scoring balloon when compared to either of this strategy alone. And in another study, the OCT sub-study that showed that the presence of fractures, minimum stent areas, minimum stent expansion, everything was better when you routinely prepare a lesion after rotablation with cutting balloon as compared to routine preparation with a conventional balloon. But in a prospective trial, that is ROTACUT trial, which was published recently, which has compared a strategy of a routine cutting balloon angioplasty versus non-compliant balloon angioplasty after rotablation in all cases. There was no difference in the minimal stent areas, and OCT also showed no difference. That means that in a broad group of patients, there may not be benefit, but if you rotablate it, and then if you have a significant residual calcium, long segment calcium, thick calcium, then a strategy of cutting balloon or modified balloon angioplasty may work. Another tool in the armamentarium is the super high pressure balloon. This is primarily used in expansion of under-deployed stent. And we have data that when compared to a scoring balloon, the diameter of stenosis and minimal stent diameter post was better with the super high pressure balloon when compared to scoring balloon, although OCT parameters are no different. This is a 60-year-old gentleman, acute anterior stillation of eye. LAD was totally occluded. We tried to open up the vessel, but the lesion was not yielding even with OPN balloon at 35 atmospheres. So in this, at this point, we performed an intravascular ultrasound catheter. Ultrasound catheter was delivered with the help of a guide catheter extension. You can see that there's an arc of calcium that is primarily towards adventitious, indicative of deep calcium. So if you have deep calcium, then most of the atheroablation strategies may not work. So in this case, we had to use the relatively newer device that is intravascular lithotripsy. So we had to deliver it and deliver 50 pulses, then subsequently prepare the lesion and placed 2 long drug-eluting stents with good results. So intravascular lithotripsy is a semi-compliant balloon. We have spark gap emitters with the balloon filled with saline and contrast. And when the emitters are delivered, it will create vapor bubbles that will hit the calcium at around 50 atmospheres, while the soft tissue deflects away and create longitudinal and circumferential fractures, as indicated in these micro CT images. And we have data from 4 large randomized single-arm studies, from DISRUPT studies, which has looked into all groups of calcified lesions extending from 2.5 to 4 mm in diameter and length up to 40 millimeters. And it has shown that immediately post-procedurally, the luminal gain is much better for intravascular lithotripsy with a very low incidence of angiographic complications. And in an OCT substudy, it showed that the minimum calcium mark, which is needed to demonstrate fractures with intravascular lithotripsy, is at least 2 quadrants. But most important data is that the stent expansion, minimal stent area, and area of stenosis is not dependent upon whether you demonstrate fractures or not. So this is another case, 60-year-old gentleman, acute inferior acetylation of eye. We opened up the vessel, long segment lesion, operated, placed a long drug-eluting stent from RCA into posterolateral branch. But when we tried to deploy the proximal stent, the stent was not expanding. There was a significant residual lesion. Tried to open up with a non-compliant OPN balloon, it was not expanding, and intravascular ultrasound showed there's a concentric calcium behind the stent, which is preventing the successful expansion. So at this point, we had to use intravascular lithotripsy, which is a very useful device at this point. We had to make sure that the emitters are at the site where there is significant calcium, delivered 70 pulses, prepared with the non-compliant balloon 22 atmospheres, and that was the result which is obtained. So intravascular lithotripsy is not approved, or there is no packet insert for indication of our use in after the deployment of stent, but this is a very important, useful indication for intravascular lithotripsy in an under-deployed stent. So let me end my talk with this take-home figure. So if you have a fluoroscopic calcium, and if the imaging catheter is not crossable, then obviously you have to create a channel to get your devices in. So an atheroablation strategy may be preferable. But once you cross it, then all the decisions or choice of a device should be based on imaging. And if you have a superficial calcium, that is calcium more towards the intima, then you can use scoring balloons, cutting balloons, and intravascular lithotripsies. But even if you have deep calcium, most of your atheroablation strategies may not be effective, and if you need intravascular lithotripsy to modify the lesion. And if you have calcified neothelioma, cutting balloon may be a first choice because it helps to anchor the balloon into the plaque. And if you have calcium behind the stent, intravascular lithotripsy is very useful. But in some cases, you can get away with OPN balloon. And if you have a nodular calcium, then probably an atheroablation strategy may be better. Thank you for the patient here, and I'm happy to answer any questions.
Surgeon, the last case you showed, no, underexpanded stent because of the calcium. So you could have used even, have you tried the OPN balloon prior to the IVL use?
Yeah, actually, the IVL was used in a second sitting. The first procedure, actually, we tried the non-compliant balloon, OPN balloon, but that was not expanding even at 45 atmosphere. That's recommended RBP, it was not expanding. So So then we had to bail out, then take the patient back on the
So a stage
date. So it's a stage procedure because IVL is not available on ad hoc basis in our lab.
Sure, I know that. So practically for the youngsters, the practical issue is the entry profile of the different strategy balloons. So the lowermost will be our high pressure NC balloon, then comes your scoring balloon, and again out of the cutting balloon, if you compare the older generation Flextome versus Wolverine, the entry profile of the newer Wolverine will be softer, and the mid shaft will be little bit flexible, and probably in 0.017 when compared to 2.1 of the Flextome. So the Wolverine has changed, the entry profile is easy to use, and it even lesser size when compared to the Flextome. So even you can theoretically use in the 5 French instead of 6 French. And then of course IVL and all that.
Sarjan, it was a very informative talk. We all know that when we want to use a balloon-based strategy, the best option would be an IVL, but then the cost is prohibitively expensive, so we need to resort to other options like the cutting balloon, the scoring balloons, or even the new one from the Nipro, the NSC Aperta, which you can go even up to 24 atmospheres. Now, how do you decide on when would you select a scoring balloon over a cutting balloon? Because now we have the Wolverine, the trackability used to be bad with cutting balloons in the past. Now, because we have Wolverine available now, it's as good as the scoring balloon. So how would you decide on what would be the balloon of choice? Now, I would rate the super high pressure balloon, Opian balloon, as something very similar to the IVL balloons, because there had been situations with us wherein you showed a case scenario wherein the Opian couldn't open it up, but then the IVL was helpful in that particular situation. We've had situations wherein 80 pulses were delivered at a particular site. Ostial RC were not able to open it up, but then ultimately with the Opian balloon, 4mm Opian balloon, we were able to open it up. So how would you select between these two options, and how would you select between the other three options, like the cutting, scoring, and the NSC Aperta, the new one that's available?
Actually, if you see the balloon profile and balloon architecture, it's all familiar with the operator familiarity. For example, if you are familiar with the scoring balloon, that scoring balloon works. And cutting balloon works. The one situation where the cutting balloon has distinct advantage over scoring balloon is neotherosclerosis, especially instant stenosis, because the balloon slippage is the main issue here. So if you have a cutting balloon, then cutting balloon help to anchor the balloon there and help to deliver the force in a more focused way. But other lesions, de novo lesions, I think it's primarily your operator familiarity and handling of the devices that matters. I don't think we don't have much evidence or to choose between scoring balloon versus cutting balloon in de novo lesions. But of course, if you have a superficial calcium, all these will work. But in the case which I have shown, there is a deep calcium. So deep calcium, where the calcium is primarily towards the adventitia, and if you have, it occupies more than 2 quadrants, then most of the ablative strategies like cutting balloon, scoring balloon may not reach there, and the stent may not expand. In such a case, IVL has the maximum efficacy in such cases. So coming to answering to the point, I don't think, personally, I don't find any difference between cutting balloon and scoring balloon in de novo lesions unless the operator is, it all depends upon your operator and center experience.
Very nice lecture. Just one small comment, as you ended up saying, there is a difference. The cutting balloon, I think, is a shade, it cuts into the fibrous tissue at least. And one thing I just want to pass on, the size of cutting balloon, what Boston Scientific says, they say the pressure is nominal 6, 7, 8. I used to do 6, 7 years back, I learned from Dr. Antonio, take cutting balloon 0.25 less or 0.5 less and go to the burst pressure. By that way, the chances of perforation are less, because if you take the same size and go to the burst pressure, the perforations can be there. You said no perforation. It can be there if you go on the high side. If you go at 6, 7, 8, the blades will not cut into. It will be a wastage. You do OCT, the cuts are not there. So take 0.25 or 0.5 less and go to the burst pressure. Nothing will happen. And it will cut deep into the fibrous tissue and results will be very good.
That's exactly the practical point is a 4 mm blade, and if you are making 0.25 mm less than that is the vessel. So even if it is made the burst pressure, it won't go beyond the vessel size. And one thing I just want to add, the scoring balloon versus cutting balloon. The cutting balloon, this is not controlled dissection, but whereas the scoring depends on. Sometimes scoring balloon may be circumferential round, so it's a little bit controlled than the your cutting balloon. And if you have issue with the distal most lesion, the calcific and no other things are going distally, then you can put 2 or 3 wires and put a balloon, so that will make a modified scoring like feel. So it's a distal most lesion, you can try that also. Simple, practical and less costly when compared to your scoring or cutting balloon. And thank you, we'll go to the Deepak talk. Deepak, again, the ablative strategy, and they will come more on that.
Good morning to all of you. First of all, let me take this opportunity to thank each and everyone joining us here today morning. Over the next 15 minutes, I shall share with you something on ablative strategies in heavily calcified lesion. Well, when we have a heavily calcified lesion, we always need an ablation strategy as well as a fracturing or a balloon-based strategy. Well, I'll start with the case history of a 78-year-old gentleman who had an involved myocardial infarction, who underwent a primary angioplasty at a different place. They were not able to get the balloon across. However, TB3 flow was achieved and was referred to us for further for management of this calcified right coronary artery. Here we know that it's a heavily calcified right coronary artery. We started the procedure through the femoral approach. How do we manage this particular heavily calcified coronary artery? Now, when you have heavy calcification, you always need an ablation strategy. You also need a cracking strategy. Ablation strategy, it helps in volume reduction of the calcium over there, and the cracking strategy is a balloon-based strategy that will help us to make cracks inside the calcified lesion so that we can have a better expansion of the stents as well as the balloon. So regarding ablation strategy, it's mostly rota, orbital atherectomy and laser. When it comes to the cracking facilities, it's the cutting balloon, the scoring balloon, OP and IVL, and the new NSC Apata. So this is how it would look like. So when you have a heavily calcified lesion, you would always want to have a volume reduction. The volume reduction could be achieved with the help of rota, orbital atherectomy, or laser. That's how you would want, when you have heavily calcified lesion, you would want to ablate that particular area before you put in a balloon, so that you reduce the volume, the balloon will work in a much better way. Then followed by cracking with balloon-based strategy would help us to achieve a proper balloon expansion and a proper stent placement. So these are the options that we have in managing a heavily calcified lesion. Probably you have the ablation techniques, that's the rotablation, orbital atherectomy, and the excimer laser, and the balloon-based strategy, what has been described by Dr. Sarjan at this point of time. Well, coming back to our patient, we started the procedure through the femoral approach, 7 French guide catheter. We wired the lesion. Then went ahead with an 1.5 millimeter bar at 180,000 RPM. At 200,000 RPM, we were able to open it up, because you could see that, if you carefully watch, you can see that it's more of intimal calcification. Even looking at the fluoroscope, you can identify that it's hugging on to the burr, so it's more of intimal calcification as well as more of adventitial calcification based on this particular imaging. So once we are done with the rotablation 1.5 millimeter burr, we did an evaluation with the OCT. You could see that there were areas of thin calcification. There were area of 200 microns calcification. You can see that there were areas of thick calcification, almost 1 millimeter in thickness. You can also see that particular area, it has been polished over there. So with the rotablator, you can see that particular area, the calcification had been polished over there. Then you can also see that there were calcified nodules over there. And you can also see eruptive nodules. Those are the eruptive nodules. So we understood that point of time that ablation was not enough in this particular situation, because we have done very less to the calcification over there. So we went ahead with a 2 millimeter burr at 160,000 RPM. We were able to do further more burring. It took another 3 runs to get across the lesion. And so we understood that we were able to do some more volume reduction at that point of time. And then finally, we did a repeat OCT run. You could see here that after the 1.5 millimeter bar, that's a sort of ablation that we could achieve. But then with 2 millimeter bar, you can see that there is some more volume reduction that has happened. Here again, if you look at this chunk of calcification sitting there, after 1.5 millimeter rotablation, we were not able to remove significant amount of calcification. But then in this particular image, you can see that with the 2 millimeter bar, you have removed more chunk of calcification, and that is what you can see over there following 2 millimeter ablation with the rotablator. Then we went ahead with the non-compliant balloon, cutting balloons, 4 millimeter stent deployment. Despite that, we made out that there was significant amount of malapposition and expansion, and you could see that that was a nodule there which is compressed over there, and on either side the stent is not well apposed, but then the malapposition is not very significant, and you can also see here that in this particular area where the volume reduction had happened, where the calcium has been polished, you could see that the stent is very well opposed over there. So it just goes to say that when you have a heavily calcified lesion, you need to have a proper ablation strategy followed by the balloon-based strategy so that you can have a much better expansion and better apposition with proper apposition and expansion of the stent. So finally we went ahead with the 4.5 millimeter non-compliant balloon, and that was the sort of result that we could achieve in this particular patient. Well, this was another patient, 60-year-old chap who presented with effort angina. You can see that almost all his vessels were normal except that there was a left main bifurcation stenosis, which can be appreciated. In the cranial view also, you can see the chunk of calcium sitting there at the bifurcation. So we went ahead with a ablation strategy followed by the balloon-based strategy. In this particular situation, we decided on an imaging-based PCA. You can see the amount of calcification in this particular image, the bifurcation calcium extending into LAD as well as the left circumflex artery. We started off with imaging from the left main to LAD. You can see that there is, now I'll come to the images. You can see here that these are the nodules there. You can see a nodule at 6 o'clock position. You can also see a nodule at the 3 o'clock position. So in this frozen image, you can see the nodule over 3 o'clock position as well as 6 o'clock position. And also we looked at the bifurcation mode. In the bifurcation mode, you can see that the circumflex ostium, it's almost a slit-like opening, and on either sides of the circumflex ostium, you are able to see the nodules there in that particular area. You can I hope you can see appreciate the nodules on this side as well as on either side of the circumflex. We started with ablation into the LAD as well as into the LCX. Getting the rotablator into the LCX was difficult. You could see that the guide was backing out, and finally we were able to get into the circumflex at higher RPMs. And once we are done with that, you could see that the flow was good in both the vessels. Now we again came back to OCT. We did an OCT evaluation. Now in this particular, this was a pre rotablation OCT. You can see that there is a nodule over here. The wire is actually touching onto that nodule. That's the wire going into LAD. So we hope that the rotablation should help at this particular area. Then we wired the circumflex and did rotablation there, which made us to ablate the nodule over the circumflex mouth also. Now you look at the second image here, you can see that following rotablation, you can see that that's the particular area the burr had gone through. You can see in a furrow over there. And then if you look at the circumflex ostium compared to the first image, you can see that the circumflex mouth is also much bigger following the rotablation, which means that the ablative strategy was helpful. And then we went ahead with an angiosculpt, and following a DK crush strategy, that was the sort of result that we could achieve. OCT wise, it was looking good, the MLAs were good, and that was the final luminal areas. Now, when do we decide on orbital atherectomy? When you have a heavy calcification, which is not very extensive, and when you have nodules, these are the situations where orbital atherectomy would help us. This was another patient with effort angina, creatinine myelin on the higher side. You can see that there is a left main bifurcation stenosis, and it was a calcific stenosis. That was a guide catheter image. In the second image, you can appreciate the amount of calcification, the bifurcation, which was extending into the left antedescending artery, as well as the circumflex artery. We did an OCT imaging right at the beginning, and you can see that this is the circumflex ostium there, and you can see that nodule there. That's a chunk of calcification at the bifurcation, which can be better appreciated in the 3D image. You can see the circumflex ostium, and you can see the nodule at that particular area. And you can again appreciate in this particular image, this is the circumflex, and that's the nodule sitting there at the ostium of the circumflex. So the nodule at the ostium of the circumflex, that was the measurement more than 1 millimeter. We went ahead with orbital atherectomy at low speeds as well as high speeds, 80,000 and 120,000 RPMs, and into the LAD as well as into the circumflex. And subsequently again we did an OCT evaluation. You could see here that the left main pre-orbital atherectomy, the minimal luminal area was less than 2. Following orbital atherectomy, it was 3.3. When you look at the circumflex ostial nodule, this was the nodule that was present to start with, and following the ablation, you can see that the nodule has been ablated. And when you again look at the LAD, that was a nodule sitting there. You can see that that's been sanded away. That was the area polished out, and you can see that there is significant amount of volume reduction at that particular area. And these are the pre and post ablation, orbital atherectomy images at the bifurcation. That's the nodule seen there, and that has been the imaging following the orbital atherectomy. You can see that the nodule has been shaved off. Again, we went ahead with a balloon-based strategy. Angiosculpt was used. You can see the crack that has been formed. The crack has been formed exactly at the area where the volume reduction has been achieved. So that was the area where you could see the calcification at 4 o'clock position, and finally went ahead with DK crush technique, and that was the final result that we could achieve. Now coming to laser, when do we decide on laser at the ablation strategy? When we have lesions which are uncrossable and under-expanded stents. Those are situations where laser is going to be helpful for us. This is a patient who had twice stenting to the right coronary artery, multiple stents in the right coronary artery, 2 stents overlapping over there. Still, you could see that this particular area, it's an under-expanded stent there. And then that was the lesion with which he presented. He presented with a acute coronary syndrome. If you look at these images, you can see that this particular area, it's under-expanded. Exactly, that's the area where you have the restenosis. So we decided that not to go ahead with another stent over there. We decided that we should settle down with a balloon, a drug-eluting balloon. So we started lacing. So that was 1.4 laser. Now, okay, so prior to lacing, we also did an OCT run. You could see that there is significant calcification inside the stented segment. Outside the stent, also significant amount of calcification was seen. We went ahead with lacing. That was we laced with the 0.9, 1.4 laser catheter, as well as we laced also with the contrast lacing was done. Finally, balloon dilatation was done, and that was the final result that we could achieve following the drug-eluting balloon. We were happy with that. You could see that this was the pre-procedure under-expanded stent. That was a post-procedure opened up stent, and this was the final result. Minimal luminal area was only 5.4, but then we were happy with that particular luminal area. Now, this is another patient who had an angioplasty 1 year ago to the proximal left anterior descending artery, not to the ostium of the LAD. It was done in North India. Exactly 1 year later, he presented with effort angina. He had a new lesion in the proximal left anterior descending artery. At a different center, they tried to open it up. The balloons could not open up this particular lesion at the ostium of the LAD, and so he was referred to us with the sheath in the radial artery. So we decided to have the procedure done through the radial artery itself. That's again a 7 French guide catheter through the radial artery. The vessel was open. We tried to get across to see what exactly was the lesion there, because it was just 1 year following the first procedure. We did not expect heavy calcification over there. We tried to get the OCT catheter across, but then the OCT catheter wouldn't cross that particular lesion. So we went ahead with lacing. Again, that was 0.9 millimeter catheter, then 1.5 millimeter catheter, and then you can see that we were doing the contrast lacing. Once we did the contrast lacing, we were able to get across. With contrast lacing, you could achieve a better luminal gain. And then these were the images following the contrast lacing. You can appreciate in these two caudal images, the tight stenosis, you can see that the luminal gain is good. And again, in the cranial image also, you can see the tight stenosis, the luminal gain following lacing is good. So ablation has been achieved with lacing also in this particular situation. And that was the luminal area that we could achieve following lacing with contrast 3.28 millimeters square. That was a OCT run immediately following the lacing. Then we were also able to make out that there was a significant amount of eruptive nodules over there. And also you can see that there is a nodular protrusion there. So multiple calcified areas were seen. So we went ahead with a Wolverine, but then we were not able to open it up at high pressures, 18-20 atmospheres. Then we went ahead with an IVL. That was the IVL balloon being used. That was a 3.5 millimeter IVL balloon. Following IVL, you could see that there were multiple areas of fractures. Those are the fractures seen following the IVL. Finally went ahead with stenting, and that's the pot balloon. That's a new pot balloon that is 4.5 millimeter. You marketed by the Viva. You do not have a significant overhang of the balloon on either sides of the markers. So that was a pot balloon used for final dilatation, and that is what we could achieve at the end of the day. So lacing was helpful in this particular situation. If we didn't have lacing in our center, probably at that point of time, we would have resorted to a rotablation. Probably we'll start with an 1.5 millimeter, but then an 1.75, and then go ahead with a balloon-based strategy. Well, that was the final result that we could achieve in this particular patient. This is another patient who had an anomalous RCA failed angioplasty to the right coronary artery. You can see in the second image that the lesion was not looking very bad. We expected that we would be able to wire it very easily, but then a Fielder FC wire would not cross that particular lesion. We had to work for a while so that we were able to get a Fielder XT wire across that particular lesion. The guide backup support was very bad. We were not able to, we want to exchange it for a rotafloppy, but we were not able to get a catheter across, a micro catheter across that particular lesion. Even we tried with a guide extensional catheter, we were not again able to get it across. So finally we decided on laser. That was just a 0.9 millimeter laser catheter. It easily went across that particular lesion. Once the laser catheter went across the lesion, we were able to get a microcatheter across. Then we were able to get the rotafloppy across. Finally, with the help of Guide Plus catheter, that's the Guide Plus catheter, we could reach near the lesion, and then we were able to deliver a long stent, and that was the final result. So dear friends, when we have heavily calcified lesion, it's always good to have a combination of ablation strategy as well as a balloon-based strategy. When do we decide on rotablation? We decide on rotablation because it's a cheaper option. It's you could when you have a long lesion, heavily calcified lesion, very critical lesion, very intimate lesion, those situations you would achieve a better result with rotablation. It's cheaper, faster, effective, and you tend to feel good when you have a long lesion that the rota goes across. When we decide on orbital atherectomy, usually in large vessel, nodules, not so extensive disease, and in extensive disease we wouldn't try to use orbital atherectomy because it's going to be very time consuming. And finally, laser's got niche indications when it's an undilatable or an uncrossable lesion. Thank you so much for your patience here.
Deepak, fantastic cases and the results. Regarding the third case, that was you used the LMC and daughter vessel calcification, used the orbital atherectomy,
yes,
than the rotablator. Just want to make more concentration on the left main lesion than the daughter vessel, right?
Yes.
Because there is an ostial circumflex nodular lesion is there. So if you comparing the rotablator versus orbital atherectomy, is an edge for rotablator?
No, we decided on orbital atherectomy for few reasons. One, it's a left main. Probably we thought that at higher RPMs, we'll have a better luminal gain with the orbital atherectomy compared to rotablator. If we were to use a rotablator, probably we'll have to use an 1.752 over there. Then we all obviously wanted to do something for the circumflex ostium because there was nodule there, the circumflex ostium. So if we were to use again a rotablator, we'll have to change the burr into LAD 1.5. You start with 1.5, then 1.75, then again remove the burr, go into the circumflex, again go change the burr to 1. It's going to be a very time-consuming, tedious procedure. So in absence of orbital atherectomy, certainly we would have gone ahead with rotablator, but because this was more simpler. Secondly, it was not so extensive calcification, because we know that we wouldn't take a lot of time.
There is a clue that angiographically, if the calcification is not moving with your cardiac cycle, it is not extensive. If it is not moving, not moving with a still image, that's a deeper calcification. So the indirect clue is there. And again, if you are using orbital atherectomy in a ostial circumflexion, then there will be damage for the left main. So the left main also calcifies, so that will protect. So the beautiful choice of that lesion is orbital atherectomy. Regarding the final, last part one, that was laser on the underwent the angioplasty in North India, and you did the procedure.
Yes.
So what was the duration? The first procedure and
it was just 1 year. We went through their CD also. The final result was good, except that the ostium of the LAD, they had deliberately stented the LAD without stenting the ostium. In the ostial lesion was there hardly 30%. Lesion within 1 year. We saw so much of eruptive nodules. Probably Vijay Kumar around should help us to make us understand.
Actually, those times the stent might have taken longer time to push the stent through the tighter lesion. So it is unusual.
Deepak, in the last case, you used a laser followed by a rotational atherectomy. What is the reason for that?
So the laser was just to get across the lesion.
But when you
We
have
were
a
not
laser,
able to get the microcatheter across the lesion. That was the reason to get the microcatheter across, exchange with the rotafloppy, and then went ahead
no,
with
but
the
once you have a laser, couldn't you have done a balloon? Was a rotor really needed after
So
a laser?
we didn't actually do imaging for that particular case. That was the reason we wanted to. It was a failed angioplasty at another center, so it was. We initially itself started off thinking that we are going with a rotablator, but then because of backup support, which was bad, we were not able to get the
Agree.
microcatheter.
My question is, if you use a laser, do you still have to use a rotor, or would balloon after a laser be enough?
So the imaging would have given us a better picture. We had opened the rota bar. We were ready with doing that, but because the microcatheter didn't go through, we went ahead with a laser and then did a rotablade.
Excellent cases, Dr. Deepak. The same question is another way. You had two left mains. Both of them had calcium nodules. Why rota in one case and the orbital in second? I mean, because availability or different reasons?
Yes, sir. So one was in the pre-orbital era. That was 2 years ago. The
Okay. Otherwise, you would like to go for the orbital.
orbital, because it was nodule right at the ostium, the
Absolutely,
circumflex on
absolutely.
either
So cutting was
sides.
much better.
Either sides.
Can you tell us for the crowd typical indications for laser?
So
Typical indications for
these are the
laser.
two indications when we have a significantly underexpanded stent, the stent not opened up. The one that was shown by Dr. Sajan, wherein they used a IVL to open it up. So that would be one indication for a laser, and second one would be an uncrossable lesion, like what Sharath had shown in the morning. A CTO, he was not able to.
People are using for acute MI and ACS. They say there is no reflow after that.
Yes, sir. We've
Absolutely no
been
reflow.
we've been using that for acute MI in huge clot burden,
Huge
sir.
clot burden.
Huge clot burden. Thank you so much.
Thank you, Deepak, for the enlightening talk and cases. And we'll move to the third challenging case by Dr. Karthik Vasudevan. Yes.
Hello, thank you Deepak and Rajshekhar Verma for giving me an opportunity to come here and present this case. So I'll be presenting a case of rotatripsy in a complex calcified CTO LAD LMC crossover, stenting under OCT guidance. So my patient was an 80-year-old gentleman admitted with peripheral vascular disease under vascular surgeon. He underwent tibial angioplasty and was transferred to the floor. 2 days later, he sustained an NSTEMI, developed chest pain, had troponin leak. ECG showed some T inversions in the anterior leads. So we took him for an angiogram. And the angiogram showed a calcified LAD CTO. We can see the in this view, heavily calcified LAD distal left main, and it was a CTO filling retrogradely. And there was a mild disease in this first OM or AMS, whatever you call, and a type A lesion in the RCA. So in view of heavily calcified CTO left main, so advised CABG, CTVS consult was taken in view of his age and peripheral vascular disease and multiple comorbids. He was considered to be a high-risk candidate for CABG. Relatives were not too keen and they wanted to go ahead with the PCI. So what we planned was to cross the LAD CTO first, then do the rota, and we could see the calcium on the fluoroscope itself. There was heavily calcified lesion. The mid, I thought it will need a rota, and the ostium of the LAD and the distal left main, you could see the deep calcium there on the fluoroscope itself you had observed. So we thought IVL, we would keep the IVL backup and then decide after doing the imaging and then stent do a LAD LMCA crossover and PCA to the RCA. So this is a chip case. If you see the scoring, it scores about 8. Anything above 5 is a chip case. So our score was 8. So CTO was crossed. Initially I go with the went with a Fielder XT with a microcatheter. You can see that the wire is buckling. It was not able to cross and it was going into the false lumen here. It was not penetrating the distal cap. So I escalated to a stiffer wire, Conquest Pro 12, and I could redirect the wire and I could cross the CTO. So exchange that with a BMW wire. And rotafloppy couldn't go, so I just pre-dilated with a 1.5, and through the microcatheter I exchanged a rotafloppy wire. Then this is the 1.5 bar. So went with 1.5 bar and ablated the lesion, and especially the mid one. You can see that in the second frame it crosses, suddenly gives way and crosses. Did about 3 to 4 runs, and once that was done, I tried to put the OCT catheter in, but it wouldn't cross. Then I took a 3 millimeter balloon and pre-dilated the proximal part also, thinking that there may be something there which is holding on, and I could not cross. Even after 3 millimeter balloon, I could not cross the OCT catheter. So then what I thought is, because it was not going, I thought this will go ahead and do the IVL as planned before. Ideally, I would do the OCT, then decide on the ablative side, because I had done the rota. So I thought I'll do the OCT, but because the OCT didn't go, I thought I'll just go ahead with IVL. This is the 3.512 IVL at 4 atmosphere, 80 pulses to the proximal and the ostial LAD and the distal left main. So after that, my OCT went in, and you could see the cracks there. Nicely, it has given a lot of cracks. And you can see in the distal left main, it's almost 270 degree of calcium, thick calcium here. And that is there, you can see the cracks in the calcium. So after that, we went with a NC balloon, nicely prepared the bed, and I deployed 2 stents, 2.7538 distally and 3.533 proximally, and post-dilated with a 3.5 NC, proximally 2.75 distally, and port I did with a 4.8 NC to the distal left main. So after that, we did a OCT run, and you could see the distal, it was nicely opposed, no edge dissection. In the mid, there was some under expansion, and MSS were good in the proximal LAD and ostial and left main, almost like 12 in the left main. So I took a small balloon, 3.8, and went at high pressures in this part, the mid part of the LAD where there was under expansion. So, and after that, I didn't do a OCT run because this is an 80-year-old gentleman already. We had used a lot of contrast. So after this, we just took the final pictures. So that is the final picture. As you can see, the left main here, the circumflex is not affected, nicely flowing there, and is the LAD. And after that, RC was a routine stenting, just put a 322 onyx stent, completed the procedure. And so typically the approach would be, if a balloon crossability is there, then you do a pre-dilatation and do a imaging, either a OCT or IVUS. You look for 3 parameters: calcium arc more than 180, length of the calcium if it's more than 5, and the thickness of the calcium if it's more than 0.5 millimeter. If it's S, then it indicates it's a deep calcium. Then you go with lithotripsy balloon, IVL. And if you got a good expansion, then do the stenting and stent optimization. And if it's not a deep calcium, then you have to resort to rotational atherectomy, orbital atherectomy, or laser, as shown by Dr. Deepak very nicely. And then you get an optimal balloon expansion after this. Then you do stenting and optimization. If you don't get a good expansion, then again you have to resort to IVL. And if the parameters are not met in the imaging, then that is, the calcium is less than 180, or it's not very thick, it's more of superficial, then you can do it with non-compliant as cutting a scoring balloon, as Dr. Sarjan has showed. Then if you get a good expansion, then you do a stenting and stent optimization. Even after cutting and scoring balloon, you don't get a stent optimal expansion, then again you have to go to lithotripsy. And if the balloon is, you can't cross the balloon, then you straight away go to rotablation, orbital, or laser. So this is a complex case of calcified LAD CTO and distal calcified LMCA in an octogenarian. So management of calcium has changed with rotablation, orbital atherectomy, and laser, of course. And usage of IVL with rota is called rotatripsy. Image guidance has helped us during intervention, leading to better understanding the pathology of the lesion, choosing the right atherectomy device, and then also optimizing the result, what is called as a precision angioplasty. Thank you for your kind attention.
Thank you, Karthik, for the very nice case. Just a suggestion. So, have you tried with the rotablator in the proximal part?
Yeah, we did. No, proximal part we did through entire length. So what my plan was to avoid IVL, do the OCT and see whether if we've got a good cracks in the calcium, if it's not too deep, then we avoid the IVL, just do away with the NC balloon. But I couldn't get the catheter down. And on the imaging, you could see the angiography. It's quite thick calcium on the distal
So
left
what was
main.
the speed, the distal rotablation?
1600 to 1800.
So even though the popular belief, the ablation depends on the burr size for the rotablator and the speed for the orbital atherectomy, but still we can use it the higher speed with the 2 lakh unit rather than 1.6 or 1 lakh 60. So you can try with that and use the wire bias technique sometimes. So it may helpful and we can save even up to 2 lakh IVL sometimes. So the luminogram look relatively simple, but probably as you said, there will be the calcium nodal and little bit complex calcium. Anyway, nice result. I think.
Karthik, how do we manage to use IVL? We need to have 1:1 sized balloon, right? So you have a small vessel distally and at the osteo you have so did you use 2 balloons or?
No, I didn't use the IVL for the mid. It's only for the proximal LAD and distal left main. I chose 3.5 only for the proximal part. But anyway, mid I had ablated with rotablation. I didn't use it. I just used NC balloon. It cracked easily.
And again for the CTO segment, when you do the burring, you start with an 1.25 or?
1.5.
1.5 is not an issue.
Again, issue is such a CTO, if you are using the OCT, there will be some sort of hydrostatic dissection propagation.
Yeah.
Because then again,
Injecting
injecting and without standing the distally, so there's an issue. So practically, if you already opened the CTO distally with the rotablation and prior to that you have made a dissection and again you are using OCT, there will be some sort of hydrolytic dissection may propagate distally. So in that case, theoretically and financially, the IVUS has some better choice than the OCT.
No doubt about it. No, I thought about it, but because I wanted to see the depth of the calcium, calcium assessment somehow I feel, OCT is much better,
Thank you.
Very nicely done case. I wish we could have, after the rota, the basic purpose is for the rota is to make a place. After that, we should have under expanded place where we could have used the scoring at cutting balloon at the higher pressures. This under expansion probably would not have happened.
No, the problem was in the proximal part.
No, but
calcium in the proximal part.
Taken care of, but there is a still under expanded strand at the mid part.
Yeah.
That part has not been touched by the IVL. That has been the rota only.
Rota has done.
So rota has made a place. If we had taken a cutting balloon there and cut through the fibrous tissue partly on one side or the other, probably the things would have been better.
No, but it expanded. I used a NC balloon at 18 atmospheres, 820, 24.
Basically, the rotablation and orbital atherectomy, it will be shave off and it will not make much cracks.
Yeah.
So ultimately, your stent need an extra space in the media and slightly inner part of the adventitia. In that case, you had to have some sort of scoring or cutting balloon, even after with the modification by the rotablation or the orbital atherectomy.
No, when I used the NC balloon after that, it expanded.
Okay.
I didn't expect this much of under expansion.
And even after pre-treating with the orbital or rotablation, there will be some sort of thermal injury. So your even NC balloon will make wonders because the heat generated there that will easily expand that site.
So what is the pressures at which, just wanted to know from the senior operators here, what pressures do you go up to the maximum with a cutting or a scoring balloon? Wanted to know from everyone.
Wolverine, I have gone up to 18, 20 I go.
25 with which one? It's a scoring or a cutting balloon? Both 25 atmospheres.
No, but one thing, Deepak, word of caution.
Basically, the teaching module, the cutting balloon, you should not go with the, no, sir. The teaching module for the examination, you should not go more than 12 to 14. So because what happened, no, there actually it can be, actually it is semi-complete rather than NC. And it will grow. So the teaching point, it should not exceed more than 40. But see, no, sir.
No,
So to me, daily, routinely with the usual NC balloon, used to go to 24 or 28 in our own, the residents might be knowing us. But the teaching module, you should not go beyond the blood pressure and the cutting balloon.
One point there. See, the Wolverine is on a NC balloon.
Yeah.
So Wolverine
But
is NC balloon. It's so Wolverine you can go safely. there's no problem. But if you to use a angiosculpt, which is a semi-compliant balloon, no, it depends at what the pressure it cracks. If you're cracking at 12, 14, why you would want to go to high pressure? If it doesn't crack, only then you go to high pressure, right? So I've gone up to 18, 20 on the Wolverine, it cracked and we left it like that. Nothing happens.
Roni sir, your opinion on that? Oh, in an extreme case, okay, during your talk, okay. In an extreme case, what pressures would you go up? Routinely 14, 16, not more than 18. In an extreme case, can we go up to 25?
No, I'm not a fan of high pressure balloons. So I generally never go to more than 20 atmos unless we're using an ultra high pressure balloon. Even my usage of ultra high pressure balloon is on the lower side. So we generally prefer to go for an modification with an IVL, which I think is a little more clean and decent because I think these ultra high pressure balloons cause a lot of dissections. There have been instances when you have got proximal dissections going up to the left main, some perforations. So I know financially it makes sense to go with an ultra high pressure balloon. That's why it's always preferred earlier, but I think it should be moderated with the pressures that you use.
Mahesh sir, at 25 atmospheres, have you had ruptures with that? At 25 atmospheres?
No, the problem with an ultra high pressure balloon is that we use an ultra high pressure balloon only when the NC balloon doesn't crack at 20-25 atmospheres. So obviously you're going to take it to 40. Otherwise, why would you use an ultra high pressure balloon? Because it doesn't make economic sense. So an ultra high pressure balloon you'd always take to 40, and I think at 40 it does work. It does work, but I would prefer to use an IVL if I had the money.
No, Deepak, one more
The
thing
question,
is...
the question asked was, how much pressures you can go in a scoring balloon? The answer is, I have gone up to 25. Do I go for 25 for every case? No. If required only, you can go. You can safely go to 25. And I have not had any ruptures so far.
Dr. Madhu.
Yeah, Dr. Ronnie, I mean, you use an IVL, but IVL it goes up to 50. But you said you are scared of using an OPN to 40, but you're okay with IVL 50.
I think the mechanism for both are entirely different. So an IVL is not likely to cause a rupture, though the pressure generated within the balloon is 50, while an OPN is more likely to cause a rupture, which is what my personal experience is. So and the amount of proximal dissections that you can get with an OPN once it ruptures is horrendous. That's why, but I think OPN it makes a lot of economic sense.
Ultra high pressure, usually these high pressure balloons are NC balloons. So it is not like semi-compliant balloon. As you go in high, the balloon size won't go too much, but you get a higher pressure. So even when we dilate the OPN balloon, we feel that something might happen, but most of the time the chance of perforation is very less because the pressure generator is high, but the volume of the balloon is less, expansion is less.
And Dr. Werner's opinion on this, what pressures do you go the most?
I live in a country where we don't have so much money like you seem to have. So in my lab, I use rotablation and IVL. And that's it. And then regular NC. And with this, you can solve all the problems.
So to conclude for the younger generation or whatever our generation, how much pressure to go all depends on what is the inner pathology. So for that, imaging is most wanted. So Dr. Ronnie will be telling. But I can tell you that that's why the manufacture and the physics involved in the manufacturing of the balloon, engineering of the balloon is important. You can go very high pressure 40 and all with a 2-layer balloon, that is OPN balloon. Then comes your ultra high pressure balloon is there. And this depends on your inner side calcium, how much is asymmetrical or symmetrical, where the sharp edges are there. So it is very unpredictable. But mind you should not go more than RBP, the manufacturer's guide. So very high pressure selected cases. Otherwise, you can always go with the less than that rated base pressure. And you have all choice of like lithotripsy and rotablet, everything is there. So this all depends on different clinical characteristic and how the imaging tell you, balloon tell you should have the imaging technique to predict the balloon whether rupture or not. And then lastly, your own experience, you will be very confident and you will do all this. Otherwise, you have to be very careful, and also the location of the vessel. you should not be high pressure in your dislocation. The proximal, the vessel can withstand the pressure. For example, proximal LAD. Everything is embedded in the myocardium, so it can withstand the pressure. So, lot of characteristic and the pathology and the our clinical condition is important when you decide to how much pressure you go or not. And with this, we conclude the session. We conclude this
Thank you.
talk.
Thank
And
you,
thank
Ashok.
And we'll move to next. Okay, the keynote lecture, the severely calcified lesion, current state of the art by, sorry, the last one, those, okay. So now the imaging algorithm for the calcified coronary, Dr. Ronnie Matthew. So we'll enlighten more on that. I think all our doubts now, our discussion will be covered in this topic, talk, how image help to decide.
Yeah, right. Thank you, Dr. Ashraf, Dr. Deepak. At the outset, let me thank Dr. Anil and Dr. Verma and team CHIP Summit for inviting me and having such a wonderful meeting. It's really heartening that, we have this great meeting at our beautiful city of Kochi every year. And congratulations, and I hope you have it every year. Usual. Second. Okay, you take this up. Good. Connect it. So, my talk has been made very easy by this wonderful talk from Dr. Sarjan, Dr. Deepak, and this great case that was shown. So, I'm just going to summarize this. That's all. So, this is the problem we have with calcium. One is we have a failure to cross the lesion with devices. As you see on the left panel, the balloon was not going in despite hitching. And even if you cross the lesion, you'll land up with underexpansion. And that is the Achilles heel where MACE increases. Now, contrary to belief, calcium is common. If you look at the ADAPT-DES, about 30%. Look at the Syntex, about 50%. And this does cause increased MACE. In this data with about 66,000 patients, you see the TLR with a calcific lesion is 47%, stent thrombosis rates are pretty high. Now, if you look at angio, IVUS, and OCT in this good paper, calcium detected by angiography has very good specificity. But if you look, angio is not that sensitive, while IVUS and OCT has a sensitivity of about 80%, IVUS being the best. Now, both of them have two different principles of detection, as has been told very clearly. IVUS, by sound, highly sensitive, but the problem is it throws a shadow. While OCT, because of light, has an advantage that you can get the volume of calcium. And that is where we all are concerned with, because the moment you know the volume, you can decide if you need to do a ablative technology. In addition, it also tells you the type of calcium. Now, there is a scoring based on intravascular ultrasound, and that's basically based on the arc of calcium and the fact whether you have a calcific nodule and whether based on the size of the vessel. But to me, the calcium scoring by OCT probably is a little better, because here you take the thickness, you take the arc, and you take the length. And very simple, the rule of 5. If you've got a 0.5 mm thickness, you've got a 5 mm length, greater than 50% arc, you need to do some advanced preparation. Having said this, now what all our doctors have shown up so far, what is your goal of your therapy in a calcium lesion? One is to cross first. Second is to modify the lesion. And this, as Dr. Deepak has showed, you do it by volume reduction or by a fracture. The end is maximum lumen gain. And you have all the tools at your disposal that we talked about. Balloon-based strategy, the score, cut, ultra-high pressure. Non-balloon, we are now rota, orbital, IVL, and laser. So when do we use when? Now, if you're going to use imaging algorithm, and that's where it's very important to understand, your Optis catheter must cross, right? Otherwise, you can't do an imaging algorithm. Now, the Dragonfly profile is 041. That's roughly 1 millimeter. And the only thing that is near 1 millimeter is an IVL balloon. All the rest are less, but you must understand that you can therefore get an NC balloon that crosses, but you will still not get an imaging algorithm. So, for an imaging algorithm for calcium modification, I think the most important thing is the imaging catheter must cross. So that's the first part of my algorithm. So if your balloon doesn't cross, you have to use a rotablation or a laser, get it to cross, get the imaging catheter to cross to find out if you have a high score of calcium. Some fundamentals that you must remember. So as I said, if your Dragonfly catheter or your balloon doesn't cross, you got a rota or a laser. Now look at the other end. Your balloon crosses and you see that lesion does not yield. So at that point, you got a rotablator or an IVL to help you out. Now after rotablator, there have been cases shown where your lesion doesn't yield. At that time, you have an IVL. And the last, which we don't want, if your stent is put in and it does not yield, you got only an IVL or a laser to help you out. And generally, if your imaging catheter crosses, you can be sure that your IVL will cross. Now, this is a case in which the balloon did not cross. The 1.25 balloon doesn't cross, so you do a rota with a 1.25 burr. And as has been shown by Dr. Deepak, what you see are these cuts of rota. These shaved out area that tells you that the rota has cut into the depth of the calcium. And that is the ablative modification that you want. So you therefore decrease the thickness of calcium. And once you're able to decrease the thickness of calcium, you're able to crack it with a balloon and do it. Now, so therefore, the ablation that I showed you depends on A, wire bias, 2, the calcium distribution, and 3rd, the lumen dimensions. Look at this example. Same case. You got a large lumen here, but you got a calcium on that side. You use orbital, that orbital will cut that side of the calcium, though the vessel lumen is large. Same case, small lumen, orbital will cut all around. So, why did this cut? Because the wire was biased towards that calcium. So that's called wire bias. Now, if you put a 1.25 millimeter balloon, 1.25 or 1.5 rota in a lumen that is 2 millimeters, you are not going to cut calcium unless you get this wire bias. And that's very important. This wire bias cuts the calcium onto that. That's the importance of wire bias and the distribution of calcium and the lumen dimension in doing any form of atherectomy. Now, this is the indication for laser according to me. Now, this is a case in which, this is not my case. It's a case in which they have not been able to cross anything across this calcium. They used a guide support and they put a laser, and Dr. Matthew was able to cross that and ablate that. And once you're able to ablate this, now you take a rota and you create an adequate lumen and use an IVL or whatever depending on what your imaging shows. Now, this is one case where a 2 millimeter ultra high pressure balloon does not crosses, but does not yield. So at this point, even the IVL will not cross, because the balloon has got a smaller profile than the IVL profile. So what do you do under these circumstances? Again, you've got only a rotablation to go with. In these situations, you do a rota, and again, the same thing that I said. You will get a cut. If you use a 1.5 millimeter burr, you'll be able to get an exactly 1.5 millimeter lumen inside, because the burr has just cut the calcium. And if you see at this particular point, it has again shaved this. But unlike the previous case, you have a diameter of calcium that is still left. And this is where, as Dr. Karthik said, IVL is helpful. To break the remaining bulk of calcium, you need IVL to do a lithotripsy. And once you do a lithotripsy, as he has already shown, you see these good box patterns where the calcium is actually ruptured, and you will be able to increase your lumen size finally. Now, ultra high pressure. So this is what we have been discussing. It comes often at a price. Now look at this particular case. An OPN, after we burn, we send the OPN inside, and this caused a huge dissection that goes up. Luckily, it does cause calcium breaks exactly as you see in an IVL. But you see these huge dissections that luckily as he has stopped into the left main, that sometimes it can go right out, up the left main. So it's not that you should not be using an ultra high pressure, it should be used, but remember the caution that this can cause. So we come to the second part of the algorithm. So you've seen this high risk calcium. Now, if all these points are not there, I believe you can go with an NC scoring cutting balloon and ensure you got an optimal balloon expansion. If you have these high score calcium, go for a rotablator or an orbital, modify it, try to see if you get an optimal balloon expansion. Now, you may not get it as I showed you. If you have it, go stent it. If you don't have it, at this point, I believe you should use an IVL, and with an IVL, subsequently go in for a stent expansion. Calcific nodule. Now, this has already been discussed. Now, this calcific nodule, the problem with the nodule is it's eccentric. And unless you're a wire bias, as you said, you cannot cut it. But look at the IVL in this case. This particular calcific nodule has been cracked to a certain extent. You can see these cracks. You can modify it. But look at this particular nodular protrusion. It doesn't make a dent with IVL. Now, this is what should not happen to us, and that's why I call it image regret, or regret that you did not do an image. Now, this is, of course, a patient who has come with an acute coronary syndrome. He had an NSTMI anterior wall, he had an acute anterior wall MI. So you just want to get a TIMI-3 flow. So you go and immediately put in a stent, but then you got less than 50% expansion. And now, even your OPN does not cross. And it's understandable because in ACs, you generally will not go and do an IVL. Your aim is to just get a TIMI-3 flow. But then this is a 50% lesion. So you see, your MSA is only 1.7 millimeter at that point. Totally unacceptable. At this situation, you have only an IVL to bail you out. And if the IVL doesn't cross here, then you got only a laser to bail you out. So here, with an IVL, you can get some amount of disruption. You've increased the MSA to 7.2, which seems acceptable. Though the pictures are not very great, I think 7.2 is pretty good in a calcified lesion, and you come out. So that's the last part of the algorithm. In these special situations, you have an unexpanded stent, you go to an IVL. You have deep calcium, go to an IVL. Nodular calcium, I think the jury is still out whether you should be using an orbital or an IVL. I believe orbital should be good, but I think there are enough investigators all over the world who believe that IVL does help in nodular calcium. So to take you back to this algorithm, the first part is to ensure that your imaging catheter crosses. And once you image, depending on your scoring, if your scoring is high, I believe you should not be using IVL here, but you should be using a rota or an orbital, because economics decide on that. Try to get an optimal balloon expansion. Only if you do not get an optimal balloon expansion, go to an IVL. And of course, in an unexpanded stent, you have no choice but to go to an IVL. Thank you all for your kind attention. Thanks.
Great, cases and the discussion. I just want to ask the one slide showing that that orbital atherectomy with the wire bias. Am I understanding correct? The orbital atherectomy and the rotational atherectomy will behave similarly in a smaller vessels, because many of the time it may ablate. For larger vessel, there is no need of wire bias, because the image shows the eccentric calcium that case, and it will accommodate the whole space and the 360 degree the orbital atherectomy. So there is no need of any wire bias, just like rotablator for orbital atherectomy.
No, yeah. There is a point in which you make that if you have a wire bias in a rotablation, it will cut more easily. But if you do not have a wire bias still in a large vessel, in an orbital, you will not get a shape unless there is nodular protrusion inside. If you have a nodular, that's why in a calcific nodule where you have a protrusion inside, orbital really works and shaves it off in a large vessel.
So
But in a vessel that is not large, that is large
then you
with
can
no
use-
protrusion,
You can increase the speed, then it can make it rather than.
I'm
so-
not. I don't know an experience in
just
that. I'm not
asking,
too sure.
asking, right.
No, it's according to me, it's not possible because unless you have a nodular protrusion, you will not be able to get a.
We can make it, wire bias along with, we can increase the speed.
To 120?
120, then it may have some. And the second case, there was a IMH, and there was many of the IMH, what on the proximal lady balloon burst, and invariably it will affect the L6 ostium. So is there any issue with that case?
Yes, we did check for that, but luckily we were very lucky that it
Lucky.
did not.
No,
it
nothing
did
happened.
not
Okay.
affect the L6 ostium.
Dr. Mahesh.
Just a fabulous presentation as usual. I just want to say one point that we had presented 21 patients with 54 calcified nodules, all treated with IVL. We had 95% success and excellent results overall. This paper was accepted in the TCT and presented in the TCT this time. So IVL is a very good modality for calcified nodule, contrary to the belief that it may not work. Only thing that you may have to use all your 80 pulses in one spot with slight movement up and down so that it doesn't overheat and perforate.
Yeah, Mahesh, entirely agree with you because this has been shown by even Dr. Ziad Ali in his talk that when you do this surge at the site of the calcific nodule, they are able to get this. For eccentric calciums, he showed a large number of cases. I think they also presented there. And that's why I said, I think IVL does work. But, probably, you got to give a space to orbital also.
See, in the calcium nodule, it doesn't, if it doesn't cuts off the IVL, it doesn't cut off the nodule, it breaks the bases, minor fractures, and when you put a stent or a balloon, it is pushed to one side. That's
No.
what their mechanism remains.
Yes, see, I think it's more complicated than this. There should be a talk on that. There is nodular calcification and there is calcific nodule. These two are entirely two different animals. What you're talking is a calcific nodule. A calcific nodule is basically made up of calcium fragments which can be pushed. A nodular calcium cannot be pushed. A nodular calcium can be ablated. The results long term are very good. While a calcific nodule is fractured calcium lying inside. And I think Dr. Ashok Seth will also be able to tell us about this because he has done the shockwave registry. There are two different animals behaving entirely two different ways, having two different methods of treatment and two different MACE rates.
Thank you, Dr. Ronnie, for the wonderful speech. And now we are all waiting for the keynote lecture.
Can you hear me?
Severely calcified, Dr. Ashok Seth.
Hello?
Yes, sir. Yes, sir, we are hearing.
Okay, you're able to see me as well?
Yes, we are seeing you.
Oh, excellent. So let me just then screen share and see how I can move ahead. My screen share doesn't show my slides. Just a moment. My screen share is not showing my slides. Yeah, just clicked on the share and it didn't show the slides. Sorry, guys, I'm just trying to get that sorted out because suddenly my screen share is gone. If you have time to proceed to something, I'll be happy.
Probably you'll have to log off and then log in again.
Yeah, do you see my slides at all at the moment?
Not it, sir.
You don't? Okay.
We are able to see you,
just
we
give
are
me
able to hear you,
half
not
a
your
moment
slides.
and then. No, I'm quite clear that my screen is not being shared with you, so I'm just going to log on and log off. Okay?
Okay. We'll have a short quiz in the meantime for the crowd. We'll give you 2 minutes, sir. Okay.
Yeah.
Can you put the screen?
Okay.
You have a quiz?
See, if I do this here, my screen is not shared. और share कर दिया ना, the screen में मेरी slides नहीं आ रही हैं. That's what I'm trying to tell you. Can we just?
question?
No, now we can see, sir. Slides. Okay.
Yeah, okay, we'll go ahead with Dr. Seth's lecture. Dr. Seth, we can see your slides. Okay, go ahead. Change. So, can you hear us, Dr. Seth? Yeah. Slides are seen?
My slides.
Yeah, we can hear you.
Slideshow. Put it on slideshow. I'm functioning on the hospital laptop, and that's why this is
Yeah.
issue. But you can hear me now?
Very well. Thank you for joining
Okay.
despite all the limitations. Thank you, sir.
No, I'm so sorry. I'm really privileged to be there, and it was one of my major, wishes to be with you all. I celebrated my dad's 100th birthday day before yesterday, and was out till last night, and then had some hitches in the morning. So it's a pleasure to be here, and I was hearing some of the lectures while we were getting this prepared. So it just made my job much easier, because I'm going to talk to you much more about some of the questions which were being asked, because a lot has been addressed, and I really appreciated Ronnie's talk around imaging, which is so vital, but it actually takes away a lot of my job here and makes it easier. So technical considerations, we're going to discuss really intricacies around many of the techniques that we do and device synergy and the understanding around it through a long period of handling calcium and then every device together. We know all this. We know that we need guide catheters, and anybody who does heavily calcified lesions, the 6 Frenches, is missing out on certain points of not just guide catheter support, or even more importantly, bailing out complications becomes an important aspect of thinking ahead. So while we prevent complications, we must be prepared for complications and bailing it out. So we have all those, which are very standard, but imaging is an important aspect. Ronnie's just explained that to you. And imaging is not just important for decision making. I have to emphasize that imaging is also not just for decision making, it's not just for optimization, but it is actually a safety issue for the patient. If you don't understand the vessel and its size, you can mess around with a heavily calcified vessel, not knowing what sort of size of the balloon and what sort of pressures that you can take, and perforation can be a very high charge that you pay for not understanding the vessel. And do not implant a stent till the lesion is fully dilated in 2 orthogonal projections is a corollary and an axiom that we all must follow. But despite that, even if I can say this to myself repeatedly every day, I will still have a patient a month where I would say, but it's underexpanded in one view, and I wish I'd looked at the balloon till I'd implanted the stent. I want to take you to a different axiom, and that's again very important. If you see a stent underexpanded in one projection, you have to check into the other projection. And if you have an expansion which is large in the other projection, and I'm now talking about that occasional instance where not just everybody, even experts like us, would implant a stent and then notice it only later that it wasn't expanded completely. It's not the residual stenosis in a single projection that matters thereafter. Do not chase the lesion, chase the MSAs. And that's my second axiom that you should add to this. So after that, you're not going to chase the eccentricity in one region. Image to understand that adequate MSAs been achieved, and we'll just come to that a bit more slightly later. Now, we've got a number of devices in our armamentarium now. We've got to be experts at all that, but we also have to understand the role of these devices. Ronnie told you about that, but he told you when to use it and what to use it for. But how to use it becomes my bigger issue. And I think I want to explain that the real world of severely calcified lesions consists of this. Not a discrete calcified stenosis, yes, which does occur in 10-15% of the cases, but heavily calcified vessels in real world patients, like the left main bifurcation in an 80-year-old with LVF and ejection fraction of 30%. We have that anomalous RCA with a total occlusion, which is calcified, along with nodular calcium in other vessels. We got an 86-year-old lady after TAVI, 4 years post TAVI, has got an LV function which is deteriorating when she presents with LVF, and she's got a heavily calcified left main bifurcation. Or patients who had previous bypass surgery with underexpanded stents, double layer of underexpanded stents, which are heavily calcified. And device synergy, therefore, understanding devices becomes very important. So you have these balloon uncrossable lesions which were dealt with. We have primary upfront rototripses for balloon uncrossable lesions. But then we have elective use of devices for reasons which are well understood. While IVL is one of the most user-friendly and effective tools for treatment of heavily calcified lesions to date and is effective, we need to understand that it also rations its pulses. We have real-world lesions which are long, which go from a 3.5 proximal vessel to 2.5 distal vessel, and therefore, and we have to have multivessel disease, and therefore rationing of pulses along with device synergy for volume reduction of calcium primarily or thereafter becomes an important point. I heard someone raise the issue that there's unnecessary, I mean, they don't find the use of OPN over non-compliant balloon. I'll come to that. And I think we're going to put that into perspective rather than just make a statement around that. So here's a patient, of course, he has RCA, this is LAD, this is left pain and heavily calcified, and he's got a low creatinine clearance, he's got left side, which is horrid, he's had recurrent LVF, at the moment he's settled, you can see the long diffuse LAD disease. Now I've just come to, he's also got a right heavily calcified vessel, but in this, if I was to use an IVL, I'd have to start with a 2.5 ml IVL for distal part of the vessel and bring it to a 3.5 IVL for a proximal part, and then do a bifurcation IVL, and that's a huge amount of expense. For me, this is modification of the calcium nodule proximally with rototripsy, because this is clearly a balloon uncrossable lesion. That helps me with the rota, helps me to actually treat a 2.5 distal vessel primarily with rotational atherectomy. I can then treat the proximal with a 3.5 and deliver all my 80 pulses here. This is a 120 IVL C2 plus, where I deliver the rep stress of the 40 on the right side, and then into the ostium of the circumflex, another 20 pulses, and I'm absolutely pretty good. So device synergy helped me not just in uncrossable lesions, but treating such vessels where the right, after IVL has been treated with good results, and then the left system is treated with rotational atherectomy, the 1.5 bar, which is definitive for the distal LAD, which takes away the nodule and uncrossability of the proximal LAD all the way down. And a distal stent gets implanted, the circumflex ostium gets rotablated. A distal, after imaging, distal stent gets implanted with just balloon dilatation on top of rotational atherectomy. Proximal is IVL on that nodular calcium. Proximal, and that gets expanded. And then you have IVL, bifurcation stenting, and huge lumens achieved, right in the left vein to 16, and in the ostia of the circumflex to 9, ostia of the LAD to 10. So, I mean, device synergy becomes an important aspect of understanding, but let me take you not through all this, but this I'm not going to take you through because this has been covered by Ronnie very nicely, and I'm not going to take you through. I'm actually going to take you through some of the nuances around complex calcification where you need to understand your devices. So I'm going to talk about tips for each device. How do your device fit into my severely calcified combined device synergy algorithms? Scoring and cutting balloons for severely calcified lesions, absolutely nonsense as far as I'm concerned. I would actually just disregard it completely. Following rotational atherectomy, good use. Following rotational atherectomy is known to give large lumens, but for eccentric calcium, anybody who says, I'm going to actually treat eccentric calcium by cutting balloons, by the way, the balloon's going to just expand on the other side. Good for concentric thin calcium, bad for eccentric calcium because the blades are going to cut the other side, risking perforation. Remember still, even Wolverine is an expansile balloon. It grows by 0.5 millimeters. Its nominal pressure is 6, 7. It grows at 11 atmospheres. It's already growing. By 18, which we commonly use it as, it's actually grown by 3.7 millimeters. Be careful. It's not a non-compliant balloon. And that's why I would actually, if I cut, I actually take a 0.5 millimeter less balloon, go up to higher pressures. Good for mild to moderate calcification, good for thin circumferential calcification, bad for eccentric calcification, moderate and possibly good use following rotational atherectomy. Of course, we have some data around following rotational atherectomy. There was a discussion around ultra high pressure OPN balloons. And someone made the statement, it does not grow. I want to caution you. OPN balloons do grow. They just take high pressures. This is exactly the chart that you should understand, keep it in your mind. I've compared OPN with non-compliant balloon. Here's a 3.5 non-compliant balloon, and as you know, rated burst is 19 or 20 atmospheres for a non-compliant balloon. By 25 atmospheres, you'll go to 3.76. It's beyond the rated burst pressure, and beyond that, we don't have any data. An OPN at 20 atmospheres is 3.67. At 25 atmospheres is only 0.02 millimeter less than a non-compliant balloon. I hope you register this in your mind. The same chart at 20 atmospheres, only 0.01 millimeter at 3 millimeter balloon. At 25 atmospheres, it's only 0.02 millimeter less. It's still growing. At 30 atmospheres, it's 3.29. At 35 atmospheres, it's 3.36. That's a 0.36 millimeter growth. That's why you got to be careful even with an OPN. But it's the best non-compliant balloon you have. Look at 20 and 25 atmospheres. I would use OPN as the best non-compliant balloon in our life if I had to be safe. But when I use an OPN, because it does grow, we actually have to keep in mind that all it does is take ultra high pressures. By 40 atmospheres, most of the OPNs could rupture. By 45 atmospheres, beyond 45, invariably all OPNs will rupture. So I go up to 35 to 40 atmosphere in a vessel whose size I know by imaging. If I have to have an underexpanded stent for any reason, or I want to get a larger luminal gain, I would go with a OPN. I would actually take a 0.5 millimeter less OPN. I would take it gradually up to 35 to 40 atmospheres. It's safer than a non-compliant balloon. It's great for unyielding lesions. It's great for post-rota, where you really want to actually crack the calcium further. It's great for underexpanded stents. It's good for heavily calcified lesions as a standalone device, as a non-compliant balloon, and it's great for device synergy for rota OPN or IVL OPN. So use support wires and not coated wires. Take a 0.5 millimeter less balloon. Maintain at 35 to 40 atmospheres. Do not try and go beyond 40 atmospheres because majority balloons would rupture. And I do have, if I find there's and then MSA. Imaging is a must for you to understand whether it's adequately dilated. It is MSAs that matter. And for MSAs, I've got to define it. I would say for a mid-LAD, 5.5 millimeters, I prefer 6. OCT-wise, it's 4.5 millimeters square. MSAs, I prefer 5. And for proximal LADs, we well realize that it's got to be 7 and above. So imaging is a must to understand the vessel and size it. Rota, understand guide wire biases. I'll just give you a few algorithms around rota. Be careful around angulated anatomies, and I have got an algorithm for what if rota doesn't cross. So guide wire biases are like this. You can actually have such tortuous anatomy, and if I was to tell you that this is a 1.5 millimeter burr, and look at the way the burr is going to actually go through the vessel, and the left side and the right side shows you that. If I continue iris perforation, by the way, despite 32 years of experience of rotational atherectomy, I'd say 31 years of experience of rotational atherectomy, I actually perforated a vessel a week ago exactly for this very purpose, not understanding, rushing through the guide wire bias, should I say, thinking that my burr will go through despite this guide wire bias, and I perforated it. I had to put a covered stent. And by the way, the nuances of the covered stent are also to be understood by all. And so here's the downgrading to a 1.25, and now you'll see how the burr goes through, still grooving into the media, by the way, but that's still better. This is then followed by a 1.5 burr, and then you have results like this, and then the diagonal also can be done with rotational atherectomy, and you can get a good result. But you avoided a perforation there, which is most used. You have these angulations, and a halfway rota is something to understand. One doesn't have to rotablate the whole lesion completely. Once you fracture the calcium plates proximally, you actually have a better chance of going around the bend slowly with a 1.5, but don't try it. I think if you fractured proximally, just go across and balloon that angle, and believe me, it'll balloon. So the whole lesion doesn't have to be rotablated. Partial rotational atherectomy is a reality. You can balloon some of it and do away with that. If you haven't, you still got IVL, and you haven't, you can actually still go down after some ballooning with rotational atherectomy distally. So, and the third thing to understand is how do you do it with a guide extension catheter? only the 1.25 burr goes through a guide extension catheter. You will find a use of it in anomalous coronary arteries. You will find a use of it in angulated vessels where you want to go across the proximal calcified bend. And the 1.25 burr, the only 6 French guiding catheters goes through a Guidezilla. And you'll remember that. If rotational atherectomy belongs to Boston Scientific, the Guidezilla also belongs to Boston Scientific and takes it. The 1.25 burr doesn't go through any other guide extension catheter. But a 7F guide extension catheter would take through a lot of other, would take through a 1.5 burr easily and could take up to a 1.75 hard push if first introduced. And of course, you can have these heavily calcified tortuous anatomy, which nothing would cross, and even a 1.5 burrs could fail after 10 minutes of burring. So what happens if you fail? Downsize the burr. And by the way, if you downsize the burr and it fails to cross after 5 to 7 minutes, upsize the burr because it's got a larger burring area. You increase the speed to above 200,000 revolutions per minute. Change the burr after 5 minutes. You can change the wire to an extra support wire. And of course, do granuloplasty with CTO balloons, which absolutely burst that, break that lesion and get a purchase for your rotational atherectomy to guide. So this patient had 20 minutes of burring time, by the way. So all the systematic 5 burr across, followed by 1.5. And of course, in the present days, one would also follow that up with IVLs. A word about IVL, and I guess this would be my last slide. I know you can tell me in the interest of time, how much time do I have? But I would just say that good practice to pre-dilate lesions first prior to putting in IVL. Why? Firstly, there's no point shoving it through tight, calcified, long anatomy. It's a device. It's not just a balloon. It has to fire its pulses out there. The second aspect is that you don't want to fire on the balloon material. You want some contrast to be there to be activated to give you that 50 atmospheric sonic pulses. And for that, you don't want to fire it against the balloon material. So partially dilated IVL, which opposes calcium, is far better than an underinflated IVL balloon on which you fire. So must remember that. So pre-dilatation is a good habit to get the IVL across. More cycles over eccentric nodular calcium. That's why C2 plus is a great one for eccentric and nodular calcium. By the way, eccentric and nodular calcium will require more pulses because they dissipate in the normal tissue, and that's why you have to deliver it. More the arc of the calcium, the greater is the effectiveness of IVL. We must keep that in mind. You can exceed the nominal pressure of the balloon, but remember it's a 50 atmosphere impulses which are going in there, so you don't want to rupture the balloon at high pressures, causing dissections and perforations, as has been noticed. Deliver the pulses, or deliver all the pulses. Don't take them home. Don't say, I've done 40 pulses, the lesions look open. You've paid for it. You might as well give it to the patient. So deliver all the pulses. Predilate the lesion to facilitate IVL crossing. Distal to proximal. High profile sucks the guide in. But you have to size it to some area of the vessel. Imaging is important, not just because you know what to do, but where's the worst calcium? And where do you ration your pulses the most? So for me, imaging, when I look at it, I say, which is the worst part of that calcium? Why am I going to base my IVL on a 135-degree arc of calcium? Why wouldn't I do it at the thickest part of the calcium and the most circumferential part of the calcium? And then I know my 60 pulses go in there, my 20 pulses go in somewhere along that 4 centimeters of a lesion. Distal to proximal, place the emitter at the most calcified part of the lesion. Remember, it's 02640, which means 2 millimeters away from the proximal is the first emitter, and beyond the 2 emitters is 6 millimeters. And deliver more pulses. I've already said that. Just my last slide, and I mean, I could go on and on from the complex patients I have. But here's the biggest learning experience that you can actually have through the simplest lesion, which was given to my fellow by myself to say, nothing big deal, discrete lesion. Yes, there is an element of calcium there. I think we should image it. I mean, you can hardly see that. And I think Ronnie made a very important point. If you don't see calcium on angiography, but you see it on imaging, believe you me, that doesn't require any calcium modification. That will open up, will give MSAs. Angiography defines only the worse the calcium, it'll be seen on angiography. Lesser degrees of calcium will not be seen on angiography. That's its poor sensitivity. And that's why it's high specificity. So if you don't see it well enough on angiography, you can. But here you see well enough on angiography. So this is to be imaged. It is circumferential calcification, though focal. I decide, therefore, and it's thick. And this is more than 5 millimeters, and therefore decide for an IVL. And then I have 40 pulses delivered in this cranial view. And look at that. IVL looks much larger than the vessel, and my job's done at 40 pulses. So I say, fine. I look at it by imaging. There's calcium fracture all over the place. I mean, there's something that I don't look to, and I must say it to you right now. I actually did not look whether I had calcium. I had the calcium at the thinnest part of the vessel, and yet I didn't have any fractures in the deep calcium. Now, that's not a great thing, because looking here, you put in a stent. The balloon inflates very well. You put in a stent, you post-dilate to 18 atmospheres. It's a final result. It's a little bit looks larger than what it is. And I then leave it to my fellow to do further dilatations and look at the underdilatation in the ariocaudal projection. There's a 50 degrees residual stenosis. And then you have an underexpanded sense. And when you image it, and after an NC balloon, nothing happens to it. After delivering the remaining 40 pulses intra-stent for that underexpanded area, nothing happens. And then when you look at it with imaging, you have a lumen, MSA of 3.82 on OCT. So we faltered even with our imaging. We did not see whether the deep calcium was fractured. We had an oval appearance, but in an AP cranial, in a single view, we had a hugely expanded vessel, and that was obvious why it was hugely expanded, as you see the rotation of that cursor. And then I go up with an OPN to ultra high pressures, 40 atmospheres. I still have a residual stenosis and ARIA projection. I have a great lumen. Now my MSA is 5.16. It's over 5 millimeters, and I'm good. I've done my job. I have an eccentric lumen, and that is why I say imaging saves you, the patient. Not just it tells you more, it saves you. And this is a clear example why you don't chase eccentric stenosis, why you actually image, and why you chase MSAs. And this is an area where even OPN gives you the safety of doing the job for getting MSAs rather than just with the NC balloon did not get me. So I'm not going to belabor points numerous. I mean, we could go on and on many of my cases, maybe some other time for this purpose, because I could show you perforations when I did not do imaging and used OPN. I show you great expansion of underexpanded stents, in fact, double layered stents, calcium within 2 layers, again, by the combination of using IVL and ultra high pressure balloons to get maximum luminal gains on vessels which had remained underexpanded, and double layers of stent put in for the last 6 years. With those, I'm open to questions around use of each device and its role in our present day, real world, heavily calcified lesions. As you know, we just finished the Shock India registry, which was presented, and I thank the investigators for that 1,050 patient registry, which was presented in the late breaking science at the TCT and aroused a lot of interest. And thank you all for being a part of this huge efforts of calcium modification and device synergy in our country.
Sir, thank you so much. Deepak here, sir. Sir, as usual, it's a very scintillating talk, and we're all mesmerized by your presentation, sir. Just wanted to listen something from you on tips on orbital atherectomy too.
I think orbital atherectomy is a great tool, and we're going to now, because we do both, we're going to define paths for both. For me, orbital atherectomy works much better for nodular calcium. It works much better where workhorse wire or that the Viper wire can actually cross through. It works much better in vessels where you can actually, for uncrossable lesions, it has a less of a role in my mind because it's got the nose cone which has to actually cross. So for uncrossable lesions, it's clearly rotational atherectomy, and for nodular and eccentric calcification, it would be orbital atherectomy. The advantage of having a single burr giving us large lumens in volume reduction is profound for nodular and eccentric calcium. That's what I would say. And also for osteal lesions where you can actually backward come back and ablate osteal calcifications at angulations is an advantage rather than going forwards at an angle.
So in these sort of extreme cases, these examples that you shared with us, would you ever prefer orbital over rotational atherectomy? And in your practice, what percentage would you prefer going with an orbital compared to rotablate?
Yeah, that's a great question. I think we've been doing rotational atherectomy for 31 years. Uh, therefore, bias towards rotational atherectomy remains because it's served us well over years. Even for calcified lesions or Shock India registry, less than 5%, 7% cases were for volume reduction. Less than 5% cases of rototripsy were for of the case not of the total cases of rototripsy, which was 11%. 6% was for probably volume reduction. Only less than 5% have been for non-crossable lesions. My favor remains in favor of rotational atherectomy, and that's obviously the biases towards having used it for such a long period of time and seen its results. My only reason for it is exactly what I said. Nodular calcium, eccentric calcium for volume reduction, and osteal calcification, where I would want to do burr backwards rather than forwards.
Sir, thank you so much, sir. If there are no more queries from the audience. Yes, sir. Thank you so much for joining us, sir. In spite of your limitations, your laptop had broken down despite you joined us. Thank you very
Thank
much,
you.
sir.
And thank you for
Thank you
joining.
very much. I wish I was there with you.
This was a grand occasion for you personally also. Still you came over. Thank you very much. Thank you, sir.
With this,
Thank you.
we
Thank you to all
conclude
of
the
you.
session, and thank you all. I'll move to the next session, symposium. Handing over the mic.
Thank you very much, sir. Thank you to the chairpersons. An excellent session, but we move on. We have the left main symposium next, and may I call to chair this session Dr. Madhu Sridharan, Dr. Ramakrishna Pillai, Dr. Sajan Narayana.
We'll have the quiz for the audience here. Scan the QR code and access the quiz. Yeah, so this is the question. Calcium modification is required all these following OCT scenarios except calcium thickness 625 microns, calcium arc 30 degrees, calcium length 7 millimeters, all the above and none of the above. You can call it A, B, C, D, E.
Fastest finger first gets a prize. Chairpersons, we can start the session now.
Over to the chairpersons now, sir.
Dr.
Pillai.
Yes, now we'll go on to the left main symposium, and we have Dr. Balbir Singh waiting from Delhi, so we'll go on straight. Welcome, Dr. Balbir Singh. Thanks a lot for joining us from Delhi.
Yeah, thank you very much. First, I would like to thank the CHIP team and Dr. Anil for having me here. It's a difficult topic because it's not so common to see a left circumflex pure osteostenosis. So if we go and see, let me share again because I'm not able to move the slides. Can you see my slides? Okay, so if we talk about left circumflex pure osteostenosis, we have to learn some lessons from an LAD ostium because we more frequently do LAD ostium rather than LCX ostium. So some lessons have to be learned from LAD ostium. So LAD ostium, when it happens, we don't know what's happening in the left main. Suppose this is the stenosis in the LAD ostium. We don't know what's happening in the left main. What may be angiographically a normal vessel there could be a plaque. So you have various methods of trying to stent it. So this is one method where you get beyond the ostium, but partly the stent is in the left main. This is very commonly practiced by many individuals. The other is try to nail the LAD ostium, which again is a practice. Now these two have real challenges. Both these practices have real challenge because you don't know what's going to happen to the circumflex ostium. You don't know if this plaque in the left main may actually get worse when you put this stent. So this practice has been a little bit criticized, and imaging can really answer this question. So, for example, if you have a real anatomy by IVUS or OCT showing you a plaque in the left main, which is not seen angiographically, a stent implanted right at the ostium can actually make this left main worse. You can see a plaque, a longitudinal shift into the left main, and things can get worse, and the patient may come back with restenosis within the left main or a stent thrombosis. So these are challenges which we have learned, and so evolved the crossover technique. Looking at all these challenges, a crossover technique looks more elegant, allows you to handle the circumflex ostium if need be. You could do a kiss there and take care of this. It also addresses the distal part of the left main. So these are lessons we have learned from the LAD ostium. So circumflex ostial lesions are more prone to heavy calcium, recoil, rigidity, stent under expansion, in-stent restenosis, and thrombosis. So these are the challenges of circumflex ostial stenosis. So let's look at this patient of ours. I have a 1-year follow-up on her. Look at the ostium of the circumflex. The LAD ostium looks good. Angiographically, left main looks good. There is one lesion downstream in the circumflex, and then there is an ostial circumflex, which is very significant. This patient was very symptomatic with angina. So this is the question in today's discussion. How do you treat this kind of a lesion? So most operators try to avoid bifurcation techniques in LCX ostium because they are afraid that they would jail the LAD, which is typically a vessel which is much larger than an LCX and always has to be respected. So one of the reasons most commonly used technique in LCX osteostenosis has been to adjust the stent to the ostium, try to nail it, which I think is not a good idea to do. This is a beautiful paper published this year in Heart Journal. This year in Heart Journal, which is very interesting. They looked at ostial LAD or LCX stenosis. They had 47 patients with ostial LCX stenosis and 240 patients with LAD stenosis. You can clearly see the choice of operators for LCX stenosis is either medical therapy or bypass surgery. Stenting was less often used because of this fear of what may happen to the. But if you look at the TLR, ostial circumflex stenosis had the highest propensity or a hazard ratio of 7.4, p-value 0.01. So this is ostial circumflex is a bad thing for TLR. But interesting finding of this study was the observation that left main TLR. So what happened in the ostial circumflex stenosis is that patients were coming back with TLR of the left main. And it seems in this study, majority of physicians actually tried to stent the ostium of the LCX and not address the left main. So they were very careful in trying to nail the LCX ostium. And as a result, almost half ended up with a TLR within the left main, which tells you that things are not good. This is a beautiful study from Korea, 2010, looking at the IVUS of distal left main and looking at what happens in many patients. So you can clearly see ostial circumflex stenosis is only 1%. But when you have LCX ostial stenosis, there is a plaque shifting, plaque already there in the left main, very clearly seen in the IVUS study. So this tells you, this is the red herring, you can have an LAD ostium which is cut off, doesn't go into the left main, but you don't have a circumflex ostial lesion which does not extend to the left main. Of course, this percentage is only 1%, so you can't make a lot of things from this small number of patients. But clearly, this shows if LCX ostium is involved, there's a high chance that left main is also involved. So obviously, we had 2 wires. I wanted to save this ramus, so I just balloon dilated this first OM before I entered into the other vessel. So the way to stent, you can clearly see this is the lesion at the ostium. This is a lesion in the circumflex. Way to stent is crossover, floating stent, 2-stent technique. If you want to really, are you so afraid of the LAD or a stentless technique? So I'll just show you what a stentless technique means. So this is the 2021 European Bifurcation Club. So it says that optimal management of ostial LAD or ostial circumflex, also called Medina 011 or 001, is an unresolved issue. So even the guidelines consider this as an unresolved. But we know from the data of LAD stenting, we know that crossover stent had much lower MACE compared to an ostial stenting, and that really has to be practiced. This is a paper which is very elegant, 1998. So they told us that if this is talking about LED ostium, they told us that if angle is more than 80, and if you debulk this LED, you have a much better chance of not causing a plaque shift into the circumflex ostium. And you can see DCA fared much better compared to a stent in not causing a plaque shift. So in this patient, after stenting the distal part of the LED, this was all IVUS guided. Unfortunately, I could not get the IVUS images. It's 1 year back, so I couldn't get it. So having stented the distal part of the circumflex, the left main distal had a plaque, which was plaque area was less than 20. So there would have been some operators who would have thought that nailing the circumflex ostium could be a technique, but I don't think that is a good technique. So we actually started from the left main ostium, extended the stent down into the circumflex. And having done that, the next was to do a pot. And then rewire the LED. So this was the pot, and then rewire the LED. So you would see that rewiring the LED would require a pot so that you create more. And see this technique of rewiring. So take a loop, go into the circumflex so that you're sure you're not going behind the stent struts, and then do a kissing, which was 3 on LED and 3.5 on circumflex. This was followed by another pot, and this is the pictures following the pot. So you can clearly see a very good result on LED and LCX ostium. So only one stent was used in this bifurcation, and clearly good result. Now this patient had a follow-up of 1 full year. This was done last July, and in August I have done a stress echo on her, which is negative. She's completely asymptomatic, not willing for another angiogram. Now this is a patient taken, there are only case reports of LCX stenosis. There's no big series. So this is a patient I've taken from the literature of a large chunk of calcium in the LCX ostium. And there you can see on OCT, a big calcium chunk and a calcified nodule, clearly telling you a very, very high risk patient and the LCX ostium. So in this patient, how would you treat? You have calcium, you have a calcium nodule, and you have LCX. So this is what they did. So they did a stentless technique. So they crossed the circumflex, then use LCA for the calcium. Crossed the LCA with after the LCA, they crossed with a balloon, a 3 millimeter balloon, and then put in a drug-eluting balloon. So drug-coated balloon was used after that. Size to the vessel, no kissing on the LED. A 3-month follow-up OCT showed 4.5 MSA, minimal lumen area on the circumflex ostial, and this is the angio at 6 months. So this is one way of treating of a stentless technique using a drug-coated balloon, but it has its own limitation because you could be dissecting in that area, which could be very dangerous. This is another technique which Japanese are doing because they have the DCA. Japanese are very fond of this kind of a technique for all LCX ostium, and there is a small 4-patient series on this from Japan. So this is an LCX ostium stenosis. A DCA was done. This was followed by a drug-coated balloon. You can see a drug-coated balloon there, and an 8-month follow-up on this lesion shows an excellent result. And this is another way of doing it. Now, the advantage of DCA here, it's not available to us, but the advantage of DCA here is that you have no dissection. So this is a great advantage to have this rather than using NC balloons, which can cause a lot of dissection. Now, talking about another technique, which is called the floating stent technique. This can be done. This should be only guided by imaging, without which this can be a very dangerous technique. The second important thing is to look at the eyebrow sign. So if you have a positive eyebrow sign, this can be a dangerous technique, because once you have a floating stent, this is of LED, once you have a floating stent, so this B figure shows the eyebrow sign, and the D figure shows no eyebrow. So this can be safely done with a floating stent. The problem is, if you have a floating stent and you cause a caninal shift, getting back to the circumflex could be very dangerous, because you will go by the side of the stent. You will crush this portion of the LED stent, and whatever you may do, you may end up by extending the stent to the left main and become like a crossover stent. So this is the danger of using a floating stent, because if you have to recross and do a kissing to the circumflex, this circumflex balloon may crush this floating stent in the left main. And plus, a floating stent in the left main is vulnerable to these stent struts lying free, not touching the lumen, not touching the wall, and be another source of thrombosis. But the clinical data on floating stents is not as bad as what you may think it to be. Now, side branch evaluation by EB-Jink becomes an important and integral part of whenever we do isolated crossover stent, because it can guide us that what is the problem likelihood going to happen on the other branch. For example, if you look at the carina tip angle less than 50 degree, if you look at the branching point to the carina tip less than 1.7, we know these are the risk factors and they can be easily calculated on OCT or IVUS. And you can actually make an idea that what problems that you can get in this. And finally, this is again to show that when you do whatever RTL, whether it is LED or LCX, and imaging can, from both the vessels, LED and LCX, can guide you as to what the plaque in the left main is, what the plaque on the ostium of the two vessels is. For example, if I was doing this case and I found a plaque area on the LED of more than 40%, I know I have to use two stents. Whatever I see in angiography is not reliable, and this can be of an very high importance. So in conclusion, I would say imaging becomes an important and integral part of stenting an LCX ostium, and treat as if you are going to treat a left main bifurcation. Don't get into an idea that this is not going to be difficult, it's only LCX ostium. Crossover strategy is probably the best because you can get back into the LED and do whatever it may require once you are in trouble or once you feel that the LED flow is reduced or there's a plaque shift to the LED, you can easily go back to the LED and complete the whole picture. So keep in mind that when you're treating LCX ostium, it is like treating a left main bifurcation. Thank you very much.
Excellent talk, Dr. Balbir Singh. A couple of questions. So when you're treating a crossover, so what you do for the LED, would you, you said in the case you did, you dilated the LED with a 3 millimeter balloon. So would you image the LED after that to see for dissection? And two, would you do a drug-coated balloon or just a plain balloon?
Okay, so there is no data as of now that it should be a drug-coated balloon. But if there is a plaque shift and you see an LED which shows a stenosis, you have to be very careful. But in this case, you saw that after the kissing, there was a very nice result and I did not suspect. So my thinking is that when you recross a strut which has been opened, there is always a small risk of the catheter, whether it is an OCT or an IVUS catheter, of causing some damage to the stent struts. And one should only do it if it is required. And I would only do if I think on angiographically there is a problem. And DCP for opening the struts has not been studied that well to be practiced as a
it's just because it's a LED, you know, the LED is the most important vessel, so.
Right. So I think that fear of LED dissection, if you don't have a plaque on your initial baseline study, there is very little chance. You have sized your balloon and there is no plaque. There is very little chance of causing a dissection at 6 atmospheres or 8 atmospheres pressure. Very little chance.
We all see that circumflex ostial stenosis isolated is a very, very difficult subset to treat. We understand that. In a given case, what would be your preference? Stenting from a left main to circumflex and then crossing into the LED, or treat it as a stentless technique?
Right. So first, LCX pure ostial stenosis is a rare condition. Very few patients have it, so we can't have a large series to define which is a better strategy. LED ostium has been much more common, and we have comparative studies of fixing the ostium versus crossover, and clearly showing crossover is better than fixing the ostium. So LCX stenosis, the other important thing that comes up, if you talk to Gary Mintz, he says that if you image this LCX ostium, if LCX ostium is involved, there is very high chance that the left distal left main plaque is there. and to do a osteal LCX stenting is most challenging. And I showed you 43% patient had an TLR because of a left main stenosis when the LCX stent was placed at Aussie. So probably the crossover stenting is the best idea. The fear of the operator is what will happen to the left LAD. That is the major fear every operator has. That LAD is such an important vessel. When you cross over, what will happen to the LAD? So I said you have to be prepared as if you're treating a left main bifurcation.
At least when the circumflex is dominant or non-dominant with the large OM branches, this crossover strategy should be preferred, isn't it?
So if you have a non-dominant circumflex and just an osteostenosis of circumflex, I guess if the patient is not too symptomatic, a medical management would be probably the best answer rather than trying to fix a non-dominant artery.
Yeah, actually, good case example shown for DCB application to circumflex oximetry. It's a very, very attractive treatment option. Do you have any imaging endpoint by which you go for a bailout stenting in an isolated circumflex? For example, if you have decided upfront as it's a DCB case, but you plan to place a crossover stent as a bailout procedure, you have any imaging criteria by which you go by that?
Right. So, very good question that DCP and no balloon technique is without a dissection. So there will be some dissection if you do imaging. So what kind of dissection should you leave? And what kind of areas you want to achieve. So in an osteal circumflex, you would like to achieve an area at least 5 millimeter and above. Even though some people would think 6 is the ideal area to get, but 5.5 area and above would be the minimum that you want to achieve. And if you have not achieved that area, I think there is a risk even if it is a DCP. So in DCP, I have spoken to Kokili, who's had the largest experience with using these. He leaves a lot of dissection. And he says if you have good MSAs and you have TIMI-3 flow, that dissection is not really bad. But our fear is if you image with OCT, you will have some dissection there for sure. There cannot be a case of a balloon angioplasty followed by a DCB not to have a dissection. And that kind of confidence we have to gain, that even if there is a dissection and good MSA, you can just leave this patient. But unfortunately, this is the area that if you have a thrombosis because of the dissection, it will extend into the LED. That's what the fear is actually.
Thanks a lot, Dr. Balbir. I think the organizers are telling for a short of time. So
Thank you, Dr. Balbir. He was supposed to be here in person, but for illness in the family. Thank you. Next time we'll have you here in person. Thank you very much.
Thank you, Dr. Anil.
Thank you.
Anil, next is Dr. Silvestri. Yes. Dr. Silvestri, it's an honor to have you again today. So it's left main PCI, the journey so far.
Can you hear us, Dr. Silvestri?
Yes, can you hear me?
Yeah, we can. Please go ahead.
Okay. Good morning. Thank you very much again for the invitation. I'm going to try to bring you in a long journey of 30 years. I hope this journey will be as comfortable and quiet as the one I did on the backwaters on the houseboat a couple of years ago. It was very nice in Cochin, and it's a good memory for me.
So can you put your camera on, please? You are not seen. Your slide is seen.
Okay.
Yes,
Good morning,
thank
everybody. It's sunrise here in France. I said that I wanted to bring you in a long journey of 30 years. Next slide. Yes. Obviously, you probably remember that Andreas Grünzig himself, who is our mentor, has been the first operator to perform a left main angioplasty at this time, of course. And I think we must all remember first this important sentence he published in 1979, that he has been successful to treat a left main stent, but the procedure, even if relatively simple, has a potential to be complicated, and both the complications are sudden and serious. So you have to keep in mind this center before starting left main angioplasty. Then, when the stent era arrived, the end of the 80s, beginning of the 90s, some audacious cardiologists, and I belong to them, started to implant stent in the left main. Stephen Ellis first in USA and S.J. Park in Korea. And myself, we have published the first series of patients with the bare metal stent, the Palmachat stent at this time. And next slide. And we show that the safety was there because when we started to do angioplasty of the left main, we had a fear of the collapse of the patient, of course, by inflating in the left main. We even start with what we call the cardiopulmonary support at this time, which was the equivalent of the ECMO now. And we saw that finally we had enough time to inflate the balloon and the stent in the majority of the cases. So the procedure was safe. Oh, come back, please. The procedure was safe, but the main problem was the in-stent restenosis, which was up to 30% at this time with the old bare metal stent. Next. I had the opportunity also in India to implant my first stent. I want to remember this nice moment also in Pune, in Ruby Hall, the first left main with Macaulay and Dr. Yermat in 1989, and the patient went fine for more than 20 years, I heard recently. So I was very happy to do this first case. It was an ostial left main with a bare metal stent at this time. Next slide. And then we have seen a dramatic increasing trend of patient complexity coming with of course, the improvement of devices, with the improvement of the stents. More and more difficult PCI has been done worldwide, and particularly in the left main. You can see that nowadays in this trial, which take the patient, collect the patient over 12 years, we have now an average rate of left main PCI in the majority of high volume centers between 3 and 5%, 3.6 exactly in this trial. So we have to face this situation very often. Of course, CABG still remain the gold standard. We will see that later, but more and more patients with left main want to have angioplasty, and more operators are keen to do a left main angioplasty nowadays. That's a good thing. Next. So we had to collect, of course, a lot of patients and perform trials to show that the stent was progressively a good opportunity for patients to avoid surgery, even if CABG still remained the gold standard treatment. So all of you remember the Syntax trial, which was a randomized comparison between the old Taxus stent and the surgery. And you can see that, again, the safety was proved. The mortality at 10 years at Syntax was equivalent in the subset of left main, around 30% for CABG and PCI. Next. It was the same also for the Korean pre-combat trial. Park published the 10 years follow-up also. We show a TLF, which was equivalent between surgery and stents, which was mainly the sirolimus for this team. Only the gap of ischemic-driven TLR was there, about 8%. And this gap is still quite equivalent in the majority of the trials between, let's say, 5 and 10%, because the need of repeat revascularization, not really on the left main, but most of the time on the other vessel when the patient is trivessel disease. Next. And recently, more recently in 2016, we had these two controversial trial, Excel, which was a comparison between surgery and everolimus stent, and the Noble, which was a randomized Scandinavian trial between surgery and biosensor stent. And you can see that the results were completely different because, of course, the endpoints were different. The Excel trial, the TLR was a secondary endpoint, and the PCI could reach the non-inferiority, whereas in the Noble trial, the non-inferiority of PCI was not reached, probably because this difference of TLF and TLR at the end of the 5 years follow-up. Next. So this meta-analysis recently published 3 years ago combined all those trials, and you can see that more or less, we are very close. The two techniques are very close for the mortality, of course, and still the gap of TLR is still there in favor of surgery because of in-stent restenosis. Next. Of course, if you look at some registry, it's different. This recent registry in Scandinavia, again, the results were really in favor of surgery because the outcome of PCI was, again, with bad result in terms of TLR. So if you go to, in some countries, sometimes if the patient, of course, have a high syntax score, the majority of those operator will have tendency to send the patient for surgery. Next. So we cannot speak about the journey of LeftMain without speaking about imaging. A lot of speakers have already developed and spoke about that. We have started to do LeftMain angioplasty 30 years ago, of course, without any imaging. So we learned without imaging. Then we learned the result of imaging, and it was from the beginning very confusing for us because when Park showed that the mortality, even the mortality was influenced by the use of imaging, it was very confusing for us in Europe because we didn't have the feeling that we could kill patients and that the results were not so good than in the center where they use imaging, but the results are there. Of course, it's only registry nowadays. Next. We don't have any randomized, next slide, please. We don't have any randomized trial, but if you look at this meta-analysis, including, of course, not only LeftMain, but including the Illumin 4 and October, the last important trial published recently, comparing imaging versus angio, OCT or IVUS versus angio, you can see that there is a trend, a significant trend in favor of imaging for complex patient, including, of course, the subset of LeftMain. Next. There is, of course, consensus nowadays to use imaging to assess, of course, the severity of LeftMain and complex procedure, also for the guidance, for the optimization, as well as for the mechanism of failure or in-stent restenosis. Next, please. There are advantage and disadvantage for both methods. Of course, the majority of the speakers previously have shown that already. I think we can skip this slide. Next slide, please. One important point is that nowadays, if you look at the guidelines, it's allowed to do a LeftMain stenting without imaging. Maybe in the next future, with the result of optimal and doctors LeftMain trial, which will be probably presented at the next PCR, the guidelines will change. It's true that more and more, even myself, I believe that imaging is probably mandatory. IVUS mainly, but also OCT, which give us higher resolution and surface detail, except for the ostial LeftMain. But most of the time, when we have some confusing images by angiography, we started to use more and more imaging and IVUS or OCT. Next. So the journey has changed, of course, from the beginning by using now more and more imaging. And we all know that I was looking at the previous presentation of the ostial circ angioplasty. It's true that the final MSA, as Ashok said also, it's very important. This is the only way to achieve a perfect result and to complete the result of surgery. We must have the larger MSA or MLA at the end of the procedure to really reduce the TLR, which is finally, so far, actually, the only difference between surgery and angioplasty for LeftMain. Next. Which patient, if you cannot afford it, or if the patient or the hospital cannot afford to, of course, to use imaging, which is the major problem, the cost. I believe that complex bifurcation, distal bifurcation, Medina 111, two-stent strategy, ambiguous images severe diameter discrepancy, very long lesion, any situation where the stent malleable position can be anticipated, then of course we must do the effort to use imaging and explain the patient or at the hospital that the outcome of the patient will be probably better in this situation. Next. This is what I said previously. This is probably mandatory. It will be probably mandatory in the next future to use, and it is mandatory in some centers all over the world actually, but because of the cost consideration, it becomes optional in some centers nowadays. Next. A few words about the distal left main bifurcation, which is still a controversy between, of course, CABG and the tooth stent technique. We had recently, a few years ago in 2019, the result of this Chinese trial that all of you know, which emphasized the Dick-Roche technique. Next slide. Versus the provisional. And we had, and I was happy to participate to this trial, the 3 years EBC main result, where we could show the comparison between provisional and the systematic dual stenting with only 39% of imaging using. And you can see that at the opposite of the Dick-Roche trial, in the distal left main, there is a higher rate or revascularization rate with the systematic dual use of stent. So it's very confusing nowadays. We don't have yet the answer. Some operators say that two-stent technique is mandatory. Some operators say that we can start with the provisional, and in case of bailout or in case of poor result on the circumflex, which is the daughter vessel most of the time, in this case, we can use the different technique of two stents. This is the trend currently, I think, when you have a simple left main without long disease on the daughter vessel. If the MSA is less than 4 square millimeter, or if you have a physiology less than 0.8, then you can avoid to put a second stent. In all the other cases, of course, by the use of imaging, the two-stent technique is mandatory. Next. I want to emphasize also the importance of the experience of the operators. We have this Chinese also trial which showed that, of course, it's only a single center study, but among a huge number of left main PCI, there is a significant difference, and it was proved also in a British recently a trial published. If the operator has a high volume, more than they said 15, but it seems to be a low number. But the lesson is that 1 or 2 operators should be dedicated in a center to do left main, and the other operator, this is what we are doing in our center, the other operator must come with the master, with the more skilled and experienced operator to learn progressively, and the operator should bring their own patient to do with the experienced operator to increase the success rate and to have a better outcome, and progressively learn and work, and then can do the left main PCI alone in their own center. Next. So this is finally the current guideline. You can see that we start from a long time ago, 10 years, in 2010, from a level of recommendation 2B. Now we have for a patient with syntax score less than 32, the 1 and 2A recommendation. Only the patient with a lot of additional lesion with a syntax score more than 30, 32, 33 should be sent for surgery. But, you know, it depends of the distribution of the lesion, the size of the vessel, and many parameters also. And some patients can also have benefit for angioplasty and stent nowadays, even if the syntax score is high. Next slide. Of course, I cannot speak about left main without mentioning the role of surgery, even if the surgeon is a kind of competitor, but we have to think to the patients first. There is probably a role for surgery in the treatment of left main stenosis nowadays, for different reasons. Of course, we have to prove first that the lesion, and particularly the left main lesion, is significant, because angiographically sometimes it's difficult to assess, and we have all seen few years after bypass, when we check the bypass, that the left main lesion is still there because it's not significant and the bypass are blocked. So it's very important to assess the severity of the lesion first to decide which is the best option, particularly if you want to send for surgery. Of course, we have to evaluate the risk of the patient and the Syntax score. In theory, the best candidates for surgery is a low operative risk, high PCI risk, and high Syntax score nowadays. But of course, once again, it depends of the center, it depends of the patient, it depends of the operator. Next. I said that because, next please. In the majority of the cases, when you have a Syntax score and the result of trials, we always mention the MACE, the hard endpoint like mortality and TLR and myocardial infarction and stroke, but we never mention and we never collect all the morbidity of surgery that you can see. Of course, that will not kill the patient, but why do we compare the angioplasty, the repeat angioplasty, and we do not compare with this all complication we can occur in a small rate of case, true, but when you have a renal failure, when you have a sternal dehiscence infection or mediastinate, then of course it's very complex for the patient to recover and it takes a long time, and it should be also have in mind before deciding for sending the patient for surgery and compare with the mortality of surgery, which is finally the risk between 5 and 10% of TLR, which is quite simple to treat. Next. Normally, we should, in the majority of the center, of course, have a heart team discussion for all the patients. To be honest, even in my center, we do not discuss all the cases because when you have experience, but it must be written on the file of the patient because it's medical legal, so you have to be careful. In US, for example, the lawyers are at the door of the cath lab sometimes, and you have to mention that you had a discussion with the surgeon in theory. But majority of high volume operators know that. Next slide. We have to next, please. We have to know all the the parameters to decide which patient is in favor of surgery or which patient will have benefit of angioplasty. Next slide. So to summarize, I think that today the left main treatment must be a reflection between the angiographic anatomic factors, of course, the clinical factors of the patient, and the local factors, because the results are completely different. You could see that on the randomized trial and the registry. The results are completely different from a center to another one. So we have to propose the best solution for one particular patient in each center, and the solution will be probably different from a center to another one, and the outcome also will be probably different. Next slide. So in conclusion, I will say that left main PCI nowadays is a mature, safe, and effective alternative to CABG for selected patients. Imaging is probably the foundation to start, and probably in a couple of years will be mandatory. High volume operators drive the outcomes. I think it's very important. It's a case-to-case decision. The simple provisional stenting is often enough for distal lesion in majority of the cases. If you use a two-stent technique, you must use it rigorously and carefully because it's very important to have the best MSA and MLA as possible. And the optimal result is, of course, mandatory to compete the result of surgery. Thank you very much for your attention.
Dr. Silvestri, it is an excellent talk. Can I just ask 2 questions, just to be provocative? If you have intracoronary imaging in the lab, would you do any case without intracoronary imaging? And 2, if it's a distal left main with a long normal left main, would you still cover the ostium of the left main?
So the first question, unfortunately, I have to answer with the economic consideration that we have in France, in my country, and in some countries of Europe. Unfortunately, we have no reimbursement. This is what I said yesterday.
If
I
you
know
have
it's-
reimbursement, would you still go ahead and do without imaging? If you have
It
reimbursement,
depends. It depends of the cases. Because I think with experience, I know that some operators, even with experience, they use systematically. But in some cases, I will say that I can appreciate the size of the left main by experience, by comparison with IVUS and OCT. So in some simple cases, the one I showed yesterday, I was completely sure that the left main was around 5 to 5.5 millimeter. So I use a 5 millimeter balloon for a pot, and it was a 5 because we checked by OCT and it was the right size. But in the majority, I would say that in 70 to 80% of the complex distal left main, I will use imaging. But I know it's very controversial. This is why I think it's very important to have trials comparing angio randomized trial, because we can push the authority to help us to have reimbursement for that in the majority of the country. This is very important. If we really prove that the outcome is different, then we can make the pressure, put the pressure. But in the EBC main, which compare 1 to 2 stents with 39% of IVUS and 61% of angio guidance, there was no difference. So this is very confusing because it was high volume operators in Europe, and I was one of them, and included 35 patients in this trial, and I didn't use any imaging. So it's very difficult for us to understand, and if we had a lot of patients coming back with in-stent restenosis or with a higher rate of mortality, but we don't have. We follow our patient, and even with angiography guidance only, we have participated to many trials, and the results were similar. So let's wait for the guidelines. Let's wait for the randomized trial.
what about ostial left main? Would you cover the ostium of the left main for all?
It depends. It depends of the length of the left main. It's true that at the beginning, when we started with Thierry Lefebvre to include patients in our registry, the two places where the restenosis rate was higher was the ostium of the left main and the ostium of the circ, of course. So if the left main is diseased, we can see that the left main is diseased either by angio or, of course, by imaging. It's more clear. Then we cover if the left main is short. If you have a very long left main with only the disease at the distal part or middle part, we leave it alone.
Thanks a lot, Dr. Silvestri.
Thank you.
It's an excellent talk, and thank you for your time.
Thank you very much. Take care.
Thank you, sir, for accepting our invitation and being online. If it were not for bureaucratic reasons and visa denial, I think Dr. Mark Silvestri would have been amongst us today. Maybe we'll look forward to his presence next year. Having said that, thank you very much again for devoting so much time to the conference, both yesterday and today.
Thank you. Bye-bye.
Can we have Dr. Shivakumar for the last talk?
At the outset, I thank Dr. Deepak Davidson and Rashir Verma for the invitation given to me. And having listened to the journey by Dr. Mark Silvestri and wonderful case discussion by Dr. Balbir on isolated osteal LCX, I was asked to show challenging left main, and better to show one case that was a request by Rashir. Let me see. He wanted to have a detailed discussion. Try to bring a real world case scenario. The case which I'm going to share with you all today is a 60-year-old male admitted with chest pain, which was typical diabetic unstable angina. One important comorbidity which we noticed in this man was an anemia, which we did a detailed workup. We did even blood transfusion. We couldn't figure out the cause for anemia. Preserved LV and preserved renal function. I'll just freeze my because the angio was done elsewhere. Just for the want of appreciation of the disease for the people here, definitely one can appreciate there is a big chunk of calcium involving the osteal LCX. There is again a calcific lesion involving the osteal LAD. Obviously, angiographically, one cannot exclude left main from here. So, to bring it to the real world case scenario, it looks like if I apply a syntax score, it comes somewhere low to intermediate. So obviously a tempting case for PCI, but obviously one cannot omit bringing a discussion of CABG with the family. We involved the referral physician, the family, and the cardiac surgeon. And the family wanted to know whether CABG can be considered as a bailout. But we clearly told the best time to decide for CABG is now, not after bringing the patient to the cath table. So that means we discussed the procedural steps with them and clearly made them to understand there is no in between we can shift the patient. Having committed for PCI now with this lot of people involved, now we need to produce a result which is on par or on even superior to CABG in long term. Patient was having a non-dominant RCA, which I didn't show here. So dominant LCX, Medina true complex bifurcation. So we started with an intra-aortic balloon pump. Obviously, that's an area for discussion here, whether someone could done this case without intra-aortic balloon pump. There is enough papers and data that if you have decided for an MCS support, upfront MCS is better than bailout MCS. I mean, taking an MCS after a cath lab crash is not a way to go. And regarding the wedge catheter, which I have kept here, I can definitely say it is not mandatory, but definitely it will be help you to judge your, when the unpredictably if the procedure goes long, whether the patient is accumulating fluid or to manage your load of contrast and inotropes, definitely it gives some idea. So again, another discussion here will be, Sargent brought about your prepare calcium trial, which clearly tells bailout rota rather than upfront rota. But sometimes, in a case where there is a non-dominant RCA, a complex true bifurcation calcified, getting an imaging catheter or a balloon-based strategy initially and a bailout as a rota, sometimes you may end up in a abrupt vessel closure. You may have to be rush up things, and upfront rota, you will have a complete control over the case rather than bailout rota. But of course, you need to have a mastery of this tool when you have decided for the upfront rota. Another disadvantages will be with the rota in this case against IVL will be, you cannot park a wire on the LAD. So considering all this discussion, and another discussion will be here, why 1.5 bars? Looks like the LM and LCX is so huge, why not 1.75 bar? Here being LAD is also calcified, if I take a 1.5 bar, the 1.5 bar I can apply for both LAD and LCX. If I have to increase the single burr philosophy is in the modern era of rota, single burr philosophy is the way to go. If at all I have to increase the 1.5 burr to the 1.75, maybe by dropping the speed from 170 to 140, somebody claims that it can, the burr can swell up to 1.75.
Shiva, so I just talked to Verma. Can we make it interactive so we can go through each of the steps? It will make more
That's
interesting.
very idea. I am spontaneously my own bringing the discussion. So if somebody starts stuff.
So we got 20 minutes. So from the beginning. So you said about anemia. So what is the hemoglobin and what?
The admission hemoglobin was somewhere around 9. So we committed for a very complex PCI. So we did some workup, like whether it's anemia of blood loss or anemia of.
So when you have complex left main with anemia, we are not sure of. So how much of workup would you do? Would you exclude a malignancy because you are
malignancy
looking
was
at
ruled out. Nutritional was ruled out. Anemia of blood loss, we were not very sure, but at this juncture of admission, there was no ongoing blood loss.
Right, because you are looking at long-term dual antiplatelets and...
Yes. That discussion we had with the patient.
And second, this is osteal LAD and osteal circumflex calcification.
Yes.
Why did you put a IABP initiative? What was it mandatory or?
A very demanding patient, and the referral physician was around non-dominant RCA. Even though it's a preserved LV function, that calcium which in the osteal LCX, we all know that rota to the osteal LCX doesn't behave as we expect. Sometimes it can create a big rent on the opposite side of the calcium. So if I lost the LCX on table, I thought I will have an upfront MCS. If not impeller, at least some support device.
Because I think this debate is going to be there tomorrow, but I think
Yeah,
everyone
it will
should
be
be
there.
aware that, you know, putting a MCS has its own problems because, you know, you can have bleeding and you can have complication because of MCS.
Yeah.
And one more thing, when
That
you're
in
doing...
a patient with the pre-existing anemia, MCS
Yeah.
is always...
And one more, when you're planning for a rota, why did you not image first before the rota?
That's what I said.
Because
if I play with the imaging catheter, if I damage the vessel, then again I'll be rushing through things. So I thought even after the imaging, whatever may be the imaging inside, angiographically it is significant calcium. The imaging is going to quantify the calcium and going to tell you which kind of modality rather than whether to go orbital or rota, IVL. It's going to, but one cannot manage this case with a simple preparation philosophy. So you are committed for an aggressive preparation. So that's why I thought I will do some initial preparation, then I will take the imaging in between rather than to start this case. If it would have been a calcium not of this extent, I would have started this case with imaging. But obviously, angiographically, if you see this case, it is very dense calcium sitting at both osteums and involving the LM2.
Did you assume that the imaging catheter would not cross?
I felt so because of the, or it may cross injuring the vessel, which may, see, if I go with this case with upfront rota, very gentle, then bring in imaging, I wanted to have a control over this case from the beginning. I don't want to, none of my step should take me out of control. This is my opinion.
But generally, as per the recommended algorithm is first image, and if balloon,
Imaging should be part of PCI, but it doesn't, imaging proponents doesn't sell when to bring in imaging. Is it so when to bring in imaging or imaging versus not imaging?
if the imaging catheter doesn't cross, then it's rota first. But if the
That's
imaging
what,
crosses...
That's what. See, imaging catheter versus balloon, this is like a bailout. I clearly taking the case for bailout rota or upfront rota. That's again a discussion.
For vessel sizing and stent sizing,
Yes,
right?
absolutely.
So the plaque morphology, the operator believes that imaging doesn't add anything to the angiographic appearance.
Yeah, that's.
Yes, go ahead.
Yeah. So this is regarding the burst size, which I opened up some discussion regarding 1.75 versus 1.5. Again, we can have a discussion on that. If somebody has a different thought, IBL versus rota or rota as per the burst sizes, we can have, or I can move on.
But that will probably be with after the imaging, probably.
Yeah. Perfect. So this was, initially wire was kept on a different branch. This is a 1.5 bar. A very gentle movements. You can appreciate my keeping my wire on a different branch to favor the bias towards the calcium. And unlike LAD, which I'm going to show you now, LCX were a little tricky, but at the summit of the calcium between the LM and LCX. But after that, the burr was moving predictably. And the same burr, we took it for the LAD also, same 1.5 bar. And LAD was being a pretty straight vessel, we didn't have much challenges. we didn't do any change of wire position, unlike in LCX, which we thought it worked. LED, of course, it was a long diffuse calcium, whereas in LCX it was I need to burr more at the ostium of the LCX, where I thought it kind of a noodle kind of a step. That's the reason why I was keep on changing the wire position in LCX, but not in the case of LED. This is the rotor to the LED.
Shiva, a small doubt, Shiva.
Yes.
Shiva Deepak.
Yes.
Shiva, you initially had your wire inside the circumflex.
Yes.
And because you were finding it difficult to get the burr across the lesion, you told that you've got the...
No, wire went easily.
Yeah, then you changed the wire into the OM
No,
branch,
no, no.
right?
Wherever the branch it went initially, I took the burr.
Yeah.
Then
halfway through...
intentionally I changed the wire to the another branch, in the L6.
How did you do that? You took out the burr and
no,
then
no,
you
why-
went again with the microcatheter into the branch, or you just pulled out the wire
No,
halfway through and then pushed it
while,
in?
while on the burr, you can press the brake defeat and
You
pull,
pull
and
it
you can
back
change
and then pushed it?
push.
Ah,
You can
but
change it, or
when
you
you-
can bring it back to the guide and change the wire position and take the burr again. It depends on how you
But then
train.
you wouldn't have a control of you cannot torque it, no? You just
No,
have
this
to
is
push it, it
the
has to go
latest,
some-
not that foot pedal one. This is the Rota Pro. What is that new one?
Rota Yeah, Pro. Rota Pro.
Which we
Still-
have. You can put the brake defeat, and you can have a full. You can
Yes,
have a
Shiva.
little more control.
Yes, Shiva. Both with Legacy as well as your Rota Pro.
This is a
You have the
floppy
new-
wire only. This is not a
Yes, Shiva. You have the Rota wire drive, the new wire.
Rota wire
which
drive,
is
yeah,
more-
this was
so
drive.
Did you have a torque also attached when you pulled it out and pushed it into the
Yes.
OM branch, or by chance you had to push it and it went into the OM branch?
No. It was not. The wire was not moving on its own. It was intentionally we did the
No, you did
placement
on.
of the wire.
No, the question Deepak is asking whether you did it on Dynaglide or while you were burring.
No, it was while burring.
And similarly, from circumflex back into LED, how did you wire? You again took out the burr and then went across into the LED with the Rota wire, or you just pulled it
Just
out? and-
kept the wire, kept burr in the guide, and just changed the wire position.
There is some concern about some dissections or some injury to the vessel after the process of burring.
During the L6,
And then
whether I would have changed the.
Yes. Whether you would cause further dissection injury while rewiring. Then you have already pulled out the wire from LCX. So which probably a use of
No,
a
no.
guide extension-
After the burr to the LCX, we did a check, made it sure the artery is good. Then only we moved on to the.
A safer idea would be to use a guide extension. And
Yeah.
keep the wire in place. in
Keeping a
LCX.
guide extension, I'm not that familiar with the guide extension and rota. So whichever familiar for me.
Yes, sure. Whatever said. and
Usually
done.
for the rotor, guide extension is for the distal rotor rather than it being a revolving around the LM and bifurcation. I thought.
Again, whatever said and done, getting a burr through the guide extension catheter, even if it's a 7 French compatible, it's always cumbersome. It gets stuck at the
Yeah.
proximal end of the guide extension. It always gets stuck. Great difficulty only you'll be able to get the burr through. That's point number one. Second thing, what I had in my mind was every time we want to do a bifurcation rotablation, when you have two vessels, circumflex and LED, at least for the beginners, it's safe to do the easy to wire vessel first. Let's say you here
Easy
you
to
have
wire the vessel.
you
You want-
have
you-
LED is easy to wire.
You feel like LED do the first.
First do LED and then come to circumflex, because you, in case you have closure of that particular vessel, you will be easily able to wire the LED. That would be the
I
thought
initially
process.
thought that the burr is required only for the LCX. I can manage the LED with balloon. But as LED LCX ostium, which I thought very demanding, which went smoothly, I thought I can quickly finish the burr to the LED. So initially the plan was to make a balloon-based ablation for the LED and rotor-based ablation for the LCX ostium. What was the other question? Yeah, guide. Sometimes people keep the wire and protect the microcatheter. Have you guys done it? I have not done it. Maybe Dr. Werner can tell us. And of course, I generally, we have a low threshold to use, even otherwise also, cutting balloon, having Boston changed from Flexum to Wolverine. Wolverine, I feel it's a very trackable balloon, so It was planned preparation with the cutting balloon to the LAD as well as to the LCX. And the IVUS was done from LAD. The very purpose was there is a gross mismatch between the LAD and LM. So I cannot finish it with the one stent. So it was decided for 2 stents. Having decided for 2 stents, where to overlap, where to land, and diameters. Of course, we need to know whether the IVUS has, sorry, let me play the IVUS. Yeah. Okay. Right. Playing.
Okay, we take your word for it.
Yeah. So it just told us some luminal gain was there, some reverberations were noticed, but no much fractures, noticeable fractures were not there. We could appreciate some shaving, but definite luminal gain was there. Just give me a try, one try. Somehow it is jumps.
Dr. Shivakumar, can we finish in 2 minutes?
Yeah.
Okay.
LCX I was run, I couldn't bring the image, and this is a first stent to the LAD as per the IVUS landing and diameter and proximal overlap. Then once the mid LAD was finished, we moved to the LCX ostium. We did some preparation with the cutting balloon to the LM also. It was a different sized cutting balloon compared to the previous stent. And we brought in our LCX stent, protruded in a way and pulled back the balloon, so-called proximal side branch optimization. Then we did a step crush as per to the size of the LM as well as to the size of the LAD. When I am doing a crushing as per the LAD size, you can appreciate the wire has been removed from LCX. Then recrossed. Once you do this side branch proximal optimization and step crush as per the LM and as per the LAD, naturally your recross will fall into your most optimal cell. I mean, it will be falling in either the so-called non-proximal, non-distal cell. That's what one will be aiming, so-called mid cell. And we did a first kiss. And of course, it's an elite forum. Everybody will know the steps of DK crash. So the short LM. So we wanted to cover the ostium. The good size stent 4 plus, I think, synergy, LM to LAD overlapped, and this was a stent crash. And pot again, recross the distal. I just wanted to show my recross. Okay. This is a pot. Visited the LAD, and I'm pulling it back. With the buckle, if I move, there is no further area for the buckled wire to move. That means I have crossed distally. Of course, one can confirm with the IVUS. OCT gives a better confirmation than the IVUS, but HD IVUS also one can confirm whether it's a distal cross. Then, of course, FKBD, second part. And we are in a post-Excel era, and there is a clear data now. If you achieve high tertile MSA, for example, for a given LCX MSA of 5, and for each one increase in MSA, you reduce MACE by 50%. I mean, for a 5 millimeter squared of ostial LCX, which was the pre-Excel era recommendation, if you predict an MSA of 20%, if you achieve 6, it will become 10%. If you achieve 7, it will become 5%. If you achieve 8, it will become 2 point, like that. So we got great numbers, undoubtedly, for the LAD ostium, L6 ostium, POC, and LM. I think we got some 9, 10, 11, 12, 13, 14, like that. And of course, second part. And this is a final. Thank you, one and all. Sorry I took some time.
We had some discussions. Thank you.
Thank you, Dr. Shiva. It's an excellent case. Thank you, Anil and Varma. We've come to the end of the session, and I think we'll break for lunch.
We're moving on with the next session, the session on the CTO symposium. This is for wanting to catch up with the live session that will be happening today evening. So may I please invite the chairpersons, please, for this session. Dr. Vijay Kumar, Dr. Mahesh, and Dr. Ashraf, please. Lunch will be open till 3 p.m. I request you all to kindly help yourselves as per the time. We're moving on with the CTO symposium. Dr. Vijay Kumar, Dr. Mahesh, and Dr. Ashraf to chair the session, please.
Let's have lunch break. Otherwise, I'll have to chair, speak, and listen. We'll have to. Just telling them.
What time do you?
20 minutes break.
Okay, this is on behalf of the organizer. We have a 20-minute break, ladies and gentlemen. Request you all to kindly come back on time. I invite the next set of chairpersons onto the dais, Dr. Vijay Kumar, Dr. Mahesh, and Dr. Ashraf. Dr. Mahesh and Dr. Vijay Kumar are already here. We hope Dr. Ashraf will be joining us soon. Over to you, sirs. Over to our chairpersons, Dr. Mahesh, Dr. Vijay Kumar.
So, good afternoon, welcome you back. So, we are going to start the CTO symposium, and I call upon Dr. Radhakrishnan and Dr. Ashraf. They are there, please come and join with us. The first talk is on imaging in CTO PCI by Dr. Nakamatsu. Please, Dr. Nakamatsu.
Okay, good afternoon, everyone. So my name is Dr. Nakamatsu. I deeply appreciate that you invited me. And so now is taking the lunch. Okay, okay, start. So my talk is imaging in CT PCI. In this time, I would like to focus on the CT image and IBRS, and I would like to discuss a little bit in the future. Sure, like this. And the first of all, that I would like to discuss about the CT image, the CT guide for CT PCI. When to do a CT image, and what we want to know, we can analyze. Personally, I would like to summarize 4 issues. One is the toxicity of root. The second is calcium distribution, and the collateral root, and especially an extracardiac root. The others mean an entry and the best size. Now I would like to show the case. This one is the RCA CTO, and as you can see, so this CTO length is a bit quite long. From the beginning, the austere part of the RCA, their exit is here included the distal bifurcation. So in this time, very difficult to estimate the actual the morphology, and using by angiogram, and even if the bilateral one. So the toxicity, how about this? I will show you the left side the picture or right side picture. So everybody cannot know that the actual toxicity by bidirectional injection, even if. But maybe the CT angiogram can reveal toxicity segments. And okay, please look at these actual CT images. And for the LAO, we can see the toxicity like that. And for RCA, RAO, the toxicity is like that. And using this angiographic view. Okay, I know, so this a CT image can catch up on the diastolic phase. But even if the diastolic phase, we can see this the toxicity meant actually the more complicated toxicity, maybe. Okay, And due to the this like tochasty, I think the impossible to passage from the antegrade by the guide wire manipulating. So in this time, the started the bidirectional manner, and as you can see, this antegrade system then going to the how to say that? So going to the very tortuous the route like that. So the route is already perforated or not? Please remember that the previous CT angiogram, the image. So we already confirmed from the LAO view and RAO view. So the compare with the previous CT angiogram, the route, so maybe the seems like the same as this actual antegrade guide wire route. So maybe this one is not perforated. Maybe this antegrade guide wire going to the CTO lesion, and even if there are extra plaque. And finally, we perform the reverse cut technique. Finally, we can get the good result like this. So I will show another case. There was no calcification. So, and this one is a bilateral injection. They build the RCA along the CTO lesion. So there's no calcification. Look like. But actually, they are checking their these like CT angiogram. We can confirm the calcium distribution. And the more high sensitivity and checking the calcified part compared with the angiogram, And from there, this curved MPR emerge planar the reconstruction, and they can develop this calcium distribution. So, and from the angiogram, there is no calcified part, but from this CT angiogram, we can confirm the calcified lesion. And where is? So this distribution to be in the center. Center means to be difficult to perform the antegrade procedure. That's why. And going to this antegrade guide wire to the interplaque of the CT lesion, maybe touch with this calcified lesion, and there may be automatically going to the extra plaque. So this is like situation that be difficult to the passage by the guide wire by the antegrade. So, and there maybe that this lesion have the possibility of the final procedure is retrograde. So, but actually, so in this time, I started from the antegrade, and but this and as you can see, and this guide wire going to the it looks like an extra plaque and touch with something. So the compare with the previous CT angio image. So maybe this part is here a calcified part. So this calcified will be in the center of the vessel. So in this time, immediately I switched it to the retrograde manner. So that I performed the reverse cut technique to finally, and we can get a good result like this. And I showed another case. So this one is here, the diagnostic, the angiogram. And as you can see, this lesion is very quite long. Looks like go along RCA CTO. And definitely, this CTO that started from the beginning, the austere part of the RCA. But please look at the right side movie. Where is the exit? So we can see that looks like completely the flow like that. So very difficult to confirm the CTO, the exit, actual exit. Is this lesion is quite long or not? Where is the CT exit? But due to the performing the CT angiogram, we can confirm the actual CT exit. So from this case, and very amazingly, that we can confirm the extracardiac collateral channel from the bronchial artery and the bronchial anomaly artery. So this anomaly bronchial artery that continuously to the going to the heart, and finally this bronchial artery connected to the RCA. And as you can see, so there are this bronchial artery connected to the just CTO exit part like this. And so actually this CTO lesion looks like the long one by the angiogram, but we can confirm that this lesion is a short one by the CTO angiogram. So actually this case in the can perform from the antegrade first, And finally, this guide wire going to this two lumen like this. Then I would like to move to the IBUS talk. And IBUS guidelines for anti-receipt PCI. We have two manners. One is IBUS guided entry. The second is IBUS guided rewiring. So firstly, I would like to discuss about IBUS guided entry. And as you know, this algorithm is a very famous one, the APC to cloud algorithms. And after that, careful analysis of the angiography or the CCTA and the approximation cap ambiguity, yes, okay, and we can go into their IBUS guided entry procedure. But so I have a clinical question: how is the efficacy of IBUS guided entry procedure? So, and we checked the Japanese CT experts released data 2017. So in this year, the domestic cases and their intention to treat antegrade no-stamp case is a totally accumulated 150 cases. And we make two categories. One is confirming the wire position at the intima. So that means an IBUS guide entry and performing, and after that, insertion to the guide wire to the CT region. And after that, confirming the guide wire position by the IBUS, be in intima as be in intima. Easier number is 40. The others. So from this data, and the group is confirming wire position at intima is superior the guide wire success and antegrade success, and more or less rescue retrograde moving the manner and compare with the others with significant. So the key point for performing the IBUS guided entry is confirming the wire position at the intima. We named this like manner. The procedure is a complete IBUS guided entry. And as you know, that we have some systems of IBUS guided entry. The one is a basic system, the IBUS at the side branch, and the conventional microcatheter, single lumen microcatheter for CT wire. This one is a basic system, and we can perform it using a 7 French. And the middle one, the middle schema one, is a dual lumen microcatheter using a dual lumen microcatheter system. It's here due to the using a dual lumen microcatheter, and we can get a good backup force. But we would like to recommend please using the 8 French guidance. So that's why for avoiding the thrombus. And the right side is their already published Dr. Kinoshita slipstream system, very simple one. And they're going to the conventional guide wire to the side branch and light on the IBUS and light on their same guide wire with the dual lumen microcatheter. It's a very simple system, and we can perform it using a 7 French guiding. And but this system is once get advanced guide wire to the CT region, but very difficult to change the system from the dual lumen microcatheter to the single lumen microcatheter. So this in the slipstream system is very suitable for the short segment of the CT region. I will give the tips for the performing this IBUS entry. In the side branch, which is close to CTO region, is useful for the confirming the guide wire position, but by IBUS. And I would like to show you the actual case. This one is the LAD CTO. And it looks like this lesion is not so long, within 20 millimeter, and there's no the calcified lesion, and there's no toxicity. Looks like maybe we can accomplish by the antegrade the manner. Okay, and we can see the very nice side branch for performing the IBUS guided entry. So actually, basically this entry is ambiguous. So in this time, though, due to the short length of this CT region, so I performed the slipstream the procedure, and get advanced side branch, get advanced conventional guide wire to their side branch and add the septal branch, and additionally going to get advanced the IBUS, and additionally they gave the dual lumen microcatheter. And even if this system, so in this time we need a very hard guide wire. So I escalated the Confianza Pro 12. So they finally get advanced this Confianza Pro 12 going to the CT region, and after that, and checking the disc guide wire position. Yes, looks like I get advanced to the internal plug. So maybe this route is correct. So finally that we can get the good result like this. So, and I would recommend with another talk is the IBUS guided rewiring. This one is basically a very complex procedure. It used to be, and still difficult to manage. So, but nowadays, as you know, we can and we can do the tip dissection method. So this method is a very simple and reliable and anticipating the direction of the guide wire advancements. And maybe the tip dissection method will be game changer. And I show the schema about the tip dissection method developed by Dr. Okamura. So very simple the procedure. So just only the focus on the guide wire tip and guide wire shaft. Okay, and so this one is here guide wire tip, and this one maybe here is a guide wire shaft. So this direction is here. Okay, and firstly, please check the guide wire tip direction and the shaft position. So please additionally check the CTO body. So due to the confirming these the morphology, and we can very easy way to recognize. So this guide wire should be rotated counterclockwise or the counterclockwise. And as you know, so this Telemo, the Antworp W IBUS. So I know this IBUS is not available in India, but maybe available in the near future. So this specification is tip to transducer length is just only the 8 mm, very suitable for the performing IBUS guided rewiring. And I would like to show the actual case. This one is RCCTO. And looks like easy. So looks like this the lesion have looks like a microchannel, but very difficult for me. And firstly, I use XTR guide wire, but unfortunately, this XTR guide wire, the shortcut via the bifurcation, via extra plug, and I move to the performing the tip detection. So IBUS system is with the term and the WR. And the single room microcatheter, the fine cross, and I use a Confiance Pro, and the likewise. So this one is the actual IBUS image. So and here is the vestibular interplug, and we can see that via tip vector the shaft is here. So in this time we have to change the 19-degree counterclockwise, and after that a little bit take out. So, and after that, take out a little bit and counterclockwise 19 degree and push in. So finally, this guide wire going to the distal true lumen like this. And finally, going to the disc Confiance Pro 12. And finally, we can get a good result like this. So looks like this procedure is a very simple one. So the Dr. Okamura's group and published and consecutively their data. So consecutively the 15 cases. So the duration of the time the performing the tip detection is 2 to 19 minutes. The median is just only 5 minutes. And maybe the very easy way to performing this tip detection method. So nowadays this tip detection method is developed up to the ADR. So this movie is very impressive. We can see here is a true lumen, and this guide wire attached with the vessel wall, can see. And after that, push this hard guide wire and going to this true lumen. So this tip detection method can confirm the estimated true lumen direction and guide wire tip and shaft and direction of the guide wire. And this one is the current summary of tip detection, the ADR. So the compare with the Stingray and the angle-based the ADR is just only the performance at the extra plug to distal true lumen. And very difficult to confirm the guide wire tip direction. Okay, but on the other hand, this tip detection ADR can confirm the tip direction and lesion morphology and where is the correct direction. So the last talk is IVAS guidance for the reverse cart. So maybe you know that if you failed the reverse cart technique, please use the IVAS. Due to the using the IVAS, we can confirm the guide wire positions. Positions mean the antegrade guide wire and the retrograde guide wire. So you know that both guide wire being in the same space is a very easy way to make a connection. But on the other hand, the different spaces is very difficult to make a connection. So this case very easy way to case easier. As you can see, both guide wire in their extra plugs have intimate space. So actually in this time very easy way to make a connection. But on the other hand, so this antegrade guide wire be intimate, and the retrograde guide wire be in their sub-intimate space. So in this time very difficult to make the connection. But we can give the options. And from this IVAS the study, optimal sizing the balloon and changing cart position and move the cap and the original cart. And a little bit I would like to discuss about the forward in the future. So we need now the forward-looking IVAS. We need that. And please make the some company, please make. And nowadays, the Asahi company is developing this system. So maybe you know that this one is a plasma-mediated ablation system. So this is the true lumen mapping and axis vector analysis software and ECG synchronized fluoroscopy. So maybe they are available in the very near future. Take-home message. The imaging CTO, PCI, CT, and IVAS, and in the future, and imaging modalities can support angiogram image. Those imaging modalities give us other insights for CTO PCI procedure. In the future, a developed imaging modality will simplify the CTO PCI procedures. Thank you for attention.
Thank you for the wonderful presentation. Just for the audience, to conclude that the IVAS in the CTO, you can use the side branch if there is side branch and pull back, or without side branch flush occlusion, you can use the IVAS in the submitted space and see you can modify your wire position there to penetrate the true lumen. And then he mentioned about the difference in the IVAS with Boston and the Volcano, and the third one is the Thermo. That can be very short tip, and it is better than the counterparts in CT or PCI. And he made one, you can have both sequential or simultaneous IVAS and CTO intervention. To prevent that, he used dual lumen microcatheter along with IVAS. So that's a unique method. So just use the 7 French and dual lumen microcatheter and IVAS in the same wire.
Okay, thank you very much. Very nice question. And very unfortunately, I would like to recommend please use 8 French. 8 French, and simultaneously they're using this thermo anti-war IVAS and with the single lumen microcatheter.
So you have to make 8 French for that.
8 French
otherwise
is
you
better.
can use the 7 French and either
Yes,
simultaneous
and
sequential.
okay, and if we choose the conventional microcatheter like fine cross, maybe we can insertion to the both the devices the simultaneously in the 7 French, but the friction is very high, and we are afraid of the make a thrombus in the guidance. So that's why we would like to recommend using the 8 French. Thank you.
Practically in our counterpart, when you see the Boston versus Philips, the Boston have a longer shaft, so the
Sure.
better will be the Philips for the CT intervention.
Okay, yes, and the problem is here, that 2 problems, and one is here the distance from a tip to the IVAS. The second is here crossability. So this anti-war thermal IVAS have the good crossability. So some of the Japanese guy that try to cut their tip using a scissor, therefore the shorten the length. So this is one kind of tip.
Thank you, Dr. Nangavatsu, for the wonderful talk. Due to paucity of time, we got to move on. I request Dr. Gerard Werner to take on the stage. He's the first German cricket fan I've come across. We had a in-between discussion about tomorrow's match.
Thank you very much. Thank you for having me here. Dr. Verma invited me long ago, and it wasn't too difficult to get the e-visa. So the Indian websites are very well developed. So outcomes, it's a little bit an ambiguous term. Is it long-term prognosis or the immediate outcome of our CTO-PCI? And success rates, this is the topic. There is a classic paper, I think, that sparked the idea from Mid-America Heart, 20 years experience from Barry Rutherford's group, that CTO success is better for the patient than CTO failure. And they matched cases with with regular PCI. But what does the difference do? Is it the failure that is harmful or the success that is beneficial? At that time, of course, the success rates were in the range of 70, maximum 80%. Complication went down over the years. But what's very important, I take always from this paper is when you as an operator failed, don't leave the patient alone. The CTO failure without CABG was the worst outcome. If you put the patient to an alternative therapy, they did much better. More recent paper from the Canadian Multicenter Registry confirms no revascularization in a CTO is worse than revascularization, and there were different modalities of revascularization. CABG seemed to be better than PCI, but of course we have no direct comparison. The single largest registry is from UK in the mid-2010s, comparing more than 14,000 patients. Again, CTO success translated into better survival. CTO failure was detrimental. Again, we don't know what would happen to these patients if we leave them alone. We have a lot of comparisons of these registry data. I just picked one from India itself, and it's all uniformly demonstrated that in the registries, all-cause mortality is better if you do a CTO procedure successfully. But randomized comparisons are not there. And I will tell you that they will be never there, because if you look at the mortality in the registry from UK, really every patient was included. You see the mortality after half a year was in the range between 1% and 2%. The open CTO registry from US, also taking every patient, had a mortality of 2.8%. If we look at the two randomized trials currently available, which did not go into long-term mortality, Decision CTO and Euro CTO, you see that the 1 year mortality was below 1%. In these studies, we only include the healthy patients, so to say. The really sick one is not included in a randomized trial. That's why we will never see a benefit. But that doesn't matter, because we have proven in the EuroCTO trial that we improve the quality of life. And improving the quality of life, no symptoms, without additional tablets, is a valid goal of medical therapy. What I came across, and there are not many data regarding that, but I think I came across this data from Dr. Muramatsu, where he looked into the long-term survival and looked at whether the patient had a consistent patent artery or whether it occluded during the course of time. And you see that it is very important to keep the artery open. So we come to the real procedural outcome translated in a good long-term outcome. Taking the good stent. And surprisingly, despite all the fuss about getting even smaller struts, in the CTO setting, in PRISM 4, in a randomized trial with angiographic follow-up, the science stent was still the best to preserve long-term outcome, lowest in-segment restenosis as compared to one of the new very low strut thickness stents. And of course, as compared to the old Cypher stent, stent thrombosis was much reduced if you used modern, still, I think, standard stent that we use in CTOs. And of course, we would assume we had the discussion today already about left main and imaging. So it's even more intuitive to assume that in the complex situation of CTO, and Dr. Nagamatsu just showed you these wonderful examples, that we would expect that imaging favors outcome. But actually, if you look at this meta-analysis, which was done by a group I was part of, does not show any data that confirms this if you put all the data together. The only really favorable outcome was less stent thrombosis. So again, here we need to have further studies in the future. How do we improve the success rate? Because we have seen successful procedures are better than failed ones. And it's obvious, it's depending on operator volume. This is a classic analysis from Manos Prilakis from the NCDR registry in US. Success rate increases with annual CTO volume. At the same time, MACE during the procedure decreases. Another study from the group that does a lot of ADR, this registry showed again operators that did 50 to 100 cases or even less than 50 cases per year, their success rate was in the range of 80%. Only those who did more than 100 cases per year achieved a success rate above 90%. And I think that is the only acceptable limit or threshold that we should have today. 80% is not good enough in our times. But the reality is that CTO PCI is undertreated at a low level of expertise in most countries, in US and as well as in my own country. So how do we get people becoming better operators? It's a different skill set because you have to learn to manipulate wires with a higher risk of perforation. You heard of 12-gram wires, we even have 20-gram wires. And you need to manipulate these wires in the region of no visualization. So seeing CTO PCI performed without contralateral injection is still happening today, but it is a crime. You need to get experience with a multitude of devices, and the number of devices is increasing every year. And the mindset must be there. Not everyone will be a CTO operator. I have people in my lab watching the cases, and then I had some time a guy who is certainly a good operator. He asked me after 15 minutes, do you have a threshold when to stop the procedure? Maybe he should have asked me after 4 hours then. But after 15 minutes, maybe it's not his way to become a CTO operator. I learned from masters, watching cases. Here, Hideo Tamai, he was my mentor. He got me to Japan to learn more of the CTO PCI. And of course, you need to learn what happens on the table, all the different devices. Now, operator volume is, again, not well defined. There is an interesting study from Progress CTO, this study that's going on in the registry from US. And here, the high volume operator was defined as an operator doing more than 60 cases. Is that really already a high volume operator? There was an interesting observation. Success rate marginally increased with this high volume operator, but they had a higher MACE rate. That was contradictory to what I showed you before. But there might be a risk. If you are too good, maybe you lose your decency or your humbleness, and you take on crazy cases which probably should be left alone. So in our mind, I think 60 procedures per year is not enough. We looked at our Euro CTO registry where we looked at retrograde success rate, And there we defined the high volume operator, the one who is more likely to be successful in a retrograde procedure, by having 60 retrograde procedures per year. That means well above 100 procedures per year. And of course, we learn. So the EuroCTO registry told us that over the years here from 2008 when we started until mid-2010s, we got better in all faculties, also the antegrade, the retrograde, and the retrograde procedure. But there are individual differences. So the club's level right now is 91%. In 2023, that's very good, and there are individual operators who are better, and some, of course, who are a little bit worse to make up this average. But I think 90% above should be achieved. And finally, the technical approach might influence the outcome. That is debatable, but I give you some arguments. That the STAR technique introduced by Antonio Colombo has never enough time to do all the number of cases. So he thought knuckle through and get through at the end and then put stents, proved not very successful. If you put drug-eluting stents there, even then you have an occlusion rate of 50%. But unfortunately, STAR concept is revived now with the new knuckle wires like the Gladius MG. And even I do some knuckling if it's necessary. It's of course better to knuckle and dissect than to fail at all. And then you create an investment procedure. But don't do the mistake of STAR. Don't put stents when you are not sure where you are ending in the vessel. Rather in these patients back. And if you look at the outcome with ADR, still popular in talks, but not really popular in reality, at least not in Europe. Less than 2% is ADR. But there are few angiographic follow-ups, and the one that is published and available shows you 45% restenosis. And of those patients who remained open, often you see these severe and ugly aneurysms. And when you go with the US strategy of dissecting, then you will end up with a lot of subintimal pathways. These are IVUS data from the Columbia group. Even with antegrade wiring, 20% subintimal. Retrograde dissection reentry, 90% subintimal. And when you are subintimal, you have branch occlusions, you have more perforations, and slightly more tamponade. If you go the anatomical way, the IVUS shows you that you are only in 12% subintimal and even only in 25% of the retrograde procedure. And I show you an anatomical approach. This was a case where it was not such a long occlusion, but it was for me unable to get through antegradely. I went subintimal, I go retrograde, and had some knuckle there, and then retrograde goes up, but I want to see how will I have to put stents. And you see the antegrade ultrasound position is subintimal. So of course I could stent there, but there was a good situation where I could reconnect differently. So I rewired with a retrograde wire as a marker and put the antegrade wire in the same space like the retrograde wire in the luminal space. And if you put the stent there, you preserve all these hundreds of branches. And these branches are not just made for anatomical specimens, they have some real world use. And there are a few data, often ignored, that tell you if you shear off septal branches like this, then you will really have perfusion defects after these complex procedures. These are data from dissection reentry groups. The persistent perfusion defect is more in ADR and RDR. And if you lose RV side branches, you have impact on the right ventricular function. And if you look at these data, subinterstitial versus intraplaque crossing, the TVR at 12 months is much higher when you have subadventitial crossing. So no wonder if you have these high rates of subintimal passage that the MACE rate is more than double after 1 year. But these data are from the ADR group. So let me finish. CTO PCI should be performed only with a presumed high success rate to guarantee a good long-term outcome. High prevalence of CTOs requires a higher number of trained operators to perform CTO PCI. It should be incorporated in every large institution's intervention program. The technical approach to CTO PCI does impact the long-term outcome. Anatomical reconstruction, I think, should be preferred to primary dissection. But of course, if there is no alternative, even I will throw a knuckle. Thank you.
Great talk. And just have a query. Many of the CTO cases, distal segment very diffusely diseased, the distal segment. And the success means the recanalization or without standing. So suppose if you are leaving the distal vessel as such without standing, these patients do better rather than standing because there will be positive remodeling on long run if you opened it and just leave it away and then recheck again. Because many of the CTO long standing, there will be diffuse disease distally, and making long dissection, you are making increased chance of ISR. That's why one of the slides showing almost 19 to 30% of the patients having diffuse ISR or 10% having occlusive ISR after standing, even after successful CTO PCI. And second thing about the retrograde, reverse card, the subintimal tracking, many of the time it is because of the collapse of the true lumen when you are putting the antegrade wire. So to prevent that, IVUS usage, or you can inflate the balloon in the subintima with 1:1, the size of the proximal vessel. So we can avoid the collapse of the, a true lumen.
Okay. Thank you. The point about the patients is well taken. I usually start cribbing after 12 minutes of a CTO, when can we stop? So I think it requires a different kind of mindset, different kind of personality. Great work. Please continue. Thank you very much.
The last part of the session, live case in the box by Dr. Anand Nyanaraj.
All right. Thank you. Thank you, Verma and my friends, for inviting me. So this is a patient we did about 2 years ago. A 66-year-old diabetic had CABG in 2007, diffusely diseased vessels. Lima was flowing but diseased. RCA was not grafted at that time, and SVG to OM flowing but very small vessel, and presented with pulmonary edema in 2019. So I had stented his proximal LAD into the septal to increase the flow for the RCA. And even then he was still symptomatic, so we had planned for the RCA CTO. Then COVID came and patient never turned up. Then August 21, he came with pulmonary edema with an end STEMI, severe LV dysfunction, then managed medically and planned for angiography. So this was the Lima, and you can see the LED is diffusely diseased, trying to supply the RCA. And RCA was, proper CTO. And the duration of the CTO we don't know. And you can see again in the cranial also that LED is okay, but too small to support the entire system. And this was his left main to settle. And I did the angiogram and didn't look too bad, so decided on medical management, shifted to CCU, and there he had severe angina, ST depression, so brought back to the cath lab and stented that proximal part of left main. Patient immediately stabilized and shifted him, and he was still on the table. I was talking to the attenders, and there was a call from the cath lab, went back, left main occluded. So he had arrested on the table, and so with resuscitation, it ballooned it again. Then once the balloon was done, he stabilized. We put him on IABP and temporary pacing. He was extubated. Every time this guy recovers pretty fast. Next day, IABP was removed. LV function remained bad, but his heart failure clinically improved. Discharged again. Then I told him that we'll do the RCA after a month. But 5 days later, he came back with another instomy and again pulmonary edema. This time it was refractory. We really could not, get him out. So I just gave a mortality of 30%, which was based on nothing. But I had no other thing to say. So anyway, so we took him up this time. So this was the actual live in box. I'm not able to control the video from here. Can you project it now? Project it now. No MR. We didn't check viability. Can you play that? So this was accidentally recorded because we had a live case on that evening, so the entire setup was there. So I just thought we'll record it. We started the case relatively uneventfully. Then you can see again this stent was patent, but he was still very symptomatic. So I took a bilateral injection to see how long the RCA CTO was. So just at the end of that injection, he arrested. So we had to pull out and shock him multiple times. So this went on for about 5-10 minutes. Then again, I was stuck. I was not sure what to do next. But then this patient was not going to come out alive. Nothing can be done. So I decided to wait for him to recover a little bit and then proceeded with the procedure. You can see that a lot of things are going on. Then we had to massage him for some time. This was just injecting both right and left coronary at the same time. Both were side hole catheters, EBU and JR. So going forward, there's a lot of massage there. Okay. So finally, we got back to the procedure, and massage has been going on for too long. Okay. So we got back to the procedure. So this time I decided not to go, not to inject bilaterally. And I thought I'll take a microcatheter down into the PDA and then decide what to do. So we wired with the fine cross because that was I thought that was the catheter that would occupy the least amount of space in the septal. So we had the wire in the PDA. So I took the fine cross down to PDA. And took an injection there. So it looked like a decent sized PDA. So after this injection, again he arrested multiple VFs, VTs, and so this time and retrograde approach was ruled out. So there's nothing, we cannot use the septal for anything beyond that one shot. So we put him on an IABP and TPI. Again, massage is going on for a long time. Then we got him intubated also. I mean, I'm just moving the time frame, but still there is. Okay. So finally, we decided to do it antegrade because that was the only option left other than abandoning the case. That looked like a relatively safe option in this situation. So we crossed with the Fielder XT wire, but that caravel would not go past that point. And the wire also would not cross beyond the mid RCA, mid distal RCA. Tried multiple wires. Every time, everything would back out and I had to stop from the beginning. So this was a Fielder XT, which crossed to some extent. I think this was a Gaia. Then I tried to dilate it with the balloon, the proximal part. This is a 1-0 across CTO balloon, just to create some passage for the microcatheter, and I could get it up to this point. Then, of course, the wire wouldn't pass any further, and I was not sure where we were. And in all this confusion, I could have taken a radial access and injected from Lima to see where it was, but that never occurred to me at that point. So, still struggling. So all kinds of, then I switched to, again, lost access. Then I switched to Corsair XS Pro. There seemed to be some progress, but the microcatheter was still not going. So I had to balloon it again with a 1-0 balloon, then 1.2. So then I will come to the presentation part. Okay. So this is where it was stuck. Then this is an interesting picture. The wire was not going. So I took a new Corsair XS Pro, and the microcatheter just went through it without a wire. And that was a strange thing that happened. You can see that. So the microcatheter actually crossed the most difficult parts. And beyond that, it was quite easy to track the wire down into the PDA. Assumed it was PDA. Then with some difficulty, I was able to take the microcatheter down. And exchanged it for a Grand Slam to have some support. And of course, stented the whole thing. So at the end, you can see that there was a very small PDA, disappointingly small PDA, but it was flowing. And we extubated the patient after 3 days, discharged him, follow-up of 6 months, he is doing well. And he had one episode of influenza A pneumonia and survived that also. And he has got moderate LV dysfunction. And the big regrets are I should have taken a third access. and that would have made it a little easier. And without verifying distal wire position, pushing hardware is not a good idea. And conclusion is all is well that ends well. And doctor saves a patient who's destined not to die.
Dr. Golraj, very great case and very great end result. I think the most probably the septal is so huge, so that means even before there's a chronic total occlusion in the lady, and this septal is giving most of supply to the.
Yeah.
So that is going to the moment you wire, the usual scenario there will be spasm. That spasm retrogradely.
No,
retrogradely going into the left.
I don't
main
think there
duct
was spasm. I think there was delay in the dye being removed from the distal bed of RCA.
Probably microoscopy.
So that caused a lot of. But when I injected from the microcatheter, that episode lasted almost 20 minutes. His VT, VF, hypotension lasted a very long time. So
the patient improved probably that the PDA that definitely improved.
Thankfully, we were able to get into the true lumen distally antegrade.
Dr. Werner has a comment.
Yeah, I was wondering about the circumflex. Was there no circumflex?
I didn't look for it.
No, but
they didn't.
You know the patient for several years.
Yeah, but I think the first time when we did the PCI, there was a venous graft, and there was a very poor distal flow of the circumflex, and it was not a big vessel. So I didn't look at it. The first one, I don't have those pictures. I never went back and looked at it.
That was
okay. Thank you very much. Very nice case presentation, Dr. Anand.
Thank you.
So very tough one. So I deeply think that calm is a very important. CALAM is a very important and for the parent. Thank you very much.
Yeah, I think to maintain calm is the most important.
Anand, Dr. Anand.
Yeah.
Basically, that was the microcatheter going into distal intentionally without wire is intentional or
intentional.
Very good, because many of the time, if there is difficulty, because when your wire is there, it is difficult in passing the microcatheter. You take the wire softer part, so that will become more toward the center, and it will go into the mid part of the RCA.
Yeah, the wire somehow tends to knock on
the side,
sharp corners,
to the
whereas this acts like a cross boss. And I have done it more than once.
The usual technique, if you pull the wire little bit proximally, the softer part will be at the end, and that will float in the middle.
Yeah.
So it won't, the microcatheter hard part won't come with the calcific part of the vessel wall, more in the center of the lumen. So that is nice demonstration.
But the last time I tried that, the tip of the microcatheter got stuck into a calcium and broke off. So there are problems also.
Okay.
Yeah.
Yeah, just looking back, do you actually think that CTO opening into occlusion was the one that saved the patient?
Yes. Because I did nothing else. That was the only procedure that was done. And his heart function has significantly improved, which it has not happened over the last 1 or 2 years. And he is in class 1 symptoms now.
The patient is practically surviving on the lemur. What gave you the idea that you should approach through the lemur?
No, I would not have approached through the lemur.
Your last sentence.
No, I would have taken a 5 French to see if I was in the PDA.
Okay.
Just to have a dual.
It was a wonderful case. So I'm just making a small joke. You should give a pneumococcal vaccine.
Thank you.
The
Thank you.
PDA actually gives some rise to the septal colon, septal. So revascularization of the septal vessels often goes a long way in improving the ejection fraction and the contractility and overall survival.
Yeah, the first procedure was actually lemur to LAD to septal.
Yes.
I had stented from LAD to
But what
septal.
I'm saying is the RCA.
The reverse, okay.
Yeah, RCA, while you improve the antegrade flow to the PDA and the posterior part for the septal, the posterior interventricular septum gets vascularized better. And that is often a good way by which, even though it appears like a very small vessel, the degree of improvement is much marked.
Yeah. Thank you.
Thank you, Dr. Anand. I'm always a fan of your wire work. The wire movements are excellent. Thank you.
Thank you very much, sirs. Move on to the bifurcation symposium. May I invite to chair this session Dr. Joby Thomas, Dr. Rajesh from Amrita, and Dr. Rajiv C. The first speaker, Dr. Mahesh.
Thank you, Dr. Anand, for giving us some spare time. We are almost running close to time. If we finish the bifurcation symposium in the next 1 hour, we will be good. So I just remind the chairpersons to try to keep to that time.
I need my 15 minutes.
Definitely, your 15 minutes is yours.
We'll have all the 3 talks first and then have the discussion.
Thank you. So, I'm supposed to speak on the philosophy and practice of provisional stenting. I thank Dr. Anil and Dr. Verma for this opportunity and fabulous audience. Thank you. So, I will be speaking philosophy, biology, chemistry, and a little bit of physics. So, this is the physics part of it. So, why does this, how do I get the laser on? For laser? No, there is a... Control L is usually. That'll do. Very late. So the point I'm trying to stress is that, see, where is the areas of maximum stress for 1,200? It is at the ostium of the circumflex and ostium of the diagonal. So that's where the bifurcations where you have the maximum stress, and whatever you do, you're only going to increase this. And sorry. So the physics of the stenting shows that there is a significant change in the flow patterns after we make a stent, and so the stress on the vessel, the damage to the vessel, and the flow patterns in the vessel change significantly. So you cannot quite predict as to what is the good result that you've got just by looking at the flow. So there are some factors which are very important. It's called the right contour, the left contour is the proximal main vessel, the distal main vessel. You have the side branch. You have a point of bifurcation where the artery is actually bifurcating, and you have one area which is the called the largest possible circle touching all the 3 contours, and you have a polygon which is 1, 2, 3, 4, 5 sides. So this polygon is very, very important, and the aim of the whole bifurcation lesion is to keep this polygon intact so that your flow and your final results are good and the future results are good. So what are the side branch? Side branch can be classified into non-left main bifurcation and left main bifurcation. All left main bifurcations are considered as prognostically relevant in side branch, so you just got to treat them as relevant. So category A is with angiography, category B is with intravascular imaging. You have side branch length, or what is called as an SNUH score, which is a size, number, height. So you have to define whether that side branch is going to be of significance to you or not. You have category C with coronary CT and category D with myocardial perfusion. With the echo, there should be more than 3 territories, and for SPECT, there should be more than 10% of reversible ischemia. So once you have defined that the side branch is significant, then you have to respect the side branch accordingly and make sure that you tackle it the way it should be tackled. Medina classification is the only authorized authority or method of classification which you can use for defining your studies and defining all your parameters. So you have 1, 2, you can have multiple side branches and then name them accordingly, and then go ahead and make it a bifurcation or trifurcation as you like it. So the ABC of approach to complex bifurcation lesion is with the provisional stent strategy. Stage A is the main vessel and side branch wiring, full stop. Stage B is main vessel and side branch preparation. Stage C is stent implantation and optimization. Only 3 steps to be remembered. Keep it simple and keep it fast. So this I will in my concluding slide, I'll talk to you about this presentation. So you have a left main, what looks like a good ostium of a circumflex, and you do a significant pinching of the circumflex post your provisional stent. How do you deal with this? We will ask your opinion after the discussion is over. So approach to bifurcation, the philosophy, 6 or 7 French system. The bigger the system, the better it is. Please go with the 7 French.
wiring to the more difficult side branch first, prepare the main vessel, routine dilatation of the side branch before main vessel is a question mark. There is one study with Pynatol which suggested that it will be good for the future outcomes, better. There is a second study which says that the long-term outcomes of a side branch dilatation is bad. You decide. The bottom line of my presentation will be it's operator dependent. You got to take a call. So if there is a very tight side branch, you should actually go ahead and dilate it. Second point I would like to stress is about POT. POT is also called proximal optimization technique, which was first introduced by Dr. Olivier in 2007. Stenting of the main vessel is done according to the distal sides of the main vessel. Hence, the POT is required to optimize the proximal side of the vessel. Everybody does POT for practically all the cases of bifurcation that we do nowadays. Ensure the adequate length of the stent in the landing. There should be at least 6 millimeters of stent in the proximal portion because that's the smallest POT balloon you have of these days. It's a non-compliant balloon. Most of the time, there are very exceptional occasions where you can use a semi-compliant balloon. The position of the POT balloon makes all the difference. It has to be immediately proximal to the carina, and the dilatation should cover the length until the proximal edge of the stent. I will show you in diagrams for making. The side branch stent, after the side branch stenting, if you have done a side branch stenting, the new metal carina is present and the final POT balloon should be proximal to this carina, should not go on the carina, it will spoil the fun. POT technique improves clinical outcomes by optimizing the final stent. And if you have done a kissing balloon, you have to do a repot, mandatory. So this is what I was trying to stress. You see this? If I push this thing forward as much as to the metallic carina and then to the stretching, the side branch opening gets significantly narrowed while pushing it so close to the metallic carina. If you stay away from the metallic carina, the side branch opening is much better. So when you are doing a POT, you should make sure that the metallic carina is not damaged or not interrupted upon by the POT balloon. So what is the change in the side cell after the final POT? This is the distal. You have to try and always distal rewiring is mandatory. It should not be proximal, that's all. So when you do a distal rewiring and final POT, you can see that if you have got a final POT across the stent, then you have minus 31% in the area, and here you have minus 43% when you have proximal rewiring and POT. So basically what I'm trying to say is that any approach, whether it's a kissing balloon or a provisional stent with a POT, side POT, repot approach, everywhere you should try and get to the distal and stay away from the carina and do not disturb the carina. You'll get a better volume across the diameter of the side branch remains bigger. Just one sentence about a POT, dedicated POT balloon which is coming. The advantage is that being that the shoulder is very short. Net result is that you don't go inside. Even the small portion that goes into the side branch doesn't go in there. This is just a case in picture. So you have wired the left main and the circumflex. The POT balloon is in the left main, withdrawn slightly, and you can see there is a sharp cutoff. Due to this sharp cutoff, there is nothing trickling into the main branch or the side branch, and that way you get a much better result in the end of the day. So you have a dedicated POT balloon that's already available. It's got a very short shoulder length. So one point about kissing balloon, the philosophy of kissing balloon. In provisional sending, KBI is optional. Balloon dilatation into the side branch, if you have done, then kissing balloon is mandatory. The side band distal strut crossing is important for a good kissing balloon result. If you happen to go proximally, then you may end up having to stent that area. The use of non-compliant short balloons with short overlap, the ones I told you. Size according to the reference diameter of the main vessel and the side branch. In kissing balloon, it's recommended to inflate the side balloon first. So you inflate the side branch balloon to 12 atmospheres, deflate it to 4 atmospheres, inflate the main branch stent to 12 balloon to 12 atmospheres, simultaneously inflate the side branch. So 12, 4, then both 12. That's the policy you should follow for kissing balloon. Always perform a POT or a repot if you have done the POT already. There is a modified multiple modifications of kissing balloon that is there. One is this pressures, what I told you, and the other one is a controversy with Dr. Verma. It is called POT, side POT, repot. It is the study has come out comparing 148 patients of side repot
side port, report versus kissing balloon, 148 and 134. The final diameters or circular diameters were better with the first technique. So provisional sending routine KBI is not required. First study was Nordic bifurcation study, then the COBIS 1 registry, which you usually used in the previous generation of stents, and COBIS 2 registry, which showed the newer generation of stents, that the routine final KBI did not make any difference. So when should the stent branch be treated using a provisional strategy? No consistent definitions, again operator dependent. So angiographic criteria from serious bifurcation trial, Pan et al., everybody says more than 50% stenosis, do the side branch study. Then the intravascular imaging criteria, October trial says side branch minimal diameter, less than 50% of the side branch reference diameter. You should go ahead and do it. Physiological indices are also a way of not doing the side branch. The significance of side branch compromise that warrants further interventions is at the discretion of the operator. Everything in bifurcation is at the discretion of the operator. Following part, the operator determines whether further intervention is required. If SPV intervention is required or deemed necessary, then that has to be rewired. I'll show you the methods, and Dr. Jaber will take on from there. So, if the side branch yields a suboptimal result, further stenting using T, TAP, or culotte technique is recommended. Ideally, the side branch is wired through the distal strut. That's very important. If proximal strut is only the one that is accessible, you'll have a more difficult time, but you'll get equally good results. So, what I was trying to say? You do a main branch stenting. Step 2, you do a pot, and then you get a procedure. End of the chapter. If you got a good result. Now, if this doesn't work, you have to rewire into the side branch. Preferably take out the main branch stent, put it into the side branch stent, and reverse it. You can also use a third wire. And then you do a kissing balloon, and then you do a report. And at the end of the report, after the kissing balloon, if you're looking good, your procedure is over. If you're not looking good, the rest of the things will be dealt by Dr. Jaber. You have to go for provisional stenting. So, if in provisional stenting, just one word, if you can manage to the distal strut, your provisional T stenting, which is the easiest thing you can do. If you are not being able to manage through the distal strut, your proximal strut, your options are culotte and tap, and both will be discussed in the subsequent lecture. So, provisional pathway, second stent, T stenting. If you have got a very bad side branch, that is again very simple. Put a stent into the side branch, do a pot, a kissing balloon, pot, and come out. These lines, these cartoons below show you the complications that you can land up with, and the solutions to that is beyond the scope of the lecture. So I'll just stick to my part of the story. This is how you manage straightforward side branch stenting. There is a second option of a tap, and third option of a DK Culotte. These are the options you have in case you have not been able to manage with the provisional strategy. Just be careful that you don't push your catheter in too much, damage the stent proximally, and cause shortening of the stent. LMCA EBC main study did not show any difference in triple primary endpoints of death, myocardial infarction, and target vessel revascularization in provisional stenting approach and systematic two-stent approach for left main. So both are equal, provided you do it well and provided you know which are the ones you mandatorily need to go in for two-stent strategy. If the DK crush, there's always a fight between the Europeans and the Chinese on this strategy. The double kissing DK crush, 5 primary endpoints, 5% in the DK crush arm and 10.7 points in the provisional strategy arm. So they said that the DK crush arm is much better. So provisional stenting strategy is generally recommended for the simple left main bifurcations. If you are consider upfront two-stent technique in complex left main bifurcations, and if you are planning a two-stent strategy, as of now, the strategy of choice is DK crush. This is the Thomas J. Ford article which says that single stenting is better, and this is the article from Dr. Meng and all, which says that single stent is as good as DK crush, but systematic dual stenting strategies showed a tendency towards lower incidence of stent thrombosis and CV mortality. That fight will go on. We have to take a call as to which side of the story that you are linking with. Finally, imaging. Imaging is mandatory in all good bifurcation, and it's going to become probably class 1 in left main. Intravascular imaging, is very important for stent optimization. The thresholds were 5, 6, 7, 8 previously. Now it has gone up to 6, 7, 8, and 10 in the Caucasian population. OCT for angiographic guidance for PCI complex bifurcation lesions, October trial, which showed that the outcomes were 10.1% versus 14.1% when you have done an OCT guided vis-a-vis no imaging guided. Cardiac death, ischemia-driven TLR, and secondary cause outcomes like all-cause mortality, stent thrombosis, contrast, volume surprisingly was less in the OCT group as compared to the non-OCT group because you needed multiple shots to make sure that you're good. Conclusion, provisional stenting strategy is a treatment philosophy that provides dynamic approach to treatment of majority of true coronary bifurcation lesions. Starting with implantation of a single stent in one branch, careful assessment and treatment of the side branch, and with stenting only when required. Acknowledge the pitfalls and consider the approaches to overcome complications as inquired for the procedural step. Finally, this is what happened to the lesion I started off with. This is how they got pinched. FFR was done. Nothing wrong in the FFR. We got a 94%. Left it alone. 3 months later, re-angio shows the circus come back to normal. You just got to be patient. It works. Thank you.
I thought Mahesh will be talking about TAP, so I kept the TAP aside. I'll be discussing the rest of the things. The two stent techniques, bifurcation stenting with 2 stents, it should be as perfect as possible. And this is one thing that provides a better long-term result. You see, and we image and find out how our procedure looks like. A proper main vessel stenting, a proper side branch stent deployment. All these judged either angiographically or if facilities, time and money permits with the use of intracoronary imaging. No luminal, no edge issue in either main vessel or stent side branch, and a perfect neocarina, and no target lesion failure in the long run. So this is the dream we all have whenever we do the bifurcation stenting. And for that thing, what we require is a perfect pre-procedural planning, understanding the anatomy of the bifurcation and knowledge of the procedure what we are doing, contingency plans, and a meticulous execution of every step of the procedure. With proper technique and hardwares, good team, and I also took that word from Mahesh, patience. Patience is extremely important in every case of bifurcation, whether it is a single stent strategy or a double stent strategy. So for optimal 2-stent technique, optimal main vessel stenting, optimal side branch stenting, proper scaffolding in the side branch ostium, the final kissing balloon dilatation, and the report, these all things are important. So how to select the bifurcation strategy? Every given bifurcation is different. So the vessel size, that the main vessel size and the side branch size, always the distal vessel size is the reference for selection of stent. Or, of course, if you do the imaging, you can make the exact judgment on the stent size and the stent length. Angulation, the bifurcation angle, operator expertise. All operators may not be an expert in all the procedures, and what I feel is that you should be an expert in 1 or 2 techniques and go on doing that technique. And also, of course, whether it is left main or a non-left main bifurcation. So we have the 2 stents technique, the T-stent, the kilo, crush and its many variations, the DK crush, V-stenting, simultaneous kissing stent, the double barrel and all these things. Though there are a lot of techniques, most of us will be doing the tap, kilo and crush. Especially now, the mini crush is little out, but when we look at the data, still it is there. But DK crush is gradually catching up almost up. If you maybe 50% of all bifurcation stenting may be tap stenting or using 2 stents, and next comes the DK crush, and then the kilo and the DK kilo. And also the variants, the mini crush, which minimizes the length of the side branch stent, which may be 2 to 3 millimeter protruding into the main branch, or an inverted crush, where the main branch stent is deployed first and then it is crushed by the side branch, or a reverse crush where the side branch stent is crushed inside the main branch stent. So how to select it? The selection is basically by looking at the side branch and see or whether you can rewire the side branch or will you lose the side branch. We decide on an upfront two-stent strategy when you know that the side branch is important. And once we know that side branch is important, we cannot lose the side branch. So if we cannot, our judgment is that we cannot rewire it again, no question, it is a DK crush. And if you can rewire it and the angulation is more than 70 degrees, it could be a tap, most likely it is a tap or a T. And if the angulation is not more than 90 degrees, we look at the size of the main vessel and the side branch. If equal size, I may prefer a culo or a DK culotte nowadays. And if the side branch size and the main branch size, they are different sizes, then a DK crush. So this is the classical culo. The guide catheter can be 6 French or more. Wire both the branches and pre-dilate if required. And the plaque modification depends upon the morphology, especially if it is guided with an imaging. We can decide on what type of plaque modification is required, which is a cutting balloon or a scoring balloon or a rotablator. And wire both the branches. Now leave the wire in the straighter branch. So in the culo, we'll be going to the straighter branch and deploy the stent in the more angulated branch. Rewire this. Then rewire the main vessel. Then the main vessel stent is deployed. Recross, final case. But now the data shows that a little bit better technique, especially for recrossing, because here the problem is a little more of metal carina. A better technique will be a DK culo. So this is a circumflex. It was a long segment disease. We put 2 stents. So this is the proximal stent. Crossed, kissed. So this is the first kiss. The main branch stent is deployed. Again, it is a recrossed, sequential dilatation, the LAD and the circumflex, followed by a kiss and then a port. And this is the final result. You can see the OCT short. There is nothing across the side branch ostium. The side branch ostium is free of any struts and seems to be an optimal result. The mini crush, the only difference is the side branch stent is protruding 2 millimeter or rather 3 millimeter into the main branch. It is crushed with the main branch stent, then recross. Here, most of the operators have felt that the recrossing may be a little tough. That is why we always go for that was evolution of the DK crush. Again, it is cased, and that's a pot is done. So why do we go for a DK crush? And this is the most evidence-based upfront 2-stent technique. And a complete side branch ostia coverage, and the final kissing balloon is 100% success in the clinical trials. Of course, the major trials are operators with excellent experience, and many of the data is from single centers with great experience, and there is an outcome advantage as per the current data. So the DK crush, lesion preparations, that depends upon what is the type of lesion, the morphology. If it is imaging guided, it is well anchored. So we may do the imaging prior to the preparation to assess the lesion morphology and to facilitate the decision regarding lesion preparation, stent sizing, and judging the landing zones. Keep the balloon for crushing in the main vessel distal to the carina. The side branch stenting, 2 to 3 millimeter in the main vessel, and the complete coverage of the side branch ostium with a minimal protrusion into the main vessel. And before crushing, we have to assess all the side branch issue, and it should be tackled before you crush. And withdraw the wire from the side branch and then crush it. Crush preferably with an NC balloon, the size as per the distal main vessel size. And if the first crush is so important, We cannot play around with it, so it should be an optimal crushing. If inadequate, take another balloon of the proximal main vessel size, crush it properly. Once we crush it, rewire the side branch stent. Here, Dr. Mahesh was reiterating the need for a distal cross, but in DK crush, a non-distal strut crossing is preferred, and imaging here is there will be a great help if you can do an imaging. The wire should not be too distal or too proximal to avoid an abdominal wiring. So when we rewire the side branch stent through the non-distal strut, you can see what happens is the proximal cell wiring after the first crush. The wire should be away from this region of malposition. Otherwise, it can promote an abdominal wiring, and some area there may not be the drug-eluting stent. So to avoid a wire during the malapposed struts and abdominal wiring, it's better to be through the central strut. Once you cross with the balloons, sequential inflation followed by the kissing balloon dilatation, two-step kiss at high pressure, individual dilatation, then 12 to 14 millimeter, 14 atmosphere kissing balloon dilatation, and remove the side branch wire before the main branch stent deployment. Now the main branch stent is deployed, recross, port. Mahesh has discussed about the port. There may be some of the slides, there will be some amount of overlapping. Now the recross, rewire, central strut, preferably imaging guided. A sequential dilatation again, followed by a kissing balloon dilatation. And the final port. And final imaging. And this gives the best result of a DK crush, which is a perfect. So this is one case example for the DK crush. A true bifurcation lesion, Medina 111, the side branch stent crushed. It's a recross, sequential dilatation, and the kissing balloon dilatation. The main branch stent deployment, port, recross. If you are not satisfied with the recross, you can take the help of the imaging and rewire. And you can see what's happening here. This is the recross. Then the kissing balloon dilatation. Report, and report is mandatory in all two-stent technique. And finally, this is the image. So a perfect side branch ostium, the carina also look extremely healthy and good. This is what an optimal carina and the side branch look like following a DK crush. So the kissing balloon dilatation, this is a key to optimal result. Most of the operators prefer a kissing balloon dilatation in all two-stent technique. Can see if there is no kiss, it's all crowded with metallic this stent material. And one step case, even then there are the struts and the connectors across the side branch ostium. And after two-step case, if it is a perfect cross and a perfect kiss, you can see the side branch ostium is free of the stent struts. The stent struts will be moved away, and it gives a better result. Not only a better result, anatomically, in the long run, it's even-wise also, it is better. You can see the side branch ostial restenosis in a one-step and a two-step, extremely good if we can do a two-step case. Why should there be the kissing balloon dilatation? You can see the metallic narrowing and the protrusion of the struts into the side branch. And if you do a kiss, it corrects the malopposition, and it corrects the metal narrowing without altering the side branch ostial size or a stent protrusion into the side branch. Of course, it may cause some eccentricity of the proximal stent. And when we kiss, Now the preferred thing is a minimal overlapping. You can see if the overlapping is more, there is protrusion of the stent and deformity. So it's always a minimal overlapping. And the need for a distal cross strut cross in most of the bifurcation, except in the DK crush where we prefer a non-distal cross. It's important to cross the distal stele because if it is a proximal stele, what happens is a poor side branch scaffolding after the kissing balloon dilatation. If it is the distal one, it's a pucka side branch scaffolding after the kissing balloon dilatation. So this is proximal cross. This is the distal cross. We can identify with OCT the then if we are not happy with the wire crossing, if it is definitely a wrong proximal cross, it's better to take out and rewire. But if it is without imaging, then it's very difficult to tell. And said $1 million question, many people have asked, you have, with difficulty, you have wired, now will you take the wire out and do again, check it and go for it? Very difficult to answer. But if you do an imaging, definitely you will do it. And after the kiss, a perfect side branch ostium. So what happens with the proximal cross? You can see with the proximal cross, your metallic arena is crowded, the side branch ostium is imperfect. So port to correct the malposition in the proximal brain branch, facilitates side branch entry, prevents abluminal wiring, it facilitates side branch ostial scaffolding, and it restores the circularity of the proximal vessel. A short NC balloon, 0.5 to 1 millimeter larger than the main branch stent, and distal marker in front of the carina, proximal marker inside the proximal stent. And this is the one that Mahesh also shown, a port balloon which is ideal, but it is expensive. An imperfect balloon position, 2 distal, the carinal shift, side branch ostial lumen reduction. Perfect balloon position, immediately proximal to the carina and reaching the proximal stent edge. So my take-home message with for the optimization of 2 stent strategies, study the anatomy well and plan the procedure with all the contingencies for a plan B. Use intracoronary imaging to guide the lesion preparation, selection of stenting strategies, stent selection and optimization. Meticulous lesion preparation, perfect execution of each step, perfect stent deployment, side branch crossing, kissing balloon dilatation, and port, which are mandatory. Have a good team, discuss in advance, and plan ahead. Time and patience is extremely important. Thank you so much.
So, good evening. I thank Dr. Verma and Anil sir for this opportunity. And after these 2 excellent talks, my talk doesn't have much relevance, but I quickly go through the slides. Okay, can you see the slides here? Hello, right? Continue. Okay. So we all know complex treatment of bifurcation lesions is associated with worse outcomes compared to simple treatment. Angiography is limited by high ambiguity in the visualization of lesions, side branch ostium, expansion, opposition of the stent, and particularly the wire positions. Lack of adequate procedure guidance can lead to unpredictable suboptimal treatment results that are associated with the higher risk of clinical events either during or after treatment. And OCT provides a high resolution visualization of the vessel wall, stents, and wires. And it allows precise measurements and enables stepwise verification and optimization during complex percutaneous intervention. And bifurcation, as we all know, one of the most complex lesion subsets, and PCA requires a great deal of understanding. Contemporary OCT system with ACR and other display options, particularly the stent rendering and 3D reconstruction, helps in understanding the anatomy and stent and vessel wall interaction, ideally suited for PCA guidance. To start with some tips and tricks, efficient contrast usage and optimal image quality are the priorities. First run, you prepare the lesion based on angiography and acquire first ACR and OCT run. And side branch imaging only when elective two-stent strategy is planned based on angiographic findings. And second OCT run after optimization of the main branch stent and the side branch is recrossed with a guide wire. Additional OCT runs after each wire crossing, recrossing. And final OCT of the main branch and the side branch in case of two stents technique. Large pore guiding catheter, increased flow rate and maximum scan range in case of left main bifurcation. So what are the things we had to look for an OCT imaging during bifurcation PCI? One is assessment of side branch compromise, evaluation of adequacy of lesion preparation, identification of landing zones and stent sizing. Importantly, evaluation of side branch stud configuration and guiding optimal side branch wire crossing. Importantly, stent optimization and evaluation of side branch coverage and metal neocrinar length. Start with provisional stenting. The first one is the prediction of side branch compromise. This is an elegant study from Japan, which has shown that first three predictors of side branch compromise. One is a plaque distribution, either at the bifurcation point or at the carina point. The plaque distribution, which is opposite to the bifurcation, is an important predictor of side branch compromise, particularly in the presence of calcified plaque. And then other two important predictors already have been explained, that is your carina tip angle of less than 51 degrees and bifurcation point to carina tip distance of less than 1.7 millimeters. So these are the three important predictors of side branch compromise following main branch stenting in case of provisional stenting. So what do you do? How do you do it? So after preparation, do your pull back and locate the proximal and identify the proximal and distal extent of the lesion, and evaluate the adequacy of lesion preparation and identify the distal and proximal references or landing zones. And the stent diameter is based on the distal landing zone dimensions, and measure the distance between two references that will view the stent length, and ensure that you have at least 8 millimeters of stent for proximal optimization. And once you are done, put the stent in and identify your side branch stud configuration. And the most important thing is to look for a presence of any link at the carina. So the two type of carina, one is link-free carina, and this is connecting to carina. So this is optimally suited for your side branch access and kissing balloon dilatation. So this is how you do it. If you have a suitable distal cell, that is the most appropriate cell for, that is a link-free and a suitable big cell, that is the ideal cell for crossing. Suppose you have a non-suitable distal cell, you cross the next bigger cell here. Suppose you have more than one cell, identify the bigger cell for your crossing. So that is how you select your side branch access cell. And this is an example here. So this is distal RCA bifurcation lesion. So how do you proceed? Do a pullback, identify the proximal and distal vessel size, and see the carina morphology. And once you stented, see the cell morphology across the side branch. And then you cross with the wire and identify the distal crossing. And once kissing balloon is done, then you look for stented distortion and malposition, and finally neocrinar length. We'll go step by steps. So this is the one, and the plan is to do stenting into PL branch. So we did a pullback from PL branch. Here you see that there is a big block sitting opposite to your bifurcation, and the angle, if you see the carina tip angle is about close to 50 degrees, and if you see the distance, it is about 1.5, 1.6. So it has predictors for occlusion. So this branch was protected with the wire. And it was pre-dilated. The vessel size distally was 2.5 millimeters. So we put a 2.5 millimeter stent, and proximal plan was to do a part with a 3 millimeter balloon. And just see that, and it was, stenting was done. There was a side branch compromise. And here you can just see that. You see the morphology of the side branch. And here you can see a connector. So this should be a free connector-free cell. So this is it's a small branch. So it is a suitable carina type for crossing, cell for crossing. And once the wire went in, then we identify the level of crossing. So you can identify either by 2D imaging. So wire should be closer to the carina. And if you see here, you see the marker here. So sorry, it is coming. It is the wire is going through the distal part closer to the carina. That means it is distal crossing, and that is clearly shown here. You can just see that your strut. It is wire is going to the through the distal stud. And here, if you see, the wire must be closer to the carina. That is how you identify distal crossing by OCT. And you have additional modalities. You here can see that the wire has gone through the distal branch and fly through again through the distal branch. So it gives multiple options for you to optimally identify wire crossing position. So then side branch was dilated and kissing balloon was done. Now you see that. So absolutely there's no stent sets across the carina. You can see clearly. That is how you would see on 2D. And you see here the nicely scaffolded side branch ostium and the no studs across. And again, you can confirm with the 3D fly through. And this is a 3D confirming that well open side branch. And again, it gives an additional options to confirm your side branch scaffolding and well open side branch. So this is an optimally implanted provisional stenting of distal RCA. And moving on to stent strategy, and this is a patient, 64, female, diabetes mellitus, systemic hypertension, unstable angina, preserved LV function. And this is an angiogram of this patient, tight LCX, distal abdomen disease, and some osteal LAD disease. So RCA is not much of disease. So here you have 50% distal abdomen, 50 to 60% osteal proximal LAD, and significant LCX ramus disease and significant angiographic calcification. The plan is to do a femoral access, 7 French guide catheter, pre-dilatation of the LCX lesion with a small balloon, further dilatation with the NC balloon, scoring balloon, and OCT imaging of LAD and LCX, because LAD you have to make a decision whether to stent or not, and LCX for optimal lesion preparation and sizing, and LAD preparation based on OCT finding, inverted Coulard stenting technique, and ramus intermediates not to intervene. That was a plan. And the abdomen coverage based on the proximal extent of the disease. And femoral access, 7 French EBU guiding, wired with BMW and cyan blue, and because it was difficult to pass balloons, we dilated with a smaller balloon, then bigger balloon. This all based on angiography, 312 NC balloon, 310 scoring balloon. So once we are sure that we are prepared the lesion optimally based on angiography, the first run of OCT was done from LCX to left main. So this is what the OCT findings. To go quickly, this LCX ostium, there was a nodular protrusion, and the plate type of calcification distally, and the thickness of calcium is about 500 microns, and it is about 270 degree of distal calcium. 3 millimeter is a distal reference, 3.5 is a proximal reference, and the length is about 16 millimeters. And based on the findings, we need additional lesion preparation. Went ahead and NC balloon, very high pressures, and verified in 2 views of the optimal expansion of your balloon. And because we had to decide whether to stent LAD or not, it did an LAD pullback. Here, the distal main left main ostium, there is again nodular protrusion, and LAD MLA was 2.6 millimeter square, so it warrants stenting. And plate type calcification distally, the thickness is about 500 microns, and the arc is about less than 180 degrees, and 3 millimeter distal reference and 3.75 is the proximal reference. And if you take consideration into part, it is 28 millimeters length, and again it needs preparation because there is a bit of calcium. So that is what we did, and so LAD was prepared additionally, and the 316 DES into the LCX, it is an inverted Coulard technique, and the 375 into 6 NC balloon part, and the wiring, you can see that it was crossed through the distal cell. And then we did an LCX pullback. So distal left main, you just see that there's a big maloposition. And the osteal part of the LCX, there is a D-shaped expansion. MLA is about 5 millimeters square. We thought we just accept it because it is bigger than the distal landing zone, distal reference. And if you see that the carina morphology is link-free type, and there was a distal crossing, that is what you need for Coulard stenting. And 312 NC balloon, and so once the studs are adequately open, we put a 328 DES, and the part was done with a 3756 NC balloon, and then we just recrossed into LCX, and just see that again it is a link-free type and distal crossing. So the procedure, dilate with the 2 into 15 balloon, 312 NC balloon, and the kissing balloon dilatation with the two 3 millimeter balloons, and final part with the 3756. And this is the final pullback from LAD to left main, well expanded stent in LAD, POC, and distal left main, D-shaped stent, because that is what you expect when you have nodular protrusion with a maloposition. We are not going to address that. And the short or no neocarina. So you can just see that here, well open side branch. So this is the final result angiographically. So Medina 111 angiographic bifurcation, equal size branches, QLED stenting, OCT helped in lesion preparation, LCS calcified nodule, plate type calcification. It helps in device sizing, stent recrossing through the appropriate cell, and stent optimization. And a few words about some of the complications you detect. So you can just see that it again, this is indented double kiss crush, and if you see that there is no stent in the side branch ostium. So the position was such that the side branch ostium was missed. And it helps in identifying neocarina length. So this is an example of tap stenting with a long neocarina, and tap stenting with the appropriate length of neocarina, QLED stenting with a no or short neocarina, and DK crush with a short neocarina. And finally, and during follow-up, this is optimally done QLED stenting. You can just see that both the branches are open and well-covered stent sets. And here you can just see that it was actually a proximal crossing. You can just see that distorted studs and covered during follow-up. And this is one of the rarest things you can have. When you leave the studs across the side branch, they can come back with severe restenosis by endothelialization of those branches. And this already has been shown by Dr. Makesh. We have randomized data showing that absolute 4% reduction in the MACE events if you use OCT for your bifurcation procedure. So to conclude, OCT imaging provides superior image resolution, variety of software or display options for evaluation of bifurcation. It also helps in stent sizing, optimization, side branch wiring, evaluation of side branch ostial coverage, and assessment of neocarina length. OCT imaging improves outcomes compared to angiography in bifurcation stenting. Thank you.
So we have had 3 excellent talks. I think for non-complex bifurcations, provisional strategy is good. For complex bifurcations, it is a 2-stent strategy. And best of the lot at the moment with a lot of data is DK crush. But DK colo is, I think, probably, data is not much, but some short studies which had comparison, they said it is even better than DK crush. And for me, even nano crush also might be a good choice. And Jabir, for the DK crush, I think for the crush, it has to be, the balloon has to be sized to the proximal. That is better because you may have a suboptimal crush which can be disastrous.
Mahesh, provisional stenting, do you, in your practice, do you always do FFR if the side branch is pinched?
If you don't want to stent the side branch, do FFR. It will invariably be a good FFR and you can avoid it. But usually, I'm not a very big fan of physiology. I do a small dilatation of the branch and then do an imaging to see if the results are good, if the struts are not across, and then I decide after that. Physiology was an exception in this case that we had done.
Suppose you have very good flow in the side branch after provisional stenting. Do you routinely open the side branch studs?
No.
Don't open it. Dr. Chamber, actually, we talked about DK crush. And do you have any change in idea or plans after this ABC main trial? Because results are conflicting compared to our DK crush 5 trial. Do you still think that DK crush 5 is DK crush is superior to provisional stenting after ABC main trial?
No, because the Europeans are basically with the QLO. Then if you look into the data per se, the DK crush data may be better. We were discussing in the morning regarding the DK crush 5 and some of the fallacies of the DK crush 5. So what is your opinion?
I think DK crush 5, the events, MACE was driven by TLR. And because the cardiac death was not significantly different between the provisional stenting. and the TLR has been, the TLR graph between the both arms are almost same till 12 months. And the graph started diverging after 12 months. Possibly that divergence was gated by the angiographic driven TLR. So I'm not sure this TLR which had driven the maze difference in DKCrush 5 was symptom driven. It was more of an angiographic driven TLR. So I'm not sure about it. But in case of ABC main, they haven't gone for a angiographic driven TLR. So that's the reason possibly they didn't have much difference in the maze compared to dosing strategies.
Otherwise, also the Europeans are not doing much of the DKCrush.
DKCrush 5, I suppose they haven't done this final kissing and port was done suboptimally in a proximal arm compared to the perfectly done DKCrush.
But in the DKCrush, actually they have a set of criteria to become an operator. So
Yeah.
it's done by people who are experienced in doing DKCrush. They are doing DKCrush only only DKCrush.
Well,
And
they have done the proximal stending in a suboptimal manner as well.
Yeah, fully
The
agree.
results depend upon an ability to do a final kissing balloon and a pot after that, which will create a circular proximal area, then good area for the side branch as well as the main branch.
Whatever data is now accumulating from other parts of the world, the final kissing balloon dilatation success rate is quite high, close to 90%.
Yeah, but in the DKCrush 5, this FK and port was less in the proximal arm.
Provision. What I feel is that practically it's better to acquaint into one technique and be master of that technique so that it can give a better result.
Okay, thank you. I think for want of time, we'll wind up this session. Thank you all.
Dr. Deepak has got a session, I suppose. Yeah. He's got a case, I think.
It's a live in a
Live in box.
There's a live in box.
Live in box. That is, okay.
Bifurcation, yeah.
But that's not written as part of the.
Good afternoon to all of you. It's not going to be live in the box because we have want of time. We'll finish it in 15 minutes time, not half an hour. Well, this was a 65-year-old gentleman, diabetic hypertensive. He was admitted in a nearby hospital with ischemic left ventricular failure. He underwent angiography there. He had mildly elevated creatinine. This was the angiographic images done. You could see that it's a tapering left main. You could see that there is a major OM. The circumflex right from the ostium is mildly diseased. The major OM has got a very critical stenosis. And the proximal mid-LAD in this particular view appears to be mildly diseased. And you could also see that this particular patient had undergone an angioplasty to the right coronary artery almost 10 years ago. And this is the next caudal view. You can see here that the left main bifurcation appears diseased. The left main is mildly diffusely diseased whole throughout. The proximal LAD appears to be diseased. And in the cranial view, you could see that there is significant narrowing of the proximal left antidescending artery and almost down till the bifurcation. You could see that there is a distal large diagonal. You can see that almost till there is disease. Beyond that, there is some disease. However, the disease extends primarily from the left main bifurcation. You can see in this view that the left main bifurcation is diseased, the proximal LAD diseased, and almost till the bifurcation to that main diagonal branch is diseased. So, and again, his right coronary artery also had a critical stenosis. That was a stented segment. You could see that there was a critical stenosis in the stented segment in the mid-right coronary artery, and the PD is totally occluded. So he was advised surgery, left main bifurcation, LAD proximal disease, OM major disease, the right coronary restenosis, and so he was referred to our surgeon for coronary artery bypass surgery. And this was the ECG and echocardiogram during our hospital admission. You could see that he's got a stable electrocardiogram. In echocardiogram, you could see that the septum is significantly hypocontracted. There is significant left ventricular dysfunction, and so he was planned for a bypass surgery. And he was waiting for bypass surgery in our hospital. During our hospital stay, he had an anti-wall myocardial infarction. He had pulmonary edema, hypotension, ventilated. He was thrombolized. He had acute kidney injury. He had sepsis. He was not improving, so CBG was not ruled out. CBG was ruled out in view of severe LV dysfunction, renal failure, sepsis. And that was the point of time it was decided that probably we need to do, because he was having recurrent hypotension, not related to sepsis, and even he had cardiac arrest with significant ECG, ST depression. Now, that was the reason why it was decided that he needs to undergo a high-risk angioplasty. And this was the sort of challenges that we had. One, his creatinine baseline on admission was almost 2. It had now gone up to 3.5. The eGFR is around 21. He had sepsis. He had severe left ventricular dysfunction also. Now, so I'll stop here and probably we'll discuss the strategy of managing this particular patient. So this was a lesion that he had in the left coronary artery, and in the right coronary artery he had a instant restenosis which was tight with TIMI-3 flow. Can we have a short discussion before we?
Yeah. I think for the left main and circumflex, there has to be a two-stent strategy with stenting into the OM1 rather than the main circumflex, maybe a DK crush or something.
Deepak, he had an anterior wall MI.
Yeah, he had an
Why
anterior wall
was he
MI
lies
during the-
not taken up for primary?
He was too sick. He was waiting for surgery, and they were tuned to surgery. So it was decided that, and the anatomy also was not too large vessels. The anatomy was bad. Everyone was aware of the anatomy. So it was decided that straight away he was in the hospital during the hospital myocardial infarction. It was decided that we thrombolize him and take him up for an early procedure. That was what was thought of at that point of time. But then he deteriorated.
I think this qualifies for upfront two-strand strategy. LMCA to LAD and that Ramus.
Yes, and for the right coronary artery,
There was a thrombus in the mid RCA. It looked like a thrombus.
we had other images also. It was a restenotic segment. It was a focal restenosis, almost 90%. I'll show you the other images also of the right coronary artery.
Maybe a cutting balloon and then stent there.
Stent the right coronary artery.
it's
Yes, the
a full
challenge was
focal.
the creatinine was too high.
It's a focal lesion.
Yeah, it was a focal lesion. So
maybe cutting balloon or DEB.
Cutting balloon or DEB. We also, regarding the right coronary artery, we also had a thought of having a DEB to the right coronary artery, but then the problem was we wanted to have the procedure done without much of contrast. So if we were to do a cutting balloon and settle down with a DEB, we'll have to inject more and more of contrast to see whether we have optimized the image. But then if you put in a stent into the right coronary artery, everything we thought that we could get away without injecting any contrast into the right coronary artery, just with IVUS guidance. So that was the reason. So because of that, with that thought in mind, we decided that for the right coronary, no contrast, just do a cutting balloon dilatation and deploy a stent at that particular area. Settle down with IVUS imaging. That was the decision for the right coronary, rather than thinking in terms of a DEB.
A cutting won't need a contrast. Yeah.
No, sir. After cutting, you would want to see whether the images are good. IVUS wouldn't fetch you so much of information. You'll have to inject at least some amount of contrast to see whether we have achieved a reasonable flow in the right coronary. Then deploy, and then do a drug-eluting balloon. Then again see whether you have optimized the result. All those things may not be totally achieved with an IVUS evaluation. Yeah. So that was the reason why we thought that we'll move away from drug-eluting balloon and deploy a stent in the right also.
That's fair.
Anyway, you can't do this case in 21 ml of contrast. Let's be frank about it. I think that you have to strike a balance as to where the heart is more important than the kidney. Please go ahead, do your case peacefully, and at the end of the case, what I do is I give a short dialysis for about 3 hours, get rid of whatever is possible. When I have about 50 patients, I'll publish the study. So far, all my patients are doing well. So a short dialysis, please don't compromise on the heart functioning and your functioning. You have a severe LV, triple vessel disease. Do your case, then let's see the contrast later.
Mahesh, where is the evidence that short dialysis prevents contrast-induced nephropathy?
Let me finish 50 cases, then I'll publish. I'm on the jobs.
So far, nephrologists are not.
Where is Ramakrishnan? He's missing. He's my only supporter.
Sir, cardiologists have been doing the same for years together. Even in 2001, 2003, Dr. Bharachandran in Trivandrum, sir, had been doing that. In renal failure, he used to do angioplasty and then do a short dialysis. But we do not have a significant data with respect to that. Can you show the
Do
slides?
you do your dialysis before or after the Dr. Mahesh? Do you do your dialysis before or after the angioplasty? Not before, not after angioplasty.
Nephrologists say contrast is not removed.
Yeah,
by
because
dialysis.
contrast is not dialysable actually.
So we had, okay, so we had three challenges. One, the sepsis, antibiotics. Regarding renal failure, we decided that the EGFR was 21. We thought that we should try to limit the contrast to just 21 ml, probably the entire amount for the left system and nothing for the right coronary artery, because we had planned that right coronary we should just do IVUS and then settle down with a stent implantation. So this is what was decided for the left system. We thought that we should assess the left main, the distal vessel near the bifurcation with IVUS. If that turns out to be significant, probably we should have a wire in that branch, and while doing a stent implantation, we should probably have a balloon there, the embedded balloon technique for the LED D1 bifurcation, and proximally for the left main bifurcation, we thought that we should go ahead with a DK crush technique. So that was what was decided, and then this was the right coronary artery. You could see that there are two lesions. One, it's a significant restenotic segment, and very distally inside the PLV also there is a 90% stenosis and the PD is occluded. So we thought that we wouldn't touch the most distal lesion in the PLV, just manage the mid portion of the right coronary artery. So that was what was planned, and we took the patient up through an Impella CP was deployed through the left femoral artery, and we started the procedure through the right femoral artery. You can see the blood pressure, that's the pulmonary artery. We also had a pulmonary artery catheter, that is pulmonary artery catheter, the pressures were around 60. So the Impella CP was deployed inside the left ventricle, and then we started the procedure with a 7 French guide catheter through the femoral approach. The guide catheter was engaged, and initially we took a 2 cc contrast injection. That was a diluted contrast injection because we wanted to see whether the LED was flowing, because during the hospital stay he had an anterior myocardial infarction. So we expected that the vessel could also be occluded. So we were happy that the vessel was open, LED was flowing. So that was a 2 cc contrast injection that we started off with. Then what we did was that's a Impella CP. You could see the left ventricle contractility was significantly less, the Impella inside the ventricle, and the outflow is also seen into the aortic root. And then we started wiring the left-handed descending artery and the diagonal branch. The idea of wiring the diagonal branch was just to have a marker there. If at all we were to deploy a stent across the diagonal branch, that marker would help us to understand where exactly we need to position the stent distally. That we'll be identifying with the help of an IVUS evaluation. So with IVUS we made out that the plaque was extending till that particular area. You could see the IVUS catheter there, and the plaque was extending till that particular area. So we had to stent across the diagonal branch into the distal left antidescending artery, and further evaluation was done. The left main was 5 mm size, and the vessel sizing was done. There was no significant calcification. It was 180-degree arc of calcification, but however there were no concentric rings of calcification, so just non-compliant balloon dilatations were done. This was the hemodynamics with noradrenaline. Noradrenaline support, the aortic pressures were quite good. It was 140. You can also see on the monitor there on the ECG, there is no significant ST depression or ST elevation. The pressures were good when we started off the procedure. We did the balloon dilatations. However, following balloon dilatation, the blood pressure had dropped. You could see on the monitor that the BP had dropped to 80 systolic. So we couldn't wait for that because we wanted to know whether we have done some harm to the left antidescending artery with the help of balloon dilatation. So we took another 3 cc contrast injection, which is again a diluted contrast. You could see that the flow inside the diagonal branch is significantly less. The distal LED as well as the side branches are also flowing less. So we gave intracoronary nitroprusside, adrenaline, and things were much better. The blood pressure improved. So then we went ahead with stent implantation. During stent implantation, that is what was done. A 2 mm balloon was dilated in the diagonal branch. A long stent, initially a 38 mm stent, was deployed based on the IVUS size across the diagonal branch. That was the stenting being done. And once the stenting was done, we took out the balloon from the diagonal branch. Again took another 2 cc contrast injection. You could see that the diagonal is flowing well. In the first image, you can see that the diagonal is flowing well. The second wire from the diagonal was taken out. We took it into the OM branch. So that wire was used for wiring the OM branch also. So now we had to come back to the left main LED bifurcation. So post-dilatation was done for the first stent. Then we pre-dilated the side branch. IVUS evaluation was done for the OM branch. And then we took I think again it was a 38 mm stent from the circumflex, from the left main into the OM branch. That was again a 38 mm stent that was deployed and it was crushed. That was deployed, pulled back, further dilated, and it was crushed. So that was the crushing. Following crushing, we recrossed into the side branch. First kissing balloon dilatation was done. And then we again recrossed with the next stent, that was a 32 millimeter stent, 3.5, from the left main to the left anti-descending artery. However, while positioning this stent at the ostium, we gave another 2 cc contrast as seen in the first image. Another 2 cc contrast was given so that we could identify the ostium of the left main, and that was the stent positioning. The stent was deployed, proximal optimization was done, and then we recrossed into the side branch. Kissing balloon dilatation report was done. And that was the final result. In the first image, you could see that we were taking a shoot through the microcatheter. I'm sorry, it was an aspiration catheter so that we could reduce the amount of contrast in the caudal view. In the cranial view, you could see that that was another 3 cc injection. The flow was good in the LED diagonal and all the distal vessels. Circumflex also was flowing. And final, I was also identified that the stent was well optimized. We didn't have a pullback from the circumflex, but then the pullback from the LED back into the left main, the stent was well optimized. And we could settle down the left system with the not much of contrast. Then we moved to the right coronary. It was less than 20 ml of contrast for the left system. Then we moved on to the right system. IVS evaluation was done. We used a non-compliant balloon, a cutting balloon, and then finally a short stent was deployed. And then again, we took a final shoot because we didn't have to use 21 ml of contrast. We thought that we'll take a final shoot. The flow was good inside the right coronary artery. And we settled down with that. We thought that we'll stop the procedure now, and then we'll wait for a while and then remove the impella. That was the plan at that point of time. However, around 15 minutes later, we saw again the blood pressure dropped, and we started seeing ST elevation on the monitor. So you could see now that there is significant ST elevation on the monitor and the BP has dropped. We had to further, the PA pressures had increased. The PA pressures had increased. We had to further increase the dosage of noradrenaline. So we had no option because the procedure was done with less than 20 ml of contrast. We saw ST elevation. Now we had to start giving more of contrast to identify what exactly was happening. So that was the image taken in the right coronary artery. You could see that there is no flow inside the distal PLV branch because initially we had seen a lesion in the distal PLV branch. Probably the wire had destabilized that particular area and that vessel occluded. Now again the plan was if we keep on dilating that particular area and then keep on seeing what exactly was happening, we'll end up with having a lot of contrast being injected into that vessel. So ultimately what we decided was we dilated it, took a small contrast injection, we made out that the flow is not better. So then we decided that we'll go into the PLV and stent the PLV also. So again, those were the images, atrial fibrillation, blood pressure maintained with noradrenaline. Again, we had to take long stents into the PLV branch that was deployed, 2 stents were deployed and the final TIMI-3 flow was achieved. So that was the final flow. Again, we had to use another 10 ml of contrast compared to what initially we had planned. So that was the final flow that we could achieve in the right coronary artery. Patient got stabilized. You could see again the ST segments are settled down. The blood pressure was better. Half an hour later, we removed the impella and the patient sepsis settled down. Hemodynamics improved, extubated, kidneys recovered, LV function improved, and discharge on the 11th day. This was echocardiogram on discharge, and after 6 months, the LV is much better. Creatinine is around 2, and that's how on follow-up. We wanted to do a check angiogram at some point of time, but then he's not keen to undergo a check angiogram because he's doing well. Because all these smaller stents inside the right coronary artery, wanted to have a check angio, but then it was not done. So that's the final result. Just to highlight the usefulness of impella, not during the procedure. During the procedure, the patient was whole throughout the procedure, he was stable. However, when he developed the complication, when the right coronary occluded, that was the time when impella helped this particular patient. Thank you so much.
Was it a thrombus migration distally?
Probably. Not sure whether it could be, but then the final shoot after the stent implantation in the mid RCA, the flow was good in the right coronary artery. But then while we were waiting for removing impella, we saw ST elevation and hypotension. So we thought that it might be that area which was destabilized by the wire, it got occluded.
Just one point, contrast media is dialysible. Very clear.
But that is not the idea that nephrologists have generally. So you should correct.
I'm quoting a nephrology journal.
Deepak, one more thing is whenever you use Impella, it improves the renal perfusion. So there are studies which have shown that the damage to the kidney is less when you use Impella. That also would have protected the kidney.
Kidneys.
Yeah.
Ensuring good blood pressure during the procedure is also good for
Was
the
a
kidneys.
positive.
Kidneys.
Positive.
Okay, thank you.
Thank you so much.
So that's the end of this session.
Thank you, sir. Thank you to the chairpersons and the presenters of this session. Move on quickly to the next session on key challenges in CHIP. To chair the session, may I please invite Dr. Nanal Kumar, Dr. Jabir, Dr. Mukundan, and Dr. Bino Benjamin, please. First presentation by Dr. Karthikeyan. Over to our chairpersons now.
Okay. Because already we are short of time, we'll directly go to the lecture.
Lights, please. Okay.
Anomalous score.
So, good afternoon. At the outset, I would like to thank Anil sir and Dr. Verma for this invitation. So today I'll be talking about anomalous RCA, CX, left main origin, AKOS, and all of us know that the incidence is very low. And I'll be trying to concentrate on the utility of the newer guide catheters, choosing the approach, general principles. And there's no set of rules. I'll be sharing my experiences, all of them are mine cases, and just to help in collective learning. So why this discussion? Any complex PCI, CTO PCI, elective procedure, pre-procedure planning, all this are, I don't have to emphasize to this audience. So the anomalous coronaries, the challenges is that an abnormal origin, a non-circular orifice, abnormal course with bends, guide support challenges, wiring and stent delivery issues, and when do we take additional support? Because every additional support we take is going to lead to a little bit more problems. Okay, so as we all know, well begun is half done, and we engage with an appropriate guide, wire and then take active support, anchoring strategies, guide extension-based strategies, and the best thing is to keep it simple and safe. So this is a diagram, I think it should be there in every cath lab for anomalous coronaries from the right coronary origins, because that is where we get into trouble most of the time. And of course, it's good to all of us have the same nomenclature of the artery so that we can communicate with our colleagues and the team. So of course, many of these guide catheters are not available in our country, but then most of it is there, so we can kind of choose. So this is how I'm going to start. I'll be concentrating more on the guide and the engagement. The end result is immaterial. So this is the first case where the anomalous artery, RCA from the left sinus, and this is a type A. So the trial and error with multiple catheters. The first one was the Kimney, the 5 French EBU, and then we stumbled upon the Ikari 3.5, which gave us good support, and then anchor wire in the branch, and then we finished this case. So emboldened, the next case happened. My first 4,000 cases have not seen this anomaly, and then within the 2 weeks we had a second case, and same encore we did it. And this time, Ikari 3.5 was not giving good support, but then Ikari 4 gave us good support. I could nicely telescope the guide inside and then did direct stenting. So this is how we finished the first 2 cases. Now this happened 2 years later, where we used the Ikari left and for the circumflex OM, and then finished the anomalous artery also with the Ikari left. Now I'm just trying to show how this Ikari left has to be engaged. Because you have what is the advantage of this Ikari left over traditional Judkins? It has a tertiary curve and a longer primary to secondary curve distance. So if you can push it down and turn it counterclockwise, what happens is that it takes support from both the cusp of the aorta and the opposite wall. So it gives you a good, something like an EBU turned into in the counterclockwise way, and so that you can get reasonably good support. And then this is what I call the power position, where you can go nicely deep inside and then deliver your hardware. So this is how we can also use sometimes when you want to give contralateral injections, you can just push on the wire, it'll come out, then give your contralateral injections. So this is the first three cases. And then if you look at type C and type D, the Tiger catheter gives you good support from the radial approach. And then radial approach is one thing which is I prefer when I do anomalous arteries. So this particular case where we used the Tiger guiding, and the case was relatively simple. But what we realized that the Tiger guide is not good for the left system. And so I had to finish with an extra backup catheter. And then when you go to type E and F, most of the time, depending on how the origin is, a multipurpose catheter may be helpful. And it's just very coaxial and makes the job easier. And this was the sixth case where we used Ikari left for the circumflex and the Tiger for the RCA because it was a type D. Okay. So now this particular case I want to show because the diagnostic catheter which actually gave us the information was a no torque right. But the intervention is a planned intervention. I thought we'll go with the same what we know. And this is from the radial approach. And you see there's multiple bends, tortuosity, but then it does not deter. And the Ikari left will sit beautifully. And you can get your gear across and finish. So this is how we finished. And this is the last case in the anomalous RCA series where it's a type F RCA where I used a right coronary bypass and then the case was done. If you don't have a right coronary bypass in the lab, you can just fashion it from the Judkins right or a JR4 and then you can get it. If you eliminate the tertiary curve, it becomes a vert. And if it's between a JR and a vert, you can get a right coronary bypass catheter. So this is how we finished at anomalous EF. Okay, so this is the literature. I'm going to skip this. So we wrote this up. Dr. Vijay is also here, that the first 7 cases of using the Ikari left in the Indian Heart Journal. So if somebody's interested, you can go through. So next thing is the anomalous circumflex interventions. So the anomalous circumflex from the opposite sinus is always a retroaortic course. So there are 2 variations. One, it can be a branch of the right coronary artery, or it can originate separately. If it originates from the right coronary artery, it's easy because you can use a Judkins right, wire into the right coronary artery, and then use that as a support, and then you can get in. And now, this course is very important because it's a retroaortic course all the time. So you have to deal with 2 bends. And so you have to be planned because any RCA, LCX from the opposite sinus is 2 bends. And also you can, by echo itself, you can pick it up even before the angiogram. So now we use the wire in the RCA to pull and pull. If you push the wire, the guide will back out. And then we can get our gear from the other wire. So now this is balloon dilatation, stenting. So this is how we finished. And the second case was to separate LCX from the right sinus. What I did is I've changed the JR into something like coronary bypass catheter and then wired inside. And the same thing as I told you, the 2 bends will be there, and so we have to deal with this. So this was a very well deliverable stent, and the job was done. Okay. Now this was a patient who had inferior wall MI. The left main is arising from the right coronary sinus, and you can see that essentially it's an interarterial course. And so the wiring was done. I think this was a pilot 50, and then dilated. And see, this is a simple lesion in a complex location, so I'm not really worried about guide support. And this is a Tiger guide, and from the radial approach. So this is, and then I did the right coronary shot. I thought it was in the diagnostic significant, but then when I did this shot with the Tiger guide catheter, I didn't feel it was significant. The QFR was done in the lab, and I just came out. So this was the pre-procedure CT. You can see that any left main which comes from the opposite sinus will have an intraarterial course most of the time. But here it is just a little bit lower going towards the RBOT. So of course, in this particular case, what was the successful thing was the approach, the guide support, and a good deliverable stent. Okay, this is going to be one of the rarest anomaly is the left main arising from the posterior sinus. And this particular patient had twin challenges. I had to do the CT of the LAD and the left main. So this was a 48-year-old male who presented with heart failure. And I didn't do a pre-op CT, though there was a 6-month time between the angiogram and the intervention. At that time, I was not really tuned to appreciate how CT will help me. So this was the diagnostic. There are 2 CTOs, circumflex and the LAD. This is from the radial approach. And you can see that the RC is practically living on this right coronary. And a corner shot I had taken just to see how the collaterals are there. And then you see that LAD, something is filling. And the heart team discussion was because my surgeon felt that he could not see the distal LAD. He was not going to touch. And so it was decided that we will do PCI. And in between, I got a technetium done. The circumflex territory was not viable, so I had to concentrate only on the LAD. So this is the PTCA. I had taken a femoral approach and a radial approach. Whatever I did, the first 1 hour, I was not able to get good support from the femoral approach and could not engage at all. So in desperation, I went back to the radial approach. And the Judkins right came from the femoral approach for contralateral injection. And AL1, I tried the Tiger guide, absolutely no support. And then an AL1 was used and an anchor wire in the circumflex. I was able to get decent support. And with a microcatheter and a microcatheter injection, you can see that there's only the loose tissue which needed to be tracked. So a fielder XT was taken, and then a Gaia crossed into side branch. You can see that the contralateral injection shows that we are in good place. It was changed to a workhorse wire and prepared with 1.25 and 2.5. And this distal stent positioning, at that time I didn't have IVUS in my lab. So it was just from friends and seniors who were telling me that after imaging that they had not seen an LAD which was less than 3. So it was a Promus 3 stent which was taken, and I thought I got a good zone where I could land. And the 3 stent was landed. And then for the left main into LAD, I decided to take a 3.5 and just leaving the first 10 millimeters because in case I have to go back, then I don't want metal hanging out. So post-dilatation was done with a 4 mm balloon. And this is a check angiogram post-stenting. And with liberal dose of nitro, this is how I left the patient. And of course, this is what the hardware we used. So this case was presented to just highlight the challenge and the technical issues. And just anything as just a support wire or is good enough. And with a microcatheter, we can do a loose tissue tracking even in a CTO. And the utility of and limitations of radial approach in anomalous coronary artery, because we should not be fixated that CTO, I'm going to go femoral all the time. Sometimes the radial approach may also give you good support. So this was the CT. I did probably 2 years later when he came for admitted for pneumonia. At that time, a CT also was done. And you can see that this particular artery is arising well posterior, and the first 10 millimeters, there is no stent. Okay, I got this patient back for a check angiogram 3 years later, and you can see that the distal vessel has grown. And this was something alluded to even in the previous talks. That's because the distal vessel is chronically underfilled and is in a spasmodic state. And if you do IVUS, you can even actually pick up that band and then know that this particular vessel will grow. So even after the CTO intervention, we can predict which vessel will grow, and it grows at 0.5 mm per year. And this was the lessons we learned. The pre-procedure CT and intra-procedure imaging would have saved a lot of time and helped understand the anatomy and sizing of stents. And then slender sheath today is available, so we could have used the radial approach more aggressively. And so what is important in a CTO is that you have to use appropriately sized stents. And the poor targets may be due to chronically underfilled vessels. So don't give up on the LAD and have some amount of interventional optimism. And then viability guided revascularization for targeted effort. So since we have time, I'm going to show 2 cases. This is, in summary, you have to take 2 views, LAO for the origin, RAO for the course, define the origin and course, and use your guiding support, whatever you're comfortable with, wire support, deliverable stent system, and know your strength and your lab backup. So in dextrocardia, everybody thinks that once we get an image inversion, we are good to go. But then many a times it's not that easy, because I've had a double-digit number of patients who are dextrocardia patients who have done angiogram, and 3 times I had to do intervention. So this was a case where the RCA was totally occluded, the circumflex was totally occluded, and I had to do the ramus. And you can see that I made a wrong choice, Judkins left catheter. I thought it was just proximal ramus, so I will just fix it. But then invariably, after balloon dilatation, the stent would not go, the entire system backed out, acute vessel closure. You can see that the patient's contractility has dropped, intubated. You can see what is happening here. And doing CPR and aftermath, I got an extra backup catheter inside, and then fortunately was able to stent. And then this is how you can see that the LV function recovered. And in 6 hours, the patient was extubated. Check angiogram done 2 years shows a patent stent, but the 2 CTOs still persist. The patient was doing well. And this is the second case. This was an anterior wall MI, and you can see that there is a small LAD stump. And this one, we went from the left ulnar and traditional angioplasty, and we got a good result. Only thing I wanted to emphasize in mirror image dextrocardia is that you have, though you do double inversion sequence, you have to, because there's a rarity and you're not tuned, give allowance for time-intensive nature of the procedure. Because sometimes when you get into trouble, then it takes a little bit more time than your to recover rather than your traditional way. So thank you very much for your patience.
Thank you, Dr. Karthik. Actually, getting an anomalous artery, and that to a CTO in an anomalous artery, is one of the nightmares. I'm sure everybody has had challenges. Even the best of centers can have problems. Any comments?
In your series of ICARI and the right coronary, did you do it all of them through the femoral or?
No, actually 3 of them were from the radial approach, 4 of them from the femoral approach. And also what is interesting about this series is that it was left to the operator's discretion. 6 of them was done by me and 1 was done by Dr. Suma. But then in other centers, after we had shown our initial series, it was most of the people did use it from the femoral approach only because it was just a comfort factor. But now I know how to maneuver the catheter. Radial femoral does not make a difference.
Yeah, we had 3 cases actually. All of them were through femoral. And that curve of this one is making it a good support, giving it a good support.
Actually, any thoughts on the malignant course of right coronary artery, which is normal? Would you advise anything?
Sir,
there are a lot of CT angio reports
Yes,
come
yes, yes.
and they're asymptomatic. What are your thoughts
Sir,
about that?
anomalous coronary artery from the opposite sinus, RCA is always malignant course only. And if you are going to see in that zone, and if you do intracoronary imaging and show that it is happening, then we have a case for giving it to the certain. Otherwise, all the cases, it's going to be there. Even the left coronary artery coming from the opposite sinus, 1/3 is going to be malignant course. It's not, even in my case, it's actually, you can see that that particular left main does not look like a really big left main because there is a little bit of course between the 2 arteries. But then it's not mandatory that this case should go to the surgeon.
Yeah, so Deepak.
Karthikeyan, wonderful cases, plethora of cases, all anomalous vessels. But then looking at this case series, I understand that all these cases were done long ago, right? In the last 2 to 3 years, every time we see an anomalous vessel, it's easy for us to manage all these cases because you take some sort of catheter, it reaches somewhere near the mouth of the vessel, you try somehow floating a wire into that vessel, then you have a guide plus and the job is done. But prior to 3 years, 4 years ago, when we didn't have all these guide extensional catheters, it used to be very challenging. Like we also had been using these ICARI catheters, and I hope all these cases it was done few years ago, 2-3 years ago.
The first case was done in 2012. The first presentation was in Gulf PCR in 2015. The last case which I showed, that left main, that case was presented in Europe PCR in 2016. So this is a series of the last.
Now probably you should be using this guide extension catheters.
The only reason why I am little averse to use the guide extension whenever CTO comes is that when I'm in the 6 French system, multiple telescoping systems, I feel is if you can get good support from the guide and you can get a good power position, then our job is done. If you always rely more on, of course, guide extension makes our job easy, but then it's not that you're actually diminishing your working diameter when you use a guide extension. If you're 7 French, 6 French, it's okay. If you're 6 French, 5 French, it's not okay.
Dr. Ramakrishnan.
Engaging the RCA in a dextrocardia patient can be tricky.
Yes.
In the normal person, you use the clockwise torque. Here, you have to use a counterclockwise torque.
What I do is that I go to double inversion sequence right from the
True.
beginning.
Even with that,
yes, it is difficult.
Our manipulation has to be counterclockwise.
No, that is when we do double inversion. Actually, what we are doing.
What we see will be like normal.
True, but we also can correct little bit. We go a little slowly. It's not that difficult because I've done this, and many a times the problem is when you go from femoral, right femoral, it's like going from the left. So I electively go from the left, left radial or...
Whatever way the access.
Yes.
The entering
No,
the coronary artery from the aortic
what
root,
I'm trying to say,
you have to use a counterclockwise.
when we are doing a traditional patient from the right femoral artery and then engaging right coronary artery, that's different. When you do from the left, there's a small difference. That is what we are actually having in the dextrocardia also. If you go from the left ulnar or left radial or from the left femoral, it's going to be similar. Yes, yes, there is little bit, that if you're going on the same thing, but once you double inverts from the beginning, then you are actually correcting it.
Instead of counterclockwise, if you use counterclockwise, easily ended.
Yes, but then what happens is before itself you have corrected. Even before starting, from the you show the right, and then what you do is start correcting from the beginning itself.
No, there is a left-right confusion, I think.
No, it's actually first time what we do, we always try to do it with the heart on the right silhouette. But once you show it that it's dextrocardia, then I immediately correct.
Okay.
And then when we do this hand-eye coordination, that's nothing that fixated. Once we do radial,
So
we
if
always
you don't
hand-eye
correct this counterclockwise, clockwise.
It's only hand-eye coordination.
Thank you, Dr. Karthikeyan. I think you have the best collection of aberrant coronaries. Thank you. We'll move on to tackling tortuosity. Dr. Madhu is going to take us through how to tackle tortuosities. We're coming through key challenges in CHIP procedures. So, Dr. Madhu Sridhar.
Thanks, Anil and Varma, for the invite. So this is about tackling coronary tortuosity. Coronary tortuosity is common. It's seen in 14 to 40% of patients, and it's associated with advanced age, female sex, and hypertension. And it's interestingly inversely associated with atherosclerosis. Flow alterations in tortuosity can lead to ischemia in the absence of obstruction and lead on to impaired LV relaxation and SCAD. So tortuosity is not benign. How do you define a tortuosity? It can be mild when you have less than 2 bends to reach target lesion. You say it's moderate when you have 2 bends more than 75 degrees or 1 bend more than 90 to reach the target. Severe if it's more than 2 bends of 90 or 3 bends of 75 to reach a target lesion. And bend is defined as a segment with a maximum angulation in an end diastolic frame in an unforeshortened view. Now, is there any impact of tortuosity on outcome? This was studied with more than 7,000 patients and individual patient data from 6 RCTs, that's Endeavour 2, 3, 4, Platinum, Taxus 4 and 5. And here you found that moderate to severe tortuosity was associated with increased 30-day and 5-day target vessel failure, which is target vessel MI and ischemia-driven target vessel revascularization. And you also had increased definite stent thrombosis. So tortuosity does have problems. There's a central illustration, and you find that the worst outcomes are those who had severe tortuosity, which is treated with first-generation DES, and the best was with no tortuosity, treated with second-generation DES. But even with second-generation DES, you have a target vessel failure of up to 14%, which is something which we have to remember when you put stents. And you can see that target vessel failure, the ischemia-driven target vessel revascularization, and MI all are increased when you have severe tortuosity. Now, why is tortuosity associated with worse outcomes? It can be because of inability to deliver equipment, operative fatigue, when it's a complex procedure at the end of which you don't really take too much of concentration, device-induced trauma, which can be because of guide extension or a wire, associated ankulated lesion leading on to stent fracture. It can be because of large bore catheters which are used for extra support leading on to bleeding or pseudostenosis related events. Now, tortuosity, when it's with the coronaries, you can have it associated in the vasculature. You can see in the iliacs, you can have such a tortuous vessel leading up to the heart, and it can be overcome to an extent with a long sheath in the iliacs. And in the upper extremity, balloon-assisted tracking would help to an extent. Now, what are the issues with PCI in tortuosity? You have problems with wiring the lesion, with delivering equipments, and a risk of complications, which can be stent loss or perforation. And the key features in tackling tortuosity one would be a strong support. Second will be liberal use of microcatheter during wiring, and you have to prepare the lesion well. If the lesion is not prepared and tortuous lesions, you can lead to complications, including equipment loss. Support, You have to use long sheets, larger size guide catheters. Supportive catheters would help in a long way with AL1 for RCA and EBU for the left. Deep engagement of the guides, a buddy wire, and a stiff wire, maybe a BHW, Ironman, or a Grand Slam for increasing the support to deliver the system. As the first case, the patient had come with ACS. You have a tight lesion in the obtuse marginal one, but you can also see there's a lesion in the proximal circumflex. Yeah, you can see a lesion in the proximal circumflex and also in the mid LAD, which is causing some type TIMI2 flow into the LAD. Now, this is the origin of the circumflex. You can see there's two bends, which is leading along with the disease in the proximal circumflex. And you had the disease in LAD. So we had done through the radial, as we all do, and we thought we would be able to finish it, the radial. And we are trying to get a stent across, and obviously the stent was not going, so you used the guide extension catheter to get the stent across. And you can see that there's a slow flow into the LAD and circumflex, bradycardia, and the patient's having chest pain. So what do? So one, change the alignment. From radial, you went femoral and used a 7 French guide from 6 to 7, so you have more support. And you dilate the proximal part of the circumflex. And after dilating the proximal circ and a better guide support, a 2.5 into 48 expedition, which is a long stem, which is tied from the radial, could not go, could be taken down even without a guideliner support. So the same stent could be taken down which could not be taken down via the radial approach, just by changing the guide, the alignment, increasing the guide support, and dilatation of the lesion. So this is the final result after DK crush. So this is one of the ways by which you can overcome a tortuosity in the proximal part. Case 2, this is another patient who had come with an inferior wall MI. You had two bends in the proximal RCA. It was dilated, but the stent could not be taken down. Every time a stent was taken out, the guide was backing off. And so a buddy wire was used. You can use any second wire, or preferably extra support wire. It can be a BHW, Ironman, or a Grand Slam. And this is the final result after the stent. Now, guide extension catheters, the TrapLiner guideline or GuideZilla, or the more flexible catheters like the Telescope or the Guide Plus. And this are really a game changer when you're dealing with tortuous vessels. It can be taken down to coronaries and help deliver devices distally. So as we had seen in previous ones of Karthik, so when you have anomalous coronary, and as Deepak was saying, previously we used to have search for the guides to get in, but now a simple one is to float a wire across, get a guide extension catheter, and can have a stent put in there. This is another one. It's a tortuous coronary with calcification, and you also had iliac problems. So you had a long sheet for a better guide support. It was a bifurcation stenosis, including the PDA and PLB, which is dilated, and a guide extension catheter taken all the way down, with which a long stent can be deployed from RCA to PLB, and you have the final result after the angioplasty. A long sheet for better support, deep encasement of the guide, and a guide extension catheter, which can be taken all the way down. So that's the first part, support, and the second one is liberal use of microcatheter during wiring. The guide wires can be non-polymer jacketed or polymer jacketed. Non-polymer would be the composite core with cyan blue, or the Suo, or the Samurai and run through, and the polymer jacketed one, which is the Fielder FC, Cyan Black, or the Whisper, and the Pilot series. And the microcatheters improve wire handling. It allows changing the guide wire tip, and also it helps in the guide wire exchange. The microcatheters can be fine cross, Caravelle, or the Crusade, or the dual lumen catheters. And of course, the Supercross microcatheter. Supercross, you got in multiple curves, the 45, 90, 120, or the XT. And when you have these catheters, you can put it right into the ostium, and that can help take the tortuosity. Now, you also should have some of the specialized techniques for wiring, especially in acute angulation, of which are the reversed wiring is something which is very useful. It's especially used with a hydrophilic wire. The wire should be introduced to the introducer, put a 180-degree bend, and the bent wire has to be taken into the two-way bore, and not the wire tip, the bent wire. And when it's exit out of the guide, it will be like a reverse loop, and that when it's pulled back, it goes directly into the acute ankulated branch. Sorry. Now, and prepare the lesion well. You have to prepare the lesion well because in tortuosity, as such, it is difficult to get your devices down. And if it's not well prepared, then your stents, it may not go. And if it goes, and if it's not deployed well, you would have difficulty. So pre-dilatation can be either by a regular or a non-compliant balloon, a cutting balloon, or an angiosculpt, atherectomy, or a laser. Stents, it's probably better to have a shorter stent, a thin stud stent, and more deliverable stents, especially when you have tortuous vessels. It's good to have more deliverable stents put in rather than try for other ones which are probably not as easy to get into the lesion. Now, complications, as of all PCI, complications are more in tortuous vessels. It could be dissection, a pseudolesion, a perforation, or equipment loss. Now, pseudolesion or accordion is something which we have to consider when we think about all tortuous vessels. This is a lesion. You have in mid-RCA lesion, you have tortuosity down, but once you get the wire down, you see this accordion, and at that stage, it might be difficult for you to know whether it's a dissection or trauma due to the wire or an accordion. And the only way by which you can be certain it's not because of the dissection is to pull out the wire and see. You can give a lot of nitroglycerin, but unless you take out the wire, you will not be able to know for sure whether it's accordion. But when you have these kind of tortuosity distally, always keep in mind this is bound to happen. And so when there is no lesion initially, you can assume that it's most likely going to be an accordion, but you can't be certain unless you pull out the wire and take a shot. So finally, there's a case where the patient came with a ACS. It's a non-STEMI, and you can see that the occlusion of the ostial circumflex and the other vessels are almost normal. Now, it is an extremely difficult to wire, so it's a kind of a retroflex origin of the circumflex, so it's going up, down. And so we had to use first a cyan black, which was used initially but didn't go, so we had to use a tapered polymer jacket like a Fielder XTA with a supercross catheter. And with that, it is with great difficulty, we finally wired the OM. And following wiring, you had some antegrade flow, but this was a lesion there. And even a 2x12 Maverick, which is one of the most deliverable balloons, could not be taken down without a guide liner support. So you had a guide liner to be put in just for getting a balloon down. So after that, one of the things about the Fielder series of wires is that they're extremely good, but you can't see anything what's happening there. So once the job is done, it has to be taken back and exchanged to your workhorse wire. And here we use the cyan black. It is changed back to the cyan black, and you could see the lesion there in the proximal circumflex. It was dilated again with the balloon, and this was the final result, which we had to leave at that stage. You can see there's a dissection there, but fairly good flow. So we had to stop at this stage because getting even a Maverick balloon with a guide liner catheter was so difficult. So didn't want to try taking a stent down. And you have to stent from left main to circumflex in this situation, if at all you had to put a stent. And even if the stent had gone, you would end up with a high chance of re-stimulus of the circumflex ostium and a stent in the left main, which is not deceased. So we thought we'd just leave it at that and finish with POBA. And it's asymptomatic on follow-up with an ejection fraction of 45. So this shows the difficulty in tortuous vessels. Here you had a supportive guide, an extra support wire. You had to take a polymer jacketed wire, a cyan black which was taken initially, which had to be changed to a tapered polymer jacketed wire. You had a supercross microcatheter for wiring. You had a guide extension catheter even to get a balloon across, and still had to stop with an angioplasty. So it's a typical example why outcomes are poor in patients with severe tortuosity. So in conclusion, coronary tortuosity is not uncommon and associated with poor outcome. May have concomitant tortuosity to the peripheral vessels like the iliacs or the upper arm. Wiring the lesion and delivering equipment may be difficult. Risk of complications are higher, and strong support, liberal use of microcatheter, and adequate lesion preparation form the mainstay in tackling lesions with moderate to severe tortuosity. And despite best effort, we may have to accept suboptimal results. Thank you.
Thank you, Madhu. Great talk, good examples. But despite all the newer gadgets available, at times we may fail even certain tortuous lesions. So, which wire do you think which can give the best support to straighten the vessel? Or is it everything is same, the Grand Slam, Ironman, BHW?
It just depends on what you're familiar with. In our place, we use a BHW.
BHW, all right. And with the guide catheter, I think the life has become a little more easier, the guide extension catheter.
Yes.
But do you think an implants may help along with, especially your case in that circumflex where it was extremely difficult to cross? An implants, would it, do you think
No,
it
because
would have helped?
here we had taken a EBU 3.5 to
Yeah.
4, and it was pushing all the way in. So beyond
Almost
that,
like an implants.
it's almost like it. And despite the tortuosity and the angulation, so I getting the balloon itself was difficult. So I wasn't keen to put a stent.
Rajesh wanted to ask something.
The case which you showed, one wire we find it very useful is the choice extra support wire. It gets you good support. Your wire is a Fielder XC.
No, Fielder XTA for
XTA.
wiring and then a silent.
That doesn't give good support. This choice extra support gives good support.
Madam?
To remind everyone about a case. See, actually, in olden days, they used to say for tortuosity, if you straighten the lesion too much, you will end up with a dissection. So I remember, I think it was India Live. There was a lady with a single bend, and they put one stent, it dissected. Finally, they ended up with 7 stents in a simple type 2 LAD, type 2 or type 3 LAD. So I'm very happy that you didn't have a single dissection. But I'd like to just discuss with everyone, what would be the ideal stent which conforms? Of course, you have already said thin strut. This happened many years back in the India Live they showed. I still
No.
remember that case.
Any
7
of the-
stents they put.
Any of the thin stunt, deliverable stent, newer stents, like, I don't want to name any companies, but all of us would know.
I think with the advent of drug-eluting balloons, you may have some solutions instead of POBA also. Maybe it might be smarter to do a drug-eluting balloon in the very tortuous lesions and come up. Thank you, Dr. Madhu. Excellent talk. We move on to instant restenosis. Dr. R.K. Jain on how to deal with and what are the solutions for instant restenosis. Shall we check that and go off the next presentation? Rajesh is ready. Have this after the. Just hold on 1 minute. Just hold on. Huh? In the interest of time, shall we? I don't know, you can sort it out while we go with the next presentation? We have the live case coming up from New York at 7:05 sharp. The latest in OCT and the most complex of cases will be shown. Just go ahead with the presentations in the meantime. Now Rajesh is going to talk on thrombus-laden coronaries, how to deal with it.
So good evening to all of you. Massive thrombus can be seen in around 15% of patients with ACS, both STEMI as well as NSTEMI. And you know, it's a risk factor for distal embolization, no reflow, stent thrombosis, as well as long-term adverse cardiac events. Even 2 years after the index procedure, it's a risk factor for late thrombosis. So it's not an infrequent enemy. So when you see an enemy, how to tackle the enemy, so let us go through the steps advised by Sun Tzu, as given in his book, The Art of War. Now, various steps include to attack the enemy, to surround the enemy, to avoid the enemy, to battle, and not the least, the most important step is to flee. I am an expert in that step. Okay. So, most important during a war is to avoid self-injuries. So, when someone like Dr. Verma, who is an expert in martial art of Kerala, which is clarified to ask you to attend a CHIP meeting, you have to obey. Okay. So thank you, Dr. Verma, my dear PG Sandeep, as well as Anil sir, for giving me this opportunity. So first is know your enemy, how mighty it is. So never underestimate anyone. So it's always better to overestimate the thrombus. So how will you get a clue that this is going to be a large thrombus burden? When you see an abrupt cutoff, when there is an accumulated thrombus proximal to the occlusion, when you see a very large vessel, when the length of occlusion is more than 3 times the reference diameter, when there is a floating thrombus proximal to the lesion, and persistent diastasis. And you know how to grade your enemy. So, you know 1 to 5. So you can divide 1 to 3 into low grade and 4 and 5 as high grade. But remember, neither the coronary nor the thrombus know that there is a classification like this. And see this. It's a completely occluded left main with the thrombus hanging into the aortic root and dancing. Okay. So once I showed this angio and asked the crowd, how will you manage? So people told, I will put one carotid filter here, next here, do angioplasty. But nothing can be done, you know. Patient is in shock, profound shock. Even the line was taken by radiographic landmark. So patient is in profound shock, VT stone. So just pull back the catheter, aspirated, then again entered, wired, could establish some flow, but patient expert. So I'm not showing those slides just because, just accept the fact that there is no armor against fate. Both you, me, and everyone will have to stoop before the fate. Now, you have to go beyond the burden. You have to know what is the nature of the thrombus also. In coronary, it is mainly fibrin as well as platelet, whereas in acute ischemic stroke, it is RBC, and in venous thromboembolism, it is again RBC and fibrin. As time elapses, the nature of the clot changes with more fibrin as well as more lymphocytes. And you know, the clot has a head, body as well as a tail. The head is more of a platelet and fibrin, and the tail is that of RBC. So, you know, our fibrinolytics act on the fibrin, and it has a less effect on the RBC, that is red thrombus. So there is a method in China that to circumvent the issue of the ischemic reperfusion injury, they go distally and instill the thrombolytics there, because there will be a slow thrombolysis then, rather than giving it proximal to the thrombus. Now the advantage is, it is said that around 20% of the ischemic, that is necrotic area, is contributed by the reperfusion injury rather than the culprit itself. Now, when you, where do you anticipate your enemy? That is, the terrains where you see are, of course, STEMI as well as NSTEMI. Then stent thrombosis, definitely. The entire coronary will be full of thrombus, venous graft occlusion. You know, Then during coronary interventions, when there is an acute vessel closure, you think about dissection. Recently we had a problem, we stented, but only later we realized that it is an acute vessel closure due to thrombus. Now, not all occlusions need be due to the thrombus. We had situations where a myxoma presented as acute MI, then a patient was on follow-up for papillary fibroelastoma, the aortic valve developed anterior wall MI, and on table we found that papillary fibroelastoma disappeared. So remember, for a war we need weapons. So people like Dr. Varma or Dr. Deepak will have cath labs with all those the armamentarium in the first figure, whereas I am sitting down with an air gun. Okay, so I'm sure 80% of the guys sitting here have only limited resources. And these are the weapons for us to tackle this enemy, that is intracoronary thrombolysis. Then we have various thrombectomy devices like manual or mechanical. You have export catheter, the heart rail, the thrombustor. You can even use the guide extension catheters like GuideZilla, GuideLiner. Then mother and child technique is can be used here. There is something called a double guide catheter technique, which I am not going to all these. Then there is something called a twisted wire technique, which you use to retrieve the embolized stent. The same can be used to pull back the thrombus. Then these guys may have penumbra, angiojet, excimer laser. I haven't even seen those hardwares. Those who have it, well, you can use it. Then something like mesh covered stent, solitaire, all those things are there, but we have only limited resource. Now, the patient, 40-year-old heavy smoker, comes with anterior wall MI. He is hemodynamically stable. So never underestimate your enemy. On table, anytime, the patient can become hemodynamically unstable. So immediately after getting all these lines, the patient worsened, VTVF, became unstable, then repeated balloon dottering was done and low pressure dilatation was done and established flow. Now this is the result. You see a huge thrombus straddling across the left main bifurcation. So the question is, how will you manage? Then I told you that and I'm an expert in fleeing, okay? So you need not take all these deadly weapons. The Lord Krishna seldom used his most deadliest weapon. So you have to choose the weapons very wisely. So I thought I will aspirate it, but the result of the tapas was not totally tasty. So I'm not going to those trials. But all-comer trials didn't specify thrombus burden as eligible criteria. So it's not unreasonable to use these hardwares. So LCX was wired and the thrombus was passed and nothing happened. The thrombus is remaining there. So what to do? Now, always remember that when the patient is admitted to the casualty, when the patient may arrest there, PGs may resuscitate. By that time, they may forget to load the patient with the antiplatelet. So always remember that. Ask the team whether the patient was loaded. So this is not a simple thing. I have noticed it many times that they will tell, yes, the patient was loaded, but go into it, most probably they might have forgot. So always surround your enemy with a ticagrelor, aspirin, and even you have cangrelor available. Intracoronary tirofiban can be given. The data I am not going to present. Then intracoronary streptokinase is also given. So I tried to surround the army because, even Abhimanyu could not come out of that Chakravyuha. Okay. So nothing happened. Now the image shows what the hell it is at the distal end of the left main. Is it an LM dissection or ulcerated plaque? Now an OCT was done, full of thrombus. Nothing could be seen. Now I'm not an expert in imaging, but still. So you see a lot of thrombus there. So what are the options? Will you stent from LAD to LM to LAD, a balloon trap the LCX ostium and then stent, or you go to bifurcation strategy? So basically, I hate the bifurcation strategy in the presence of an acute MI. You will only kill the patient. That is what I feel. So defer stenting is another option. So then again, desperately I used heart rail STO1, then aspirated, and it is remaining the same, exactly the same. So again an OCT run was repeated, again The hell is remaining full of thrombus. No improvement. By this time, 3 times intracoronary thrombolysis was given with the 2 to 3 lakhs of streptokinase each was given. So still it is remaining. Again, desperately multiple times OCT. That dissection flap I could not make out. So one of the strategies to avoid the enemy, So defer stenting. Then we started tirofiban and heparin infusion, and the patient developed severe hematuria after 3 hours of this thing, tirofiban heparin infusion. So when sorrows come, it come in battalions, So the tirofiban was stopped and heparin infusion was continued. So when you take a strategy of defer, then you know that you are between devil and deep sea. Now, having decided to battle, what are the weapons you have all those embolic protection devices, like distal protection, distal filter, proximal occlusion devices, then various stents like M-Guard, stent I'm not going to the details of it. So anyway, I decided to defer the stenting because the mechanism of benefit, the gradual resorption of the thrombus, improvement of the TIMI flow, decrease in the vasospasm and decreased peri-procedural complications of the slow flow. So various advantages and disadvantages are there. I'm not going to it. The first trial always will show some benefit, and subsequent trials will show there is no benefit. That is the trick in all clinical trials. But remember, the follow-up of these trials have shown some benefit, long-term follow-up. Now, the non-uniform time intervals between the index procedure and the deferred angiograms were probably one of the reasons for these differing results. And we thought we will do the repeat angiogram after 5 days. So the patient was asymptomatic, mild LV dysfunction, EF was 45%, and after for 5 days, the patient was absolutely stable like this. So how to do a defer stenting? I need not explain it to you, you are all experts. If it is a TIMI grade 0 to 2 thrombus, you directly stent it. If it is 3 to 5, the anterograde flow is achieved, no ongoing ischemia, consider glycoprotein 2B3 and deferred stenting. If there is no anterograde flow ongoing ischemia, then thrombus aspiration, angiojet or excimer, if you have it, you can use. Then direct stenting, balloon, embedding the ostium of the LCX, and then stenting, all can be done. Now, at another case, an anterior wall MA, just see the ostium of the left main. So what is it? So, will you stent it? Now, in medical college, you have to complete a primary angioplasty with a single stent strategy within a figure of 62,000 rupees. So, no scope for any imaging. So, what to do? Whether to lyse? Anyway, patient was lysed, tirofiban was given, and see the repeat angio that fully disappeared. Now, this is an anterior wall MA, LAD proximal total, thrombus aspiration followed by stenting. Now, after stenting, just behind the stent, you see a thrombus. Now, the tackling of this thrombus was very careful. So, you occlude the LCX balloon and then aspirate. Otherwise, if it go into the LCX, the patient can arrest on table. Now, this was the final result. Now, the last case. So, you'll have to give me the 1 minute, okay? What is happening? Okay. So, sometimes it can be man-made disasters. I told you, when sorrows come, it can come in battalions, as Shakespeare told. So, this is an acute inferior wall MI. Patient was in shock. Desperately, the operator tried many things, and finally, he decided to stent despite the thrombus load, and stented. The patient was shifted back to cath lab, and this developed after 5 hours. And I was called in, complete heart block, shock, recurrent VTVF going on. Somehow desperately tried aspirations and could get some flow. And unfortunately, the PG who was assisting me injected a little bit air also into the system. Okay. So now immediately the patient crashed, arrested, CPR going on. I had to desperately rewire it. I will take 1 more minute. He took away from me. So the patient had recurrent VTVF, so I had no other. Anyway, he's going to die, So I just deep throated that guiding catheter deep into the RC up to the crux and aspirated everything, and this was the wonderful result. And somehow, patient, despite our efforts, patient survived. So, supreme art of war is to subdue the enemy without fighting. So always remember, prevention is better than cure. So avoid acute coronary syndromes. Always, because these hell is seen in thrombocytopenic coronaries are seen in smokers. So discourage smoking. Thank you. Thank you so much.
Excellent presentation. One question I have, usually we get very heavy thrombus burden in ectatic RCS. Very difficult to get the thrombus out. So what are the options in that? Is a laser, even though it's not available, theoretically useful?
This is one thing which, the last one which I showed, if you are courageous enough, but that is not the ideal way to do it. So you have to, introduce a balloon deep into the coronary, and over the balloon you can just clockwise torque and then deep throat the guide. You can easily aspirate it. You will get excellent results.
But the chances of dissection will be there.
You are careful enough, you won't.
Laser, is it useful in such situations?
Pardon?
Laser?
Oh, laser is reported. I haven't even seen a laser, but I think where is Deepak?
Deepak has laser. There is, when you see in the radial angiogram, huge thrombus. If you change to femoral 7 French, and the 7 French aspiration makes a difference. We have seen in some cases.
Yeah, one thing which they have done, they have highlighted is, see the catheters with a round tip is more effective than a tapering tip. They mentioned the Poiseuille's equation and all, and now I don't know. I had the lowest mark for in +2 for physics, So you can go and read. So
Rajesh, a fantastic talk with your sarcastic comments. And as you rightly pointed out, when to retreat is a very, very important military strategy. An extremely important military strategy, because if we put a stent in some of the cases you have shown, that's the end of it. We cannot come out, because most of the time what we have seen is in a huge thrombus burden, we have to manage medically. It is a medical management that is important, not the metal.
Never ever put a stent in such a coronary.
Putting a metal will add insult to the injury. And another thing is the quote we have seen, I think, over 2 or 3 talks before. You cannot kill a man who is destined to live.
You come in, Verma.
Yeah, laser, as pointed out, is an effective technology in getting rid of the thrombus. We have seen it live in Medanta with Dr. Praveen Chandra demonstrating how in a very, very significantly thrombotic coronary artery, the laser passed through and the thrombus just sort of vaporized.
Thrombus just melts away.
Yes, yes. The second thing is, instead of giving intracoronary thrombolysis, where the drug may or may reach the thrombus, what you can do is you can use a thrombus aspiration catheter, pass the thrombus aspiration catheter into the thrombus, make sure that the drug that you give does not come backwards. It has to go forward and it has to lyse the thrombus that is there.
Chinese group say you go distally and then give it, so that it
not
will be
too distally, because you don't want it to flow into the distal coronary and not lyse the thrombus that is behind it also. So just just deep enough into the thrombus so that it does not leak back. Use a newer thrombolytic agent and use 1/3 the systemic dose. After giving the dose, wait for 15 to 20 minutes, recheck again. 90% of the thrombus would have been dissolved. And if there is some residual thrombus, a second application of the newer thrombolytic agent in the intrathrombic location rather than an intracoronary location will work wonders.
Dr. Verma, previously we had a catheter called a clearway catheter. Now what we use is we perforate a balloon, and all balloon is perforated and put it going into the thrombus and deliver the drug.
Yes, but it's easier to deliver the drug through a thrombus aspiration catheter because of the bigger lumen and the easier deliverability.
The problem
through a slit balloon, the problem is that you cannot inject so fast, and the flow is because the lumen is very, very small. And if the slightest kink means that the drug will not flow distally at all. You will have to use a lot of force.
Actually, this is the point I also wanted to make. How the putting holes, instead of making holes, it should be longitudinal slits.
Yeah,
and
longitudinal
then
slits.
Try
Not holes,
it out
it's a
once, and then when balloon is there, you can always use the balloon to daughter, give it at distal places,
And it is-
and then at different branches you can go and give, because it's not only at that lesion, it has to be even downstream clearance. So you have to go down and give. So it has to be in multiple points. We have used streptokinase, reticulase, all these stuff, and it does work. And coming out without stenting is sometimes the most prudent thing to do.
And mostly you will be able to avoid, because this type of thrombus burden is mostly on a non-occlusive plaque. So once the thrombus is cleared, usually they may not
In
require a
fact-
stent. What is your experience on that? The re-angios?
Re-angio.
Re-angios. Mostly there won't be anything. Patient can go home without a stent.
Absolutely.
In fact, even left mains, we have used just the Tiger catheter and aspirated. OCT after a week shows only a plaque, eroded plaque, nothing to do.
See, when you it was very entertaining, your slides, very thoughtful, thought-provoking.
See, when you inject this through this thrombosuction catheter, you may inject it with a big force. So you can wash out the thrombus back into the aorta sometimes. So if you can use this clearway or small slitted balloon, that danger is less.
There was a criticism with thrombosuction all along, no, that you can cause strokes. Can we go ahead with the next talk? We have the slides ready for Dr. Jain talked on in-stent restenosis.
I thank CHIP CO directors, Dr. Deepak Davidson, Dr. Anil and Rajesh for inviting me to talk today. Today I was told to talk about laser atherectomy, specifically in-stent restenosis, and some of the CHIP cases we have done. If time permits, I'll go through the CHIP cases, but most of my talk will talk on use of laser and how we have used this laser atherectomy in patient with in-stent restenosis. In-stent restenosis is not rare. Even with second generation stents, is about 5 to 10% of all PCIs. What's important is ISR increases with increasing number of layers. So whenever we do in-stent restenosis, you make sure that you don't put another stent until you know what is happening inside, what is the cause of in-stent restenosis. So for one layer is 2% at 1 year. If you keep 2 layers, it's told to 16% at 1 year. If you have 3 layers, it's 25% at 1 year. So the more the layers is the worse. So before you put more stents in ISR, make sure you do an imaging and understand what is the cause of ISR. These are one of the very beautiful article which is published in AHA in circulation. These are the common cause of in-stent restenosis. The first is stent under expansion, which can be seen in ICT, OCT or IVUS. Second is when you have a significant plaque at the stent edge. That means you landed the stent in a plaque zone which is more than 50% plaque. Third one is a thrombus which extends into the lumen on IVUS and OCT. The fourth one is non-overlapping stent. Whenever you do a overlapping of the stents and you don't approximate, you don't overlap, that's a site of restenosis. And then you have a dissection flap, which is in the distal area, which can make by OCT. We have a criteria on OCT, what type of dissection you have to stent. And then the fifth cause is the fractured stents. Whenever you have fractured stents, you get ISR. So these are the common causes of in-stent restenosis. And these are proposed algorithm for treatment for ISR, and especially if you have an IVUS or OCT. So if you have stent under expansion, you do a plain balloon, a cutting balloon, or a scoring balloon. You do an ELCA laser, or you can do followed by an IVL if necessary, or then a drug-coated balloon. And if it's a stent under expansion. If you have non-overlapping stents, then you do a drug-eluting stent. And you have a stent fracture, you better to do a drug-eluting stent. And you have a dissection at the distal end of the stent, use a drug-eluting stent. So in-stent, if you have known the morphology, if it's a homogeneous ISR, then use a drug-eluting balloon, that's enough. If you have non-heterogeneous and you have a layered intimal hyperplasia with a lipid rich, you might have to use a drug-eluting stent. Again, you have a multiple stents, use only drug-eluting balloon. So this is a proposed algorithm. This is another slide which shows the three causes, histopathologically, neointimal hyperplasia, neoatherosclerosis, and stent under expansion. We can well see all these by OCT imaging. In the first image, you can see homogeneous, bright, uniform layer. This is the first type. And neoatherosclerosis, you can see heterogeneous composition of the intimal hyperplasia with a necrotic core, thin fibrous cap, lipid and calcification, and foamy macrophage accumulation. So when you have neoatherosclerosis, you go and better do a stent again. Under expansion and homogeneous, bright, uniform layer, you can get away with a cutting balloon and regulating balloon, and if stent is under expanded, expand the stent. This is a very busy slide again telling the same thing, which I will not go through. And this is a Waxman instant histolosis classification. Type 1, which is mechanical. Type 2 is biologic again. Intimal hyperplasia, neoatherosclerosis, null calcified, neoatherosclerosis calcified. And in mechanical under expansion of the stent, definitely high pressure balloon and ELCA can be used. And when there is a neoatherosclerosis calcified type, you can use an ELCA and a scoring balloon. Mixed pattern again can be combined mechanical and biological etiology. And the fourth type is chronic total occlusion, and fifth type is more than 2 layers of stent. And these are the armamentarium available right now: plain balloon, rotational atherectomy, brachytherapy, ELCA laser, cutting balloon, and orbital atherectomy, IVL. These are all available for the treatment of this. I'll just go through our experience with laser atherectomy just to know mechanism of action. It has 3 mechanism of actions: lyse pulse and absorbed by tissue. And this light pulse ablates some mixed morphology at a molecular level, and this breaks molecular bonds and debulking the lesion. The acoustic pressure wave modifies the calcium, and this cracking calcium and changes the vessel compliance. The cavitation bubble expands and collapses, and this debulks the mixed morphology and breaks down material into the size less than RBC, and this enhances the lumen gain. These are 3 mechanisms how the laser atherectomy occur. This is again nicely shown. If you see the light pulse, which causes change in the plaque morphology, mechanical and sound, which is caused by the layer, which creates a wave, and the bubble, which causes a cavitation. All these 3 ablate at the molecular level, modify the calcium, and debulk the mixed morphologies. Laser setting through things, I just want to know there is a fluency, there is how much energy we use, and this is like hammering. And if you do repeated hammering, how is the repetitive rate? So these are the 2 important parameters when you lace. We use a fluency of start with 40, go up to 60 and 80. And then repeated rate, again we go 40, 60, depending on the type of lesion. I'll just go through that. So you can think of fluency rate. Fluency is nothing but the energy delivered, direct relationship or the size of the vapor bubble. Higher the fluency, larger the bubble. Higher setting typically required in calcium. Higher setting typically required more effective in thrombus. Repeated rate of the layer pulse, it's like a jackhammer effect. Little, if any, has effect on the vapor bubble. Higher repeated rates typically required in calcium setting. Our standard protocol is the first pass we do with 45 fluency and 25 repeated rate. Second pass at medium setting. And the third part we go for the higher setting. This is a classical how we do lasing technique. Just go through some of the examples we have. This is a 50-year-old male who had a positive TMT in August 2021, underwent a PTCS stent to RCA with us in 2021. And he had a OCT guide while IV lacerated PCS stent to RCA, and present again in class 2 angina, and he had ISR of RCA, and we did a LCA assisted PCA with a drug-eluting balloon to RCA in 5th month of 22, and his follow-up is doing fine. And this is the lesion. You can see there's a type 1 lesion, and we thought this is stent expansion, even though we didn't do the imaging here. And this is the laser atherectomy catheter, 0.9 mm ELCA catheter. We did by 80 by 80, 6,600 pulses. And after this, we used a cutting balloon and a drug-eluting balloon, and this is finished the procedure, and this is the final result. And patient at the end of 1 year is doing fine. The second example is a patient who had a re-stenosis. This is a patient, 53-year-old male. He underwent CABG in 2004, then first stent in 2004 to PTCS stent to LCX. At the time, a Taxa stent was used, and followed in 2015 again by PTCS stent to LAD. He had recurrent angina. He underwent a bypass surgery in 2014, Lima to LAD, and SVG to all other vessels. And in 2014, he had again angina, all grafts were closed. Then he underwent a PCI to LMCA with LCX and ECMO support in another center. Again he had angina, then it was a Rota PTCS stent to LCX with a IVAS guidance in 2021. And now again he comes with unstable angina. He has a single circumflex dominant vessel which is survived, and this is the circumflex with the left main restenosis. So in this patient again we used a laser atherectomy with 0.9 LCA. Like we said, 45 fluency and 45 repeated rate, 3 passes. We went up to 80 by 80, 4 passes. And after that, LCA, we used a cutting balloon, and then we used a OPN balloon 3.5 into 10 millimeters, and then we used a drug-eluting balloon 3.5 into 9 millimeters. And this is a final angiographic result, and you can see there's no left main, all the grafts are occluded, it's a dominant circumflex. And the patient is fine now 1 year, instead of having re-stenosis. So we didn't use any stent here, because we thought it's a under-expanded stent at the level of the left main circumflex. This is another patient who had a CABG 1997, and he underwent he was fine till 2021. Then he had class 3 angina. He had SVG to OM proximal 90% lesion, which was stented in July 21 with Ultimaster drug-eluting stent. After 6 months, he developed again unstable angina with a severe dysfunction, and he was admitted with cardiogenic shock. And this is the instant restenosis in this ISR. At that time, last time when the stent was done, patient had a calcified SVG graft. So we have to use a OPN balloon to open the stent at that time, even SVG graft. And still then he had a restenosis here now. And now we opened up with an LCA laser following by a cutting balloon and a drug-eluting balloon. And patient is fine at the end of 1 year clinically without restenosis. So again, another patient with re-restenosis LCA and patient with an OCT guidance. This patient, he had acute inferior MI in July 2022. Angio showed triple vessel disease, PTS sent to right coronary artery, and onyx stent was used 3.5 to 24. Again, he had unstable angina in 1222. They thought LAD lesion is significant, they stented LAD. And they did a drug-eluting balloon to mid RCA, and they thought proximal RCA was significant and stented that lesion 2.5 into 20 millimeters. Again, within few months, he had again unstable angina, and at that time, angio showed a ISR of the mid RCA stent. So in a peripheral hospital, because he had unstable angina with positive markers, a POBA with a cutting balloon was done, and patient was told he can go for a bypass surgery because it's a third restenosis. This patient came to us with a class 3 angina in April. So this is an angiogram, and this is after POBA, and know that this will definitely going to progress again because the intimal hyperplasia is still there. And we offered him that if he undergoes ISR of this lesion, he can avoid a CABG because LAD looks fine. Just for RCA doing SUBG is not correct. And this is an OCT pullback, if you see that. And you can see the distal vessel is good, about 11 millimeters. And here you can see that the stent is under expanded here, and it's only 4.3 luminal area. And under expansion of the stent is a 68%. So if you see the MLD morphology, neointimal hyperplasia, the length of the stent is 50 millimeters, the diameter is 3.5, the MSA is 4.3, the proximal MLA is 10.7, and distal also is 10.7. Definitely there is a lot of malopposition. And you can see under expanded stent malopposed segment in the second OCT picture. And also you can see the overlap stent was not fully opposed. You can see there's a gap between the two stents, and that's the cause of restenosis here. So in this case, we used LCA laser here, 0.9 millimeters. We did multiple passes, and after doing LCA laser, we used a NC 3.5 into 12 NC balloon, and we dilated the malopposed stent and under expanded stent. And then we used a OPN. It's very important that whenever you are unopposed stent, and if you don't get a good expansion of the stent, better to use an OPN at a high pressure. So we used OPN 3.5 into 10 at 335 atmospheres for 50 seconds. And after this, we did an OCT, we did a Wolverine cutting balloon again, 3.5 into 10 at high pressure. We went up to 18 with Wolverine balloon. And this is a post LCA cutting and OPN balloon difference, if you can see there. And the expansion at the under expanded stent is 100%, and MSA is 8 square millimeters here. So we got a very good expansion by using a combination of LCA atherectomy, a cutting balloon, and an OPN balloon. And this step of once you have a good expanded stent, we finish and you can see that pictures here at the level of the under expanded stent is very expanded, and you have luminal area of 10.8 and expansion 138%. And then finally we finish the procedure with a drug-eluting balloon, 3.5 into 30 millimeters agent at 14 atmosphere, and this patient is last 7 months is doing fine. And this is a final result of the RCA. You can see It's a well expanded stent, and I think it should do well. This is a second picture in another view. So just I thought I'll share some of the laser in cheap cases. This is a patient with STEMI, cardiogenic shock, and you can see the dual role of ELCA, laser evaporation of the thrombus. There was some discussion in the previous talk. And patient also had a CTO and with a cardiogenic shock. So this patient is 72-year-old with no comorbidities, and he was admitted to emergency room with cardiogenic shock with a profuse sweating of 1 to 2 hours. His BP was 60/40. He was started on inotropic support, and EC showed STEMI with severe LS function. And because he was worsening, we put a bedside femoral vein and started him on vasopressor support, and he was in cardiogenic shock, SCAI stage 3, and intraventric balloon pump was put in the ICCU only and shifted to cath lab with NIV support. An angiogram showed these are hemodynamics of the patient, and he was in a very bad shape. We counsel the family that we can just an attempt, check the angiogram, we can offer him something or not. And you can see that intra-aortic balloon pump. This is the right coronary artery. You can see it's good. And this is the left pictures. And you can see there's a total occlusion of the LAD, and there's a calcified vagal, and there's a proximal LAD ostial, there's a thrombus. And that is the culprit of the anti-MI. And we couldn't cross with any balloon. We crossed with a XTR and 1 millimeter balloon and 0.75 we could not cross. Then we have to use a guideline extended, using a guideliner. We did a vaporization of thrombus, and then we crossed with ELCA laser there. And then we did a plain balloon with a 2 millimeter NC with a guide extension catheter. And this is the final result. And the patient was kept on intra-aortic balloon support, and this is the final result. We didn't want to stent because we will not know where to stent, and because it was very bad, we can't go on stenting the whole LAD, we backed out. As the previous speaker said, you should understand when to back out also. And this is the final patient, and patient was discharged and doing extremely well. And this is my final case. This
Dr.
is
Jain, we'll have to stop.
Yeah,
the
I think
live.
I'll stop, yeah.
Thank you very much.
Yeah.
I think sorry about the initial hiccups.
No
We
problem.
have to move on to the next session in the rest of time for the live meeting. So I request the next session to get started now.
Thank you very much, sir. Thank you to all the chairpersons and the presenters. May I invite the next set of chairpersons, the session on cardiogenic shock. Dr. Prabhanini Gupta, please, ma'am. Dr. Joe Joseph, Dr. V.L. Jayaprakash. And Dr. Balakrishnan also, please. For the kind attention of the chairpersons, we'll have Dr. Ajit going on first, sir. Dr. Ajit will be presenting first.
Hello? Hello?
Hello, good evening.
Good evening. Can you hear me?
Yeah, we can hear you loud
This
and
is
clear.
Dr.
Okay.
Balakrishnan. Welcome to
They're
the
just
evening meeting.
introducing, the chairs are just introducing you.
Sure. Thank you. And can you see the slides?
We can.
Okay. Thank you, Anand. Yeah.
So discussion on cardiogenic shock. Dr. Ajit Mullacheri, please.
Can I just make one comment before he starts his talk? See, if you look at studies which have come in 2023, if you take randomized trials on MCS in cardiogenic shock, especially ECMO, there's no difference between the two. But if you take non-randomized trials, which has come in Journal of Cardiovascular Surgery, definitely ECMO has a survival advantage. Okay, sir, please go ahead.
Thank you, Dr. Prabha, and thank you, Anil and Rajshekar, for inviting me. And sorry, Venu, that I had to step in because I have another lecture in 15 minutes' time. So I'm going to talk very quickly in 15 minutes on acute MI, the current strategies of management. So as we know, it's a leading cause of death in patients hospitalized with AMI in the reperfusion area, and the mortality was as high as 70 to 80% with conservative management. The incidence ranges from 5 to 10% of patients with acute myocardial infarction. As we know, that thrombolytic is less effective and early mechanical revascularization improves survival. In the SHOCK trial, early revascularization resulted in 132 lives saved at 1 year per 1,000 patients treated, as compared to conservative medical therapy. When you look at cardiogenic shock, I think what happens here is that you have to first rule out some mechanical causes like ventricular septal rupture, like acute severe MR, isolated right ventricular shock, tamponade, and rupture. And then look at predominant left ventricular failure as the cause of cardiogenic shock, which is what we are talking about. Now, early perfusion is a key to improve outcomes in shock. And thrombolysis has low rates of reperfusion, and mechanical revascularization creates a complete and sustained reperfusion. PCI is the most frequent mode of revascularization chosen, and in-hospital survival after PCI, even after all the developments of technology, currently is close to 50%. Now, this was a landmark first trial which showed that early revascularization helped in long-term survival as compared to medical treatment. And you can see this was a SHOCK trial which showed these outcomes in terms of early revascularization. So we started looking at our data at Madras Medical College, and this was the first paper that we published on percutaneous interventions in cardiogenic shock in acute MI. And this was in the era of a single center to assess the predictors of midterm outcomes of PCI with ST segment elevation MI and shock. So this was, remember, the era when primary PCI was still not fully available, and we used to selectively use primary PCI for cardiogenic shock. It was predominantly the era of thrombolytic therapy. So this is the time from January 2001 to 2007. Approximately 2,070 patients underwent PCI in this time, and primary PCI was 235 only. And PCI in shock was 41 patients. We looked at the analysis comparing the baseline angiographic PCI data, 30-day and 1-year survival. The diagnosis was a typical diagnosis of pain, ST segment elevation, and CKMB. And shock was defined as hypertension, systolic blood pressure less than 90 for at least 30 minutes, and requiring the need for supportive measures. There should have been end-organ hypoperfusion with a heart rate which was more than 60 and an output of urine less than 30 ml per hour. We had to have left ventricular failure. We ruled out, as I told you, all the mechanical causes of cardiogenic shock causes. What is interesting in the univariate analysis of all primary PCI patients, survivors versus non-survivors, of those very small era of 41 patients, we could see that simply CPR and transfer admission was in univariate a very important predictor of mortality. So if you were a non-survivor, you were likely to have had a CPR or you had a transfer from another hospital. In terms of the angiographic characteristics, a pre-TIMI flow, which was lower, was more common than in the non-survivor, and post-TIMI flow, which was lower, was a predominant issue with a non-survivor. A successful PCI, which is good TIMI flows with a 50% less than residual, was also a predictor of a better outcome. So if you had a PCI success, good pre-TIMI flows, and good post-TIMI flows, you did better in terms of survival. Our 30-day survival was only 45% as compared to the SHOCK trial data, which was in a similar era, which was 54%. So in the phase 1 study of cardiogenic shock in our hospital, where we did what we could at that point in time, the mortality was 56%. And by preserving the ischemic myocardium, maybe the mortality came down from 80 to 56%. Establishment of TIMI flow is of paramount importance, and mortality could have been due to a delay between the shock onset and PCI and referral and transfer from another hospital to ours. So we felt at that time an early risk stratification, better referral systems, use of adjunctive therapies and assist devices could improve the survival future. Now, what happened in the next time era, that was another 10 years, is that primary PCI became the mode of treatment of AMI in our hospital. And by that time, the STEMI process was set up in Tamil Nadu and especially in MMM. And the primary PCI was much larger, 1,503. There were shock patients in 73. And we again did the same analysis. And what we found similarly that a higher heart rate in univariate, a lower systolic blood pressure, a lower ejection fraction, and severe
I think Dr. Ajit has gone offline.
that non-survivors and longer IBP duration are
Dr.
expected.
Ajit, can you put off your video because the bandwidth may be a problem. Without video, the audio will come through clear.
Okay. Let me do that.
Yeah.
Can you hear me now?
Very clear, but breaking, if you could.
Yeah. Okay, so I'm just going to put off the video for a minute. And we can see that in coronary artery disease, the severity didn't make any difference to the whole thing. What about post-Timiflow and PCI-SX is similar in the post data. We still had the same problem. If you're less successful with PCI and lower Timiflows, you had non-survivors in the group. So in phase 1 and phase 2, the differences, some were similar. But what we clearly found that despite improving all your, your transfer times, you're improving your treatments, and having less CPR and less transfer time in terms of things, we still seem to have the same poor outcomes. This was again published in Indian Heart Journal. And in the phase 2, we continued, even though patients got referred faster, lesser thrombolytics was used and more primary PCI, and IBP use was even lesser in this group of patients. So we felt at that time maybe that ECMO and VADs and Impella could possibly help with that. So temporary mechanical support, what is the data? So they are complete care used in patients who have low cardiogenic shock, who have high CVPs, who have high left atrial pressures, who have low systolic blood pressures with 2 inotropes, if they have distal low perfusion and significant wall motion abnormalities. And the clinical indications of one of them is, as I showed you, is cardiogenic shock. Now, cardiogenic shock, the definition remains the same, and the various types of available temporary PCI shocks are intra-aortic balloon pump, which is pneumatic, cannula size is 8 French. We also now have 7 French device, but you get very low support to this group of patients of 0.5 to 1 liter. There is the VA ECMO, which is a higher cannula size. You get a better support, but the problems is implantation times are much higher. The risk of ling ischemia takes place, anticoagulation is there, and hemolysis is there. The tandem heart, which is rarely used in most of our scenarios, has also the similar problems. And then you have the Impella, which is the 2.5, the CP 3.5, and the 5, which again it can be accessed easily, but you need a higher French flow, and you need to have a worry about the groin in terms of ischemia. Now, if you look at intra-aortic balloon pump, this was designed by Adrian Kantrowitz, the surgeon inventor, who showed that apart from aortic regurgitation and dissection, this is an excellent tool for patients with MCS usage in cardiogenic shock. What happened was, unfortunately, the data with this intra-aortic balloon pump in IBP shock trial had no difference in survival. The CRISPR-AMI in STEMI patients had no reduction in survival. The NCDR registry showed no difference in mortality, and the BCIS had no difference in survival. So intra-aortic balloon pump in general became a little difficult because the data did not reduce all-month or 12-month all-cause mortality. For refractory shock currently, the evidence is class 2A, but routine use of IBP is class level 3. I think it could be considered in patients with hemodynamic instability, cardiogenic shock due to mechanical complications. But let me be frank, in our hospital, we do about 120 IBPs a month. And this is very commonly used because now, number one, we have no data, as Dr. Prabha said, which I will come to in Impella, having outcomes better than in shock as compared to IBP. And this is a very good way to handle patients who are in pre-shock scenarios. For cardiogenic shock, many of the data, many guidelines have unfortunately pushed it for routine use in class 3, but as 2A for selective use in patients, especially with mechanical complications. Now look at Impella. It's like simply like a pigtail in the left ventricle. It improves flow. It improves mean arterial pressure, decreases the EDP, and improves the cardiac output and power, and improves oxygen supply and demand. But the problem in many of the initial trials, which were registries, were showing that Impella was better than IABP. But when it came to the larger trials and the larger randomized trials, it was not so. And I will come to you why this is issue. So before that, let me ask, we go through some data with Impella. In the meta-analysis, you can see in the last line, a large meta-analysis, which was published, Impella in acute myocardial infarction shock was associated with a significantly increased risk of bleeding, limb complications, and hemolysis without an improved short-term survival advantages compared to IBP. Similarly, a large paper which again looked at the randomized data of Impella compared with IBP in STEMI patients, with shock was associated with higher in-hospital mortality and others procedural outcomes. This is a JAMA Internal Medicine, which ultimately I think more or less put the nail in the coffin, which showed that in a propensity match analysis of patients undergoing PCI for AMI, the intravascular LVAD was used with increased short-term and 1 year risk of mortality, bleeding, and cost, which is, I think, a crippling cost, especially in an Indian scenario, as compared to IVP. ECMOs, we use it in crash patients or post-surgical patients who don't come off the pump. It is cheaper option, but again, the problems of limb salvage is another issue, and we have to be very careful in using these procedures. Again, it has no data now clearly, at least in cardiogenic shock and AMI, as having any superiority as compared to traditional methods. So we have all these various techniques available, the intra-aortic balloon pump, the Impella, the tandem heart, and VECMO. But practically in our terms, in our hospital, we still use the intra-aortic balloon pump as a commonest mode, and Impella is very, very selective use, especially in patients who are more like a high-risk PCI and not a cardiogenic shock in AMI. So I think with this 15 minutes, I will stop here. I have a few cases, but that we'll have some discussions on this. Thank you very much for giving me a patient hearing.
Thank you, Dr. Ajit, for this wonderful elaboration on AMI cardiogenic shock. I got a question regarding your IABP use between the phase 1 as well as the phase 2 of two parts of the trials. In the phase 1, your IABP use was around 100%, even though the numbers very, very less. But the phase 2, you mentioned about 56%. What's the reason for that?
Well, I think some of it was the time when the IABP data was being scrutinized. So cardiologists in MMM were unsure whether the IABP is useful or not, really. And they were more selective in picking these patients up for the use of intra-aortic balloon pump. Technically, right now, our usage is more than 80% of intra-aortic balloon pump back again. Many of the patients, we also realized that if you quickly revascularize with primary PCI, unlike in the first era, where it was more thrombolytic and late referral, where they were full shock, developed shock, we could avoid the use of these intra-aortic balloon pumps.
And actually, there's a full circle about culprit vessel as well as multi-vessel PCI and cardiogenic shock. Actually, earlier studies showed that doing a single culprit vessel leads to good short-term and long-term survival. And then some recommendations came for multi-vessel PCI in cardiogenic shock, but that was a negative trial. So what is your hospital policy on revascularization?
Yeah, so I think the same scenario, I probably would just fix the culprit vessel first. Unless the shock does not improve after fixing of the culprit vessel, and there is a non-culprit vessel which is tight and which can be easily fixed. Because the data for culprit shock surely showed that doing non-culprit vessels will increase events related to die and mortality. So, and renal issues. So my policy is fix the culprit, look at the shock parameters first. If there's a critical tight stenosis and the shock doesn't improve immediately or within the first 15 or 20 minutes on the table, then I would possibly go in for the non-culprit. Otherwise, stage it and do it 2 or 3 days later.
Yeah, Dr. Madhu has a question.
Dr. Ajit, I'm quite surprised. You use 120 IABP a month. So
Yes.
after the IBP shock 2, what cases do you use? Do you use for all cases or?
I'm talking about not only AMI patients. We are talking about high-risk PCIs. We are talking of surgeons. We have a big surgical unit which does about
No,
2,400
surgery
surgeries.
is fine. I was talking about the cardiac. I thought you were using.
Oh, it's not about AMI. Sorry, Madhu, if you
All right.
mistook
Sure,
me.
sure. Okay. Fine, thanks.
We still use about 25 to 30 for AMI scenarios, either pre-shock or in shock.
Yeah, yeah. Actually, your mortality of 56% in cardiogenic shock in your later phase is not bad, because no, is it for 56% mortality? Because as I said, there's a paper by Cindy Grimes, which they said when you use Impella more than 7 times in a year, the survival of cardiogenic shock still, that is say 1920, is only 51%. I was referring to that paper yesterday. So 56 without Impella or even with Impella is still impressive, whether it's mortality or survival.
I think we have to be a little careful when we interpret data. If you look at the NCDR registry, despite all the devices coming in, the mortality is steadily increasing. And that is reason is because there is more aged population coming in. There is more CKD patients coming in. And those patients will obviously have higher mortality. It may be nothing to do with your Impella or your IBP. And I'm glad Venu is there with us and listening to me, because in Cleveland, I understand that intra-aortic balloon pump is still the commonest mode of MCS usage.
So Ajit, shall we move on? I think in the interest of time, we will. Thank you, Dr. Ajit, sparing your time. Very valuable comments. Thank you.
Thank you. Thank you very much.
Very nice data.
Thank you, sir. Evaluation of a patient with cardiogenic shock, Dr. Venu Menon. Let us move to the next topic.
Can you folks hear me and see my slides?
Can I ask a question? Are you the Venu Menon of the first shock trial?
He is the Venu Menon of the first
So we
shock
are very honored to have you here, because we always read your articles, be it on shock or other things.
Go ahead, Venu.
Thank you so much. And thanks, Anil, for giving me the opportunity to speak here today. I knew Ajit would do a terrific job talking about the management of shock. And so what I thought I'd do is take a little out of the way talk on the pathophysiology of shock and be a little provocative and ask the question, where is the lesion? So what I thought I would do is take the lens of time and talk a little bit about our understanding of the pathogenesis of cardiogenic shock over the years. So this is Tinsley Harrison. He first used the word cardiogenic shock back in 1935 in his textbook, Failure of the Circulation. And then in the early 1950s, actually people started measuring cardiac output in the setting of an acute myocardial infarction for the first time. And these are the first 12 or 14 patients defined with cardiogenic shock. And you can see that even back in the 1950s, we really defined cardiogenic shock as someone with a very, very low cardiac index in the setting of a primary cardiac insult. But what is even more fascinating is with the tools used at that time, you can see that the systemic vascular resistance that was assessed in these patients with acute myocardial infarction varied significantly, showing us that the response of the periphery to an acute myocardial infarct was quite heterogeneous. So the phases, cardiogenic shock is a heterogeneous clinical entity, right? What I've shown you here is just a vignette of a number of causes for cardiogenic shock. And I think the first question to really define in terms of management is to really understand what is the primary cause for cardiogenic shock in your patient. Is it a massive acute pulmonary embolism? Is it a flail mitral leaflet? Is it a Takotsubo stress-induced cardiomyopathy with LV outflow obstruction, or just severe acute AI? For the sake of time, what I will restrict myself today is talk only about shock in the setting of LV, predominant shock in the setting of acute MI. And I might spend a little time, if possible, talking a little bit about cardiac arrest in the setting of acute MI and shock, because I think that's a fairly unique clinical entity. So let me take you back to the early 1970s. This is the first real paper that gave us insight into the mechanism of cardiogenic shock. This is data from the Mass General Hospital in the early 1970s. They took 20 patients with an acute MI who died of cardiogenic shock, and they compared the autopsy specimens with 20 patients who died of MI but from other reasons. And what you can see on the right is that the size of the infarct in patients who had cardiogenic shock was much larger than those who did not have shock. And on an average, the amount of LV dysfunction in the setting of predominant LV shock involved about 40% of the LV myocardium. So based on this initial finding, we had our initial hypothesis of what we think was the etiology of cardiogenic shock. This is a landmark cartoon by Perillo, who did a lot of work in the early days of shock. And in what I call the mechanistic model, you can see that our current concept is that in the setting of a large acute myocardial infarction, there's clearly acute loss of LV compliance that results in increased LVEDP and pulmonary congestion. And in parallel, because of the acute myocardial injury, there's a reduction in contractile reserve, there's a drop in stroke volume and cardiac output, and that results in ischemia, both in the infarct zone as well as the non-infarct zone. In compensation, the periphery vasoconstricts, trying to maintain mean arterial pressure and perfusion of vital organs. And when this compensation is overcome, there is circulatory collapse, which results in the patient's death. In many ways, the shock trial that we did is validation for this mechanistic approach. When we aborted the infarct and we salvaged myocardium by going after the ischemic territory, as Ajit said, we were able to save 13 lives saved per 100 traded. Now, when we did the shock registry, we also did a parallel large registry in which we were able to define hemodynamics with a right heart catheter in a large proportion of patients with cardiogenic shock. And shown here are three seminal findings from our early right heart catheterization data in patients with shock. One was that unlike the cartoon that I showed you with increasing systemic vascular resistance, most patients with shock had a relatively normal vascular resistance, and some patients actually were quite vasodilated in this setting. The second was that in the setting of cardiogenic shock, you see a systemic inflammatory response-like syndrome, which really mimics a septic shock-like state. And finally, we were able to define a group of patients who had ineffective peripheral perfusion, they had ineffective cardiac indices, but were able to maintain their mean arterial pressure simply because they had a markedly exaggerated peripheral vascular response. Now, because of these three insights, we altered our initial cartoon of what we thought represented cardiogenic shock. So in the early part of this century, we not only stayed true to the original mechanistic theory of acute injury causing hypoperfusion, but we also, on the right, showed that there was a secondary component to cardiogenic shock, which was purely inflammatory, with release of inflammatory cytokines, with release of nitric oxide in this setting. And both of these reactions were responsible for peripheral vasodilatation as well as negative inotropy on the heart itself. And so with this understanding, we moved on. And despite 25 years after the shock trial, as Ajit showed, we've made very little further impact. So immediately after the shock trial, the rates of primary PCI for shock went up dramatically. The mortality rate went down. But over the last 2 decades, despite optimal PCI, you can see the rates similar to what Ajit showed in Madras were in the 50% range. So why are outcomes unchanged despite revascularization that is optimal in the setting of an acute myocardial infarction? One, you could clearly say is because of ineffective revascularization. So people are either presenting too late after an infarct for us to effectively recanalize the IRA and salvage myocardium. This does not seem to be the explanation because in most of these trials, patients were well within the treatment window of 0 to 6 hours after an index MI. The second, you could say, is because of a lack of salvage. So although we're opening up the epicardial artery, we're just not getting enough flow down the microvasculature to actually salvage myocardium. But this too doesn't really seem to be the case because we often get very, very good results in this setting. And so this cannot be the explanation. Finally, it could be that we're performing incomplete revascularization in that we are not completely revascularizing the myocardium in this setting. But as Ajit said, in the culprit shock MI, Holger Thiel and colleagues really did not show benefit of a dedicated strategy of complete revascularization. So really, complete revascularization, if playing a role, it's more a niche than anything else. So are we then missing the target? So what I'm trying to say there is that as we look at this cartoon and as we work on improving outcomes with shock, have we reached a plateau of how much benefit we can get simply by opening up the infarct artery? And should we now concentrate on the periphery in terms of trying to improve circulation? Put another way, is our focus on the heart too cardiocentric? And in terms of revascularizing and restoring heart function, are we really missing the signal of what the impact of the macro and microvascular circulation is in the setting of shock on other vital organs, which now account for the major cause of death in this setting? So I want to move on and first ask the question, how certain are we about this alternate inflammatory pathway? And so this is about 20 years since we originally proposed this pathway. And this is a paper in Nature Research, 30 patients in France with an acute myocardial infarction and shock. You can't read the chemicals here, but as we reported 20 years ago, acute inflammatory markers like interleukin-6, TNF-alpha, all markedly elevated in the setting of cardiogenic shock. This is data from Spain. They're looking at various chemicals that can be inflammatory biomarkers in the setting of shock. And you can see up here, we're comparing patients with KILIP-1, KILIP-2, and KILIP-4. As you work to the right, the number of green is the activation of the number of inflammatory markers. And you can see as you move to the right of that cartoon, the number of activations in green increase dramatically only in the patients with a very large infarction, suggesting that acute inflammation is an essential component of a large acute MI. We then did this trial in the early mid-2000s called a TRIUMPH study. So we said, if nitric oxide is a mediator, why don't we inhibit nitric oxide using a nitric oxide inhibitor? And so these were patients with shock, acute MI, open artery, in shock. We simply gave them this nitric oxide inhibitor, telarginine acetate, through the parenterally. And you can see just by giving this agent, dramatic increases in blood pressure in the treatment arm, not seen in the control arm, really confirming that nitric oxide was playing a role in this pathogenesis of hypotension and hypoperfusion in the setting of an acute myocardial infarction. However, despite getting an increase in mean arterial pressure, we found no difference in outcomes in this clinical setting. This is data from Holger Thiel's group. This is data from the culprit shock trial. What Holger Thiel did in culprit shock was he took 4 biomarkers on admission: lactate, a marker for hypoperfusion; interleukin, a marker for inflammation; cystatin C, clearly a marker for hypoperfusion and renal injury; and NT-BNP as a marker for LV wall stress. You can see that just using these markers in patients, they were able to beautifully predict who was going to die and who was not. And when in a validation study, they use these same markers as predictors for acute MI in the IABP SHOCK 2 trial, you can see that this CLIP strategy, just using biomarkers, was better than any of the clinical predictors that we traditionally use, like size of the infarct, location, blood pressure, and age. Again, suggesting that unless we can alter what's happening in the peripheral milieu, further progress in this area is going to be unlikely. This is data that my colleague Jake Genzer worked on at the Mayo Clinic. These are 7,000 patients admitted to the Mayo Clinic over the last decade. These are in all SKY stages. And he divided the patients into those who managed or manifested a systemic inflammatory response syndrome and those who did not. And you can see that for every SKY stage, those who manifested a systemic inflammatory syndrome had a higher mortality. And shown on the right, the greater the number of markers for a systemic inflammatory syndrome, the greater the mortality. Again, confirming that inflammation in the setting of an acute myocardial infarction is a marker for mortality and a marker for poor outcome in the setting of shock. For the last 2 minutes, I want to focus a little bit on patients with cardiac arrest. Ajit very beautifully showed that even early on in the Chennai experience, patients with cardiac arrest had a high mortality rate. Shown here is another reason why the high mortality rate persists in shock, is that if you're going to deal with patients with acute shock and myocardial infarction, there's going to be a whole amount of background cardiac arrest. And in that setting, the neurological devastation and end organ injury often accounts for the mortality that we observe. One caveat I will show there is an example of what I say this is a unique entity, is here the patient who comes in with cardiogenic shock with an acute proximal LAD occlusion. We very quickly recanalize the vessel, stent it, get very nice flow both down the infarct artery and in the microvasculature. You can see that the LV in that setting is completely dysfunctional. So what we're seeing here is wall motion abnormalities, not just in the region of the LAD, but there's global LV dysfunction in the setting of stunning. And then as we put this patient on ECMO and by time, you can see that the LV function actually recovers, clearly confirming salvage both in the infarct zone as well as recovery of stunned LV myocardium in the non-infarct zone because of a consequence of arrest. So the lesson here is, in the setting of a cardiac arrest, certainly never stop your revascularization strategy simply because the LV looks bad, because that's going to look bad all the time and it's going to come back if you can actually support the ventricle in this setting. So let me conclude by saying that infarct size plays a very critical role in the susceptibility to develop predominant shock. Benefits with timely percutaneous intervention have plateaued. Inflammation and vascular dysfunction, both in the microvasculature as well as the macrovasculature, plays a vital role in shock genesis as well as propagation. Current interventions to favorably modulate the peripheral response are lacking, and cardiac arrest plays a very unique role in the genesis of cardiogenic shock after an acute myocardial infarction. I must conclude with an optimistic outlook. You know, with AI and other big data, we are able to now analyze these patients with shock in a unique kind of way. So this is data from Naveen Kapoor recently, really trying to classify and phenotype shock patients. This is really going to enable us to study homogeneous groups of patients who really need individualized treatments. In the US, cardiac critical care now is a new specialty, and you're getting a number of cardiologists dedicated to the management of critical ill cardiac patients in the ICU. And this is going to blossom research in this area. And so we run a registry called the C3TN network across 30 ICUs in the US. And the AHA has currently started a shock registry across the United States. So we believe that at this time, with this kind of interest, perhaps devices to at least support the circulation. I don't think they're going to help unless you can either restore the myocardium or restore the periphery. We think that the next 10 years will be better in terms of further improving outcome. So thank you for your attention and giving me the opportunity to present at this wonderful conference. Thanks.
Thank you, sir, for that wonderful talk, especially on the newer insights in the cardiogenic shock. One query is that very often we think that the inflammatory response in cardiogenic shock we don't see clinically, because most of the cardiogenic shock in acute MI, we see it's a cold shock. And also we had seen many data that unlike in the inflammatory response shock, which is a vasodilatory shock, vasopressin has not been shown to be beneficial in the acute MI cardiogenic shock. So what's your explanation for that?
No, I think the one thing I would say is that if you were to actually put a right heart catheter in all patients with an acute myocardial infarction in shock, you would clearly see that your understanding of what the systemic vascular resistance is doing in that setting, you'll be surprised at the responses to it. So different people respond in very different ways to the periphery. And I think one of the reasons why the current temporary mechanical circulatory support has not worked is that while we're supporting the central circulation, we have very little insight into microcapillary beds in the kidney, brain, autoregulation that are manifesting in that. So things like vasopressin, they're all working on the macro circulation. We really haven't. I think the future is going to be on trying to find effective perfusion of vital end organs. And this current strategy of just raising the mean arterial pressure may be relatively simplistic.
Can I ask whether you have tried Cangrelor in cardiogenic shock? Cangrelor.
Yeah, we do. Obviously, both in shock and following cardiac arrest, we are always very concerned about exposure to dual antiplatelet therapy as we put in stents. I must say that most of the time we just deal with crushed ticagrelor as our default. But sometimes you go in there, you can see the tablet in the stomach, the patient has vomited, there's concerns that there's no absorption. In that setting, we often use Cangrelor, but we could also, as shown in the Fabulous Pro trial, use IV tirofiban, and you can get up to 97% platelet inhibition very quickly within minutes. So Cangrelor is fairly expensive. So if you are in that kind of a problem, especially going radial, using a GP2B3A, tirofiban may be a cheaper way to get there.
Sir, excellent overview and a different perspective regarding cardiogenic shock. I got two questions. One is regarding since the inflammation is playing a very important role, is there any prognostic markers, especially including inflammatory markers, to prognosticate these type of patients, whether they should be undergoing revascularization or no revascularization? Because some patients are obviously going to die.
No, I don't think we're there yet. I do think that for any patient who's in the time window, who is in shock, I would consider revascularization unless there were other comorbidities that the patient didn't want it, the patient was elderly, the patient had a quality of life that would not want it. I think in this day and age, I think you have to start with revascularization and then go on to what's next. But I would not defer revascularization. I don't think we have the ability to prognosticate in that fashion.
This regarding the future research in this field, whether it be going more towards a pharmacological means or rather than a mechanical way of doing things?
Yeah, I think it's certainly going to be intervention first, revascularization. Number two is going to be support the circulation, hoping for the LV to recover, and trying to perfuse end organs. I think the next steps are going to be mechanisms to try to preserve end organ or prevent end organ injury. Because if the heart doesn't come back. Of course, you have an option for an LVAD or a transplant, but in the US, we're not brave enough to do that. We probably transplant maybe 1 or 2 patients a year in the setting of an acute myocardial infarction, mainly because of complete interventricular dissection or some catastrophic mechanical complication that a surgeon cannot repair in a very young patient. The LVAD is probably used mainly in chronic heart failure. We rarely ever use it in acute heart failure. So I think that, doing the same thing over and over again for 20 years, we haven't succeeded. Now is the time to start thinking about anti-inflammatory kinds of things in the periphery. But that being said, we've tried many things for reperfusion injury in the coronary, and we just haven't succeeded. So what I tried to do was be provocative and say, this is the problem that exists. I certainly don't see any solutions in the horizon in the near future.
Thank you, Venu. So we'll close this session, but this has been a very forward-looking talk, and I'm sure we have seen what is coming in the next 5 years. Thank you, Venu. Brilliant talk.
Very interesting.
Thank
Very
you.
interesting.
Yeah. Bye-bye. Thanks again.
We'll go to the last talk in this session, that is ECPR by Dr. Arun Kumar.
Thank you, Chairman, and thank you to the organizers for calling me to this meeting. So now that Ajit and Venu has laid down the ground for cardiogenic shock, organs, perfusion, etc., it will be the right time to move on to ECPR strategies and outcomes. To follow in the footsteps of Ajit and Venu is a big ask. It's made all the more daunting by the fact that Venu is my senior from the medical school, my own senior colleague from Cleveland Clinic, Ohio, and also a very prominent member in American Heart Association. So I'm a bit scared by standing here when he's there. I have no disclosures to make. The objectives of the talk will be to review the steps in ECPR, to discuss the current strategies employed, to analyze current outcomes in CPR, to summarize the evidence, and then conclude. The incidence of survival to hospital discharge in out-of-hospital cardiac arrest is about 10%. In hospital is about 25%. And the major cause of death in this group of patients is refractory cardiac arrest. I have to point out that about 70% of the patients fail to achieve ROSC when they have an out-of-hospital cardiac arrest. And most of the time, refractory VF-VT out-of-hospital cardiac arrest in these patients is associated with severe coronary artery disease or an acute occlusion with minimal flow. The survival is minimal unless treatment is provided to reverse the underlying pathophysiology. So what exactly is ECPR? Rapid initiation of VA ECMO during CPR in patients who experience a sudden and unexpected pulseless condition, secondary to cessation of cardiac mechanical activity. That is what is called ECPR. This has to be qualified by the phrase that this is in patients with refractory cardiac arrest. Now, how do you define refractory cardiac arrest? There's a lot of confusion out there. Some people say 10 after 10 minutes of CPR, some say 20 minutes. But some of the studies have used 3 shocks as an endpoint for refractory cardiac arrest. 3 shocks and a shot of amiodarone and epinephrine, and the heart doesn't come back. That is, some studies have recruited those patients for ECPR. But other thing I want to point out here is that sometimes you do get a ROSC, but it's not stable. The patient keeps flipping in and out. So unless the ROSC is stable for about 20 minutes, it's not a stable ROSC. So even those patients can be considered for ECPR. So what I'm trying to get across to you is the fact that refractory arrest is not yet well defined. Now, what does ECMO facilitated resuscitation do? It acts acutely as a bridge, makes emergency angioplasty and PCI feasible, gives hemodynamic stability, and also provides for support in the ICU. What exactly is the rationale for doing ECPR? Conventional CPR delivers, as you all know very well, only 15 to 25% of the normal cardiac output. The low flow state, throughout this talk, I'm going to use the term low flow state. It is a low flow state which leads to ischemic damage of vital organs. Venu was pointing out and asking if we are too cardiocentric, should we be caring more about other organs and give up a little bit of focus on the heart? That is the crux of my talk. eCPR can provide near normal levels of cerebral and end organ perfusion. It's a paradigm shift in cardiac arrest, what we have been thinking of from the 1950s onwards. There's a radical change happening now. The aim is to preserve the brain while waiting for ROS, definitive care, and cardiac recovery. ECMO acts as a bridge and offers support, as I mentioned before. Now, these two graphs are very important. If you look at the left-hand side, Reynolds et al. In 2013 in Circulation showed that modified Rankin score on the y-axis, it's a neurological outcome, gets worse as the duration of CPR increases. If you look at it, you can see that there is no meaningful recovery after 15 minutes of CPR. Only about 2% of the patients come out with a good neurological state after 15 minutes of CPR. And no flow interval, as the no flow interval increases, you can see around 10 minutes to 15 minutes. Beyond that, you don't get any meaningful recovery. So that is the idea behind telling that if you want to get patients on eCPR, get them on it in the first 10 to 15 minutes, not too late. Your outcomes are going to be bad if you put the patients on eCPR much later. This is the same graph. Now, when you talk about eCPR, Minnesota Mobile Resuscitation Consortium in Minneapolis has done the best work in this area. They've got a very good protocol. Most of the good results and good outcomes have come from this group. And what they say is their criteria is refractory cardiac arrest, witness cardiac arrest where CPR was given, non-traumatic. The patient should have an initial shockable rhythm. They should have received bystander CPR, as I said. When you do this, their outcomes were 43 to 55%, anywhere between 48 to 55% had a good neurological outcome. But this is in the hands of extremely well-trained team with one center, with 3 cardiologists doing the ECMO cannulation, with a very advanced, prompt response from the emergency medical system. So this group has published multiple articles. If you look at their studies, their outcomes have always been good. What are the steps in eCPR? So this is in fact an article from Apollo Chennai, which came in the Indian Journal of Thoracic Surgery. This is what they do. Just go back to the previous one. Yes. Cardiac arrest for 10 minutes. ECMO team is alerted. ECMO team arrives. Discussion with family happens in parallel. Monitored CPR, heparin cannulation, establishing ECMO flow. And once there is if there is adequate valve opening. If there is poor valve opening, you do a LV decompression in the form of an IABP, or you can use other methods. So basically what I'm trying to convey to you is you need to have a protocol if you plan to do eCPR. You can't possibly be looking for telephone numbers of the perfusion team. You can't be sending out alerts trying to contact people. If you decide to do eCPR, whichever institute it is, you need to have a protocol in place. Now that's the usual configuration. You put anywhere between 15 to 19 cannula in the artery, and which is below the diaphragm usually, a venous cannula which goes up to the right atrium, which can be anywhere between 19 to 27 for venous drainage. Drainage goes into the pump, gets pumped into the oxygenator, gets back through the aortic cannula. And you need to put an antegrade cannula most of the time to avoid leg ischemia, which is a 5 French or a 6 French sheath, which goes antegrade into the femoral artery. Now, again, going back to the Minnesota Resuscitation Protocol, they looked at patients 18 to 75, ongoing CPR, I said that, ongoing CPR with Lucas device up to reaching the hospital. So not manual compressions, Lucas device, which is a mechanical device, arterial and venous access under ultrasound imaging. I would underline that. Most of the good outcomes, less complications have been when we use ultrasound for arterial and venous access. Connect the arterial gas, go for the appropriate size cannula, and before proceeding, they check if the end-tidal carbon dioxide on arrival was more than 10. End-tidal CO2 is a marker of blood flow through the lungs. If it's less than 10, your ongoing resuscitation has not been good. You check your lactate. This group also has been looking at lactate. Their cutoff is 18, and PaO2 more than 50. If these are the markers of how good your CPR has been going on in the time before reaching the cath lab, if this is not the case, they don't proceed with eCPR. So if that's not the case, they proceed with an IABP, carry on, review the patient. So properly laid down guidelines, understanding among the team members, well-documented protocols are key to getting good outcomes in eCPR. The 3 pillars are highlighted: the timely delivery of the patient to the cath lab, evidence of adequate CPR, as I said before, and identification of reversible causes. Now, since it's a cardiology meeting, I thought I should show this. refractory VFVT, the LV ejection fraction comes back on return of circulation. 1 hour later, it takes a dip and it doesn't come up for the next 2 days. So just keep this in mind. Your LV ejection fraction, as Venu said before, is going to come up only after 2 days or something. So that has to be borne in mind. Troponin usually in the first hour is normal and it peaks around, you can see 4 hours to 4, 16, 24 hours is the time you get a peak. Cannulation steps, I went through that, I'll skip that. Basically, the aim in eCPR is arrest to ECMO flow time of less than 60 minutes. The aim of any team performing eCPR is to get the ECMO cannulation in and the flow going on below 60 minutes. So that is, if you can't reach that, then your outcomes are going to be bad. Strategies in eCPR. CPR can have 3 strategies. eCPR outside hospital can have 3 ways of doing it. One is you transport the patient, scoop and run, take the patient directly to the center where they can do it. Otherwise, you go to the site of the patient, pre-hospital eCPR. Third one is the patient travels a little bit. If the patient is far out, the team travels a little bit, rendezvous eCPR where the patient and the team meets. So these are the 3 strategies outside hospital centers. Now, if you look at it, this is determined by the fact that how far is the patient from the center. In the green is the center which is close by, scoop the patient, run to the nearest center which can do ECMO, do the ECMO, establish flow. Second one is a little bit farther away. So what you do is the team goes out and on-site cannulation. If the patient is much further away from the eCPR capable center, then you go for a rendezvous set of strategy. Now you can see important determinants are how much time you spend in the scene, how much is transportation, and how much is cannulation. So you can see the longest one is in rendezvous. The total time to establish flow is longest in rendezvous method of eCPR. Now extracorporeal CPR protocol from one of the hospitals in Cleveland, Ohio State, you can see that you should have a procedure checklist, look at things like end-tidal CO2, lactate, PO2 before establishing eCPR. We always hear that the outcomes were bad, but outcomes are going to be bad if you don't check these numbers and factors before putting the patient on ECMO. Who are the candidates for eCPR? There is again controversy in this area. I'll go to the current ECMO ELSO guidelines, age less than 70 years, witness cardiac arrest, time from arrest to CPR less than 5 minutes. CPR should have started within 5 minutes of collapse. Initial cardiac rhythm is VF or VT. Time from arrest to initiation, as I said before, less than 60 minutes. End-tidal CO2 more than 10 at arrival in cath lab. Intermittent ROSC or signs of life. Absence of previous contraindications or do not resuscitation orders. What's the outcome after CPR? You can predict it using a scale called Rescue IHCA, where they have seen that using 6 factors, you can predict the mortality during the hospital stay after a cardiac arrest. Depends on patient age, time of the day, very important, renal insufficiency, age. Age less than 60 is a good or favorable factor, whereas out of hours, weekends are bad for good outcomes, and duration of arrest as well. eCPR survival, this is data I took out from the ELSO registry yesterday. Generally quoted figure for adults is about 31% survival after eCPR. Factors determining the outcomes are older age, unfavorable, shockable rhythm, I said is favorable, shorter, no flow or low time, high quality CPR, targeted temperature management, and PCI. These factors favor a good outcome in eCPR. Now, talked about that, what's the current evidence available? Now, there are 3 studies, there are only 3 randomized studies in eCPR. One is the ARREST study, one is the Prague out-of-hospital cardiac study, and the third one came this year, that's the last one in NEJM January this year, called the Inception study. Now, please don't club these studies together, and these 3 are different. The ARREST study was done by the Minnesota team, a very experienced team. Prague's study was out of hospital. They included VT-VF and non-shockable rhythms as well. So it's different from the other study. Inception was again not a single center, multiple centers, multiple operators, no definite protocol. So please realize that there are 3 studies out there in eCPR, but they're not the same. They all use different strategies. Cannulation time, if you look at it, the Inception study took 74 minutes to establish ECMO flow. Other 2 studies were 61 and 59 minutes. So a lot of variation between the studies. Survival in the control arm in the studies was also different. ARREST Survival was 43%, the highest, because same set of operators, same center, same ICU, same cath lab, 43% survival. Prague and Inception did not have that much survival. Inception, because it was different centers, different operators, did not have any protocol, ended up with a survival of 20%. The Prague study, it was stopped prematurely. They could not show any difference in outcome between both the arms. So it was futility was the reason for stopping it. So important things to keep in mind is when the arrest occurs, time on scene, transportation, low flow duration in studies are different. Now, this is a meta-analysis which came out recently. But however, looking at all the studies, it says it was associated with significant reduction in mortality for patients with in-hospital cardiac arrest and a non-significant reduction for patients with out-of-hospital, probably related to the longer no flow. eCPR also improves long-term neurological outcomes. So that is the evidence out there. Are there any recommendations? I said about the criteria. Looked at the ILCOR, International Liaison Consortium on Resuscitation, says there is a weak recommendation for using and can be used as a rescue therapy in refractory arrest. Now, challenges in CPR, multiple ethical, organization, ICU, patient selection, and complications. It's not easy. Newer strategies, quick 1 minute on this. What is happening in eCPR? The next level, going by what Venu said, is look at the perfusion and other organs. So cardiovascular arrest is a whole body reperfusion injury. If you look at this, when the perfusion starts, reperfusion injury occurs. Control the reperfusion in a manner so as to limit the reperfusion injury is the new thing out there. There is a device called CARL, Controlled Automated Reperfusion of the Whole Body. L stands for whole body. There's a device with a special ECMO machine which can perfuse, monitor the ABG on the screen. There is a cooling device, there's a ventilator, the whole thing is called CARL. There's a multi-center trial happening in Germany at the moment. There's a special cannula with a sensor at the tip which gives the arterial pressure during resuscitation. So CARL therapy is a new thing happening in resuscitation, aimed at controlling the reperfusion. So you look at the veno-arterial perfusion, high arterial pressure using a pulsatile pump, high blood flow, immediate hypothermia using the same device, online blood gas analysis, control oxygenation, control the calcium. Reperfusion injury is most of the time due to calcium. Avoid the hyperkalemia, hyperosmolality using albumin in the solution, and sodium citrate, which brings down the calcium. So that is the new thing. And CPR, ordinary one, eCPR, and CARL, these are the difference. You have higher pressure, centrifugal flow, controlled oxygenation, and hypocalcemia. That's them using this in a supermarket. And CARL therapy, I told you about the focus on that. Is there anything in the literature you might ask? There is one study which came out in 2017. There is a 2019 study of 14 patients where 7 patients survived intact, observational retrospective study. In conclusion, eCPR is a complex and powerful life-saving intervention in patients with shockable rhythm, but it has to be applied within the optimal time. Evidence is still weak. I wouldn't say the evidence is strong. You need a good protocol and an organized system to have effective outcome. But remember, eCPR is only one component, the chain of some early activation of the emergency system, high quality CPR, and all of the components, including ICU care, has to be good quality. Otherwise, your outcome is not going to be good. Thank you.
Very interesting, this concept of low flow. So maybe if the low flow time could be reduced, more patients could survive.
Yeah, so low flow, usually I said the cardiac output is only a tiny fraction of what you normally get with the chest compression. My personal suggestion would be to switch over to an automated compression devices. In our hospital, we take the patients from the ED onwards with a compression device, and also if early on intervene and put them on ECMO.
So actually this compression device, Lucas compression device, if you take the latest CPR guidelines, because I had to talk on that sometime back, actually manual compression is the gold standard. It defeated the Lucas device. But I agree that people get tired, so Lucas device may be useful. What's your comment on that?
So I'm an AHA instructor. So for the last 12 years, I'm teaching ACLS. So I'm a senior instructor. What I've seen from my personal experience, different places, invariably there is an interruption in compression. Even now, sorry to say this, in the cath lab, the need to keep compressing is not felt by everybody in the cath lab. It's not appreciated. So from that point of view, I feel mechanical devices. If you were to compare it in a on a tightly controlled situation with somebody qualified AHA instructor, it might beat the LUCAS. But in day-to-day life, it doesn't happen.
Okay. So but then why did it come as a guideline, I mean, as a recommendation in the new guidelines on CPR? I have read it there.
Yeah,
Maybe
yeah.
I'm mistaken.
I'm not sure. I mean, there are different opinions. So,
Okay,
I mean,
okay,
some
sure.
people do not like them. I mean, like, yeah.
There are 3 types of external compression.
Yeah,
And I
LUCAS
think only Lucas is good. That's what I understood.
LUCAS is the most studied one because in this Minnesota program also, there one of the criteria for selecting patients is a patient who would fit the LUCAS device. So that is how it has come in literature. That's the reason.
Thank you. Thank you, Dr. Arun. I think we have had a good session on cardiogenic shock and
Thank you.
cardiac arrest. We'll move on to the next. Thank you, Chairperson.
Thank you, all the speakers. That concludes the session. Thank you.
Thank you to the chairpersons of this session. Move on quickly to the next session on precision chip PCI. And these are our keynote lectures. We go on with Dr. Samin Sharma, who's been waiting for some time. May I invite the chairpersons now, Dr. Anil Kumar, Dr. Madhu Sridharan, Dr. Rajesh T, and Dr. Rajesh G, please.
Good evening. Are you audible, Dr. Samin?
Yep, I can hear you well. And can you hear me also?
Can you hear us?
Yeah, I can hear you well.
No, I was telling you were here in person last time. We miss you
I know.
in your physical presence. But let us hear you now on optimization of chip.
Okay. Well, I really, I was part of this. I heard quite a bit, some lectures before. I joined about 2 hours ago. My usual wake-up time of 4:30 a.m. even Saturday, but then sometimes I sleep back. But today I wanted to just hear some lectures and it has been tremendous. And of course, as Dr. Anil said, unfortunately I could not be there because in the next few hours I'll be taking a flight to Dubai for some other hospital-related work. But anyway, I am thank all the organizers to invite me to talk about optimization of chip from planning to execution. And this is where I'm going to discuss about. 1 second. But I just want to make sure that I'm okay from audio point of view.
Yes, we can hear you very clear.
Great. So basically, I'll just go through our regular things, which I know the chip has been talked quite a bit, but some new data, which I want to show in terms of the definition, pre-procedure planning, optimal procedural strategies, expected outcome, what should be the results. It cannot be the simple cases have us good results and you say you expect similar in the chip cases. No, post-procedure care and then recommendation for the best practice. Now, the key is before we decide for PCI, and it becomes even more important for a complex high-risk patient, that you have to identify a suitable patient because the patient has to be that what we are doing is going to benefit patient. Now, the benefit is 2 ways. One, in the morbidity point of view, patients suffering, they cannot walk, they get chest pain, short of breath. So therefore, that is the quality of life. And second is the major hard endpoints of death and myocardial infarction and repeat revascularization. So we clearly differentiate these 2 factors in this patient. So patient has to be the suitable patient. So that's the pre-planning. Then we do go through that, yes, patient has an obstructive CAD and it's a complex, and I'll show you what complex means, but at the same time, it is supplying the viable myocardium. And second, that there is an assurance, there is a reasonable chance that patient will improve. One, from the physical point of view. Second, from the LV function point of view. And of course, then question comes, how much you need to open? That's a secondary issue, complete versus near complete revascularization. I think we learned in a STEMI and non-STEMI patients, complete revascularization is the way to go, but in a non-STEMI cases, means non-myocardial infarction patients, whether STEMI or non-STEMI, whether you need a full complete or in some elderly patient, probably selected, maybe enough. Or culprit 1 or 2 lesions may be enough that you don't have to go through full circle of complete revascularization. So just want to make sure when we talk about complete, it's basically we are talking about myocardial infarction or in a younger person with a complex CAD, not in the elderly patient who is 75, 80. And our goal there is to just improve their quality of life. And then always issue remain the 2 important things which we know, the kidney And secondly is the DAPT, the tolerance. So anytime we do intervention, if patient cannot tolerate DAPT, we have done the disservice to the patient. So many times those cases are selectively go for coronary artery bypass surgery where the DAPT dependence is less important. Very important point. Second is renal function. Renal function, as you know, in ACC and CDR is a now matrix for the hospital to get a payment, increased payment if you remain in the lower in terms of the AKI. So very important aspects which we are coming up. And of course, any of the comorbid conditions, COPD, neurologic issues, and then secondary prevention strategy, whether patient will be following the guidelines, directed medical therapy, which has become very important part of our revascularization guideline, which was published 2 years ago. So basically, what are we talking about? This is the combination of three things: patient comorbidities, complex coronary artery disease, and hemodynamic compromise. This is the high-risk patient, because patient with a CAD, good LV, and young person 45, maybe not truly a CHIP case. It is the combination of all three, which is the heart patient is an elderly, peripheral vascular disease, diabetes, heart failure, and then has a multivessel disease, left main, CTO, calcific lesions is the most important, and the bifurcation, and then the hemodynamic compromise. Patient has a lower ejection fraction. So these are the cases which we call protected CHIP PCI that we will need go beyond what we usually do. Support the ventricle by ventricular assist devices. So over the years, to what we call high risk has come up, starting with the ACCHA with the type C lesions. Remember those used to be B2 and C lesions. We counted them as a high risk cases, and the various other risk score have published, like Sky risk score, then ACC-AHA again, then the Mayo Clinic, the British Columbia PCI, and New York State. Then they came with and then of course, based on the Syntax 2, and the recent CHIP score, all this basically trying to say, how can we quantify the risk of the patient with three factors: taking patient's comorbid condition, physical condition, patient LV function, and patient coronary artery disease. And I can tell you, of any risk factor, the latest which came out from BCIS, from the England, which came very interesting for complexity and risk, and they came up the CHIP factors, 7 clinical and 6 procedural. And 7 clinical were age more than 80, female sex, previous MI, stroke, PVD, EF less than 30, and CKD. These are the 7 patient risk factors. Then procedural factors being a rotational atherectomy, left main PCI, dual arterial access, planned LV mechanical support, and lesion length more than 60 millimeters. So all these factors related showed that each point you go to the most of the factors except renal disease 2 points and LV mechanical support 3 points, and these are the incidences and risk factors that individual contribute to the outcome at 30 days. Mackey at 30 days. These guys did a great job. To me, it's a very good working algorithm, BCIS, and you divide your patient. Event rate could be negligible, less than 0.5% to 20% based on this 4 category of the risk. No risk, low risk 1 to 2, intermediate 3 to 4, high risk more than 5. Very interesting, a simple algorithm you can develop in your cath lab when you enter all the data and should come up with a score. Why? Because patients with high risk require more intervention, maybe staying in the hospital, more treatment, LV support, or optimization of the heart failure. And so, compared to no-risk patient, can be discharged 3 hours after PCI. Just to say, to America, low-risk to no-risk patient, more than 70% are discharged same day after 4-hour observation in the cath lab. Now, what we did is, from our database, I said, let's put this CHIP score to 30 days good, but we really want to see long-term outcome. What about 12 to 15 months? So this is the data which is 14-month outcome of the BCIS CHIP score with the 7 points of our 25,000 patients. And as you can see, the bottom numbers, that almost about 20% of cases were more than 5 CHIP score. And we came up with a very nice kind of a gradation at 1 year outcome, which is 390 days. And that is, if you have no score, 1.7 Mackey, double, 3, 6, and 12. So key was that it was a multiple of each when your risk score increases in these patients. So very interesting observation. And secondly, that it is true for all. So all CHIP 4 scores, whether it's a death MI stroke, death, myocardial infarction, stroke, not that much, TVR, and bleeding. All these risk factors also show bleeding. So basically, it was very nice, the editorial with our paper, that another validation of the BCI score, another we will be using in our day-to-day life from prediction of the event rate point of view. And as we know that there have been a lot of CHIP studies, Syntax, Freedom, BCIS, Protect 2, that Excel, Noble, Syntax 2, then Protect and USPELA registry. And we also understood that sometime in these cases, support devices are needed, and good or complete revascularization is very important to improve the patient's outcome. And these are the various CHIP studies over the last decades which we have done. So what I have combined is that how do I deal with a CHIP patient? Appropriate pre-procedure we have decided. So now patient is to the catheter. So I put this as a cube. Assess the lesion by angio, IVUS, OCT, FFR, whatever is needed. Second, alter in a complex cases, particularly modify the plaque in calcific CTO bifurcation. And then post-assessment by imaging as well as angiogram. Routine angiogram is good, but more and more data coming that combining with imaging is very helpful, which is the third A of opposition and assessment. And of course, based on how much CHIP patients you have, and will be whether you need to plaque modification or direct, and of course, the patient with a low ejection fraction, LV support. Very important because complications do occur. And at this time, when patient comes to us, expect the results like a surgical. There will be no need for urgent surgery, and we are talking about that final treatment for these patients. So this will be use of appropriately assist devices and when we use it. 3 of them, balloon pump, tendon, heart is not used at that much, could be ECMO, and the Impala is 2.5 and CP. And I would say this is the, again, suggestion, what you should be doing for the CHIP cases. Alone, complex case, probably don't need any support. You can do a PCI with the ejection fraction if normal, more than 40-45%. But if ejection fraction is 20-40%, that is our usual patient who have complex PCI, high syntax score, high STS score. Because if the lower STS score, these patients should go for CABG. Surgeons will take them. But we know that if STS is more than 5, surgeons do not take those patients, and more and more patients come back to us. So there, you need to do Impala assisted or some those. Impala is very costly in India, I am aware. But then balloon pump assisted, complete and extensive revascularization, and then of course, with very low EF for 5, 10, 15%, you'll need some support device for these patients. We use at Sinai of the 350 PCIs per month. We do 5 balloon pump and 15 Impalas. This high risk cases. And also, as I've just put in this slide for everybody's awareness that what has happened in these complex cases, that just beyond angiogram, whether you do a pre or most important, in my opinion, the post, you need some imaging to optimize your results. Angiogram is alone not good enough. And of course, physiological test, you do pre. Sometimes there is a question post, you can do a physiological to see whether FFR and IFR is more than what we expect. But key is the imaging, whether it's OCT or IVUS2 really have come up and have come with the various trials that improve the outcome of our PCI patients. We actually have app device, as you know, Dr. Keeney, very prolific. So many, we have like 20 different apps. One of them is any type of device in the cardiology uses. We have the cardiologyapps.com. So this is a website. It is not on the app yet, but it's a cardiology apps device. Every device is available. The strength, the length, company, the mechanism of action, everything is available for everyone. I recommend people to download any device you want to go, and you'll have information about this. Took us about 6 months, an extensive database in one sitting. So now, one of the biggest issue remain is the calcific lesion. So I would say, what are the CHIP patients are besides the lower ejection fraction? One, they're very calcific vessels. Second, the bifurcation, and third is the left main. Those are the 3 groups. Calcium really is increasing because older patients, the risk factor of the diabetes, renal failure, and also now the tower. We never used to do angiogram in 80-year-old patient unless coming with the really unstable angina. Now we do routinely, and we find calcific 3-vessel disease, but aortic stenosis is 0.8. So we end up in doing a revascularization. So more and more calcific patients are coming to us. And how to diagnose the calcium? There are various ways. Angiogram is very simple. You see tramp track sign. On IVUS, you can see the echogenic area and no shadow behind with the quadrant. It occupies 2 or 3 quadrants with the moderate and severe calcium. And then OCT, clear demarcated areas which can quantify also that what is the degree of calcium from score from 0 to 4. The higher calcium score will require some types of modification. And of course, we know that calcific lesion will give a trouble, will not go, stent will not go, will not expand, with dissections and maloppositions will happen. Now, calcium, just to say, it's not the acute syndrome, acute results only. The many data have come, multiples of them now, that calcium is associated with bad outcome. This is from Syntax's 10-year follow-up. Look at the mortality, almost 50% higher, 22 versus 36 in a patient with a calcific lesion who underwent revascularization. Second point, you say, well, maybe the cabbage neutralizes the calcium. No, even calcific lesion, see on the top, the cabbage versus PCI, calcific lesion a higher bad outcome, both cabbage and PCI will have a bad outcome. So calcific lesion are the bad revascularization outcome, whether it's a cabbage or PCI. Calcific lesion bleed more. Why? Because they're calcific arteries, whether radial, femoral, or other procedural vessel, they bleed because of anticoagulation we use. So calcium is associated with higher bleeding also. And therefore, we have various devices available for them. Some higher, really not a severe calcium can be taken care with a high pressure balloon or open NC, atherotomy, laser, but clearly in the calcific, severely calcific, rotational atherectomy, orbital, and the intravascular lithotripsy, IVL. So clearly of the two devices for atherectomy, rotation, orbital, we have different mechanism. One by at the chip, ablate the plaque, and of course goes downstream. This works in the vertical segment, and they have different mechanism of action, but whole goal is that modify the calcium, decrease it, and both devices are available in India. Of course, there's added cost of about 1.5 lakh rupees, but some cases it is viable and appropriate. RotaPro with using a special rota guide wire is one of the one which we commonly use, and we have very nice review of this, how to use techniques in JAK intervention and so. So also we say that what if you say, well, I want to just not use rotablation or orbital calcific lesion, but I say, well, I'll try the balloon, and then what will happen? So clearly we call rota regret. Many cases, when you start with a calcific lesion, you will not be successful with your balloon. And those people have 3 times higher procedural complication compared to your planned atherectomy. So 2 trials, Rotexas and Prepare Calcium. See, both the trials, when you try to do balloon, 16% got into trouble. Stent loss and could not deliver. Same thing, Prepare Calcium, 16%. So basically 1 in 7 will give you trouble, and these patients will have 3 times higher complication if you don't use the atherectomy. Orbital has a different way, slow advancement, and I know it's picking up in India, although slightly higher cost than the rotational atherectomy, but a good device, and does the nice, the deep cuts, very good outcomes. One thing which we noted also, lower TLR using the orbital atherectomy, clearly that compared to rotational, and that actually been seen in various trials. It does cause better deep cuts on the plaque and better stent expansion. We have published that. And the Eclipse trial, which compare orbital atherectomy versus conventional, has been completed, will be presented of 2,000 patients with the main outcome that atherectomy improve the overall outcome at 1 year. Target vessel failure will be presented next year, either European Society or TCT. Laser is good, but I think laser basically for the ISR unexpanded stent, and you cannot cross. You cannot change your device, so you cannot put over the wire system. You cannot change it to the rota or orbital, and therefore it's a good in those cases laser. Laser, I know there is a big news in India, and so many people have sent me because so much in the the general media that you don't need anything. Laser will evaporate the plaque. I mean, this is like ridiculous from medical point of view. You have no idea. In last 1 year, at least 200 either personal messages or WhatsApp messages or emails have been sent to me by many patients or many educated people that now we don't need anything. Laser will take care of evaporates the plaque. So that is what in the media. Wrong message. It's a very limited technique. In America, you take 100% of the PCI, it is used in 0.2% of cases. rotational atherectomy used in about 3%, orbital in about 2.5%, and 0.2% laser. As an adjunct, unexpanded stents and ISR cases. And of course, Shockwave, very nice device, easy, except costly, 3 times costlier than orbital and rotational atherectomy, but easy. And the biggest advantage here is that if you can get there, the good lesion preparation, and only, I would say, big advantage is that, difficulty that sometimes you may not deliver. So you have to do a pre-dilatation, which was done in about more than 60% of cases. But perforation, almost nil. That's the important and good 30-day outcome, as well as 30-day and 1-year outcome have been shown. So just wanted to show one case and then come to the end of my talk conclusion. This is a patient who has significant 3-vessel disease, left main disease, and poor LV function, and the peripheral arterial disease also, as you can see here. PAD has severe aortic stenosis, and this is the RCH closed, severe AOS, the calcific valve you can see here, and multiple calcific lesion in this particular case with a total mid-LAD, and had a stent in the circumflex before, but developed new lesions. In these cases, ejection fraction was low, so did a balloon valvuloplasty with a severe AS, then put impella, and then revascularized the LAD with a small rotabur, followed by stenting, and then took care of the circumflex because of the distal disease. This was the angiographic result in this particular case with help of balloon angioplasty, BAV, and of course impella, and then we took care of the stenting in the peripheral common iliac artery. So just to say, many of these patients come with a multiple devices to be used and to get a good results. And there is always a question whether IVL versus rota or atherectomy. I think both tech do work for the calcific nodule. Individual of these devices and their use and cost, I have put it here together. And PROTECT 4 trial is the real trial of the CHIP patient. This is the trial of the CHIP patient which has multi-vessel disease or an ejection fraction less than 40%, being randomized to impella versus control. Right now, they have done about 720 patients. We are the top enroller with 52 patients, and it's a 3-year outcome and a long-term outcome. We'll really need to see. We may have to wait about another 3 years to have the outcome, but this is the true CHIP trial, which will tell us whether real making a difference in these patients with impella or not. This is a calcific point, which, as I mentioned, that if you can get a IVL in a high calcific lesion, is good. But if you cannot, you may need assistant atherectomy, and then, if necessary, IVL can combine. So overall, in our lab, we use about 20 to 23% atherectomies. Various differences are here, and we have many, as I mentioned, the calcific aid and additional for this combined strategy. So then come back to the last point, and which is very important for our interventionist point of view. Your job is not done. That you did a decision making, patient, heart team approach, pre-procedural, peri-procedural planning, you have done all good, but then post-care, that equally important, because we have learned every aspect which is written here: cardiac rehabilitation, smoking cessation, psychosocial intervention, pharmacotherapy, management of cardiovascular risk factor, assessment of outcome. Because if you don't follow those patients aggressively in this, patient will come back in the same case and you have not done anything to the patient. Patient may have a subsequent death, develop myocardial infarction, and all the effort, hard work you did will be wasted. So just say that, what do you expect? Well, it depends on what type of patient it is. And I'm sure it was presented earlier, the notes, surgical turn-down cases, optimum registry, that mortality in these patients sometimes is about 5 to 7%. And the 30-day and 6 in-hospital mortality of 3%, 30-day mortality 5.6%, and about 12 to 14% at 6 months. And probably 24 months data will have, 12 months data probably will be about 20-25%. These are the high-risk patients, which are surgically turned down. But what is usual happen in the other patients? So this just want to tell you, all patients combined at Mount Sinai, we have a mortality of all patients,
So
excluding cardiac shock.
Can we conclude, sir? One live is waiting, sir.
Okay, I'm just going to finish it here.
you, sir.
Last, just to say that intervention has become long way to really have a very low complications. And this is my last slide, that it's a CHIP patient, very important strategy, combine and do a good outcome follow these patients pre, post procedure to have a best outcome, improve their quality of life. And thank you very much.
I think you have summarized the whole conference for us in the last 20 minutes. It's a brilliant overview and all your points are well taken. Thank you, sir. Have a safe journey to Dubai. Thank you. We will go ahead with our next talk. Dr. Werner is going to talk to us on how to reduce radiation in the cath lab. A very important message is waiting for all of us.
As quick as possible. We need to use as little radiation as possible. Why? To protect the patient. This is skin injury after 20 gray in a patient undergoing a CTO procedure. The problem is these injuries appear several days or weeks after the procedure. So none of the operators ever realized that something was done by them to the patient. And we have to protect the operator, that is maybe the dearest to us all. New devices can reduce scatter radiation. We hear about that every big meeting. But also you need to protect the staff who is not protected like the operator behind a shield, but the staff is running around and taking care of the patient, and sometimes a cardiac anesthetist is sitting at the head of the patient in the pinnacle of the radiation. However, radiation doesn't seem to be a problem if you look at the literature. Radiation damage here in a CTO intervention meta-analysis was 0 because nobody ever looks at it. In this, I just show you some small data glimpses. This is a study, just an example from Japan, procedures up to 300 minutes of fluorotime. No report of any radiation injury. I guess there was some. One of the few exceptions, just 70 procedures here from Japan, and 2 patients of these procedures had skin injury because they were looked after. And you see the individual variation of radiation dose among 7 institutions. And occupational hazards are inflicted by radiation. If you compare staff in interventional cardiology and staff in other sectors, there are more skin lesions, of course more orthopedic lesions because of the lead, more cataract, and we have occasional reports of brain and neck tumors among physicians performing interventional procedures. These might be anecdotes, but they are frequent anecdotes reported in the literature. So, in the setting of CHIP, what are the determinants of high radiation dose? How high dose of skin dose in patients? It is the lesion complexity. Occlusions, of course, CTOs are among the main factors, but also what we just heard by Dr. Sharma, the many complex lesions, the calcified lesions, everything that makes a procedure long increases skin dose to the patient and the operator. But there was an interesting observation in this study from the US. PCI operators who performed more procedures than others, higher volume, they had per procedure lower radiation dose because they were more experienced. They looked for it not only to save their own skin, but above all to save the patient's skin. And we have algorithms now, this is the setting of CTO again, where radiation is part of the stopping strategy. And it probably shouldn't be only in CTOs where you should stop at 5 gray air karma. Also in all these complex procedures we were talking and hearing about in this meeting. If you look at reported radiation dose, you will find that radiation dose is fairly high, especially, of course, in complex procedures. Most of my examples are from the CTO setting. Just look at these data from Japan with small Japanese patients, 10 gray average in the early studies by Kato and his colleagues from Toyohashi. But even from US in the mid-2010s, doses, the air karma was about 4 gray. You see, in Europe, it went a little bit down, but it's not all about body mass index that the dose is so high. It is also differences in individual operators. I show you here, apology for the German, I forgot to translate that. It tells you that we have looked at operators from 2012, the same operators 2017, they improve. The lower the scale, the better the dose. But each of these points highlights an individual operator. One operator at 30 minutes average dose has 2 gray, the other has 5 gray. And these are even in the excessive dose range. So operators different, even though they use the same fluoro time. So what did these operators do wrong? Did they have the wrong machine? Actually, only sometimes. The Philips Clarity in our data that we analyzed in 2010 to 2017 was better than most. It has the lowest variability, but if you were a good operator managing your Siemens machine, you were as good. So, how can you be a good operator? You need to watch your speed during the procedure. Maybe you don't go 330 like on a German Autobahn, but you need to know where to look. How fast am I? And that is the dose rate. You can look at the dose rate in every machine that you have, Philips, Siemens, whatever, and look at your instant speed. And that will be the accumulative dose at the end of the procedure, the dose rate. There are obvious facts that we know that the angle, the angulation will influence the dose rate. But you also can look at it in practice. It depends on your patient. For example, just changing the angulation by 15 degrees reduced the dose rate by 40%. And you can still work in 30 degrees instead of 45 degrees. Of course, everybody knows that reducing from 15 to 7.5 frames will reduce radiation, but only if you also reduce the cine rate. There is no need to do 15 frames cine throughout the procedure. And of course, we should not film a balloon. We should not film a stent. Reducing the radiation instead of filming is fluoro storage, 2% of the same dose that you would invest if you film a balloon. And it doesn't give you any more information, except for some instances when we really want to understand underexpansion. So these are data of the more recent machines, mostly studies with the Philips system, and also our study in the Siemens machine. And you see that the dose has reduced from 3.4 3,400 milligray slowly through the new machines. In US, they reduced the dose from 3.4 gray to 1.7 gray. For example, there was a study in Germany where they reduced the dose from 700 milligray to 450. But the important thing is you need to compare it among these procedures. Look at how long was the procedure, how long was the fluoro day. And we managed to reduce our radiation from 2 gray to 650 milligray, on average in complex CTOs using about 30 to 45 minutes of fluoro time. And how did we manage that? You can manage reduction of dose by using fluoro at lower rates, but the main instance is reducing the cine exposure as well. And what we did was reducing the voltage and also mainly the current on the radiation source from 745, for example, here in this example, to 326 milliampere. And that led to a drastic reduction of the whole radiation dose. 600 milligray, as I told you. So we never exceed in our procedures the 5 gray limit. It's all, since we introduced this new setting, it's all below the 5 gray level, and only rarely we exceed the 2 gray level for the maximum skin dose. And how do you do that? You need to know your settings. Interestingly enough, this is taken from a website from Siemens, how they advertise the machine. The machine is advertised with fluoro mode, with 15 frames per second for both cine and fluoro, which is wrong. And that is how they set up the machine in your lab. And then they use the average fluoro setting. And when I go to labs, I see medium fluoro settings in all the labs. But if you look at the example that I did here in a 85 kilo person, if you go to the regular fluoro and you put your paddle down, you have 17 milligrays per minute. If you reduce fluoro minus, you halve this dose. If you go to fluoro plus, you double the dose. And be assured, you can do complex CTO procedures with fluoro minus setting. The machine automatically goes up to a regular setting. But that is not only Siemens foolishness. On Philips' website, you find just the same. They advertise the latest Azurion with 15 frames per second and a very high dose of 500 milligray after 8 minutes of fluoro time. I wouldn't buy this machine if that would be the end of the story. But what you have to do, for example, on the latest Azurion, is just change the setting. Again, this is from the website. Go to fluoro minus and go to low dose exposure. And of course, here they had the low frame rate. But that makes all the difference. Last year, I did a procedure in a cath lab with the Azurion here in India. And the diagnostic was done 2 minutes, 700 milligray. I changed the settings that you see here, and I did a 20-minute CTO with 700 milligray. And that is what you need to do to keep the dose of the skin and your own dose reduced. Of course, you use additional shielding methods. You could use the red pad, or as we do it, we use the Mavic shield, which can be reused. You can also invest in operator protection, but this protects only the operator, not the patient and not the staff. And what I just found when I prepared this talk, there was a recent paper in CCI where they showed another novel radiation shielding system advertising that now the operators can just work in their shorts and don't need LED. And that, I think, is the most ridiculous statement, because they should have learned from their grammar school, maybe even, that radiation cannot be eliminated. It can only be attenuated. And there's nothing like too little radiation. Even a little bit of radiation is too much if you can avoid it. So let me finish well in time. My approach to reducing radiation would be use the initial bilateral imaging. If you do a CTO procedure, then of course you want to visualize the collaterals with 15 frames, but the rest of the procedure is done with 7.5 frames, and whenever possible, you do fluoro storage instead of filming. We can use 6 pulses per second. You can use 7.5. That doesn't make it much difference. But it's very important to set your system to low dose fluoro. That is setting 1 on Philips or fluoro minus on the Siemens machine. And if you have bad images, change the angulation rather than the dose. And of course, use low radiation angulations after passing complex procedures. If you do a bifurcation and you have passed, go back from apicranial to a regular view for the routine procedure. The only problem that we might face is this person, if he has a CTO, then we might run out of power. Thank you very much.
Thank you, sir. Thank you. All your points are very well taken. We could have had discussions, but the live case is on. We should have some discussions later if possible. Thank you, sir. We'll move on to the live case.
Thank you very much. We can hear you, sir. Welcome.
Good. Let's get started.
Sorry about the
just
delay.
a couple
We
of
were
minutes, sir. Let me just get your
We are getting the
chairpersons.
chairpersons on
Yes,
board.
sir.
Dr. Werner is here.
Dr. Nagamatsu, please. Dr. Ronnie Matthew, Dr. Natarajan, Dr. Jayagopal. Dr. Deepak Davidson also, please.
Lying to the balloon inflation stuff like
Perfect.
Over to your chairperson, sir. Over to you.
Hello, this is Gerald Werner. We see you. Again, sorry for the delay. The panel is set up, so please go ahead.
Okay. Hello, how are you guys? Welcome to St. Francis. Thanks for having us today. We have a good crew today. We have Jeff Moses. We have our fellow Dr. Shin. We have Rex helping on the table. We have anesthesia. Andy, thanks for being here this morning. And let me introduce the case to you. Next slide. So this is a 70-year-old lady. She has a lot of risk factors, cardiac risk factors. She has extensive cardiac history with PCI previously to the LAD. She has COPD. She has a history of lung cancer. She is 50 kilos. She has CKD3, COPD, as I mentioned. So a bunch of risk factors, and had a cardiac catheterization for a non-STEMI at an outside hospital. Let's go over those films. Her LV function is around 50%. And then this is the film. She has severe calcific in-stent restenosis of the mid-LAD. She has this horrific looking proximal circumflex, which I don't know if you guys can visualize on the angiogram, but basically it looks like a calcific nodule that protrudes backwards into the distal left main. And then the RCA is her best vessel. There's a few nodules in there as well, but it does not seem to be obstructive. So she was transferred to us for a complex PCI. We did this in two parts, partially because she got a lot of contrast for the diagnostic imaging the day before. So the plan for her was to do this in two sessions, if you will. We did the low-hanging fruit first. We did, at the time, a shockwave of the previous stent with good result, and the subsequent implantation of another stent in the LAD. Next slide. Keep going. And I think this was the final result. And so today we're dealing with this complex disease of this osteocircumflex and distal left main. And that's basically where we stand. We don't have an option for support. Her EF is preserved, and EDP we checked was fine. But even if we needed it, she has horrific vascular disease, so we wouldn't be able to place even a balloon pump, I think, in this case.
Yeah, but she has good LV function. She's accessible vessels. This is not a case I would contemplate support.
All right.
Anyway.
Okay. All right. So let me show you the pictures from today.
Right.
So you got an isolated circumflex lesion.
I don't think it's isolated. I think it's distal left main also. When you see this calcification protruding to the left main?
Does it transmit? But it's a very beautiful nodule sitting.
No, we
right
can
on the
see
left
it
main.
really well, guys.
Yeah. Yeah.
Here is two views. You kind of see this almost looks like a ring in the left main. You guys see that? So what will you guys do?
Image it.
Image it. Okay.
Great idea.
Great idea.
So I think the key is to figure out, does it involve the distal left main or not? So we need to image from both sides.
Okay, fair enough. So we did that already in preparation while listening to Professor Werner about fluoro. We went down to fluoro minus, just in case you guys are wondering. Immediately when he mentioned that, I'm like, let's go to fluoro minus.
That's a good idea.
Well, with 21 BMI, you can work with probably any setting, and it will not.
We don't need fluoro for that. We can see through her.
But one thing, Gerald, I'll say, we've analyzed our stuff at Columbia, which we know we've been fastidious about. And we have a lot of old rooms that have been used for 10 years. And even so, with physician behavior, we knocked the dosimetry in those rooms, same equipment, in half by just listening to your prescription and hygiene. So what you said is very impactful.
Well, thank you.
All right, so
I work on a machine that is 13 years old.
It's Germany, man. They can't afford stuff.
That's why you care about radiation so much.
Yes, but go ahead. You did a wonderful OCT.
Yeah.
So we have a good run here in the Circumflex. Let's go over this a little bit more detailed. So this is the new Ultron 2 system. The first thing you notice is they switched proximal to distal. So we're actually coming now through the guide, entering the left main. Left main looks pretty good, actually. This is the distal left main, which has actually a calcific ring, and then this is the prox circ, and this is the mid circ.
You got all that, right?
So let's go this a little bit. Let's go a little bit slower, and let's look at the left main. Wait, stop. Go back. So there's a nodule at the ostium right here. You can see that at 2 o'clock, but the lumen is 9. More than is 9.5. So we plan to leave that alone. We don't want to disturb a nodule if the lumen is preserved. And there's a very good landing zone, a couple of millimeters in the mid shaft, which is right here, with a lumen area of 12.5 and the lumen diameter of 4. And then let's go to the distal.
You want to point out what all the little annotations are, by the way, for those who aren't familiar with the.
Yeah, Zia, do you want to go through the new AI software?
Yeah, sure. So basically, you can see the calcium that's highlighted in orange in 3 different places.
Yeah.
1 on the angiogram, 2 on the circular part of the cross section, and then 3 on the automated measures. Now, who do you have there, Craig or Susan? You can change the threshold of this calcium by clicking on the curtain and simply switching it. For example, let's go to 270 here. And as you remember, the calcium score actually includes 270 as a higher risk factor, so you can see that you've even got probably almost 5 millimeters or at least a few millimeters of very dense 270 degree calcium.
Let me just say one thing, which is interesting, and we just noticed this today. The nodules aren't picked up as calcium. So in this case, it looks like it's not so bad when you look at the automated measurements, but when you actually look at the images, the nodules don't really appear that they're fully, like in this case, you see there's not so much calcium, but the nodule is nasty.
But what I do like about this, if you use the volume algorithm, you have it right in front of you, right? You have 6 millimeters of orange in a 270 setting. You know you need to do more advanced preparation. Just one glance to the right, one glance to the screen.
Can we get rid of the lumen contour for a second?
This is just a great example of what we've been teaching about nodules, is that your nodule is usually flanked by a lot of dense calcium. And you can see that on either side of this current case.
So this is the distal left main. You kind of see this calcified nodule. So this is, we classify this as an eruptive nodule, right? You can see the spiculated surface, which is really well visualized on OCT. What you don't see is the underlying structure, if you will, right? Is it a calcium base or is it more necrotic core?
Yeah, but
you have a ton of
calcium right around it.
For sure.
But Ziad, if I can interrupt you here, why didn't this software pick up the calcific nodule as calcium?
Yeah, you see that the inner layer of fibrous is highly reflective. So go back to the cross section, Craig. Go back. Yeah, if you look on the cross section, it'll go back a little bit, back and forth a little bit. Scroll. You'll see that it'll pick it up on the arc.
Yeah, there you go.
Can you turn the arc back on, Craig? Because you're not on are you on review or morphology?
No, but it doesn't pick it up. Look, it doesn't. It picks it up. You see between 9 and like 12 o'clock, but the nodule is between 12 and 3, and it's picked up a little bit, I guess, over there. But I think the main reason it's not fully picked up is because it can't image through it. You don't know what's actually behind it.
So go back to the 180 degree threshold, and you're right, Alan. So the way the algorithm is trained is to look for sharp demarcation. And because the nodule is not sharply demarcated and it's got fibrin on top of it, it doesn't recognize it as calcium. So it misses it.
Okay.
Okay.
So what are you going to do, guys? You're going to shave it, you're going to shock it, you're going to rock it?
Well, so let's do this before we do anything. We also did a run from the LAD, like you said before. I think this is, when you're dealing with a bifurcation like this, it's really important to image from both limbs. So let me show you the run from the LAD, which shows a lot of calcium also, but we feel a preserved ostium in terms of the lumen area, although there's the nodule extends into the LAD as well. So you see the concentric calcium here as well. And then, but the lumen is fine, this is above 7, and then this is kind of the prox LAD, very prox LAD, where the area is around 5. And then,
There's a little bit of the nodule for treatment.
right, and there's a little nodule there as well, but now you're back in the left main.
But there is a nodule going
So
into the
our-
LAD.
I'm sorry?
There is a calcific nodule that protrudes into the LAD.
Yes, 100%. Show that again. Go back to the prox. Oh, so here, right here.
Yeah, but the lumen is, 6.
6, yeah.
So
It's actually more than 6. You can see how it was
Yeah,
measured.
exactly.
So it's actually larger,
Yeah, I mean,
right?
so, I mean, this will come into play as we discuss our secondary strategies here. Once we stent, that's important. But right now, we're happy if we can leave the LAD alone.
Well, one of the things we've done pretty extensive research on nodules by now, and one of the things that we're a little bit discouraged by is that even though we do get good results acutely, the restenosis rate is horrific, and they actually break through the stent. So our strategy now is if we can avoid treating it, if the lumen area is preserved, we usually try to avoid treating it.
Okay. All right, so Ziad, you asked a question about
Let's go
what
on.
our plan is.
I was going to ask
here we are.
which action you're going to have. Shave, shock,
Yeah.
cut, rock.
Well, we shave first. The plan was to shave this first, and I'll tell you what the thinking is behind it.
This is CSI Orbital. It's now obviously Abbott's.
So Dusip, maybe you want to tell the panel what, I don't know if Dusip can hear me, but he just did our
you can.
debulking study.
Are you just doing it manually, not Glide Assist?
No, this is Glide Assist is on.
Glide Assist.
So the
we
reason-
have Glide Assist on, so quiet.
Yeah, I know.
So we're actually running at 6,000 RPM here, and it's just easing it through
Good.
the.
No, keep it on.
Keep it. Yeah, we want to go. Yeah. So our plan here is to walk through it on the Glide Assist, and then use the bias,
which we just
on
did
the
now.
way back. You see.
Yeah, so the reason why we like this is because we feel that the most calcification really is on the atrial side, and when you do ROTA, let's say, or even CSI, in an antegrade fashion, your bias will be away from will be on the ventricular side when really the nodule is on the atrial side, and so you have a higher risk of perfing and also not really modifying the plaque enough. The advantage with this system is that you can actually advance it through the lesion like we did now with Glide Assist, and then stand on the way back. And so that's what the strategy is now.
So one interesting concept we've been testing has been this concept of shaving and shocking, because we, and Dusip was the one who just analyzed this data, literally finished yesterday. We found in our calcified nodule population that you actually end up ablating at the maximum calcified nodule site about 14% of the nodule. So it's not an enormous amount of debulking. But what it might do is it might soften the plaque or soften the calcium so that it's more amenable to fracture by either NC or IVL.
I mean, that's an important concept. Look, I've been living with the debulking concept since directional atherectomy, and nothing really effectively debulks in the way you imagine it. The plaque modification is what we're going for, and I think that concept still, I mean, the ultimate modifier obviously is IVL. but we're setting it up for a modification in the thinning. So an NC balloon or IVL can crack the plaque and to give the compliance in the vessel that you need to put a stent in.
See, orbital would probably do an ablative thing, but I don't think it can soften the calcium all around. That I think would be a job that probably IVL would do.
Yeah.
Well, we might use that still, right? It doesn't, one thing doesn't exclude the other. So not infrequent, about 10-15% of our cases, we do either shave and shock or rotor shock.
Yeah.
But Ronnie, I want to mention something that's important but really unrecognized.
Uh-huh.
So, as calcium forms, it
Do one
forms
more
like
round, I think.
an egg.
Give her a little time.
So the outside of the calcium actually hardens first, and that's collagen-free calcium. And then collagenized calcium forms, which is very, very hard. You cannot tell which is which by OCT. So if you can cut the eggshell with the atherectomy device, what's inside could actually be very soft and be modifiable with a non-compliant balloon. So we just started looking at this in more detail and did some histology experiments that show that you cannot tell by intravascular imaging, even OCT, what stage of calcification you're at.
I'm doing Cindy just for the audience.
Yeah, that sounds.
I will do it with the
sounds pretty
OCT. Let's just do a balloon with the
intriguing, yeah.
OCT.
I would agree with you.
No, you don't want to take a picture? Okay.
I took a picture. I'll save it for you.
Yeah, let's show what we look like here. I think you can see. I mean, you don't always see that much of a visual difference, but I think you do here. And I think the upward extent in the nodules down a little bit. We'll balloon it, and then we'll see what we look like on imaging.
Right.
Well, if we
All
can
right, can we
convince you
take
to
this
do
out?
an OCT
Yeah.
before ballooning it,
Yes.
I know she has CKP.
I've been fighting this battle all morning.
I know,
Alan, I
guys.
need it
Come
for-
on.
I need it for the database.
No.
I need it for the database. Come on, man.
You're killing me, man.
You got to do it now.
Yeah,
it's
you
for the
should,
sake of
Mitch.
research.
Because
Really
let's
are
see
killing
if that
me.
hypothesis works. Whether you have ablated the shell out.
But then does it correlate with any amount of slow flow? You're thinking of that concept, the necrotic core just coming out and.
No, there's no necrotic core
No,
there. It's a soft calcium.
I haven't seen that.
Okay, you're out. Hit the button.
We've never seen slow flow with calcium.
All right.
Sir,
And can I have the Xiaom blue back?
Sir, Dr. Deepak here. Have a query. When we did the OCT imaging, we made out that at the circumflex ostium, at 2 o'clock, 3 o'clock position, it was more of an eruptive nodule, and the other areas we made out that there were nodular protrusion. So that particular area at 1 o'clock, 2 o'clock position, you made out that there was some fibrin which is not really picked up by the OCT. So seeing this eruptive nodule versus the nodular protrusion, does it make a difference in deciding on your atherectomy device, or does it mean that when you see an eruptive nodule, you are happy that your orbital is going to help you out in a better way compared to a nodular protrusion?
Yeah, that's a great question. So generally what we found is that eruptive nodules are almost uniformly modifiable or deformable with a non-compliant balloon. And so if you think of it, it's basically a sheet of calcium that's already cracked. And so now it's surrounded by either lipid or blood, so you can push it out of the way quite quickly. But here's the
Let's do the
fundamental.
OCT next.
Look how much calcium is surrounding it proximally and distally that's non-eruptive. And as a result, you need to be able to modify those segments to push the eruptive and the protruding nodular component out of the way. Like here.
I mean, Z, the way I look at it, what we're struggling with is look, you do this quick and easy with a balloon, but when you have over a 30% recurrence rate, we're searching for better solutions. You can get
And this is
great
why, Jeff, I
acute
think
results.
this dual prep registry that they're doing in Japan of doing shave and shock together, I think could actually be have a lot of insight and maybe the optimal treatment strategy.
Yeah.
Mm-hmm. So,
I mean, the question is, how much are we dealing with the recurrence of the nodule working its way through the stent, or how much of it is just biologic activity and it actually growing in there? And I think if
Yeah,
you
good-
reduce the mass, the former will probably be the turn out to be the biggest issue.
This is why
So
the
here's a-
debulking part's important, and making sure that you spend time there and try to debulk it as much as you can.
Yeah, but then even
Alan,
if you-
tell DUSIP to add it to the database.
Yeah, but even if you debulk an eruptive nodule, there's a certain limit to it, and then it would grow in through the struts.
Yeah, so Ronnie, we don't know,
yeah.
like Jeff said, we don't know if it grows in or whether it gets pushed back in by the hinge movement.
Yeah, that's true.
Yeah. So well, this in its own way will teach us what the actual biology is.
All right, let's see what you got here.
Right. So the way the
Go.
Ultron
I'll tell
is
you when
set
to
up,
hit it, okay?
Your kid could do this case.
So we have not got the
As long
Ultron
as
2
they
still
can read.
in India, and it seems a little different from what we do. It comes from proximal to distal. It's inverted for us.
Siad,
No, it took me a while to adjust. Even now, because I go to Colombia,
Go.
we don't have the Ultrian yet. So when I come here, I have to remember what language I'm reading, whether it's right to left or left to right.
Siad, moreover, would you agree if I say that it's easy to deform these eruptive nodules compared to the nodular protrusion?
Absolutely.
That is correct. Absolutely.
Okay, let's see.
Looks a little
So
less
this is the
bulky.
co-registration, right? So there's we basically, wait 1 second. So this is what happens not infrequently, right? When it gets the co-reg wrong, you really go to edit and you just hit the right vessel and it immediately corrects.
It's not just the co-reg is good. If it's wrong, it's fast.
It's fast.
Fast correction.
Exactly.
You don't struggle with like the previous system.
No, but at least the angiogram looks much better
But you
in the Ultron 2.
It is. And there's a zoom feature. You guys want to show us dynamic angio?
Yeah,
later?
we're gonna show that in a minute. Yeah. So let's see if we modified anything here. It's a little bit of an impact, but not
There's some groove in there.
some groove in here for sure.
You got that part.
We got groove in.
So right here, guys.
Yeah,
So
That's
go
a little
in
bit bigger than it
Craig.
was before.
Keep going in here. So that part now you might be able to break here.
So,
Well, what you don't see is there's the microfractures, right? So this is why I usually do an NC first and then assess, because that really shows you better, the more
We
final
do have
results.
Smooth areas. We have had some effect, and hopefully that'll thin
Right.
things out enough so
no,
that the circumferential
but considering
calcium
that
will
you've got a
crack.
lot of other calcium around other than the calcific nodule there, wouldn't it be better to use a
Let's have the
IVL at
NC.
this point rather than an NC? Because you've got other calcium too, but NC is only going to help the calcific nodule.
That's a fair
I'm
point.
not opposed to that, to be honest with you.
That's
I
a
think
very
it's
good point.
Yeah, it's not a bad idea.
Let's see. Look, for me, from the economics, let's see what happens.
So when did economics
Let's
start
just
in
say
the
economics
US?
aside, I think that would make sense.
You can have the new catheter, everything. And
In all fairness, we need the
Yeah,
the
there was a
relative
here a shape there.
contribution
That's
for
the point.
improved outcomes.
I think they've gone and pushed a
we
little there,
still-
but you can see the
we still
shade
don't have
around
good
there.
data on compared to an MC. We don't have any comparative studies. There is one ongoing.
Excuse me, please explain about the wire bias at the Lexman trunk. The distal guide wire touch where is the calcium nodule. So a little bit we can see the distance. So very difficult to cut it using, even if they're using the rotor operation.
All right, go up.
Yeah, so generally the orbit maxes out
Look at this,
its
what are we at?
centrifugal
Oh,
force
we're
at
at
1.8 millimeters.
Opened up.
Can we have the sync on, please, on the camera?
Yeah.
Craig,
Ronnie, what is the advantage of this proximal to distal image
come down.
compared to the usual? What is it an advancement? Is there any advantage with that?
I have no idea. Ziad, can you answer that question? Why did Abbott decide
All
to go
right.
from proximal to distal?
Just
What's the
watch
advantage?
this
again?
for a second, Ronnie. Just watch the balloon go up here, because this is what Deepak was talking about, the deformability.
So you see how it's completely deformed. So you're ready to stent.
Down. Yeah, so this enhanced imaging feature, on the Sync Vision, I think is tremendous.
Yeah.
On the balloon, right?
So
And you know what? You would have done this with an IVL and said, look how great it was.
No, you're right, Jeff.
Yes.
I mean, that's why this device detection is so
What,
useful.
guys, what stent did we decide to use here? 23 millimeters?
So,
We're
Ronnie,
happy
your
with the
question
landing
about
zones?
proximal to distal is a good one. And it was actually just, it was a conceptual change from the
Show me the
software
distal landing
company,
zone again.
IDEO, who made the Apple, basically the iPhone, and
going.
they thought it would be more intuitive, although
Okay, I'll come back a little bit.
clearly it's a change for interventionalists.
So that's
Yeah, it's and interventions don't like change.
I agree.
Hard enough to learn the first thing.
go a bit more distal. Yeah, go a bit more distal. I think it opens up a little bit more here.
Yeah.
So that would be actually better to land it right here. 25. We make it 28. What if you make it 28? I got you, but let's do that. Let's just go proximal to 28 and see how that looks. Yeah, bring it more towards. So if you land it there, where we are now distally, we have to extend it to 28, right? I'm a little deep with the guide, but I think that will work.
You should be
Yeah, I
good with
think so.
23.
I think this should be good.
28 we do.
Yeah.
I kind of like that actually because
So do you
it
want
makes
to
a big
discuss
difference distally.
Questions are here. What are we looking at here in terms of?
Yeah, so obviously we have limited stent lengths, right? So when we go back to the distal, so what we're talking about mostly is the distal landing zone. So if we use a 23, then we are not in an optimal landing zone distally. Just go distal, please.
So show us 23, Craig.
Go to 23. See how there is a lot of plaque here, and the lumen area is much smaller here at 23 than it is.
It's not acceptable.
It's not really a good landing zone at all.
But in the left main,
So then
you
it's-
could move a little distally.
So come back where you were before, to distally at the distal landing zone.
Here we're opening up.
And here we'll open up, right? And now we have an area of 6. So this is
What's the
a
minimum acceptable area these days for landing?
5.5.
Yeah.
No, so I think this is okay. So Zia, do you want to talk about the two strategies, the EL-based strategy versus lumen-based strategy in terms of stent sizing?
Yeah,
And
so
what it
as you
depends
know,
on?
Ultreon will
So let's have,
automatically identify the lumen and the EL if it can see it.
3.28.
And here you can see the distal lumen is 2.78. So in Illumian 4, lumen and upsize would be 3. And so we take a 3028 device. And if the EL was visible at least 180 degrees, or actually that's not even true, at least enough to make a measurement, then the EL is automatically identified and measured.
But the LM you'll have to go up to 4.5. So I don't think would a 3 be okay for that? Or would you want a 3.5? Because you'll have to at least go to 4, a pod with a 4.5.
It's really four here.
We measured 4 in the left main, which is okay with the 3.0 stent.
To the left main a little and show them that, yeah. Here it's 4.
Yeah, it's
see?
4.
So even though the packaging may be 375, Z, talking with the engineer, they're very conservative. You can always add 1/4 millimeter to these things and keep your structural integrity. Probably even more, but I don't want to get into that. But so we're getting our stent from
3.
Good Sam.
No, from where they make it in the headquarters.
In a left main.
Yeah, no. It depends on the stent, open cell, probably.
Now, could you put me on the distal landing zone? And then that's good, right here. And then go up and go left. That's it. Hit that. Perfect.
So this
this
is the
is
dynamic
co-registration.
angio coming up.
Yeah.
This is really good. This is, you can have a robot do this one.
Can I just ask?
Dude, don't diminish my work.
How is the ostium of the circumflex? You think it's adequately prepared, or you require to do something more on that?
I mean, the balloon inflated fully.
Open up quite well. No?
Right. So now, once you put the stent, what's your thought process? You're going to open the strut to the LAD, and you're just going to kiss and leave, because you got a nodule protruding into the LAD ostium.
It's an excellent question.
Maybe you got a reimage.
Yeah, that's the plan.
So let me come back a
Of
little
course, it may
bit.
be crappy on the angio, which will answer the question even without imaging. But yeah, that's our plan, is to re-image with a small balloon and make a decision, assuming the angiogram looks viable.
So this looks pretty good.
Yeah, right at the.
Let's just look at it. So ostially, I'm pretty close to the ostium. I think I'm right at this elbow.
Yeah.
Right, so it lines up well with my
Is we're looking at the marker, and we're looking at the live fluoro, the fluoro, right next door to each other. I mean, it's magged up, so for those of us with failing vision, we can see it very well.
So are you?
All right,
seeing-
let's take it.
Are you seeing both these pictures on the OCT machine, on the Optis?
No, it's on our display.
Go to 14.
Okay, it's your display.
It's on the the angio system display. It's just one of six tiles that we're looking at. When we go
Let's have that 40 NC next, please.
So you can zoom in onto the
Thanks,
live
that's good.
view,
What do we
so that
have?
it's right next to it, like the previous OCT. So you can expand that field. But this dynamic angio is really a very nice feature.
Yeah.
Don't pull.
No, I don't get that. So we are seeing that OCT box. So you see on the right side your calculation, on the left side I can see the live fluoro. So that's seen on the
Right.
Optis.
Yes,
Yeah.
yes, exactly. So that's how we place. That's how we place the stents now,
It's being this is being reported from the op.
right? So once you identify your landing zone, you don't need the OCT anymore. Now you need the co-reg, and so we base it. We place the stents based on that image.
It's really a very nice feature and well thought out, because as Alan said, you don't need the OCT anymore. You need to eliminate geographic miss, and this is the best way to do it.
Yeah, that's a great feature. So,
Yeah.
It was definitely a St. Francis push.
Look, I like to say, Z, is all they did here, this is Richie Schlafmitz in a box. He just incorporated his workflow, which is without a doubt the most efficient utilization of it, I think. And now it's generalizable.
Maybe in a little.
Strut.
Yeah,
Where's
somewhat.
the left main?
Right.
Where's the LED rather?
Looks pretty good. So why don't we take that? Go to 18.
Again, I mean, the balloons are opening nicely.
And maybe do a soft inflation here, so you can't really see. Go to like 12.
I mean, you're not moving plaque. We're just literally just expanding a stent in water.
All right.
So you just want to go to the balloon nominal size, and that's it.
And
Let's
having
have
the
the-
device detection on top really helps us to make sure that we don't end up
3.5 NC.
outside.
Maybe I should rewire. Let me have that Beamer Universal back. Let's see if we can rewire the LED.
This is a 3.0. So do we want to? Do
3.5.
You want to get the 3.5?
Yeah.
Yeah. Do we have the 3.5?
We have.
Okay, excellent. Okay. So now we've done the pot. Now Now we're going to optimize within the stent, right, in order not to disturb the, right, or the plaque distally. There you go.
Now, Ziad, why they're doing that? Can you tell us about this Ultron 2? What are the other we saw a lot of figures on the right panel, up and down. I could make out the square millimeter area. So you get the dime. I didn't understand what you see on the left.
Let's show you, Craig. Why don't you go to the another Xi'an blue?
Okay, so what you've got here is you've got your sizing. Now look the way they've done it.
1 second.
They've done your proximal and your distal and your length so that all your clinical decision making for stent diameter and length is made on the sizing. So then you have calcium, and that would be for your lesion preparation. Go to measurements, Craig. Your measurements are basically the measurements that you've previously made, and you can feel free to delete if you want to. And then Craig, go to the last curtain.
So 2.7 on the left panel is the diameter. What's the one on top? That's showing minus now.
That's what the EEL would be. So the way it's divided is two things. On the cross section, you see the area on the right and the diameter measurements of lumen and EL on the left.
Okay.
And then the way they've done it on the automated measures is you get the diameter measurements on the top and the length measurement on the top and the MLA on the bottom.
Yeah, we got that. Yeah, okay.
So it's quite intuitive now. I think they've done a good job of placing all the information. I like the top curtain for the measurements tool because it shows you basically your stent size, your distal post dilation balloon, and your proximal post dilation balloon all in one curtain.
Yeah, got it. So now you see it has calculated the EL as 5.04 millimeters. Right, that's right.
Exactly.
If we go by that, you should have a 4.5 pot.
Lumen diameter.
You're right. Yeah.
The lumen is what there? The lumen's for the area is what was the area there? 12.
I think I'm in, right?
I don't need to
1 second.
fibrous area. I'm happy.
By
with
lumen,
it.
you're 4. So for pot, you should be okay for 4 too. I mean, I don't know of any
that's
data.
what I'm saying.
I don't know of any
That's what I'm
data
saying.
of pot of
Alright.
EL versus lumen.
Go up.
Yeah, we just try to oppose the damn thing,
16.
Yeah.
right?
Yeah.
Down.
So that's a 3.5.
18. Looks like it's opening pretty well, guys.
It is interesting, though, that despite all the calcium that we saw after the orbit, the NCs, we're not going to very high pressures.
So
And
probably there was
going
no
back to what
calcium.
Deepak said, that is the rule for an eruptive calcified nodule. An eruptive calcified nodule, by definition, should be deformable. And so the lesion preparation was actually
Back to
for
the
the
OCT.
surrounding calcium around the eruptive nodule.
You want to take one picture to see how the LEDs vary?
I will when the OCT is done.
Okay.
Let's do an OCT right here,
Okay.
and then we'll make a decision what to do with the LED.
I would just
Ronnie, why don't you tell them your
optimize this.
experience of not opening the struts in the left main?
No, I know. I think you image it, and if you got a strut across the ostium, you got to open the strut.
What happens if you don't?
If you don't, you will get a neointimal growth across the struts.
Really?
So Ronnie actually presented 6 cases at Europe PCR, which were very illustrative of that. It gets like a thin film membrane on top of it.
Okay.
Okay.
Sort of like what happened with the SKSs.
Yeah,
Okay.
but it wasn't in all cases, right, Ronnie? It was just in selective cases.
Yeah, but still, it's
I'm good to
that's
go.
Yeah,
disruptive.
I,
That's
I,
good
I
to
do
know.
agree, but then see, because there was no there's no study being done on that. We could probably say it's anecdotal, but I believe if we did a proper study on that,
Go.
we would see it on all.
It looks beautiful.
LED will look at it. It's a little funny there, but we'll see.
Let's see. Well, you see the nodule there, right?
Exactly. So we'll image
That we know that we have.
I mean, already
So-
you can see your stent looks great.
Yeah, I think we should open this maybe with a 2O balloon or something, and then
Oh,
right,
absolutely.
and then we'll get
You have to
yeah.
evaluate.
Let's have that, please.
The result looks very good.
So we're happy with the expansion.
Beautiful.
Yeah, it's good.
We landed it. So there's a nodule you guys can see just distal to the stent,
Specifically trying to avoid.
which we avoided.
Now, just out of note, guys, you'll see that the expansion here says 64%, but you obviously can't do that because you're comparing the circ to the ostium of the left main. So if you really wanted to compare the expansion, like Craig's doing, you're going to bring this into just inside the bifurcation.
But why can't you just split it in two and get it from the bifurcation to the left main ostium and from the bifurcation to the distal circ?
You could. Yeah, this is on
that's okay.
tapered mode, but you absolutely could split to bifurcation mode and do the same thing.
Put on here. Okay, let's have that 2O balloon. Yeah, regular.
So Craig, show them the deformed nodule. Okay.
That's
Okay, great.
That's it.
Now you see this where the nodule was before. Keep coming back. Keep coming back. Right there. That's where the nodule was. Do you see how the nodule is pushed into the wall? That's deformability because it's the broken glass getting pushed into the blood. And so it's just, I always describe it as like it's broken glass in a pillow and you're just pushing the glass by sweeping it away. And it's almost always deformable.
I just want to make a
well seen, yeah.
So we don't have. How's our apposition in the left main?
But could you just show us the
Really
3D
inside.
of the ostium at this point on the OCT? The bifurcation?
Sure.
Doesn't go through easy. Let's have a 1.5 Takuro, please.
Go across?
No.
Craig, can you go to 3D?
Yeah, the catheter is not going across, right?
So this is something nice, guys, that we have the 3D back now in Ultron 2.0. You'll miss this in Ultron 1.0, which it doesn't have. Actually, your ostium looks great, guys.
So the 2O wouldn't cross in the LAD, so we'll take a 1.5.
Why don't you spin that back to the more longitudinal? It's trying to figure out why that won't go through the wire. The strut doesn't look that tight. Interesting.
Yeah, you're on the distal strut.
You're on the distal
Yeah,
strut,
must-
yeah.
Yeah.
So you're on the distal strut, and that's why probably the balloon is hitting the distal strut.
Yeah.
Let me bring something unusual into this discussion about opening the struts. Imagine that the patient is not returning to the same institution because of some acute problem in the future. And then they are faced with an unknown geometry or geography. So I think it's always better to open it fully as good as possible, because there might something happen in the future, and there's not, she doesn't carry the report.
And that's the EBC main hypothesis. I mean, the
Yeah.
thought process behind
Maybe I may rewire this.
There's a nodule also there in the left
So
ostium.
let me
There's
rewire with
something
the other
there.
one, with
the
the
left
circ
LED
wire.
ostium also there's something there.
So you're saying doing out of courtesy, Gerald?
Yes, courtesy to the future operator.
Exactly. No, that's always my joke. I said someday when you're retired, it's gonna come back and your fellow's gonna be cursing you because you didn't open it up.
That's
Yeah,
a
but you're
philosophy,
retired.
I think, in Europe, where you always cross and you always kiss and you leave. But I think to this always cross and always kiss,
Of course.
if you can do an image, you can probably selectively decide where you want to cross and where you want to kiss. Because in a number of cases, once you do a pot, you would have no strut across the ostium.
It depends on the location, of course. We wouldn't do it in the second diagonal or marginal, but I think the left main, where there is also now treatment, there might be a restenosis in the future. I think that is a different perspective.
What are the chances of a strut not being there if you do 100 cases, let's say, by imaging? What are the chances that there won't be a strut across the ostium of the other vessel, roughly?
No, I don't think
Yes, we can anchor
we
it,
can
right?
quantify that because there has been no data on that. But I think we do see it once in a way.
Range.
We do see it.
Once in a while? You mean once in a while you see a strut or you don't see?
You don't see a strut.
Yeah.
Most of the time you see struts.
So the default is always think of a strut there.
I don't know. I don't think we can really say that unless we quantify it on a data.
Most of the time there is a strut. It makes a sense that the European philosophy is right.
Kiss always, huh?
Without even imaging, you, as he said, open.
There you go.
So that went in
What-
pretty
what-
easy.
what
So
is-
maybe
what
that's
is
the
the
best. That
baseline
went in
imaging?
pretty
What is
easily.
the baseline imaging told us that you don't need further something like IVL.
Put this in the diac for now. Now let me take the other one and put this in the circ.
Alan, how often do you use a dual lumen catheter in these situations? Not at all, because there were some talks from UK, I think they told that you should always wire the side branch in left main settings with this dual lumen, which I think a little bit exaggerated. But do you use it?
Why? Why?
Not to be caught under the struts, probably when you don't do imaging.
Yeah, that's the only reason,
Yeah,
if I'm concerned.
If you're not going to image, yeah. But here we have we have a parking lot in the ostium of the left main with no malapposition. It would take a lot of work to get under the struts actually here.
No, we had discussions today in the left main symposium whether you in some places in Europe imaging is not so.
Well, yeah, exactly. That's what we're getting at. I agree. That's when imaging is used sporadically. I can see that, but with all due
But
respect,
cost-wise,
why
it's
would-
more expensive to open a dual lumen catheter than an imaging device.
And why would you not image a left main? That's the first question.
Those are very good points.
But you know,
No,
you
if you do the pot with the 4.0 because you underestimate it in a 5 millimeter situation, you can easily go under the strut, and you will only find out afterwards on the restenosis when they find.
It goes very easy now.
The shot, the
the
double
rewiring
barrel
to be-
situation.
We might have, to his point, we might have been under a strut. I think we should definitely do the pot again at the end because it's possible. I took the circ wire. Instead the tube balloon. We'll do the run and we'll see. But it's possible that it didn't go because we were under a strut somewhere.
Yeah, if the wire doesn't go easily after a good pot, it's always suspicious.
All right,
Mm-hmm.
I agree.
We'll verify it with this run. Obviously, we'll be looking mainly at the LAD, but we're going on LED wire, which was the old
2.0.
wire. We're just we're going
So
on LED.
let me ask you guys a question here because I am I'm with Alan here that you don't really need a big balloon to try to get all the struts up off of the LED, and that really you need to just prevent this membrane from forming, and to do that you need to make some space in the cell. what do you guys think on the panel and in terms of sizing of pot balloons for this purpose?
No, I think when you are,
Sorry, kissing balloons.
yeah, so when you are planning to just, especially in this case, because your ostium, the LED is pretty good. So your job of your kiss is only to move the strut and to modify the strut. So you need very low pressures. So it's something like a
8.
smooch rather than a kiss.
2L?
Yeah, 2L.
But I would size it to the size of the LED.
Yes.
But avoid dissecting the pressures that might dissect.
Precisely.
Yeah.
And not put a balloon too much into the LED either.
Yeah, my thinking was to try not to injure the LED until we make a decision to treat it. If we decide to treat it, then obviously we're going to use a 3.5.
And
But
we're presuming we're not making any wall contact here. We're just, moving some metal aside to permit the mirror to go through.
No, but Ziad, why did you ask that question? What's your opinion on that?
I don't know. I don't know if there's a right answer. There was no clinical difference in the OCT 3D bifurcation study from Japan as to whether you completely remove the struts or didn't, and the data is not available from October. So I don't know. I mean, I'd be very cautious not to mess with this nodule that's in the proximal LED for this specific case.
not going easy. Let's go on. I think I'm across here. Yeah. I'll maybe take a little more. See I'm in the diagonal. No. See the wire is in the diag. It's hitting that.
Are you past the nodule?
Yeah, I'm past. I think.
It's not freely going in.
No. Maybe, let me see if I can go a little more, huh?
You had a nodule and the ostium of the left main. So would you have taken a stent to cover the ostium as well? So in which case you could have gone up to very high pressures and excluded the chance of abluminal wiring?
No.
The ostium of the left main had a nodule.
Yeah, I think in general, our approach on nodules is if they're not obstructing the lumen, don't touch them. Because remember, the mechanism of failure is reprotrusion of the nodule into the stent. So if you injure it and it pokes back through, it's going to mangle the stent with it too.
See, I was talking about the nodule in the left main, not in the ostium of the LAD. But the nodular eruption is the one that comes out, isn't it? Not the nodule.
No, we actually published in JACC intervention that even the protruding nodules can reprotrude.
I think it looks great. You have a nodule, but the lumen looks fantastic, no? So our lumen area here is like 13, and then we come to that nodule that was the protruding right here, and the area is still 10. And then here, the area is fine also. It's the measurement isn't quite accurate, but we can do a manual. Can you put the measurements on so we can see what the issue is? The contour measurements? Yeah, you see how it's miscalculating?
Yeah, it's missing.
Yeah, it's missing half the vessel.
Yeah. Look at that there. I mean,
But I think
better than 16.
No, but it shows you nicely actually how you have this protruding nodule still there, but again the area looks great. Yes.
And Craig, do you want to show the beam artifact? So go back. There's a beam artifact which is making this look smaller than it is. Right, keep going. Right there. Do you see that? Yeah. At about go back one frame. Back one frame. About 2 o'clock. There's a beam artifact, and that you see that. That's the beam artifact is cutting this because it's pulling back across the with some tenting on it.
Yeah, but the area is huge. Now let's look at the left main for a second and see if we we were under strut, and then if there's an issue, we need to do a part again or not. And the stent looks good. I wonder if it's a little bit malapose still. Here, see, go back. There's a few disrupted, yes, few. So we should definitely go back and do another part.
Another one.
Yeah.
Absolutely. Yeah. It might have been under.
It might have been under, and it might have been disrupted a little bit.
That's what it looked like.
How about a semi-compliant 4 at low atmospheres?
What about the question of the LED ostium? I mean, the struts running across after the
Go back, show them the LED ostium again.
completely gone off.
There, you know.
Yeah, but doesn't the area of confluence look a little small?
No, it's a no. Can you do a measurement here, a proper measurement? For the area, yeah. Just redraw this.
Just gigantic. And that's 1/3. What you're seeing the measurement
Yeah,
is
that-
1/3 of the area. Look here. It's going to be like 14 or something.
Wow, look at you, OCTI.
Wow, Moses.
Off.
It's pretty impressive.
OCTIs.
I'm way off.
It's like you've done this before.
I mean, the one thing you have to get away from is worrying about the shape.
Yeah, right.
Yeah.
So we got another 5 minutes more. So are you going to do anything
Yeah, well,
more to the, because the area looks very good. So I think you're going to leave the LED there and just go with a semi-compliant balloon at the left main
Exactly.
and just
Yeah,
oppose
we're
the
gonna,
struts.
we're gonna just oppose those little distorted proximal struts, and I think we're done.
Excellent.
Yeah, go
So
on.
thanks for your help,
Go up to
guys. It
6.
was a very interesting discussion. I learned a lot from the panel.
I'm done.
It goes to show like how interesting these nodule cases are because we really don't know exactly what to do.
You have a fresh balloon?
Take a semi-compliant.
Yeah.
Yeah, no, I think it was a very good demonstration why.
Do you have a regular, not an NC, like a 408 regular balloon?
Did we lose them?
A regular.
I don't hear them anymore.
We're still
Did
here.
they cut off? Oh, yeah. Oh, I'm sorry.
So if we have a 40 regular, I prefer that. If not, I'll take the NC.
We should have a 4.0 regular.
Yeah,
8 or 12.
Yeah, I think it was a very good demonstration of how in a calcific nodule you could just go and ablate the top part, I mean the intimal part and get a very good expansion with just an NC balloon. And I think that was good teaching.
So there's a couple of learning points, and this came up, like I said, that we've been investigating because, like Jeff said, there's this dogma that when you slide an atherectomy device over a nodule that you somehow like cut all of it off and it's like cutting out a tumor with clear resection margins, and that's just totally not the case. The amount of nodule that's debulked is about 15%. And so what you're left with is other modalities or treatment strategies to do lesion preparation.
And when you're predominantly calcific nodule, you can just push it with an NC balloon. You really don't require any other modification tools like an IVL.
For eruptive.
For eruptive, yeah.
But for a protruding nodule, you see the key thing that they did was they used the device detection to show a complete balloon expansion with the wire in the middle of the balloon. Because if you have even a little bit of a dent, that's telling you need more prep.
And at that point, what would you use?
IVL.
Yeah.
Because you're going to try to break the rock underneath the marble.
Yeah.
Even
the
if
nice
it's so
thing is
eccentric.
these things, but it's sitting in a bed of calcium, and even if you don't crack that, you'll crack the bed, and it'll sort of, like a collapsing volcano, it'll drop into the wall. I think
Exactly.
that's how I visualize it.
Go to 12.
So it's a double hit. Nice.
That looks good.
Yeah. Okay. All right.
Let's do one more. That's a little bit hanging out.
We're just doing
Do one more
prop.
one more time.
You can take a picture.
Alan, just use the device detection there. You can see if the struts are mangled now. Since you've got the balloon in place.
Okay,
Craig,
can we
you
put the
zoom in on
device detection on? Can you make it bigger? Like the device.
Perfect.
Yeah, here we go. Okay, let me see this. Didn't fully pick it up.
Didn't pick it up. It's because you're just back
Oh.
your guide up a tiny bit. It'll work. There you go.
All right, let's see. I can mag this up a little bit if you want. This is Zia's favorite tool. It drives me crazy. It's like
Love this
radiation
thing.
therapy.
It's the hardest
I
part
know.
of the case.
Gerald is like holding his breath.
No, Gerald, honestly, right now is like he has close to being a heart attack.
The stretch
Okay,
You look great though.
Yeah, there you go. So there's the value of that.
Yeah, now device detection is very, very useful.
All right, should we do a final picture?
Why not?
Didn't mag out? Yeah. All right, let's show you what we have angiographically, guys.
Not bad.
That's good.
It's pretty good.
Very good.
Great work.
Right. Good.
Beautiful.
Good. That is very nice case. A very good demonstration. Dr. Jeffrey Moses, Dr. Allen, Dr. Ziad, on behalf of the organizers here, my panel, I thank you for this wonderful demonstration, and have a good day.
Thanks for having us.
Thanks for having us, guys. Take care.
Hi, guys. Good job.
Thanks for your help.
We did it.
Ladies and gentlemen, those who are standing right outside the hall, I request you to come in and take your seats, please. We just finished our very exciting live session. We'll be moving on to the inaugural session now in just a few seconds. Thank you. Check, check, check. Ladies and gentlemen, once again, kindly take your seats. Move on to the inaugural session. May I please invite onto the dais, in this particular order, Dr. Anil Kumar, please, our organizing chairman, to accompany Major Ravi, our chief guest for the day, Dr. Deepak Davidson, our course director, Dr. Rajshekhar Verma, course director again, Dr. Jay Gopal, President CSI Kerala chapter, and Dr. Sandeep, organizing secretary, CHIP Summit 2023. To kindly be seated on the dais, please. Dr. Jay Gopal, if you're here, sir. Dr. Sandeep, we request you to kindly take your seat on the dais, please. Thank you, sir. Begin the inaugural session with a prayer. May I request you all to kindly rise, ladies and gentlemen, for the prayer, please. Thank you.
श्री परमेश्वर गौरीसुतं भक्तजनप्रिय प्रणवात्मकं श्री परमेश्वर गौरीसुतं भक्तजनप्रिय प्रणवात्मकं विघ्नविनाशकम् एकदन्तं विघ्नविनाशकम् एकदन्तं प्रणतोऽस्मि गणनाद विश्वेश्वरं प्रणतोऽस्मि गणनाद विश्वेश्वरं श्री परमेश्वर गौरीसुतं भक्तजनप्रिय प्रणवात्मकम्
Thank you very much. Kindly be seated, ladies and gentlemen. May I request Dr. Anil Kumar now to deliver the welcome address, please.
Good evening, everyone. Let me welcome all of you to this inaugural function of the CHIP 2023. I especially welcome our chief guest of the day, Major Ravi, who has been kind enough to come and grace this occasion. I request a bouquet be given to Major Ravi. What is the relevance of our chief guest today? Our chief guest has been in the Indian Army, has been in the National Security Guard. He worked for the Indian military agencies, and he was head of operations for Operation One-Eyed Jack, the Rajiv Gandhi assassination case, and he started becoming a consultant for military-based movies. He has won the Kerala State Film Award for his movies, and more importantly, he has been involved in complex operations. So he is very apt for inaugurating the complex high-risk intervention procedure conference of the cardiology, of our cardiology group. And this CHIP meeting, we have identified that he be the chief guest for the day. We have also with us Dr. Jay Gopal, who is the Cardiology Society of India Kerala President. I wish him a warm welcome to this CHIP inaugural function. Dr. Jay Gopal has been a fellow who has been who's a fellow journeyman who has been having almost a parallel career with me, and we were writing exams together. So I found it very nice that he is the president of Cardiology Society of India, where we are organizing this CHIP conference. Welcome, Dr. Jay Gopal. We have 7 to 8 international faculty of which we have three of them here, Dr. Gerald Werner, Dr. Nagamatsu, and Dr. Arun Kumar. Dr. Gerald Werner from Germany, Dr. Nagamatsu from Japan, and Dr. Arun Kumar from UAE. I welcome all of them. I welcome all the national faculty who have contributed sincerely. Over the last 24 hours, we have been having excellent presentations, and they have made this meeting very meaningful. And I'm getting already feedbacks about the quality of talks. So I welcome all the national faculty to this function. A special welcome to all the delegates, without whom this meeting would have no meaning. I hope you are taking a valuable message home about the CHIP meetings and how to do the CHIP procedures. A warm welcome to all of you. Without the industry participation or the support, we would not have had this function. I can see all of them sitting behind me. A special welcome to all the industry partners who have made this meeting possible in this August venue. Thank you all. Thank you very much. We'll get on with the rest of the function.
Thank you, sir. I request Dr. Deepak Davidson, Coast Director, CHIP Summit 2023, to address this August gathering regarding the evolution of the CHIP.
Good evening to all of you. I'm indeed excited to be here in front of you all. Well, this CHIP Summit, it was conceived by Dr. Anil Kumar. It was basically a brainchild of him. We few like-minded people, Dr. Verma, me, Anil, Jimmy and all, we joined together and we started off the first session that was in 2019. It was conducted at Astor Conference Hall. It was good to see a lot of people joining that particular session. So we thought that we should continue this every year. But then after that, it was washed out due to COVID. And last year again, we all joined together, had the second meeting, which was conducted at Marriott Hotel. And it was well attended. I learned a lot of things from this particular last meeting. So we thought that we should continue with that. So this year again, we had a good session, started off yesterday. It was good learning for a lot of people. It was a good learning for me also, praying and hoping that it will be useful for each and every one of us tomorrow's sessions too. Thank you so much.
Thank you, sir. We now have the official inauguration of CHIP Summit 2023 by lighting of the lamp. May I request the chief guest, Major Ravi, to kindly do the honors. And may I request the dignitaries to kindly join him. I also invite onto the dais Dr. Rajiv, Coast Coordinator, CHIP 2023, Dr. Anil Balachandran, Coast Coordinator, CHIP 2023, Dr. Gerald Werner, Dr. Wataru Nagamatsu, and Dr. Arun Kumar to kindly join in for the lighting of the lamp, the official inauguration of the CHIP Summit 2023, ladies and gentlemen. Thank you very much, everyone. It's now my honor to invite Major Ravi, the Chief Guest of the day, to kindly deliver the inaugural address.
Good evening, ladies and gentlemen. I'm really surprised when I was called as a chief guest to inaugurate this function. Why? Because I'm professionally a killer and addressing the people who are the saviors. That's quite contrasting, in fact. But then, I'm really proud that my country is doing very well in the medical field. Because my olden days, I know that even a diabetic patient in my family, that was my grandfather and all, how badly they suffered in 70s and all. I used to see them. Because the medical facilities were very less, how they suffered pain and everything. And similarly, heart attack and all, it was like, once a heart attack, you are finished. That's all, end of it. And I've seen people going abroad, getting treated, coming back, open heart surgery or bypass and all this thing. It was not, we couldn't even imagine that. Now when you talk about angioplasty, one of my doctor friends gave me a gift on my birthday because I used to smoke. So she said, it's my birthday gift, one angiogram is free for you. I said, very good. So on the birthday's previous day, I was in the hospital doing this angiogram. Everything okay, 30% some block or something like that. I was okay. But then, when everything was going on, I was thinking, what if these facilities were not there? How earlier in an army and all, I have seen it. Maximum is ECG. Whatever it is, your decision is made on that. But today, so much of facilities to find out the exact position before you get into that body of the human being or the patient. So these facilities in my country, when I say in my country, I'm a proud patriotic Indian. So I always say they give my country. And I'm proud of it. Because I've seen you people doing, like, I've seen life and death quite often. When I was in the commandos for that 4 years, when I was operating in Punjab and Kashmir, I never got killed, I never got hit. But we used to kill people. Sometimes one bullet is enough. One time, 30 bullets also can't kill that person. Why? Because you, like professional doctors with the professional competency, used to save them. I still remember that officer is still here in Trivandrum, Major Rishi. He got a bullet from behind and that went from here. Nothing was seen on his face. Only a chunk of mass. And that's all. No eyes, no nose, nothing. Today, he's walking around with a handsome face because you people have done it. Why? How? Because the facilities which we got. He didn't go abroad. He didn't go anywhere. Here only. And his complete plastic surgery was done in my friend doctor's hospital in Amrita. He was about 47 plastic surgeries he has done. Now it's okay. So when I see all these things, I believe a lot of things you people are doing. And I salute the doctors. But then, I'm a very bad patient. When I was in the commandos and I was the only officer who used to run in Kargil in 1996. Only officer running in Kargil, 13,000 feet. And I used to run every day evening for about 5 kilometers. And all the doctors used to tell me, Ravi, go slow. There's 13,000 feet, no oxygen. I said, no sir, nothing will happen to me. And one day I just go for the regular routine checkup. And I found that I'm a diabetic patient. 235 at random. So physical fitness and everything is nothing. That's what I thought. It has come. I didn't care for it. One Daniel started. Then I thought one Daniel is good enough for one Milkmaid tin. I used to eat that Milkmaid also because that was free of cost in field areas. But then that spoiled my lot of systems. Finally, my creatinine went up. It was going up. Jaguswami finally said, one, come. Last time, what was your creatinine? I said, it was 4. It's okay. Then, I was shooting in Palghat for 2 days, full action sequence. Came back, driving. Jaguswami put me in a blood test and found that my creatinine was only 14. So suddenly, he got panicked. I didn't. I said, it's okay, let it go on. But then, he put me over there, put some wires from here and all these things, then the dialysis started. There also I was thinking, this dialysis will bring down my creatinine level. After 4-5 dialysis, then I can walk off. Nothing. After 2 months I realized, Ravi, you are waste. You are of no use. Every week you are going for 3 dialysis and the person who is for the public running around. Now today I am lying over there for 4 hours a day. Then the whole week is gone. That's the time I decided I got to have a transplant. Everything went on smooth. Within 3 months, I got my transplantation done from Lakeshore. After 3 months, I was shooting. Nobody knew that I had a kidney transplant. Now it is almost 2 years. So, one is that the patient should have that willpower to face all these things. I have seen a lot of people now similarly, like my case, another actor who is going through all these things, he is afraid of going for the transplant. But then his deterioration has started. So, I trust you all. But now, I got a request from my side as a normal patient. Simple examples, I'm a social service guy. Once I'm getting a call, sir, that Iron Man's wife collapsed from our colony and she's in front of some hospital. They are saying, you need to deposit 2.5 lakhs rupees for this angioplasty. I said, then what is it? No, she can't afford that. And they are not admitting. I would like to tell one name, that is Assam Medicity, Farhan. I just called him up. Farhan, I need your help. Rebecca, just send him. Send her. Admitted, done everything. And with a lot of help from others and all this thing, money problem was sorted out. But now, my request is to you all. You're all the World Forum. Why can't you all suggest this is a life-saving thing, this angioplasty, and one, I don't know what do you call it? One angioplasty, stent, correct. That is costing too much and all this thing. Why can't you all have a solid discussion with these pharmaceutical companies and you be a part of this? You people can raise a voice. I can request some people collect money and give to the hospital. But then, end of the day, who is blamed? The hospitals. They are fleecing money and all these things. Don't you think that it's a responsibility of the pharmaceutical companies also to reduce the money? So this request is all the World Forum. I request wherever, whichever countries you are, these kind of things should be cheaply available to save the humankinds. So that is the main reason why I came here, so that I'll get a good audience. It's not an audience. I'm requesting you all, because you people can raise a voice against this thing, so that it will be easily available for the people. Today, everybody has got this block and problems. Because of our living habits and everything, nobody wants to do exercise, nobody wants to do anything. So, end of the day, you people have to help them out. So it's a request from my side. Even if I come, if I can afford, I can give it. But then there are a lot of people for whom I keep fighting with the hospital authorities. Sometimes it happens, sometimes it doesn't. So, today my country is up to that level they can help. So please give a helping hand to this kind of patients by reducing the cost of the stents. If that thing happens, you will be applauded. Thank you so much. With that note, I officially announce that this summit has been inaugurated, and thank you so much for calling me out here, and wish you all the best. You are the saviors. Thank you. Jai Hind.
Jai Hind, sir. It was an honor, sir, to listen to you. May I now request Dr. Anil Kumar to hand over a memento to Major Ravi as a token of our respect and love, sir. Thank you so much, sir. It's my honor now to invite Dr. Jay Gopal, President CSI Kerala Chapter, to offer felicitations on this occasion.
The chief guest of the day, Major Ravi, the organizers of this CHIP Summit, Dr. Anil, Dr. Verma, Sandeep, and Deepak, and my dear friends. At the outset, let me say that I'm really delighted to be here, to be taking part in this CHIP Summit. I think for some of us who started our career maybe in the early 90s, I think our job then was cut out just to do an angiogram, hand it over to the surgeon, and that was it. And from there, I think we all went through the era of learning angioplasties and all the dreaded complications which we are seeing right in front of your eyes. In fact, in the early days, I was really discouraged. But I think over the last 2.5 decades, I think wonderful progress has been made. And that too, in a state of Kerala, I'm really, as the president of this Kerala chapter of the Cardiology Society, I'm proud to say that today, in this tiny state of Kerala, in the southern part of the country, we have more than 120 active cath labs. And I'm telling you the kind of work that is being done by almost all our members and the cardiologists are phenomenal. In fact, catering to a 24/7 primary angioplasties. When we compare to the kind of achievement that we have, in fact, we have done some particular studies in our state itself. When we look at the contribution that has been done, I think the primary angioplasty rates are fairly very high, comparable to what we have even in the western part of the country. So that's a great achievement. But then I always used to wonder, doing so many acute, most of our bread and butter is acute coronary syndrome, whether we really have this kind of patients to deal with. But then I must tell you that over the last few years, in fact, I remember having come to the inaugural meeting of this in 2019, the CHIP Summit. At that point of time, really started wondering whether really, is this really going to be the future? But today I can tell you that most of the problems that we see, even in a case of a primary angioplasty, it is the octogenarians, the elderly group, the chronic kidney disease patients. And I think it's so, because of all this, I think we are dealing with more complex cases, and we are actually seeing more and more of this in the present day practice. So I think it's only appropriate that this kind of meetings really take place in a big way, and I'm really happy to see that, and it's been a wonderful meeting so far. I think a lot of learning. Of course, I've been able to only spend a few hours here, but I think the kind of deliberations and the talk and the lectures have been phenomenal. So it's been a great learning process, and I'm sure the next day also would be the same, and I'm sure the people attending this conference would go back enriched in a really great way. Thank you once again, Anil, and the entire team for organizing this, and all the very best for this meeting and all the future endeavors. Thank you.
Thank you very much, Jay Gopal, sir. May I invite Dr. Rajashekar Verma now to kindly introduce Dr. Gerald Werner and Dr. Wataru Nagamatsu, please.
Good evening. It's my pleasure and honor today to introduce two of our esteemed guests and invited international faculty. So when we started thinking about CHIP 2023, immediately after the successful completion of CHIP 2022, one of the first names that came to mind was that of Professor Gerald Werner, who is now the Director of Cardiology and Intensive Care at the Darmstadt Clinic. I don't know whether I'm pronouncing the name correct. under the, it's a teaching hospital under the University of, the University of Frankfurt since 2005. Dr. Werner is well known to all the cardiologists, I would say, for his pioneering work on coronary collateral in the context of chronic total occlusions. The very classification of the coronary collaterals, the grading of the coronary collaterals goes by his name, the Werner CC grading. And it is also may come as a surprise to some that Professor Werner is also a pioneer in the use of intravascular ultrasound, one of the first persons to use the intravascular ultrasound in Germany. And the intramural hematoma as a complication of angioplasty he was one of the first persons to describe the intramural hematoma. A very, very learned person, has served as professor of cardiology and is actively involved still in teaching and educating cardiologists, young cardiologists, developing generations of new interventional cardiologists. Another of his passions was reflected in today evening's talk, which he personally requested me to give it to him. That is on how to reduce radiation risk in the cath lab. So that is another area which is one of his pet concerns. So to cut it short, I would say we are very honored today to be here, that he is here today amongst us, and we are blessed today to listen to him and learn from him. So, Professor Gerald Werner, I invite you to come to the dais and...
May I request Major Ravi to kindly hand over a memento to Dr. Werner. Wait.
Again, as a CTO, as a person who is interested in chronic total occlusions, the next name that again came to my mind was that of Dr. Wataru Nagamatsu from Japan, from the province of Osaka. He is related to Kochi in a manner of speaking. There is a place called Kochi in Japan, and he has completed his training from the University of Kochi, from the School of Kochi. So, in many ways, the name, though it's similar, but still, Kochi is a place in Japan, and this is Kochi in Kerala. Nagamatsu is again a very young CTO operator, but still has lots of experience, lots of learning. He is interested in the advancement of imaging, in the utility of imaging in the CTO process, the different aspects of CTO angioplasty. He has more than 250 published papers to his credit. He is a live operator in almost all the CTO conferences that the world has ever seen. So, a very gifted operator. We have seen him live at CCT in Kobe, where some of the most complex cases are operated upon. We have seen him in action in India as part of the Indo-Japanese CTO meetings that happen every year. We have also seen him in India CTO as well as in CHIP CTO as live operating, as also in India Live also, where he has come and operated on very complex cases. He has shown his dexterity, skill, and his mastery over the imaging and how it has helped in improving success rates in situ angioplasty. I welcome Dr. Nagamatsu to come to the dais and receive a memento.
May I request Dr. Jayagopal to kindly do the honors, please? May I also request Dr. Rajshekhar Verma to kindly introduce Dr. Arun Kumar to the audience.
Dr. Arun Kumar is our invited faculty, the third invited faculty, international faculty who has come all the way to Cochin. My first relationship with Arun was way back in 91 when I joined MBBS in Jipmar, Pondicherry. He was 2 years senior to me and was one of the first persons to officially initiate me into Jipmar. That time, that was way back in 91. Since then, we have been in touch. He has grown in stature. He has become he was an anesthesiologist who completed MD from Jipmar, and then subsequently has become a cardiac anesthesiologist. He has been trained in UK. He has worked and practiced in the United Kingdom, and then subsequently he is now relocated to Abu Dhabi, where he is the head of the Cleveland Clinic, cardiac anesthesiology. His interests include transesophageal echo and advanced cardiac anesthesiology, including ECMO, and you heard the lecture by him on how to initiate and maintain an eCPR. One of the pioneering research persons in cardiac anesthesiology from Abu Dhabi, but very closely related to all of us here. And he was here with us last year also. And it's my honor today to invite Dr. Arun Kumar to the dais and receive a memento from CHIP.
May I request Major Ravi to kindly do the honors once again, please, sir. A big hand, ladies and gentlemen, for our international faculty for having put up with us for so long and so late into the night. Thank you so much. Dr. Werner, Dr. Nagamatsu, and Dr. Arun Kumar.
Thank you.
Thank you, Dr. Verma. May I request Dr. Sandeep now to kindly propose the vote of thanks.
Good evening, everybody. It's an honor to stand here and thank you all for coming to our CHIP Summit 2023. The last year was a big hit, and I hope you are enjoying the conference this year also. So I'd like to, first of all, thank our chief guest, Mr. Major Ravi, who was an ex-NSG commando and me, and now an actor and director. We are extremely thankful for your presence here, sir. I'll also like to thank Dr. Jayagopal, who is our, at present, CSI Kerala President. Thank you, sir, for coming and attending our function. The next important people I should thank is my organizing committee, which includes me, and most importantly, Dr. Deepak Davidson, Dr. Anil Kumar, and Dr. Rajshekhar Verma. So these three people are the pillars of our CHIP Summit in any conference, because they are the ones who handpicks the speakers, and they are the ones who decide which topics to be discussed. And I feel it is the academic content of this conference that draws all, the attention and all the delegates and faculty to our. So I thank you especially for this. I also want to thank our co-organizers, Dr. Jimmy, Dr. Anil Balachandran, Dr. Sunil Roy, Dr. Praveen Srikumar, and Dr. Rajiv for giving your support for making it a big success. The third person I would like to thank is the main backbone of our conference, especially he joined along with us from last year, but this year he was the main backbone, and he is none other than Anish. You may be knowing through CSI. So he's the one who's event management, who has done event management for the entire conference, and it has really reduced my stress, and I was not at all worried that things will go wrong because he's so experienced in it. The The next team that I would like to thank is the Light and Sound by the AM audiovisual team. With so many live transmissions, there was no glitches, well transmitted, no issues, and everything was well handled with good care. The next will be the travel team who booked all the tickets and arranged for the travel of the delegates and the faculty, Jibu and team. And most importantly, the delegates for coming up all the way here to join us for this. And from, I think, CHIP 2019, it was around 25 to 50 delegates. CHIP 2022, it was around 120 delegates. And this year, we have almost 250 delegates. So it shows the growth of the CHIP Summit. And we hope to cross 500 by the coming years. And I'll also like to thank the faculty, including national, international, and everyone who came here and cooperated and gave their knowledge, and thank you all. And the main backbone of any conference, any medical conference, is especially the pharmaceutical companies and the industry, without whose support we cannot conduct a proper program. And I thank you all for your wholehearted support and making this a big success. Thank you.
Thank you very much, sir. We come to the end of the inaugural session.